After a long hiatus, we had a hybrid meeting last year. This year, we decided for a physical meeting. We have kept the provision of the live streaming also. So if you miss any interesting sessions, you can get yourself tuned to it. We have got a beautiful program here, a day-long program with didactic lectures and interactive panel discussions. After last year's success, we have decided to keep competitive case capsule presentation for DM and DNB PGTs. We hope that you will really enjoy the session. I wouldn't take long because we have got a packed schedule and we will miss the time. So without wasting time, I would hand over the mic to the master of ceremony today. They are Dr. Shubhasree Bhattacharya and Dr. Ognivo Datto, who are the pillars of our gastroenterology department, AMRI Salt Lake. So we will hand over the mic to Shubhasree and Ognivo to conduct the sessions. Over to Shubhasree and Ognivo, please.
So very good morning. First session of today is Therapy of Clostridioides difficile infection by Dr. Sujit Choudhury. And I'll invite Dr. Narayan Banerjee, Senior Consultant Physician attached with Apollo Hospital and Zenith Hospital. Dr. Subroto Pal, Senior Consultant Gastroenterologist associated with Kothari Medical Center, Kolkata. And Dr. Sujoy Rai, Associate Professor, will join us later. Sir, please.
Good morning. After a long period of time, we are here again for our Gemas, one of the popular gastro summit in Kolkata. Now, at the outset, I must thank to the organizer for giving us the privilege and opportunities to come here. Now, I invite Dr. Sujit Choudhury, who is my senior and very renowned and eminent gastroenterologist of Eastern India. He will deal with his topic, infectious disease in the GI tract, particularly Clostridium difficile infection, its pathogenesis and its management, and the newer updates on that topic. Now I request Dr. Sujit Choudhury to start his session.
Good morning. And I must thank all of you for being present here and to be a part of the 7th Gastro Summit. As an organizer, I am the first speaker. I selected these that, okay, maybe that the audience will be thin and also, and so that so all the delegates will be able to enjoy the academic flavor of this meeting. So I thought that I can start with the program, but after that, only thing that I am my next speaker is Dr. Mohan Ramchandrani, and because of his schedule, and he has taken a lot of pain for coming to me, and also I am so thankful to him for being with me, and also every year he is our part of our program. And so before going that, so that for that, actually, as an organizer, I started these proceedings today. So I will be discussing on the Clostridium difficile infection. The Clostridium is now it is called Clostridioides difficile. The nomenclature has been changed and that is accepted now. So just before going to that, just I saw a patient yesterday. I just want to share the history of that man who is now in AMRI hospital. I was referred by my colleague. The patient was admitted in the hospital on yesterday only, though day before. So this is a 63-year-old man who presented with diarrhea for 7 days and he was at home, but the diarrhea was exclusive and the passage of blood and mucus with the stool, and he was also febrile up to the 102 degree Fahrenheit for last 2-3 days, for which he was hospitalized. He had a history of hospital admission for about a month, exactly a month ago, for community-acquired pneumonia, and he was treated with broad-spectrum antibiotics including meropenem, but he was discharged without any complications of pneumonia. He had no comorbid illness other than there is no hypertension, diabetes. he stopped smoking, he was a smoker. But there is no other associated illness, no history of addiction to alcohol. So on examination, patient was febrile, toxic looking, heart rate was 110, blood pressure was normal, there was no hypotension. Examination, only thing that there is a slight significant tenderness in the lower abdomen. The investigation showed that significant leukocytosis, the platelet and the WBC count was 24,900. Platelet count is slightly low, 1,15,000. Creatinine was normal. Bilirubin was slightly high, 2.5. Albumin is 3.5. And prothrombin time is not very much high. It was INR was 1.3. Hepatitis B and hepatitis C serology was negative. But ultrasound showed features of CLD without any evidence of decompensation, no ascites. I did sigmoidoscopy yesterday only, and I advise for sending the stool sample for both routine examination, culture, and Clostridium difficile toxin. Why? I suspected that, okay, patient was hospitalized, and this is the picture of the sigmoidoscopy. So there is active colitis with ulceration, and there are white slabs on the surface, so very suggestive of pseudomembranous colitis. So this is just I wanted to share with you that, okay, this is the patient who was hospitalized about a month ago and received a broad spectrum antibiotic, presented with diarrhea, and this is the colonoscopic finding. The report of stool CD toxin has not yet come, but as the patient is looking toxic, we have started the therapy for empirically with oral vancomycin. So Clostridium difficile infection, it is a fecal-oral transmission, and it is facilitated by the disruption of the normal colonic flora. And the US data that about from 2011, there is increasing number of CD infection, and annually it was about 4.5 lakh annual incidents and nearly 14,000 deaths attributed to this infection. So it is a serious health problems. And about 10% of those patients who are hospitalized, and they carry the Clostridium difficile infection without symptoms. So these are the way by which, so it is a gram-positive bacteria, spore-forming, anaerobic bacteria, and it can produce infection when there is toxigenic strain is ingested in a susceptible person. And this toxigenic strain produce the toxin. There are two types of toxin, is toxin A, which is a enterotoxin, and toxin B is cytotoxin. Asymptomatic colonization can happen in the patients who are hospitalized, and the colonic flora is disturbed when there is antibiotic use. So and then this produces the disease. The risk factors, most important is the antibiotic use, the increasing age, female gender, comorbidity, GI procedure, even use of PPI also as a risk factors. The contact, another important issue is the community-acquired C. diff infections. The contact with the community-acquired C. diff infections can happen and can produce acute clinical illness of diarrhea, and the US data that about 35 to 48% of C. diff infection can be community-acquired. So, and in India, there are reports that community-acquired C. diff infection also has been found to be a part of the C. diff as infection, maybe one-fifth. About one hospital data that about 8% of C. diff infection and for the hospitalized patient compared to community about 1.8%. So what are the symptoms? It can be just acute diarrhea, and rarely that what I presented, that patient pseudomembranous colitis or further complication of toxic megacolon. C. diff infection recurs in about 1/5 of the patient, and a subset of patients can have a multiple recurrence, spiral of recurrence. The risk factors already mentioned that elderly age, recent hospital stay, weakened immune system, those who are more further immunocompromised, cancer, chemotherapy, or other immune disorders, and those patients who have a previous infections. Some of the antibiotics are more frequently associated compared to rarely associated with C. diffs. All of you know that fluoroquinolones, clindamycins, and the cephalosporins and penicillins are the most important. Rarely associated is aminoglycoside, tetracycline, TG-cycline, chloramphenicol, metronidazole, vancomycin. So metronidazole and vancomycin are given therapy, is a concept therapy for C. diff, but it can itself can be associated with C. diff infection. Indication of therapy when there is acute diarrhea and there is no explanation and there is a diagnosis of laboratory diagnosis of C. diff infection. But sometimes you can start with empiric therapy. I told you that this patient we have started empirically because of severe symptoms pending the lab results. How to diagnose it? There are different tests: cytotoxicity assay, culture, immune assay for toxin, and toxin gene detection test, that is NAT test. So these are the different tests. Toxigenic culture, it is not used clinically, but it can detect the toxin producing C. diff strain. And the GDH, that is the enzyme that glutamate dehydrogenase, which does not, this is liberated by the C. diff, but it does not differentiate between the toxigenic versus non-toxigenic. The nucleic acid amplification is more further advancement by which it detects the genes for toxin B. But most important test is the EIA for the toxin A and toxin B, which detects the free toxin in the stool. How to assess the severity? The criteria for severe Crohn's disease is when the WBC count is more than 15,000, creatinine more than 1.5. These patients, my patient is, if the WBC count was very high, so though creatinine was normal. And fulminant when there is hypotension with shock and ileus and megacolon. Selection of the regime of therapy. When there is non-severe Clostridium difficile, oral fidaxomicin, which is not available in India, or oral vancomycin. The dose is 200 milligram twice daily for 10 days, and vancomycin 125 milligram 4 times daily for 10 days. But it has been found that fidaxomicin is better than oral vancomycin in patients who are aged or immunocompromised, or it is a more toxigenic strain. Metronidazole, when it is not available, fidaxomicin or vancomycin, metronidazole is an alternative. So, and the follow-up stool assay should not be done because it is present in about up to 6 weeks in 50% patients. The initial cure rate with these two drugs, either vancomycin or metronidazole or fidaxomicin, is similar. So none of the other head-to-head trials showed that the superiority of a single antimicrobial therapy. But the recurrence rate is about 10% lower with fidaxomicin when compared to vancomycin. And patients, there is a more toxigenic strain called North American, a NAP1 strain. If it is a non-NAP1, then it has been found that recurrence is 3 times likely to recur when you are treating with vancomycin compared to fidaxomicin. So the guideline that severe and fulminant already mentioned that leukocytosis to the tune of more than 15,000 and creatinine more than or creatinine more than 1.5, and fulminant when there is associated hypotension or intestinal perforation or toxic megacolon. You should do the abdominal imaging and prompt surgical consultation for fulminant C. diff infection. For severe infection, oral vancomycin preferred over both children and adult, and the dose is higher, 500 milligram 4 times daily, and children 10 milligram per kg. If ileus is present, vancomycin can be given parectal also, and early surgical consultation is essential. So even in severe disease, you may think to consider fecal microbial transplant, which I will discuss after some time, and then we may need surgery. Indication of surgery: hypotension, toxic with fever, ileus, peritonitis, altered sensorium, leukocytosis, serum lactate high, admission in ICU, and end organ failure. There is a significant mortality of fulminant C. diff infection. I have already mentioned that recurrence can happen, and the recurrence is defined when there is recurrence of diarrhea within 8 weeks after treatment of initial episode of C. diff infection. and approximately 1/5 of the patient will experience an initial recurrence, and the rates become higher where further recurrence continue to go up significantly after each recurrence. So the first recurrence, the treated with oral fidaxomicin is better than oral vancomycin, but in our country we have to rely on vancomycin only. Sometimes you may think of extended pulse therapy with vancomycin for managing the recurrence. And you may have to think of the antibody, monoclonal antibody, that is basilitoxumab, 10 milligram per kg as a single intravenous dose. Subsequent recurrence, fidaxomicin standard or extended dose, or vancomycin tapered or pulse dose, vancomycin followed by rifampicin some role, and adjunctive basilitoxin, or you have to consider FMT. So what is this basilitoxumab? It is a monoclonal antibody which binds with the toxin B, and it has been approved by FDA in 2016, and the randomized control trial showed that basilitoxumab combined with standard therapy, that lower recurrence rate when 17% versus 28%. So, but at present, still the role of monoclonal antibody to prevent and treat the CDI recurrence is still not yet well established. So, how can there are other therapies like probiotics, whether there is some role. It has been found that certain probiotics combining with these antibiotic therapy as a primary treatment can increases the risk of fungemia. So there is no role of giving probiotics in managing CDI infection. Probiotics, prebiotics, and these toxic neutralizing antibody alone, they do not reduce the primary hospital CDP infection. For patient who had a more relapse, there is some role of CDP immune wheds. That is there is some study that it can be effective, which is the efficacy was similar to metronidazole. The fecal microbial transplant has some definite role in patients who have recurrent infections. The FMT, this is that just transferring the bacteria replacing the bacterial flora by healthy bacterial flora. It can be given either antigrade or retrograde, antigrade orally or by colonoscopy or enema. The efficacy is about 50% of one single therapy of FMT, but if you repeat therapy, the efficacy is more, and 3 or more, the efficacy is 90%. So it is really an effective therapy in patients with recurrent C. diff infection. How we can prevent C. diff infection? The isolating is very important, isolation of the infected person, the patient. Use of full barrier precautions, gowns and gloves while caring the patient, and hand hygiene, very important before and after contact with the patient, and preferably using soap and water, not the alcohol-based sanitizers. That cannot kill the spores of C. diff. So, and the antibiotic stewardship program, that is by restricting the use of antibiotic, antimicrobial, and minimizing the unnecessary antimicrobial, can be an effective in outbreak and non-outbreak setting, and has been found in the data that in Scotland from 1997 to 2012, by maintaining the empiric guideline recommending against the use of fluoroquinolone, clindamycin, cephalosporin, and amoxicillin and clavulanic acid, and approval is required for use of this agent, and susceptibility of this agent not routinely provided to the clinicians. So by which you are restricting. And along with that, hand hygiene campaign has been found to reduce the C. diff infection to the tune of 68%. So primary prevention, I mentioned that by minimizing the antibiotic use, avoiding gastric acid suppression, oral vancomycin, sometimes you have to think empirically in high-risk patients. Secondary prevention, sometimes a patient has, once C. diff improve, you can think of giving oral vancomycin OD for along when the patient is giving, you are giving antibiotic, and it has to be continued for another week. So these are the ways by which you can prevent and control the C. diff infection. So C. diff is a common and challenging clinical problem. Infection control and antibiotic stewardship program in the hospital setting, may probably is effective in reducing the C. diff incidence and community spread. And there is a growing evidence that there is a community-acquired C. diff infection is an important problem, maybe more in gradually when it will be detected. And also there is data in India that it is prevalent. And there is increasing evidence to support that fecal microbial transplant in managing the recurrent and severe C. diff infection. Thank you very much for listening.
Thank you, Dr. Chaudhuri, for excellent presentation. So, I'll start with one question. Fecal microbiota is one of the newest therapy, and I think if we give fecal microbiota through rectal, it works more.
Definitely.
And whether it is used in Kolkata or anywhere in India, I don't know.
It has been used in Kolkata. It has been done by Dr. Chaudhuri is here, Abhijit, and the efficacy that I know that patient has improved significantly, and definitely it is not regularly used. It is not very difficult job, and particularly that it can be done then in two ways. One is autologous, and in the that is usually not done. It is usually from a healthy volunteer. The stool is collected and processed and then transplanted to the patient, and the transplantation process can be done by enema or by colonoscopy. Usually it is by colonoscopy. If it is an extensive disease, and okay, sometimes because it has to work by, it will replace the flora will be changed, and that will, so I think personally I have no experience. But we are treating, as I have told you, that we are treating many of the patients of C. diff. Many patients we don't know the mortality of this severely because of comorbid illness and the patient ICU care, whether the patient is getting fatal because of the C. diff infection or other associated problems, difficult to identify. But definitely sometimes C. diff is severe, and these patients can be salvaged by if there is toxic megacolon fulminant, then you have to consider surgery, but otherwise the fecal microbial transplant is an established therapy. Yeah.
Yeah, in MRI Dhakuria we have used at least in 4 cases.
Okay, so I think that I have, so and what is the efficacy of that?
One severe patient definitely improved.
One patient.
Yeah, definitely improved because having
I told you about one of the patients because I was a part of that patient's management also, but otherwise I have no idea that whether it is being done regularly in other centers like in Apollo by Dr. Goenka or by an SSK, IPGMER. Dr. Chaudhuri can tell us. Abhijit. So, hey, mic down, please. Mic down, mic.
Yes, we at ILDS Shonatpur, we did one, and one of the doctors keeps on telling, he was the donor, and he keeps on telling that I'm ready to give my excreta at any point of time to salvage a patient. And let me tell you, that was a very sinking situation, as I remember, and we were struggling with the patient, and we had told the relatives that things are bad, low albumin, continuous diarrhea, very frail patient, and the patient, it's almost 3 years post FMT, the patient walked out of the hospital and comes back to the doctor in a smiling face. It's really promising if it works. Yeah. It's wonderful if it works, and the best part of it is it's very low cost. But you need to be guarded in selecting your patient. Otherwise, you end up in doing something and not getting as much reward and then getting frustrated. So selection of patient would be very important. Whom to do it? Almost all our modalities have got exhausted, I think one can resort to this with full clarity to the patient's relatives that we are doing something which is still experimental but holds a promise. I think that would be the best approach.
Thank you, sir, for your input. Sir, may I ask a question that whether you use vancomycin only or combine sometime with metrogyl or first line agent you use metrogyl? What is your personal choice and what is the role of rifaximin in management of recurrent C. diff infection?
Actually, the metronidazole role is minimal because it has been found that, but I told you that the head-to-head trial is not there, but for the first treatment, you can select anybody, either vancomycin or fidaxomicin or metronidazole, but regarding the efficacy and recommendation, still the vancomycin oral is the recommended therapy for first line therapy for C. diff infection, and metronidazole sometimes can be given intravenously in severely ill toxic patients in combination. Otherwise, as a first therapy, the combination therapy of metronidazole or vancomycin, or as the vancomycin is available, then you should not treat the patient with only metronidazole.
Shujit, can I ask something?
Yeah.
Now, suppose a patient has got severe urosepsis and on some very good antibiotic, lemurifinum or something, and he unfortunately gets C. diff. So the first dictum is to stop the antibiotic, offending antibiotic, or whatever it might be. So how do you manage such a situation where you have a sepsis unrelated to C. diff and an associated CTAD? So
we face this problem always. Sometimes when you are managing the patients of critically ill, sick patients, that patient is having sepsis along with that superadded C. diff infection. So we have to assess what is the severity of severe infection, very important. And once documented C. diff, that is toxin positive, definitely you have to give vancomycin therapy, oral vancomycin therapy. But if we find that vancomycin therapy, okay, antibiotic use is a precipitants, but concomitant antibiotic therapy, that doesn't alter the severity of the illness of C. diff infection. A fulminant colitis due to C. diff may require intravenous antibiotic other than oral vancomycin, because these patients having bacteremia, having sepsis and toxic megacolon. So if you think that urosepsis has to be treated primarily, then you continue with the meropenem or other sensitive drugs, but you treat for C. diff.
Can you enlighten us, what is the current recommendation regarding the high-risk asymptomatic patients for screening and prophylactic treatment with antibiotics? Is there any recommendation?
Actually, definitely, when the patient is not symptomatic, I think that we should take all the care for preventing the C. diff transmission. That is the most important, because when a patient is discharged from the hospital, it is implied that some of the patients are carrying this bacteria in their colon. Because there has been by the hospital acquired infection has happened. But I think by giving some prophylactic therapy to prevent the community transmission or transmission from the patient to others, at least that is not yet been established, that is not recommended.
So if there is no question, may I conclude the session?
Have to. Okay. Thank you very much. Okay.
Thank you, sir.
Thank you very much, sir. With this, we shall proceed to our second session, approach to small bowel diarrhea. May I request the chairpersons to please be on the stage. I would request Dr. Abhijit Bhattacharya, consultant physician attached with the MRI group of hospitals. Sir, please come on the stage. Dr. Shubhobroto Ganguly, consultant gastroenterologist attached with Spondon group of hospitals. Dr. Trombok Shamunto, consultant gastroenterologist and associate professor, Kolkata Medical College. Dr. Kisholay Sharma, consultant gastroenterologist attached with IILDS group of hospitals. Dr. Ognibho Dotto, consultant gastroenterologist attached with AMRI Salt Lake, Kolkata. The speaker is Dr. Mohan Ramchandani.
So in the second session, it's a very interesting topic, small bowel diarrhea, how to approach it. We know it's the fundamental topic of luminal gastroenterology, and I am inviting Dr. Mohan Ramchandani. We know him He has a vast experience in the field of gastroenterology. Over 20 years, he has around 200 international publications, and he is the director of interventional gastroenterology, AIG Hyderabad. So, sir, please.
Thank you. At the outset, I thank Dr. Sujit for giving me this opportunity. And as has been pointed out, it's a very basic topic and has been prepared to cater all the physicians who day in, day out deal with these problems. So diarrhea actually can be, as we see, is a common problem and has been defined by patient and physician. The patient says that there is an increase in the stool volume, decreased consistency, or increased frequency. But most of the time we depend on the definition of chronic diarrhea, that is the persistence of alteration in the form of the stool, and the alteration in the form of the stool has been shown by the Bristol score, and majority of the time patient will say it's between the 5 and 7, and this is the most commonly taken definition when they say that there is a decrease in the stool consistency. But coming back to the small bowel, and we know that how a small bowel is very important. A small bowel gets around 10 liters of fluid daily from the stomach and the duodenum, and almost 6 liters is absorbed in the jejunum and rest 2.5 liter in the ileum, and it gives only 1.5 liter to the colon. Colon subsequently absorbs around 1.4 liter of the fluid and give only 1.1 liter. So you see how efficient the water absorption is there in our gut. It's 99% absorbed. And even if there is a reduction of this efficacy by 1%, it will lead to massive diarrhea. So this is how the system is closely coordinated. And that is what we want to learn about the approach to the diarrhea. So once we see a diarrhea, we have to define where is the diarrhea originating from, whether it is from the small bowel, from the colon, whether it's inflammatory, whether it is infectious, what it is. So we'll ask patients, what is your problem? First of all, as I told, is there any diarrhea that we saw the definition? Whether it's acute or chronic, anything lasting for more than 4 weeks is chronic, and our diagnostic algorithm changes. Whether it's functional or organic, depending upon the alarm symptoms, weight loss, blood in stools, we have to see. Whether it's a large bowel or a small bowel, that is the most important question of today's topic. And the volume, content of the stool, and as I show, small intestine is a place where absorption takes place. And anything abnormal in a small bowel will be associated with malabsorption. So association of the malabsorption is very important. And the small bowel is a very tubular organ. Anything wrong there, inflammatory strictures or narrowings associated with diarrhea will be associated with pain. So we have to decide whether this diarrhea is painful or not painful. And also the bleeding, as I said, it can be associated with bleeding. So if we have all these answers, we will be able to pinpoint to one particular diagnosis. And of course, these diseases which are systemic in nature will be associated with some physical findings. So let's start to understand the chronic diarrhea which are associated with small intestine. And these are many areas which we have to see. There are causes which are very common, including the most common cause which we see in diarrhea in clinical practice is irritable bowel syndrome. Fortunately, there is no long-term consequences of that, but there is a significant morbidity associated with that. But majority of the disease are related to the colon. But we are also discussing about the small intestine and some of the disorders like Crohn's disease, celiac disease, lymphomas, other infections like giardiasis, small bowel enteropathies. These are limited to the small intestine, and we have to pinpoint these causes. And as soon as patient arrive to us, we have to think about whether it is originating from small intestine or not. And as we all know, the rectosigmoid function as reservoir, while the small bowel works as an absorptive area. So if there is anything wrong in rectosigmoid, that means there is a reservoir deficiency or reservoir defect. And this will lead to anything compromised by inflammatory or problematic over there in the left colon will be associated with increased frequency but small volume. While anything wrong in small intestine will be associated with large volume but less frequency. And that is how we clearly define the large volume, large versus small volume. As soon as patient come to us, we will ask him whether the volume is large or small, whether you go for too many times for bath motions, they all suggest that it's a large bowel. As I said, large bowel is a reservoir, while small bowel is absorptive. So volume will be high in small bowel, while frequency will be high in large bowel. But there is no airtight compartment there. There are diseases which can affect both small intestine as well as large intestine, like Crohn's, tuberculosis, amyloidosis. But those which are decisive about those symptoms which are decisive that the pathology lies in colon is bloody diarrhea. If there is a bloody diarrhea, if there is tenesmus, urgency, they are decisive that the disease lies in large bowel. While if there is associated deficiencies like vitamin deficiencies, you must make sure that you are dealing with a small intestinal disorder. And whenever there is a small intestine problem leading to diarrhea, we have to think whether there is associated malabsorption or not. If there is a malabsorption, that there are many diseases which can give rise to celiac, which can give rise to diarrhea, but simultaneously malabsorption, like celiac disease, tropical sprue. In fact, a recent study from India said that most common cause of small bowel diarrhea is tropical sprue, followed by parasitic infestation and tuberculosis. And these are associated with malabsorption because they affect the lining of the small intestine. And then there can be associated malabsorption. But certain disorders like bowel resections leading to bile acid diarrheas, they are not associated with malabsorption. So one has to take lot of pain, or the more meticulous history is very important. C for malabsorption. Whenever there is a small bowel diarrhea, C for malabsorption. Whether there is a steatorrhea, whether he is passing bulky, malodorous or pale stools. While those patients who have pure small bowel diarrhea, which are inflammatory in nature, will not have steatorrhea, they will have a liquid stools with sometimes blood or mucus. That is why these meticulous trees are important. One has to think about whether there is an end organ, and whatever the malabsorption is happening, is it leading to loss of visceral or somatic protein, whether there is loss of body fat, there is associated steatorrhea. So once these symptoms are seen all together, we can zero down to a problem that the disease is originating from small bowel, the disease has associated malabsorption. Then we will think further. Then also one has to think about pain. If this diarrhea is painful or not. If there is a diarrhea which is painful, that means there is associated strictures of the small intestine like tuberculosis or Crohn's disease, or there can be an organ which is away from bowel, similar appearing, but that like chronic pancreatitis leading to malabsorption syndrome. While the painless diarrhea like sprue, there is a blunting of the villi, there is decreased surface area for absorption, there is no stricture, there is no inflammation. These patients will have diarrhea but no pain, like celiac sprue, tropical sprue, giardiasis, lymphangiectasia. So these are the way we will able to more zero down to our pathology. Whether there is a bleeding or not is also important. If there is no blood, that means these are the disorders who will have like celiac, tropical sprue or giardiasis, while inflammatory disorders like IBD and tuberculosis may have some bleeding in the stool. And as I said, this may not be limited to small bowel, but extending to the colon also. One should do a good general physical examination. Must see muscle wasting, or there are some cutaneous manifestation of the diarrheal disease, like some of the rare neuroendocrine tumors, glucagonoma leading to migratory necrotizing erythema, or inflammatory bowel disease like erythema nodosum or pyoderma gangrenosum. You can have palpable purpura like in Hinochiolin purpura, or there can be a vasculitis associated with that. There are diseases like amyloidosis, which may present as pinch purpura, or celiac disease who will have a dermatitis herpetiformis, or patient with hyperthyroidism, simple hyperthyroidism will have tremors or a lid lag. So this is very, very important to have a good history, pinpointing basically whether there is associated malabsorption, whether the diarrhea is painful or painless, whether there is associated blood, and what is the physical examination. Once you are done with this, you will be able to say whether you are dealing with a diarrhea which is irritable bowel syndrome type or it is a pathology type. So alarm symptoms. So that will be taken by this, whether there is a examination which gave you abnormal finding, whether you have done the normal CBC, the ESRs, CRP, the celiac serology. If these are negative and patient does not have any alarm symptoms, that means this is just an irritable bowel syndrome. While if there are something problem over there like weight loss, nocturnal features of diarrhea, decreased hemoglobin, high ESR, you should start thinking to go more detail of the examination part. And you should start with these 4 or 5 tests which are based on stool analysis. And these are very important. First, you should do fecal calprotectin. And this is a small test which can be done in any lab. Stool osmotic gap, that means you have to calculate sodium and potassium in the stool and see. Stool pH and the stool fat content and occult blood testing. I'll come to them. These are very important tests. Once you have seen that patient has not a functional disorder, it is an organic pathology. Now we have to classify what type of organic pathology. Then, as I said, fecal calprotectin. If it is more than 250, you must say that there is an ongoing inflammation. While if it is less than 50, you can be rest assured there is no inflammation. And this fecal calprotectin is much better as compared to C-reactive protein or stool lactoferrin in identifying ongoing inflammation. So if you find a fecal calprotectin more than 250, you should start thinking about inflammatory bowel disorders. Then come to the stool sodium potassium. Now if you have a stool sodium potassium and if there is a disease which is affecting small intestine and causing it to secrete electrolytes, like here, secretory diarrhea, the stool is full of electrolytes. That means this sodium potassium will be high. So once you subtract the stool osmolarity from the plasma osmolarity, this will be less. So any diarrhea which is being caused by a irritant, or say for example that is leading to secretion of osmotic the electrolytes, the osmolarity will be less. So if there is a value of osmotic gap, which is very simple to calculate, if it is less than 50, that means the stool osmolarity is high, that means it is a secretory diarrhea. It is very important. I'll talk to you about that. While if there is a patient is taking, say for example, artificial sweeteners, or there can be a drug which can cause no electrolyte in the stool, but retention of water. The patient has diarrhea, but there are no electrolytes in the stool. The osmotic gap will be very high. So that will be a very high osmotic gap. So if you can, by mere seeing the stool electrolytes, you will say that this is a secretory diarrhea or is an osmotic diarrhea. That is very important. Then comes the fat content. That also is very important. However, the quantitative estimation is very cumbersome and people won't do that. The qualitative Sudan staining is also can be done. But if patient has real steatorrhea, you have to do 24 to 48 hour stool sample test. And if the stool is more than 14 grams per day, that strongly suggests fat malabsorption. So that is one. Fecal calprotectin, osmotic gap, stool fat content. Then pH. If there is a carbohydrate malabsorption, there is fermentation leading to low pH. So if the pH falls below 6, that indicates there is a carbohydrate malabsorption. So these are very simple stool tests. Fecal or occult blood testing. Again, if you have occult blood testing, of course there can be malignancy or inflammatory disorder, but 50% of patients with celiac disease will also have fecal occult blood test positive or even a sprue. So fecal occult blood test is very, very important. So these are the 4 tests which can be done on stool: calprotectin, osmotic gap, fecal fat, and the pH and occult blood. So these are the 4 or 5 tests which you have to see once you have decided this patient is not functional, it is some organic diarrhea. These are the 4 or 5 tests which will allow us to pinpoint the diagnosis. Also, D-xylulose test, which was done more commonly in previously but not now, but it is a very important test to say that the fat malabsorption is because of either malabsorption, that is mucosal abnormality, versus maldigestion, that is deficiencies of enzymes like pancreatic enzyme. I'll not go into the detail. Now, once you are ready with all the tests, you are now pinpointing the diarrhea into either inflammatory, fatty, or watery. So these 3 disorders are there. So we'll come back to one by one. And the inflammatory disorders are the common disorder where we have a high fecal calprotectin. Once we have high fecal calprotectin, we'll go to the inflammatory. If we have high fecal fat, we'll go to the fat malabsorption. While others problem where there will be nothing, like the watery diarrhea. Now these watery diarrhea, as I said, are either secretory or osmotic. Now secretory diarrhea, as I said, are because of non-inflammation and non-fatty. The watery diarrhea is a loose stool that does not contain either leukocytes, there is no lactoferrin, there is no calprotectin, no blood, and just no elevation of fecal fat. So secretory diarrhea is caused by reduced water absorption and results in very high stool volumes. And symptoms persist at night, and they also persist while fasting. While similar appearing watery diarrhea can be osmotic diarrhea, that is caused by water retention in the intestine. As I said, stool osmolarity, sodium, potassium. There will be no electrolytes in the stool, but the water retention is caused by poorly absorbed solutes like artificial sweeteners, as I said. So it is very important for us to understand whenever a patient comes to us as for a watery diarrhea, whether it's an osmotic diarrhea or a secretory diarrhea. If the secretory diarrhea, as I said, the volume will be very high, there will be no response to fasting, there will be very high stool electrolytes, and then the osmotic gap will be less. While osmotic diarrhea, their stool volume will be moderate, but also once you stop the offending agents, diarrhea stops. There are a lot of, there's no electrolyte in the stool, the stool sodium will be very less. So that is how we distinguish between osmotic and secretory diarrhea. Also, we have to understand that, I'll take 5 minutes. Huh? Okay. So that is how we have to approach. As I said, the secretory diarrhea, one has to exclude the infections, and also the small intestine can be seen by capsule endoscopy, CT, and small bowel disorder. So what we have seen now with these 3 new modalities, small bowel examination by enteroscopy, capsule endoscopy, and MR enterography, these have changed the paradigm. These have changed the way which we see the small intestine. The small intestine can be seen by enteroscopy, by balloon-assisted or spiral. We are now doing spiral enteroscopy a lot, and that has changed how we can travel throughout the intestine. And this is one example where patient came to us with diarrhea, and you can see a large transverse ulcers. This is tuberculosis. While patients who have diarrhea and they have cobblestoning, there is a longitudinal ulcers, there is edema. This is Crohn's disease. And then mere by morphology you can see there, these are the longitudinal ulcers over there. We saw one patient recently who came to us with arthritis and loose stools, and this whole small intestine was shaggy, mucosa, whitish mucosa. The biopsy was taken, which has shown past positive inclusion bodies and foamy macrophages. This is Whipple's disease, very rare, but can be checked by taking small intestine biopsies. This patient who had ulcerative colitis like small intestine picture, he was on steroids and has come to us with loose stools, watery diarrhea, weight loss, and simple biopsy from the small intestine shown strongyloidosis. These patients respond very well to the ivermectin, and the patient was absolutely all right. This patient who had a chronic renal failure, patient presented to diarrhea, there was ulceration, there was nodularity, and this came out to be amyloidosis. So this is the help of the small intestinal biopsy which we take, and then can be diagnosed a disease with generalized mucosal abnormalities like these patients with, I showed Whipple's disease, amyloidosis, Crohn's disease. So these are the examples of the small intestine disorders which can be taken proper biopsies from the targeted site. It is very difficult to do small intestinal endoscopy as compared to the endoscopy of upper bowel, because there is the small bowel is a freely hanging peritoneal structure. You have to use one device to go inside the small intestine, because if you push, it will not be pushed, it will get looped, and that is why we use a device assisted. So diarrhea from small intestine, I will say that to conclusion that it is a common problem, but most of the causes are non-infectious. Most of the time we see either celiac or Crohn's disease. The thorough history taking and clinical examination is pivotal. Basic laboratory tests are very important to distinguish between inflammatory or secretory or osmotic diarrheas. Colonoscopy should be done initially, but you may require to do biopsy from the duodenum or take the help of enteroscopy. Most common diagnosis patient in our clinical practice still remain to be IBS, but there are certain features, as I said, on the history and physical examination, which will tell us that it is not IBS, and you need to do a thorough examination in the form of stool test, other enteroscopy or capsule endoscopy examination to pinpoint the diagnosis. And treating the underlying cause is the mainstay of the treatment, and majority of the patients can be treated by the algorithm which I have provided. Thank you very much for your patience here.
Thank you, Dr. Ramchandani, for a very lucid presentation. Can I just start by asking a couple of questions? In your practice, what are the common red flag signs you notice for in chronic diarrhea? You have all seen the algorithm. It's a very elaborate thing. So just common red flag signs.
I will say that if patient has a weight loss, nocturnal diarrhea, blood in stool, abdominal pain, these are some of the findings which I will say that once patient comes to me, I will start thinking about organic diarrhea rather than a functional diarrhea. And also the basic examination like CBP, low hemoglobin, high ESR, high CRP, and also now we are doing fecal calprotectin as a flag sign where we can say that this is an inflammatory disorder or this is an irritable bowel syndrome. So these are the 4 or 5 things which I do quickly in my clinic to say whether it's organic diarrhea or not.
And coming to fecal calprotectin, is there any role of fecal calprotectin assessing the disease activity instead of subjecting a patient to repeated colonoscopy?
Yes, it has been shown that if the patient is on Crohn's disease and on the maintenance treatment, and if the calprotectin can be used as a surrogate marker for a mucosal healing.
Thank you.
Good morning, sir. Sir, I have one question. Sir, we all know biliacid diarrhea is being increasingly recognized as a common cause of diarrhea, and in fact, 1/3 of IBS-D patients are said to have biliacid malabsorption. So now we all know biliacid undergoes enterohepatic circulation from the terminal ileum. So if a patient has obvious predisposing condition like an ileal Crohn's or TB or resection, we can suspect that biliacid malabsorption may be the cause. But in those patients who do not have any obvious predisposition to bile acid malabsorption, so how to suspect that bile acid malabsorption will be the cause of diarrhea? And sir, at your center, do you use any tests to establish that the patient has bile acid malabsorption?
I think there are some tests available but not done in our country. But I think, as you rightly said, bile acid diarrhea should be thought about once there is a predisposing condition, like ileal resection. If there is too much of ileal resection or less ileal resection, more than 100 centimeter, less than 100 centimeter. If it is less than 100 centimeter, it is because of bile acid. While it is more than 100 centimeter, it can be because of the fatty acid, because bile acid is deficient and the fatty acids are more. And then we can use some bile acid binding agents as a marker, whether the patient is responding or not. But the sophisticated tests like some nuclear tests are not available, but they are done in the West, but not in India. I have not seen that done.
One more question, sir. For this small intestinal bacterial overgrowth, these hydrogen breath tests are being increasingly used nowadays. But most of the conditions that predispose to SIBO, like resection or diabetes or chronic pancreatitis, they themselves cause altered motility of the small gut.
Yes.
And one of the most important causes of false positivity of the breath test is the rapid transit.
Yeah.
So, sir, at your center, you're doing motility studies in all the patients for the breath test, or you just go for the breath test?
No, we are not. We are doing breath test, but we know that the sensitivity and specificity of breath test is around 70%. But it's very cumbersome to do a motility test first and then followed by the breath test. But we are depending on more of clinical and breath test. But we know the limitation of breath test. Of course, what you have pointed out is absolutely right, that breath test cannot be taken as a standalone test for SIBO. That's very nice, yes.
Sir, I am from the pediatric background. We have cases of congenital diarrheas which are very difficult to work. Do you have any facilities in your institute, add-on facilities to work those there?
I don't think so. We don't have those pediatric, as you said, we are not having that much.
The structural disease and the
very
transport.
rare and difficult to establish a program unless it is a very high-end tertiary pediatric gastroenterology department.
Sir, one question. In your institution, what is the most common cause of chronic small bowel diarrhea with malabsorption syndrome?
I think celiac still is there, and also the Crohn's disease is one which can be. But I think with malabsorption, celiac and also tropical sprue, both.
What is the trend of tropical sprue?
I mean that we see blunting of the villi, but TTG is negative. Vitamin B12 is low, folic acid low. So we start treating with these, suspecting as tropical sprue, and they respond very well to the supplementation and also the rifabutin. Also we give that.
Also.
Yeah. So that got tremendous response. But still, I will say that celiac disease is one of the common. But we get a lot of reference from the North India. The celiac is not very common in South India.
So is there any question from the house? So then we can conclude the session. Thank you.
Thank you.
Thank you. Thank you very much, sir. With that, we shall proceed to our next session, Management of Critically Ill Cirrhotics by Dr. Dharmesh Kapoor. May I please request Dr. Sanjay Banerjee, Consultant Gastroenterologist attached with the ILS Hospital, Kolkata, to please chair the session. I would also request Dr. Shashwata Chatterjee, Consultant Hepatologist attached with CMRI Hospital, to chair the session.
Good morning, everybody. Now we are switching gear from gastroenterology to hepatology and specifically critical care hepatology. And we have with us Dr. Dharmesh Kapoor from Hyderabad. I think he's one of the finest hepatologists of this country. Dr. Kapoor is presently senior consultant at Yashoda Hospital, Secunderabad. And he is one of the finest hepatologists, as I said, dedicated to clinical hepatology as well as research. He is an academician with more than 50 publications. He is a member of ISG, INSL, and ISG. Dr. Kapoor will take us to how to manage a critically ill cirrhotics in our day-to-day practice. Professor Kapoor, please.
Good morning. Thank you so much for that introduction, and gratitude to Dr. Sujit for this invite. We've been a member of this meeting for the last couple of years, but I think we are meeting in person after a long time. So without much ado, my task is to talk about a critically ill cirrhotic in the liver intensive care. So we are all aware of these definitions which were given about 3 decades ago: the systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. So this is basically the response of the host to either an infectious or a non-infectious agent, and results in a number of physiological and pathological changes which culminate into organ dysfunction. Organ dysfunction spills over from one to other organs in the body, leads to hypotension, which cannot be resuscitated with the just fluid therapy and vasopressors, and then leads to a state of shock and refractory shock. Now these particular events of the SIRS syndrome, or the pointers towards the SIRS syndrome, they have potential pitfalls in the cirrhotic population who've got an altered thermoregulation. At times they would be on beta blockers and you might not get the desired heart rate to diagnose SIRS. At times they are tachypneic. In fact, most of the decompensated cirrhotic patients are tachypneic, and you therefore might have a lower PCO2 than normal. And then at times if they are encephalopathic, again this particular pointer does not diagnose the SIRS syndrome for you. And due to hypersplenism and a host of other reasons, they might not have white cell counts in sync with the infectious agent. So these are the potential pitfalls in the earlier definition. Now, more recently, sepsis has been defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So the same infectious agent in different people might lead to a different response, and hence the host response to this particular agent, which is either microbiologically proven or just a putative agent, is termed as sepsis. When this leads to an organ dysfunction, and it could be one or more, we call this this particular syndrome as what we are calling severe sepsis in the erstwhile definition. But now there is a quantitative tool to assess the number of organs affected and the degree to which these organs are affected. And in the new definition of septic shock, it's not just the use of fluids and vasopressors, but also a lactate level which is greater than 2 millimoles per liter or 18 milligrams per deciliter. So these are the changes from the erstwhile definition. Now, how do we diagnose this? So the most important thing is to pick up in the community somebody who needs to be on your radar. So rather than the SIRS, we have switched to the quick SOFA. Quick SOFA is defined as a respiratory rate of more than 22, altered mentation, you could do it by the GCS or any other tool like the 4 score, systolic blood pressure less than equal to 100 millimeters of mercury. If 2 or more of the criteria in the quick SOFA are positive, then you take this patient either to a high dependency unit or at least keep him under your radar to see whether this patient would need to be triaged and then taken to the intensive care. This particular score was given almost less than 3 decades ago by Jolie Vincent, and this is what we have now transformed into the Cliff SOFA score. So the human body is divided into various organs, which is the cardiovascular system, the respiratory system, the coagulation system, the central nervous system, kidneys and liver. So these 6 organ systems define the organ dysfunction syndrome, and whenever we are prognosticating our patients in the liver intensive care or in the general ICU, it's always a good idea to talk to the next of kin about the number of organs which have been knocked out, whether these are being supported medically or whether there is a need for organ support, and each of these steps is going to define the mortality for a given patient. Please remember, greater the number of organ failure scores, greater is the mortality. So in the general intensive care, the mortality of patients who get admitted with severe sepsis or septic shock, there is a mortality of about 25 to 30%. In cirrhotic patients who get admitted to the critical care unit or liver intensive care, you could peg it up by another 10 to 12%. In fact, some large series have shown that if 100 patients get admitted to the liver intensive care, there would be more non-survivors than survivors out of hospitalization. I'll repeat that. There will be more non-survivors than survivors out of hospital. So what this basically means is that you might be able to get the patient out of the intensive care, maybe to a step down unit or to the floors, but this patient comes right back into the intensive care again. And therefore the net number of patients who would actually be discharged from the hospital would be fewer than those who are actually able to be discharged to the community or the hospice. So the mortality of the sepsis in or septic, severe sepsis and septic shock in the cirrhotic patients is extraordinarily high. So what the new score tells you is that the baseline SOFA, if somebody comes from the community 0, if there is an increase in the SOFA score by 2 or more, then you say that this patient has got organ dysfunction and this patient patient needs to be under your constant observation. Has this particular score been used in the cirrhotic population? Yes, this was a publication which came about 5 years ago from the University of Padua. So you can see that those patients who have got the quick SOFA as well as the sepsis 3 definition, that means from baseline there was an increment in the SOFA score by 2, they have got the highest mortality. Again, for the sake of this audience, it makes good sense to classify our patients whether they come from the community, which is community acquired infections, or patients who have been coming to the hospital, say for a large volume paracentesis, say for albumin, say for antimicrobials. So these will all lead to the healthcare associated infections. And the third one are those who have got negative cultures at the time of admission and in the next 48 hours and then start to show signs of sepsis. So those would be hospital acquired. So it always makes good sense to divide your patients into community acquired, healthcare associated and hospital acquired infections. In this particular study, all three the patient cohorts accounted for about 30% or so of the infections. The gram positives and gram negatives are an equal number, again which is slightly different from the general community, where gram negative scores over gram positive. You get a fair amount of fungal infections in this cohort because they are subjected to antimicrobial therapy time and again, and the mortality within the ICU in the first few days is almost 1 out of 5. So we are dealing with a very, very serious problem. Now, the classification of CA, HCA and HA also allows you for an empiric antibiotic plan for these patients. So when we have a patient who walks into the ICU, these are the various things that you should do. So we are all aware that there is something called fluid resuscitation, and I will talk about this in a little bit more detail in subsequent slides. Use of vasopressors as well as inotropes, monitoring devices, how invasive do you want to go. So the surveillance cultures must be taken in each and every patient, and you should try to sample everything that you possibly can. So it would be blood, urine, ascites. If there are chest shadows, then you would want to do the sputum analysis. And if you have an altered mentation and it's not fitting into the classic syndrome of hepatic encephalopathy, then you might want to neuroimage them sooner, or you might want to do a CSF analysis also. We still go for a number of erstwhile tests to diagnose fungal infections. There is a huge explosion of knowledge based on the nucleic acid testing in these patients, MALDI, TOF, the NA80s, and so on and so forth. You should have a low threshold for imaging if you think that there is a source control that is needed to control the sepsis. So oftentimes you might have some physical signs which tell you that this patient would need source control, and in those situations a cross-sectional imaging is helpful. You might not always get your answers through a bedside ultrasound. And empiric antimicrobial therapy, the same principles of the golden hour hold true for the cirrhotic patients also. Greater the time from stepping into your ICU or into the ER and the first appropriate antibiotic, higher is the mortality. And this is even more than the general ICU population. So it's extremely important to classify your patients into CA, HCA, HA, and then choose whether you would want a step up or a step down approach. So empiric antimicrobials should not be given for a period of more than 3 to 5 days. So you do the surveillance cultures and then be guided by the antimicrograms, and antibiotics generally for 7, 10, 14 days depending on whether this infection was acquired in the hospital, whether stage the source control has been adequately achieved or not. The longer duration of antimicrobials is generally needed when the source is still active. So if you are not able to see an improvement in the mentation, improvement in hemodynamics, improvement in the urine output and the glycemic status, white cell count, inflammatory markers, so on and so forth, then again revisit the diagnosis and see whether you want to image this patient. Low threshold for initiating empiric antifungal therapy. The selective decontamination of the gut has not been shown to be uniformly helpful, though in patients who have ventilatory associated pneumonia there is some role. Get the culprit device out. At times it's easier said than done, but the central venous catheters, Foley's catheters, so on and so forth should be out. At times you can have very challenging situations when patients develop endotipsitis, and then in the interest of antimicrobial stewardship, you should de-escalate antimicrobials quickly. Again, very, very relevant point. Oftentimes some units are guilty of continuing to manage their patients in spite of futile ICU care. So please remember that it comes at a huge cost, and that is antimicrobial resistance in the other patients in your unit is also going to deteriorate. If you have patients with MDR bugs in your unit who are probably not going to make it, but still you continue to nurse them or support them in your intensive care. So futile ICU care is a huge component of liver intensive care. These are the commonly used antimicrobials, and I would skip this slide in the interest of time. So coming to fluid therapy, so all of these have been used in the cirrhotic population as also in the general population. The basis of fluid therapy still remains crystalloids for us. You can use normal saline, and there is nothing abnormal in that, in spite of the literature which would tell you to the contrary. So if you have to give your patient small volumes of fluid, then there is no difference between 0.9% saline and a balanced salt solution. In our country, fortunately, the cost difference between the balanced salt situation and 0.9% saline is not huge. In the Western world it is, and therefore if you have got to give a lot of volume to a patient, then of course the balanced salt solution makes sense. We are no longer using gelatins, dextrins, starch, so on and so forth, but albumin has again caught the fancy of the hepatology world. So we know that albumin is evidence-based in few situations in the cirrhotic population, namely patients who have got spontaneous bacterial peritonitis with adverse measures, patients with the post-paracentesis circulatory dysfunction, or to prevent that, those who have developed an HRS AKI. So these three are evidence-based. Everything else we are using empirically, but there is not robust evidence in literature to use albumin. Two recent studies, so let's first talk historically of these three landmark trials in the non-cirrhotic population. All these trials showed that albumin was not better than the other resuscitation fluids to manage patients who present either with sepsis-associated hypotension or with septic shock. Only in the AIRS trial, the one which you see right in the center, there was all patients with septic shock, but other patients only had severe sepsis or sepsis-associated hypotension. So there was no difference between albumin and crystalloids. But two things stood out in all these studies. Those who had got septic shock, their albumin was marginally better than the balanced salt solution or 0.9% saline, and those who had traumatic brain injury, albumin was inferior. So these two are points of caution whether you practice hepatology or not. Also, you have to be very cognizant of the fact that if somebody has got leaky capillaries, which is not uncommon, those who have got acute lung injury in the setting of sepsis or severe sepsis, you should be a little careful in using albumin. Two recent studies came from our country. One was the use of 5% albumin against 0.9% saline in patients with sepsis-induced hypotension, and these were studies from ILBS in Delhi. There are serious challenges with both these studies, but both these studies showed that 5% albumin and 20% albumin could be used in a proportion of these patients. So it was seen that patients who were resuscitated with 5% albumin, and they were better, though the survival difference was not very different. And similar results were seen even in an intention to treat or per protocol analysis in patients who were treated with 20% albumin resuscitation. Now the challenges with these two studies, in the interest of time, is that what we have learned from the general critical care literature is that the standard paradigm of using 30 mils per kg of fluid to resuscitate no longer holds true. The amount of fluid that you need to resuscitate a patient who's having hemodynamic compromise is much lower. There is also a leaning towards an early use of inotropes. So that makes perfect sense. If you continue to resuscitate your patients just with fluids, you know, as it is, patients with cirrhosis, with hyperdynamic circulation, that might be in any other syndrome also, would have got an endothelial dysfunction right to start off with. And therefore, when you give these patients huge amount of fluids, they are likely to seep it into the interstitium, and you might find that the patient's anasarca might worsen, he might develop pulmonary edema, or he might even be difficult to ventilate if such a patient is on mechanical ventilator. So the caution is, give less fluids. Less is more. Start inotropes early, and then you would be able to wean off your patients quickly. What about the pressors and inotropes? So most of the times we are using pressors in the hepatology practice, and the drug of choice is noradrenaline. So as just a leaf from the earlier slide, you use less amount of fluids and start noradrenaline or norepinephrine early. You can start with a dose of 0.05 mics per kg per minute and gradually escalate to get a mean arterial pressure of more than 65. Now again, this is not sacrosanct. If somebody was having hypertension at baseline, then the map that they would need following resuscitation would also be slightly higher. We hardly ever use adrenaline. I use adrenaline only in the pediatric practice. Vasopressin or terlipressin, its analog, something that we are all very familiar with, should also be used early. It's got a completely different mechanism of action from norepinephrine because it acts on the V1 receptors. Also, it has got a catecholamine sparing effect. So please remember, catecholamines can produce arrhythmias, catecholamines can produce tissue hyperperfusion, and catecholamines can produce hyperlactatemia. And all these things are very important when we monitor these patients. So it's extremely important to have a catecholamine sparing effect, which we are easily able to do when we start terlipressin slightly early in these patients. Dobutamine, very poorly studied pressure, a very poorly studied inotrope in the cirrhotic population, because these patients are hemodynamically, their prototype is that they've got very low diastolic pressures, and we know that dobutamine further lowers the diastolic pressure, and therefore it has been sparingly used. But I think there is something to watch out in the dobutamine space. We probably need to go back to the drawing board and see how we could have a mix of the three drugs so as to optimize the vasopressor inotropic support in these patients, because the ultimate aim is to increase the delivery of oxygen to the tissues and for the tissues to be able to uptake that oxygen. So oftentimes we lose track of that. So we are only focused on the monitor which is hanging on the head of the patient, and we keep looking at the arterial trace, keep looking at the mean arterial pressure without realizing why we want that mean arterial pressure. So that mean arterial pressure is needed so that the tissues would get adequate oxygen for their metabolic needs, the tissue perfusion is good, the CO2 washout is good, and therefore the end organ dysfunction does not set in. So MAP and lactates can have a dissociation. So it's not as if to say that you start with a MAP of 50, you have been able to achieve a MAP of 65, and that the lactate will also fall from 4 to 2. Now that depends on how the tissues are metabolizing. So how do we monitor? So it could be very invasive in a patient who's very sick or who's undergoing transplant or who's shifted from another unit, at times also in the setting of acute liver failure when we are considering these patients for transplant. But the standard would be to have at least a central venous line in these patients, an arterial pressure line for these patients, measure urine output on a continuous basis in a patient who's encephalopathic. Otherwise, one would not want to put a urinary catheter in these patients. You could go either with the SVO2s or SCVO2s or lactate clearance. All three are equally good or equally bad, provided you know the pitfalls which each one of them has. In a patient who's mechanically ventilated, you could use the pulse contour analysis, and you could have a flow track in place, which is what we use most commonly. We have now gone away from the times of PICO as well as pulmonary artery catheters. And again, there is a renewed interest in studying microcirculation, something like a capillary refill time. We are not doing it, and we are not teaching the next generation also. It is an insanely sensitive and an excellent test to see what the tissue perfusion is like. So you just do the capillary refill time on your given patient who's in the ICU, and you will have a very good idea of what is going on in the microcirculation. So this is an algorithm for the hemodynamic management. First step is using crystalloids. You could use 0.9% saline, or you could use a balanced salt solution with a mix of 5% albumin. 20% albumin might not be a great drug to use in just for resuscitation. Like I said, you start using the inotropes early. The role of the pressors in this particular cohort is still not very well defined, but the endpoints of resuscitation remain pretty much the same. So you should have an elevation of the SCVO2, you should have a declining lactates, improving mentation, improving inflammatory markers, improving white cell count, improving urine output, improving glycemic control, and most importantly, and something that we never talk about and never teach, that is return of the intestinal function. So that's extremely important in the sick patients. So just someone develops ileus and he's got background cirrhosis, that itself is a good enough sign to tell you that this patient is not. So this is how we would manage these patients. Renal replacement therapy, just like in acute liver failure, more often than not, you might need it for the non-renal reasons. That means just for the middle molecules, the cytokines, so on and so forth. These patients, unlike acute liver failure, do not have a very high rate of filter clotting, but still you might need some anticoagulation in these patients. Some patients, some units are daring enough to use citrate in this setting. You can have the other agents also, which I would briefly mention about. What about the bleeding in critically ill cirrhotic patients? Again, it should be addressed either as a portal hypertensive bleed or bleed because of the stress of the intensive care admission. So it's very important to distinguish between the two. Don't transfuse these patients empirically. because many of them would have significant portal hypertension, and portal hypertension only worsens when you give transfusion products to these patients. So we must be able to distinguish between the minor bleeds and major bleeds, and only major bleeds would need your attention. And again, point of care testing like the ROTEM or the TEG would come to your rescue to decide what should be the triggers for transfusion. Now, there is a recent publication from GB Pant about use of IV LOLA, which is L-ornithine L-aspartate. Again, this was an unselected cohort of patients with advanced hepatic encephalopathy, but I bring this slide here because about a quarter of patients also had an underlying sepsis. And these authors could show that if you use IV LOLA 30 grams per day for a period of 5 days, there was a better improvement in the hepatic encephalopathy scale in these patients. And there was, but however, there was no difference in mortality compared to those who were treated with the standard medical management. So the things which would be of interest to the critical care colleagues would be the use of the timing of the hemofiltration or hemodiafiltration, the dose of hemofiltration, hemodiafiltration, and the adsorbent based therapies, which again have caught the fancy of many workers in many units in some parts of our country also. So you can have the tobramycin coated cartridges, you could have cytosorb which adsorbs the cytokines, and you could have the oxyrase from the Baxter platform which adsorbs both the endotoxins as well as cytokines. And these other components including nutrition are extremely important in your day-to-day management. What about the use of corticosteroids? So this is a recent publication from Mayo Clinic which showed that there was no difference. Generally, corticosteroids were used in that cohort of cirrhotic patients who were already needing higher inotropes, and they also had lower lactates. So that means 2 words of caution. It has got a catecholamine sparing effect, and normally you would not want to use when you think that in spite of your resuscitation and antimicrobial therapy, the lactates continue to climb. But these authors could not show a difference in mortality amongst those who were treated with the so-called adrenal dose of corticosteroids vis-a-vis standard medical therapy. So what about the EGDT? So the ICU colleagues are very fond of this particular term, early goal directed therapy. So there is no such thing as early goal directed therapy. This was a famous paper from Rivers published about 2 decades ago, which actually set the stage for the saving sepsis guidelines. So all of those who work in the ICU would be very familiar and would swear by these guidelines. But this particular concept has now become an archaic concept. As you can see, there were 3 large New England Journal publications from different parts of the world 7 years ago, which showed that there was no difference between the usual care and the EGDT, because the ER care and the care provided in the peripheral units has become so better. So don't go hammer and tongs giving fluids to your patients. So please assess the responsiveness of the patient to the fluid therapy. Only about 50% of patients would be fluid responsive in the best case scenario. That is in the general ICU population. I suspect that among cirrhotics it would be even lower. And what you see on the right side is a very, very famous study where it was shown that those patients who get more fluids are more likely to die. So it's extremely important to follow the SOSD principle. So you need initially salvage, then you optimize, then you make the whole hemodynamic sustainable, and then you de-escalate quickly. So do not go hammer and tongs and think that if you are giving enough fluid, regardless of what that fluid might be, you are doing any benefit to your patient. So this is the algorithm, and this is how we would want our patients to be managed, and I have dwelt upon most of these points earlier. And then for those of us, I do not know how many intensive care colleagues are there. I thought I would just leave you with some brain teasers. So the first one is, what is the commonest acid-base abnormality in a patient with decompensated cirrhosis? Just think about it and you can come back with the answer. It's very, very straightforward. What is the commonest blood gas acid-base abnormality in a critically ill cirrhotic? So very rapidly from decompensated, someone who starts needing the intensive care, it would be different. And then, there are various ways of analyzing the acid-base status and the blood gases. And one of the very popular ones is what is called as the strong ion gap, or the SIG, by Stewart's physicochemical method of analysis of acid-base. So this particular equation gives you a good idea as to who might not make it through the ICU care. And those of us who spend a lot of time in the intensive care would know what I am talking about. Thank you very much for your attention, and I'll be very happy to take any questions.
Sir, thank you for a very lucid talk. I have a couple of questions. The first question is, is there any critically ill cirrhotic patient you would not be willing to shift out of the ICU despite improvement? And the second question is, what is your opinion regarding the timing of renal replacement therapy and absorbent based therapy?
Right, so the first question is an excellent one. So something that I didn't mention in the talk for want of time. So these patients, especially those who are decompensated, also have a component of sarcopenia. In fact, some of them might even be deconditioned because they keep coming back to the hospital. They keep coming back for a reason which takes away a huge amount of protein from their body when the body itself is synthesizing very little by way of protein. So I think even though you might be forced to keep a patient in the ITU because of this particular reason, for his frailty and for his sarcopenia, but we would probably add more manpower to a given patient and at least get him out into a step-down unit. So because I work in a transplant setting, the biggest stumbling block to a successful transplant is your patient not having been decolonized before surgery. So even if that decolonization is for a very brief period, in fact, my aim is always actually to send him out to a hospice. So we have a hospice service also, or community where the patient can be very closely monitored. And you see that as the numbers grow, the patients, even though they might be defined by a very bad liver severity score, those whom you are able to send out to the community, albeit for 48 hours, will tend to do much better. So that is the answer to the first question. Now about renal replacement therapy, the timing is still very dubious. So please remember, like I said, you should be only as invasive as is needed. So unlike acute liver failure, where the guidance is very, very robust, that means somebody who's got a volume overload, early features of ALI, hyperlactatemia, hyperammonemia, abnormal temperature control, bad patient phenotype, all these are indications for putting the patient on RRT. Mind you, none of these I have touched upon the so-called features of azotemia. In a patient with cirrhosis, this is a little more difficult. Why so? Why we should be very circumspect is because if somebody is a candidate for transplant and everything else has been readied towards that, then my threshold becomes very low for optimizing this patient. But if there is someone who's had a repeated run of these things and this AKI is transforming into CKD, there is no provision for a transplant for whatever reason, patient phenotype, not getting clearances from various colleagues, other specialties, logistics, finances, donor availability, so on and so forth, my threshold would be very high. So I can't give you a very objective answer to the second question.
Is there any question from the audience? Sir, when do you start empirical antifungal? At what circumstances?
Right. So again, this is guided oftentimes by the patient's history. So someone who's been into the hospital a number of times, which is not uncommon in this patient cohort, and comes back, say, with more than a SOFA which from the baseline has increased. So mind you, their SOFA would not be 2 because you know their baseline SOFA from earlier admission. And if this patient comes with, say, a very high white cell count, but we are finding that now there is a mix of lymphos and polys, and this patient has altered mentation, has gone into ileus, I would start them on an azole therapy much sooner. So there are so many things which we never discuss in the cirrhotic population. So you know there is a partially treated infection in every specialty of the human body, but you would never have heard a term called partially treated SBP. Does that term exist? The answer is yes. Of course it exists, but we never got down to writing it or telling it to the world. Probably the world also knows about it, but it's a poorly defined entity. So these are the patients in whom I would have a low threshold for starting the azole. The important thing is to de-escalate quickly. So the moment you see that your patient is getting better, by whatever scoring system you use, you should de-escalate quickly. If it is empiric. If it is however guided by the antimicrobial, and tomorrow your beta-D-glucan or a mannan anti-mannan comes positive, then this patient would need the therapy for the full length of duration, which could be 14 days, 21 days, or even longer than that for fungal peritonitis.
Thank you, sir. So if there is no question, on behalf of the organizing committee, I profusely thank Professor Kapoor for his enlightening lecture, and we conclude this session. Thank you.
Thank you. Thank you very much, sir. Gemas extends its warm greetings to all its faculty, the delegates, their distinguished guests. This is the 7th Gastro Summit that is being organized by Gemas, and it had been a continuous journey since 2015 with academic and philanthropic activities. May I request Dr. Shujit Chaudhary for the chairman's speech.
Good morning. On behalf of Gemas, I welcome you all in this 7th Gastro Summit. Gemas is our trust which was formulated and started in 2016. This is an association of gastroenterologists and GI surgeons, mainly who are working in AMRI Salt Lake. But along with this academic activity, we are doing some social services also, and we are an organization which is an 80G beneficiary, and we are getting lots of help from not only from the pharmaceuticals but also from the other benevolent peoples. So for the Gemas, we are doing yearly CMEs, and I am privileged, we are privileged to have the support from all the prominent, eminent faculties of our country and also from the international community of our subjects who are helping us for continuing our scientific activity every year. So with these few words, I want to welcome you, and I hope this Gastro Summit will be helpful for enrichment our knowledge in the management of different gastrointestinal and hepatic disorders. And with these few words, I want to start our inaugural ceremony. Please, okay.
May I now invite our chief guest, Professor D.N. Guha Mujumdar, a very well-known name and institution in himself, the ex-professor and head of the Department of Gastroenterology, IPG MAR, Kolkata. I would also request Mr. Rupak Borua, another well-known name, the CEO of AMRI Group of Hospitals, Kolkata, to please come on the stage. May I request Mr. Parikh, the unit head of AMRI Group of Salt Lake, to please come on the stage. A felicitation of our chief guests, our guest of honor, with flower bouquet on behalf of Gemas. We are indeed honored to have you amongst us, sir. We are really honored. A felicitation to Mr. Borua, our chief guest. A felicitation with flower bouquet to our unit head, Mr. Rajesh Parikh. Sir, we are indeed pleased to have you with us. May I now request for the lamp lighting ceremony, Dr. Abhijit Chaudhary, sir, you are requested to come on the stage, sir, for the lamp lighting ceremony. Professor Karumbir Chakraborty, sir, we would request your presence too. Apart from this, all the members of the Gemas, Dr. Shujit Chaudhary, the chairman, Dr. Sudipto Ghosh, Dr. Devkumar Rai, Dr. Sanjeev Chakraborty, Dr. Badal Das, Dr. Amit Dotto, we would request your presence, please. We would also request Mr. Parikh, unit head, and Mr. Rupak Borua, the CEO of AMRI Group of Hospitals, to please come for the lamp lighting ceremony. May I request Dr. D.N. Guha Mujumdar to please come on this for the lamp lighting ceremony.
सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ॐ गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया सुखकर्ता दुःखहर्ता वार्ता विघ्नाची पूर्वी प्रेम कृपा जयाची सर्वांगी सुंदर उटिशेंदुराची कंठी जळके माळ मुक्ता फळांची जय देव जय देव जय देव जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव जय देव
A few words of blessings from Dr. D.N. Guhu Mujumdar, please. A few words of encouragement, sir. এখানে দাঁড়াবেন স্যার না স্যার দাঁড়িয়ে বলবেন
Dear friends, it's my great pleasure to inaugurate the 7th Gastro Summit today, for which I thank Dr. Sujit Chaudhary. Also, I express my appreciation to the team of gastroenterologists, both physicians and surgeons, who have been involved in organizing this Gastro Summit. Successively, during the last 6 years, and this is the 7th year, it's really praiseworthy that not only for engaged in clinical practice, these gastroenterologists are also quite careful in increasing the knowledge base of the fellow gastroenterologists and clinicians about the advances of gastroenterology. Being a senior person, I've got the opportunity to bridge the gap between the physicians of earlier period of 20th century and the modern gastroenterologists who are trained, for which I was somehow instrumental to initiate this in Postgraduate Institute, Kolkata. You could remember that in spite of not availability of the modern gadgets, these medical scientists did a lot of service and research to remember patients like Dr. R.N. Chaudhuri, Dr. Tushar Shah, Dr. Asian Day, the great researcher who diagnosed, who actually invented that the secretary diarrhea is caused by a toxin by cholera vibrio, and also the even the Dolinicona and others. Actually, I was privileged to get some training of small bowel disease by John Hopkins people at IPG at ID Hospital, Kolkata. When I joined the Postgraduate Institute, I was fortunate to have seen the joints of hepatologists who were working at that institute on portal hypertension, and I saw a person like A.K. Basu, Professor A.K. Basu, who carried out as many as 400 portal hypertension surgery at that particular institute. And when I progressed, I found that the surgery has been replaced by management of peritoneal hemorrhage by initially sclerotherapy and subsequently by means of banding. I found that the so-called medical jaundice has been completely diagnosed, was changed by advancement of identification of various viral agents and several types of viral hepatitis. The development of antiviral agents has revolutionized the treatment and management of viral hepatitis. Really, the advancement of endosonography has helped a lot in diagnosis and management of hepatobiliary diseases. To tell a few that the therapeutic procedures of endoscopy are gradually reducing the scope of surgeons in management of GI diseases. Still, I must say that a lot of things you need to be careful to follow, to have further improvement of understanding the management of severe alcoholic hepatitis, management of drug-induced jaundice. We are in an enigma to understand the problem of Ayurvedic medicine in causing liver disease, to manage the acute necrotizing pancreatitis. There's a lot of advancement, but still a lot of things to do. So I must thank all of you. I shouldn't bore you. Being an old person, I shouldn't bore you all for my talk. Thank you very much for your patient hearing.
Thank you very much, sir. We are really obliged. May I now request our chief guest, Mr. Borua, for a few words of encouragement, please.
Professor Dr. D.N. Guha Mujumdar, all the faculties, delegates, particularly the faculties delegates who have come across India, welcome all of you in this conference, and particularly the delegates and the faculties, those who have come, welcome to this your city of Kolkata. AMRI Hospital, as you know, that it is one of the largest healthcare chain in Eastern India. We are managing 3 hospitals in Kolkata and 1 hospital in Bhubaneswar, and almost 1,200 beds under our control. AMRI Hospital has, particularly I'm talking about Salt Lake, AMRI Salt Lake, that is first, we, particularly during this COVID situation, the first COVID started, AMRI Hospital, Kolkata, actually, Salt Lake actually started the first COVID hospital, dedicated COVID hospital, tying up with this, your government of West Bengal. And our doctors, our whole healthcare professionals actually had proved their bravery during those times. That 66 bed we started, and over the time, the AMRI hospital increased the bed strength to 1,000. I'm talking about the COVID bed, which is includes this, all the hospitals, the satellite center, and we converted this your Salt Lake Stadium as a satellite hospital or the field hospital. So combining 1,000 bed, we have control, and all our doctors and professionals, actually, the healthcare, other supporting staff, nurses, housekeeping technicians, they had supported the society, the community. I'm really grateful their unstinted support during those times. I'm very happy to be here at the very outset because Gemas, I just came to know Dr. Chaudhary was mentioning that Gemas is not only doing this kind of academic activities, but as well Gemas is engaged in a lot of philanthropic activities. It's great because these are the organizations, there are organizations, all the different specialty, but doing the promoting academic activities along with this this kind of philanthropic engagement, it's really an appreciable work, and I really appreciate the Gemas. Thank you so much giving me the opportunity to be here. The organizing committee, Dr. Chaudhary, Dr. Sudipta Ghosh, and all the members, I'm grateful to all of you. Anytime, because AMRA Hospital also supports a lot of academic activities. We are really engaged in a lot of academic activities across our all units. We are doing a lot of DNB programs, all the faculty programs, or many things we do. Anytime, if you need any kind of support in terms of promoting your academic activities, we are always with you. Because these are the programs, because medical science is changing very fast changing because of technology, because of digitizations, because of artificial intelligence in place, big data. Every day the science is changing. This kind of, the programs, this kind of scientific program, this kind of academic activities will give a lot of support to these our junior doctors to keep pace with the medical science, whatever the changes is happening in the world. So thank you so much. I really appreciate this kind of a program, and I see that there will be a lot of takeaways for our junior doctors. There is a lot of exchange of knowledge will happen, and my best wishes that this program will be a grand success. Thank you so much.
Thank you very much, sir. As I had mentioned earlier, that Gemas has also extended certain philanthropic activities all over. Now, may I call Mr. Rupak Borua and Dr. Abhijit Chaudhary to distribute the financial help amongst the students. May I request Debanjan Chottoraj of Bakura to please come on the stage. Shomokanna Ram from Domdom, Dastu Mondol from Domdom, Dishani Roy from Domdom, Devdeep Kundu of Domdom, Jagannath Dhar, Devshankar Das from Domdom, and Wasim Akram from Subarnapur, Shongita Poral from Arambagh, and Sonika Poral from Arambagh. We would request Dr. Abhijit Chaudhary and Mr. Rupak Borua to please distribute the financial support to the students. May I repeat the names once again? Debanjan Chottoraj, Shomokanna Ram, Dostu Mondol, Dishani Roy, Devdeep Kundu, Jagannath Dhar, Devshankar Das, Wasim Akram, Shongita Poral, Sonika Poral. May I request Dr. Sudipta Ghosh for a few words about the activities of Gemas.
As we have mentioned, that apart from our academic activities, we continue to extend our support to the needy students of Midnapur and so that they can pursue their career. We have donated bags and books to the children from a village near Sonarpur and also a village near Midnapur to give them sari. We went during the Durga Puja, we went out to Sundarban and a village in Midnapur to give them sari and dresses. The smile on their face took away all the tiredness for visiting those remote areas. We always dream big within our limited means. We can do it better if we get more help. Ending with a famous line from Tagore, আমার সকল কাঁটা ধন্য করে ফুটবে ফুল ফুটবে, আমার সকল ব্যথা রঙিন হয়ে গোলাপ হয়ে উঠবে. Hope you will enjoy the program. What's it? আমরা ফিনিশ আসেনি একজন আসে আছে ঠিক আছে তুমি এবার কথা বলো Thank you, our dignitaries. Thank you, Professor Gumujumdar. Thank you, Professor Chaudhuri. And thank you, Mr. Borua. I think we will again back to our academics. Over to Shubhasri and Ognivo, please.
So our next session would be Hepatitis B Beyond Domain of a Specialist by Professor Abhijit Chaudhuri. And to chair the session, may I invite Dr. Bibhuti Saha, Senior Consultant Physician and ex-HOD of School of Tropical Medicine, Dr. Jayanto Mukherjee, Consultant Gastroenterologist attached with ILS Hospitals, Kolkata, Dr. Shobhik Ghosh, Associate Professor attached with Medical College, Kolkata, Dr. Devottam Bandyopadhyay, Consultant Gastroenterologist attached with AMRI Hospitals, and Dr. Bhashwati Acharya, Consultant Pediatric Gastroenterologist associated with Amri Hospitals.
Good morning, everybody. So it is a proud privilege to introduce my beloved teacher, Professor Abhijit Chaudhuri. He needs no introduction. So he is the head of the Department of Hepatology, SSKM Hospital. So he will speak. He is a master of liver diseases. So he will speak today on hepatitis B beyond domain of a specialist. Sir, please.
Good morning, everybody. Thank you, chairpersons, and I extend my sincere thanks and gratitude to the organizers of the meeting for this opportunity. And as I'm going to tell you over the next 20 minutes or so on the story, on some parts of the fragmentary parts of the story that hepatitis B has told us over the years. And at the very outset, let me tell you that, as I understand, it's a very stale story. Why I say stale is, as I'll tell you, that not much thrilling and vibrant advances has taken place in hepatitis B as compared to other branches of hepatology over the last 2 decades or so. And Professor Gumujumdar, teacher for everybody amongst us, is present here, and I'm pretty sure while he hears this, he would immediately say that, hey, this is the same story that I used to tell 30 years back or 40 years back to my students. Why I say so, it's not as bad as I'm painting it to be, but is not as good, because the hepatitis B was the first virus that became evident in front of us. But hepatitis C and other viruses, having it appeared before the scientists much later, made much more progress at a real galloping pace, and hepatitis C, I can say, melts like an ice right now, and we are also happy. And compared to hepatitis C, hepatitis B still remains. We keep on struggling with the virus. So with that, let me take you, I'll focus on an outline, and I'll focus on 2 clinical issues which might be helpful for the clinicians present here instead of being a very dense specialist driven talk. So what are the hard issues that we need to realize? First of all, it needs to be very clear, and we all know that we cannot eradicate the virus. We need to be very clear, but while telling this story to our patients, because the patients come to us asking a very simple question, sir, is the virus going to stay with us all through our life? I think we need to be, very delicate. This is a delicate question, and we need to be subtle in expressing that, yes, it's going to stay with you, but it's not end of the road. That's what precisely I do. And what we do is, we can control with the available drugs. We also know control the virus in the serum, and with a hope that we are also doing some good things in the tissues, particularly liver tissue and elsewhere, where the virus primarily resides, and expect improvement in the long term. But again, I emphasize at the very outset that even under the best of the circumstances, your patient of hepatitis B whom you are treating is not off the hook for development of hepatocellular carcinoma. This needs to be very clear. But at the same time, we need also to be very clear that we don't need to tell our patients every day that you can still develop hepatocellular carcinoma, because that thought overrides all other thoughts in front of your patient. So we cannot eradicate the virus, we can control it. Next is, it's not a viral disease, it's more of an immune-mediated disease. We also know that. The virus triggers the flame, and the body ignites our cells to produce the disease. We also need to understand that. Then that's why the antivirals that we keep on using have not proven to be that useful that we would have loved to be. Interestingly, the last new drug that appeared before us is more than 5 years ago. So in between, lot of, today is the era of molecular biologicals, monoclonal antibodies and all these, but we have really not succeeded to get another new drugs while efforts are on. I'll tell you some snapshots of that. But last new drug was tenofovir alafenamide. We all know that. And after that, we are still playing with the same virus, same antiviral that we had been doing. So right now, the most important thing is to select out whom not to treat and whom to treat. And again, I say that of all people with hepatitis B virus infected patients who present to us, we can, under the best of the circumstances, treat 10 to 15% or more, or up to 20%, not more than that. We know the natural history is, there are many stages. I'm not going into details of that. But the largest majority of the people we keep on seeing are the inactive HBV infected people. They don't need any treatment. I emphasize, they don't need any treatment, need to be on follow-up and close very good counseling. Otherwise, they are doomed to be in depression. And so they are the people who are surface antigen positive, anti-E positive, have got varying titers of HBV DNA, we know that, and their ALT is normal. We need to keep them on follow-up because they are fragile, and at some point they can break into a stage which is chronic hepatitis B, because it has been lasting long, because viral mutations, body's immune system and all this. So ALT, I will emphasize again, ALT is a very important marker. So ALT, HBV DNA and E antigen are the three markers that are going to be in our hand to assess when to treat, whom to treat and whom not to treat. And it's good to keep normal ALT people not to treat, under the not to treat umbrella, because they are bad responders to treatment. Acute hepatitis B, most of the adults resolve. And in chronic hepatitis B, when we treat them, what we expect is, we expect them to go into the phase of acute hepatitis, when the virus pushes off and HBs antigen goes off and anti-HBs develop. Let me tell you, emphasize that most of the people whom you treat, you are not going to get rid of HBsAg. So you need to tell them that your HBsAg is going to persist with you, but the snake will go, but the snake shell will remain. So if you are clear from the very outset, the expectations of the patient is also very clear. We need to understand an outline of that. The virus enters into the body, uncoats itself in the cytoplasm of the hepatocyte, then goes into the nucleus, and this is where the bad thing starts happening. It replicates within the nucleus, produces its own progeny, then goes back into the cytoplasm, where the protein synthesis takes place in the machinery which is called ribosomes. Then, the DNA of the virus comes into the assembly with the viral proteins, and encapsulation takes place again in the cytoplasm. Then, other stages also happen and the virus is finally secreted. So what we are doing right now, we have got only replication inhibitors. All the drugs that we keep on using right now are only replication inhibitors. And they are very, very superficial to it. It's like whitewashing a house which is still rock in agony. So you can get a DNA which is, almost gone. But that's not end of the story. We need to realize that. We are trying to develop many new molecules, and all these are, some of the areas I'll tell you subsequently. But people are also trying to target the immune system, because as I told you, the immune system is the final arbiter, and there are many molecules, and particularly TLR agonists, checkpoint inhibitors, which are showing promise. So, I emphasize, and I would put before you, that ALT, which is elevated, is a good thing to happen in a chronic hepatitis B virus infected individual. If a person's ALT is low, you are unhappy, because the body is in deep slumber. It's not mounting an immune response against the virus. And whatever drug you give, you are almost certain to fail. So, a vigorous immune response with an ALT elevation is going to be your good, and this heralds most often recovery. But a weak immune response is going to give you an ALT normal, and we know of the immune tolerant phase when DNA is high but ALT is normal, because body is not recognizing this as a bad thing that is happening. So whenever you have got a ALT high, you have got an immune active phase, and this is the phase when you should go in and try to push the virus further. So your role as a physician is only to potentiate the body's attempt to get rid of the virus. All the drugs that we keep on using only bolsters the body's attempt to get out of the virus. So ALT elevation is good. ALT between 2 to 5 times the normal, up and a bit of normal, is where you should go in. State of immune system activation is the final arbiter. So who needs antiviral? If the ALT is less than 60, it's better to wait. Keep the patient on follow-up. Keep on monitoring for every 6 months with ALT and DNA. If the DNA is more than 10,000 copies, in mostly E antigen negative people, and ALT is more than 60, if the patient have got cirrhosis evidence on ultrasonography or other means, then you have got reasons to treat once the HBV DNA is normal. So now I come to a case, and this is a very common case, and I'll put before you 2 clinical scenarios. This is a 22 years old lady who wanted to donate blood and was informed to be HBs antigen positive, and now reports to a physician for advice. This is a lady, remember, who is at the childbearing age and is yet to marry. So the questions that she presents before the physician is how to get rid of the virus. Is it possible? Very common question that we keep on facing. How did I get this misfortune? This is the overriding question. Can I marry? Can I bear a child? Do I pose a threat for infecting others, particularly those in the family? The lady is in deep agony within herself. She, separates herself within the family. What all bad things can happen to me? Do I need any treatment? So you need to answer all these questions. So initial workup of value are this. We don't do E antigen these days thinking DNA is the final say. Please do E antigen, DNA and ALT and rely on those. Platelet is going to be good to tell you whether portal hypertension is present or not. So also depend on that. Very simple marker, platelet count. And one of the commonest reasons for low platelet in common scenario is having chronic liver disease underlying. So you can have all these scenarios, we know that. So if the patient have got a low platelet, ultrasound showing irregular margin and all, if the lady will be diagnosed to have underlying cirrhosis and advanced liver disease. An active infection will obviously depend on DNA, ALT and all. So the middle tier is a group whom we need to treat. The inactive HBV infected we need to keep on follow-up, and we need to tell them that you need to be kept on follow-up. So the answer to the question, how did I get it, is better answered by telling you don't need to think around this. That's what precisely, what I'm going to tell you is a biased view which I have developed over the last 20 or more years of treating these people. Because otherwise it becomes a witch hunting and you end up in great despair. So can I get rid of the virus at all? So your answer should be no, HBsAg is going to persist to you. Get prepared mentally. will persist. But that's not end of the story. In only a microscopic minority, and in India it does not happen. Almost, I have seen in a very, in lifetime I have seen only a very few. However, in all probability, you will have a normal life. Again, emphasize on a normal life. Otherwise, you are in, again, it become more of a psychological issue than a physical issue. Viral status, liver disease, 2 hourly I have told, better once yearly follow-up. Can I marry? Again, your answer should be on the affirmative. Yes, you should. In a socially sensitive manner. I'm not going to details of those. Every physician will have their own discussion. Sexual transmission is possible, although chances are low. Why I say low? Because we, Google and all these issues highlights this factor. And I have seen people not going to marry only because of thinking of the sexual transmission. So I think it's better to err on the side of doing human justice rather than telling the darker side of the story. That is possible. We are often very reductionist in our approach, and we should not do that. Ill-informed, negatively poised and paranoid society often keeps on telling this. And in today's world, this is very much high, and particularly the IT-savvy world. So get vaccination to both of you before marriages. We have got a hepatitis patient support group, whom we have seen marriages also happening within that group and outside group also. So this is a very important role for a physician, to be very positive themselves, not to be frightened that the patient is going to tell me that you told me to marry and then I am landed up in disaster. We keep on facing many allegations all through our life. It's better to be positive and do human justice rather than, being negative. Suggest barrier methods for 4 weeks after vaccination. That's also important. So we need to be scientific, but socially sensitive scientists. Can I bear a child? Yes. Again, very emphatically, no worries in getting pregnant. Again, all of us keep on seeing abortions being advised in the first trimester to unfortunate ladies with hepatitis B who have, conceived. It's a crime. I emphasize it's a crime. There is no medical termination of pregnancy should not be talked of when a person with hepatitis B, we should hail that. We should welcome that. We should promote that. Because that's going to make your hepatitis B more of a positive issues in the society. No problem in breastfeeding. Breastfeeding should continue. We need to be again very clear in that. The mother should be tested and treated if highly viremic. I'll come to that. The child should be given the due respect at birth. The frequency of transmission in the mother is related to hepatitis B virus DNA and E status. We know that. High hepatitis B virus DNA and E antigen positive people should be undertaken for prevention of transmission. The best time is 24 weeks of pregnancy, 22 weeks of pregnancy. You test for E antigen status and HBV DNA. If the HBV DNA is more than 10 to the power 6, you treat with tenofovir. And even TAF has proven to be safe in this group of people, and you administer HBIG as early after birth and vaccination to the child. So treat the mother if highly viremic and give HB and all those things at birth, and you prevent perinatal transmission. And tenofovir has been proven to be very effective. I emphasize very effective. Tenofovir alafenamide. This study has just come in clinical gastroenterology and hepatology in 21. TAF is almost safe in women in the pregnant phase also. So if you need to treat a lady in pregnancy, you can safely treat that lady with TAF. And this is a large study from Taiwan where they have treated with TAF and tenofovir, and as you see that it was absolutely safe. So what is the algorithm? The algorithm is, if a pregnant woman comes to you with HBV infection, first trimester, assess virus and disease. If the lady has got active disease, suspected cirrhosis, treat with tenofovir or TAF. End of second trimester, again DNA and ALT. If the HBV DNA is high, again start at 28 weeks, start tenofovir and then go on for the usual dictum. If the lady needs a surgery, and this is not the lady, an inactive HBV infected individual needs a surgery, we keep on facing this. We should encourage the surgeon very emphatically that HBV infection is no contraindication for surgery. We should encourage our OT nurses to allow to do surgery on a HBV infected individual with all the precautions, double gloved and all those barrier precautions. And assess the patient's viral status. If the patient is a E antigen positive, high ALT, you treat the patient. But there is no reason you should defer surgery or you should advise not to go in for surgery. Another clinical scenario is CKD, which I'm going to discuss. So surface antigen positive person with CKD, chronic kidney disease, comes to you. You evaluate the virus and assess the patient. There are standards means for assessing the patient. Your primary reason for assessing the patient is to see whether chronic liver disease is present or not, because that would dictate your urgency for therapy, and obviously kidney status, creatinine should also be monitored. So we have got, so here is a 48 years old male patient who was diabetic, which is very common, diabetic nephropathy, hemodialysis, surface positive, ALT is almost normal. Here in ALT is a very frail marker to guide your therapy. HBV DNA is very high. LSM, which has evolved, we are, unfortunately I emphasize again, we keep on measuring fibroscan once every 3 months. This is bogus science. I emphasize that fibrosis does not change in 3 months. Fibrosis can change only in less than 2 years or 3 years, it's not going to change. So please do a fibroscan at the baseline and don't expect your fibroscan numerical value to guide you in less than 2-3 years time. It's useless. So let's not do that. So this person's LSM was 18 with irregular liver margin. So obviously telling us the person have got cirrhosis. So if in whom to start therapy? In patients undergoing hemodialysis, if the HBV DNA and ALT, regardless of ALT, here ALT is not going to be guide. We need to keep in mind moderate histological liver lesions. If you do a liver biopsy, often not done. I'll take some more time. But I'll try to be as emphatic, as small as possible. Moderate fibrosis by non-invasive marker. So you have got a very good non-invasive marker like LSM. Although LSM have got some fallacy in the setting of renal failure, we should keep in mind, but if you have got a value of 40, say for example, or 30 for example, you are pretty sure that the patient has got underlying liver disease. TAF is fairly safe in people with renal failure, but you need to modify the dosages. Both for entecavir is the drug of choice even today, but TAF is safe. So we need to modify the dosages in people who have got low creatinine clearance, and there are very clear rules for that. So treatment decisions. So HBV diagnosed in CKD patient, no transplant prospect. Now you decide whether the patient is cirrhosis or not. Treat for complications like portal hypertension and all those usual. And treat the patient for HBV also. And continue hemodialysis. If the patient is a prospective kidney transplant patient, again treat HBV, proceed to kidney transplant. If the patient has got cirrhosis, explain. And these patients are good candidates for combined transplants. We are waiting for a patient like this to do a transplant. And if not feasible, then continue with HD. Post-kidney transplant patient, obviously, we need to treat the patient. So these are the treatment decisions. So summary of this part, before I come to the new advances, next 3-4 slides. Cirrhotic HBV infection in advanced liver disease, advanced kidney disease needs treatment with HBV by oral antivirals. Transplant candidates should be treated before transplant and then go in for a transplant. Entecavir and TAF are the fair choices. Monitoring of renal function is very important. Monitor renal function. If it alters, then good. So what's the future? So next couple of slides in 2-3 minutes. So we are talking of a term called HBV cure. Cure is something like what happens after acute hepatitis. In the first slide I told you that your surface antigen is gone, your anti-HBs is developed, your immune system is very strong and is protecting you from a relapse. That's cure. It's like a cemented house, not like the whitewashed house that we do with nucleotide analogs. And so how do you achieve that? So you have got many molecules which are jumping on the corridor, but we are not sure which of these will enter into your bedside. In the next 10 years or so, you have got the antivirals with the Nuox capsid modulators, which one of them I'll show you has appeared this year only. You have got silencing RNA, which shuts off HBsAg secretion. And as you shut off HBsAg secretion, what you do is HBsAg paralyzes the immune system. So your immune system gets bolstered. So you have got a reduction of HBsAg and you develop anti-HBs. Your cccDNA, this is the ghost of the virus that stays within the nucleus, progressively goes down. But importantly, possibly, we are going to have a combination of a good antiviral with a good immunomodulator, and none of these are foolproof right now. So this is a September 2022 Journal of Hepatology data. Vebicorvir is one of those early CAM, capsid assembly modulators that has appeared in addition to nucleotide analog that had shown promise, as you can see. VBR plus nucleotide analogs have reduced HBV DNA, and people have also got a marker called pregenomic RNA. This is another evolving biomarker for hepatitis B virus antigen. That is a promise. So TLR7, TLR receptors, increase. So TLR8 receptor agonist, I'll show you one, potentiates. It's not interferon, which was the strongest molecule that we used to have. A lot of side effects. So one study that has come again accepted in Journal of Hepatology is a selgantolimod, which is a TLR8 agonist given for 24 weeks. It's a phase 2B study, which is dosing study, which has shown again promise, but not fair proof. People are using checkpoint inhibitors. I'm not going into detail of that. This is a cancer chemotherapeutic, as you know, PD-L1 antagonist. So this has also shown promise. So as I wrap up, how do we conclude the current knowledge on HBV therapy? You have to be very clear when a person comes to you with HBV surface antigen positivity, measure ALT, measure E antigen, again I emphasize E antigen, measure DNA. And then, not indicated are the immune tolerant groups, normal ALT, monitor these people. As soon as ALT rises, you hit it hard. The low replicative stage, inactives. So, treatment indicated is ALT elevated, high antigen, if the person has got cirrhosis and all. Importantly, there are some, gray areas where a clinician's choice and a good discussion with your patient has to take place. That is E antigen detectable, high DNA, patient is in the 4th decade or 5th decade of life, normal ALT, but the patient is anxious and says, doctor, am I free of my chances of, high DNA? And patient repeatedly asks you, am I free of chances of hepatocellular carcinoma, which everybody keeps on telling me. I would like to treat this individual, personally. But it's your choice. Science is less clear on this. It's a fair judgment on your part, because you're not going to harm the people, because tenofovir does not develop resistance that much and other molecules, and you are giving the benefit of doubt to the patient for treatment. Strong family history of cirrhosis and family history and personal history of HCC. Again, a very important background knowledge for you to decide on which patients to treatment. So, on one hand, you remember, you tell your patient that you need to be on follow-up and monitoring. You are not off the hook. It's not like you keep on going. So, you monitor your patients, even if those patients are not treated once every year. Otherwise, you treat the people to get them, in a better shape for not to progress. But remember, even under the best of the circumstances, the DNA negative people can still develop HCC. Obviously, we don't need to tell the patients every time that, you can still develop HCC. No, that's not, but we need to keep this in mind that this can still develop. So with that, I think I tried to give you a snapshot, as I told you at the very outset, and one or two clinical issues on HBV. HBV is like it's like one of those Homer's great things, Iliad and Odyssey. And we are going to hear more and more in the years to come. NASH and HBV remains the unresolved problems over the last decades or so, and more new information is going to get us enchanted in the years to come. Thank you all for your patient hearing. Again, I'm grateful to Dr. Sujit Chaudhary, Dr. Sudipto Ghosh, and the entire team of MRI and Gemas for this opportunity. This is a great opportunity, and we keep on talking. Thank you.
Thank you, sir, for an excellent talk. We know that we have lots of the things to know still about hepatitis B, but I would like to open this for the audience or the chairpersons for the questions.
You have rightly mentioned that the immunotolerant phase nowadays called E-positive infection stage. So if advanced stage, our prime aim to therapy to hepatitis B is to reduce the HCC chances. So should you follow the rule of REACH be some prognostic marker for development further HCC? That was from the Taiwan study that suggests that the patient may in future develop HCC. That group of patient we should treat after 30 years of age. Patient with immunotolerant phase should treat with the tenofovir because it is a high genetic barrier resistant drug.
Yes, there are many indices and there are very many biomarkers, emerging biomarkers also, which tells you better chances of development of HCC in those people who have got high HBV DNA and all. So that's why I told at the very last slide that there are gray areas, and this is one of the gray areas. If the person is very young, say for example 20 years or so, and have got high DNA and normal ALT, then I would like to wait. But if the person, say 40 years of age, continues to have a high HBV DNA, and this should take place with discussion. All those indices have got a positive predictive value of not more than 70 to 80%. So this is good to have, but ultimately the decision has to be taken through a thorough discussion between the patient and the doctor. After explaining that, I'm treating you because of these circumstances only. So you have got reasons to treat, but you have got reasons to not to treat also. So it's a bit...
Sir, another thing, the HbSAg clearance is also not that he is cured from the hepatitis B, because it's an occult HB. Because again, the patient if receive any immunosuppressive drug, then you have to cover with the antiviral. So once hepatitis B is, I think it is always hepatitis B. It may be occult Hep B after HbSAg eradication and anti-HB is positive. So I think it is a...
Yeah, there is no drug which can get out of...
Sir, I have another question. What we are finding at the moment when we are giving immunoglobulin, pregnant mother, whether treated or not, immunoglobulin, hepatitis B vaccination complete. But we as a pediatrician, we are not very keen to test that child because we know the coverage is so high. But we are finding very low percentage, like 2 to 3% of children who are coming later on with some derangement of LFT. Then we are doing serology and then we are finding they are still positive. And their anti-HbS is very low. And they are dubious whether we will give booster dose, whether if we are giving when their HBV DNA is negative. But still, can we insist when they are coming for treatment, the pregnant mothers, that around after 1 year or after 1.5 years, you should check your babies? Because we ask the pediatricians as well, but sometimes people forget.
No, that should be advised. Follow-up is very much needed.
Because if mothers are also aware, then it will be really...
Follow-up is very much
because
needed.
we are finding this percentage, then it's becoming very difficult. Thank you, sir.
Excuse me, one question from my side. That the immunization is one of the most important and most effective approach for controlling the disease spread in the society. Is there any role of treating more and more patients with antiviral to reduce the chances of spread in the society? Because immunization is not rampant and it is not available for each group of patients. It is only for the neonates and the childhood. So is there any role of more and more patients to treat with antiviral to reduce the chances of spread in the community?
See, in a country like India, with the volume of infection that we have and with the amount of money that is slated, it may not be policy issue, it may not be that clear, because most of the people will be inactives with very low HBV DNA or undetectable DNA. They may not transmit. So, yeah, this is a good idea, but in practice it's not very easy to happen. Even the National Viral Hepatitis Control Program is struggling to reach out to those people. Actually 20% only, it is assessed, 15 to 20% only of HBV infected people can be tasted and treated. Most people remain untasted in India. So most of the transmission takes place from the untasted positive people. That's the problem. So there are issues, but that may be one of the solutions.
So we would like to end this session. Thank you, Professor Chaudhary, and audience for a patient hearing. It was nice to hear an excellent talk. Thank you.
Thank you.
Thank you. Thank you very much, sir. That had been a very interesting topic. Now we shall move on to our next topic, plasma exchange to treat acute liver failure. May I request our chairpersons to please come on the stage. We have Dr. Gautam Das, Senior Consultant Gastroenterologist, attached with the MRI group of hospitals, both Mukundapur and Dhakuria. May I request you, sir, to please come on the stage. I'd request Dr. Pradipta Guho, Consultant Gastroenterologist, attached with Zenith Hospital, to please chair the session. May I request Dr. Tuhin Mitra, Consultant Gastroenterologist, attached with Fortis Hospital, Kolkata, to please come on the stage.
So Professor Ipen is a well-known figure. He is the head of Department of Hepatology from CMC Vellore. The famous Vellore protocol is known for the treatment of acute liver failure. So I think without wasting time, I request Professor Ipen to proceed with the treatment.
Thank you, sir. First of all, to Dr. Guha Majumdar, I'd like to pay my respects and my happiness of seeing you once more here, sir. Thank you. Thank you to Dr. Sujit Chowdhury and for Gemas for this nice occasion to be here. So let me come to the topic of discussion. This is on a new therapy which is now getting to be of interest in liver diseases, but an old therapy in various other disorders in the body. For example, renal diseases, hematologic diseases, neurological diseases like Guillain-Barré syndrome. Plasma exchange is standard of care for 30-40 years. But in liver failure, it is new. So I would touch upon these two aspects. One is, there is now more and more evidence that plasma exchange, we call it PLEX. PLEX improves survival in patients with acute liver failure. And I'll focus a bit on phosphorus-induced acute liver injury or acute liver failure and how does it work. So what is plasma exchange? It has two steps. One is removing plasma from the person who is ill, that is called plasmapheresis, and replacing it with the fluid. In liver failure, the preferred replacement fluid is fresh frozen plasma. So these two arms together is called plasma exchange. In the human body, there is 5 liters of blood and half of that is 2.5 liters is plasma. So if, depending on the volume of plasma exchange in liver failure, we can categorize it into high volume plasma exchange, which is what Larson et al. Used, where they've exchanged 4 times the plasma volume, that is about 10 liters per day. That's a large amount of plasma being exchanged per day. Standard volume is what from ILBS, Raki, Maibel and Dr. Sareen have described, whereas 1.5 to 2 times the plasma volume has been exchanged. At CMC, we have been using low volume plasma exchange, that is half the volume of plasma. So if usually it is about 1.2 to 1.5 liters. Now why low volume? This is the standard volume used in neurologic disorders like Guillain-Barré syndrome. And in the very first patient, the neurologist who told us that we could try use plasma exchange in that particular patient who developed drug-induced liver injury after phenytoin, and she was on a ventilator. And with this low volume plasma exchange, he got extubated. Then we realized there's something happening which was not the normal expected course of events, which happened a few years ago. That's what has led us to this treatment, what we use in our center. Now this is the landmark paper in this field. Larson and group from 3 European countries used high volume plasma exchange and showed that especially in patients who did not have liver transplant, the survival benefit was seen more. Of course, not everyone survives, but compared to an arm where they did not get plasma exchange, the survival was about 10% more. Based on this, the American Society of Apheresis now has given recommendation that high volume plasma exchange could be a standalone first-line therapy for patients with acute liver failure. That's the grading of the recommendation. While in other scenarios, it's on a case-by-case basis where one would use it. This study has come from ILBS. Dr. Raki Maibel is the first author, where they use standard volume plasma exchange, a randomized control trial, in 40 patients with acute liver failure who also had cerebral edema. And so they used 1.5 to 2 times the plasma volume per session. And they could show a 21-day the survival was better with patients who received plasma exchange. Now let me come to a bit about Tamil Nadu data. In southern parts of India and in western India, for this study in Tamil Nadu, ingestion of rodenticide is one fashionable way of committing suicide. So rodenticide contains phosphorus. So this study done in 2019 by the Tamil Nadu chapter of the Indian Society of Gastroenterology across 6 districts of Tamil Nadu established that for every one patient with paracetamol-induced liver toxicity, there were 75 patients who had taken rodenticide. So though our entrance exam questions have got paracetamol as exam question, that's a Western problem. So in southern India at least, the problem really is phosphorus. So in that particular study, over a 6-month time period in 2019, there were 450 patients who developed rodenticide-induced liver toxicity. The mean age was 22 years, and 1/3 of the patients died. So this is 2 years, just the year before COVID. So it's almost like more than COVID, that's in that age group really. And in that data set, one patient underwent liver transplantation. So this is the ground reality when you look at it from this angle. So urgent liver transplantation is not feasible for most patients in Tamil Nadu at present. Now, many years ago from Amrita Kochi, this criteria was derived from their data set of patients with rodenticide-induced liver damage who are referred for liver transplant. And from their data set, they derived these 2 criteria, which evidently are very severe liver disease criteria. And they suggested that this could be the criteria for list for liver transplantation. So in their report, of 8 patients who met this criteria, who could not have liver transplant and only were given standard medical therapy, none survived. Of the patients, 14 who underwent urgent liver transplant, 86% survived. We were waiting for one publication to come from CMC, and in time for the Gemas conference, last night this article has come online, so it's now available on Google, that from our data set, there were 26 patients who met these criteria out of a denominator of now about 100 patients who with rodenticide liver toxicity who underwent plasma exchange. And now the survival was 62%, 1 month survival. When we look in the subgroup of those who are younger, 18 years or younger, there were 8 such patients and the survival was 75%. So it appears that, and none of the patients opted for urgent liver transplantation. That possibility is not there. So plasma exchange is available in all centers. Whichever center has got either a dialysis facility or has got an active blood bank can do plasma exchange. So as I see it, it's highly likely that more and more all over India, which is already starting to happen, more and more centers will be using plasma exchange for this indication. So this is what came out last night. So of patients who met the Kochi criteria for liver transplantation, and 2 patients of the 10 were not eligible. They were hypotensing and on inotropes, so we did not take them. Of the 8 who were eligible, the survival was 75% at 1 month. Now this has caught the attention of the Tamil Nadu government and the National Health Mission in Tamil Nadu, the subset called TAI, Tamil Nadu Accident Emergency Initiative. They have 6 pillars of focus. One of them is poisoning, because there's a big public health problem all over India. In Tamil Nadu, as I mentioned, rat killer is one of the problems. And they've put in a variety of steps. They brought out SOPs, how to manage them. They've said that we should provide a hub and spoke model for treating these patients in each district of Tamil Nadu. And they have already installed plasma exchange machines and facilities in 6 government medical colleges in Tamil Nadu. The plan is to make it happen across Tamil Nadu. At CMC, currently patients travel far distances to come for this treatment. So 100 to 500 kilometers. It is almost like saying 20 years ago, people were traveling like that for myocardial infarction. That doesn't make sense. The hub and spoke model is currently practiced in Tamil Nadu, where for myocardial infarction, at the primary care, thrombolysis is given, and then those who need angioplasty is then referred fast track to the tertiary care. The plan is to have a similar model for rodenticide poisoning, that is phosphorus causing liver failure, a huge problem in Tamil Nadu. Now, apart from plasma exchange, there is one new development in this field. That is, these are all patients who do not have an option of urgent liver transplant. The answer is zero. That's not possible. So the question comes about the importance of avoiding sedatives. Now, I am not going to go into that details of this slide today, but we are acutely aware of this. And when we avoid sedative drugs, the survival again improves. All sedative drugs are cleared from the body in the liver. They are metabolized in the liver. So if I give 1 mg of midazolam to a patient with acute liver failure, it's like giving 5 mg. So then the chance of me getting respiratory depression, needing an intubation, ventilation, etc. are very high. So it's not only need for a machine, it needs a team. It's like saying, can anyone do a liver transplant? I guess anyone can do, but will it be successful? I'm doubtful. We need a team. So the team is, so this is the team which each district government medical college now will form, where the plasma exchange will happen. There is an admitting team, which in Tamil Nadu increasingly is a toxicology or hepatology. At CMC it's hepatology. The plasmapheresis is done increasingly at CMC by transfusion medicine, because we use a centrifugal type of plasma exchange. It can also be done by nephrology. There are nurses who are trained in this, and there are technicians. I foresee that it will soon happen all over India. I do not recollect when dialysis happened first in India. I don't know. But it doesn't matter to me. All over India now we do dialysis. I foresee that this will happen for liver failure in all over India. That's what I think will happen. So with our encouraging results, we are increasing using Plex in our department. And this was the very first patient, which was, as I mentioned, a phenytoin-induced hepatotoxicity, was on a ventilator. Slowly, it caught our attention, and now we do, every week, we will do between 1 to 3 new patients. So this year, till last month, we have crossed 79 such patients, while at the bottom row shows the number of liver transplants. So we do only cadaveric liver transplant in CMC, and it's only a small number. So as you can see, we are forced into looking for other treatment options, and I believe this reflects most of India. Now, where do we use Plex in liver diseases? We have 2 large groups. One is acute liver injury or liver failure, and 2 is in ACLF. And as Dr. Guha Majumdar mentioned, in one of the areas which he mentioned, we find increasing use. We like patients with severe alcoholic hepatitis. They do quite well. I'm not going into that talk today, because that's another topic by itself. As well as severe drug-induced hepatitis. The very first patient of ours was such a patient. So increasingly these patients are surviving. The Tamil Nadu chapter of ISG has brought on guidelines on managing rodenticide. This is by a new journal called, again brought out by the Tamil Nadu chapter, called GHEP. It's available free of cost, gastrohepatology endoscopy practice. And these are the world's first guidelines on the use of Plex in liver failure. I would encourage it, if anyone is interested, look it up. Lastly, a few words on how does Plex work. So the case for macromolecules. So we believe that the answer comes from looking at the liver microcirculation. So we use the logic that if all these years different types of renal, dialysis, etc. were tried in acute liver failure, and survival didn't improve. While now survival is improving with plasma exchange, maybe the problem is molecules which are too big to be dialyzed. So it could be macromolecules which are getting removed. And in the liver sinusoid, microcirculation, the lining is fenestrated, which has got a two-way traffic of fluid from the sinusoidal lumen into the space of Disi, front and back. If these get clogged up, that is acute liver failure. So we believe that's what's happening. It's like having a traffic jam. I do not know about whether Calcutta has got traffic jam. Vellore has got it. I know that Calcutta also has got traffic jam. So this is 9 o'clock in the morning in front of CMC hospital. Okay, it's full of. So this is acute liver failure. So if you got, you can make out macromolecules, that guy on a bullock cart. You can make out inflammatory cells coming in. You can make out enlarged Kupffer cells lining the endothelial cell, etc. So the idea is to make it like 3 o'clock in the afternoon. Now I can go through very fast. Now this hospital will function. So the microcirculation is getting clogged up by the inflammatory response in the liver injury. So one such candidate molecule is von Willebrand factor. Every medical student knows VWF because the deficiency causes a hemophilia-like illness. It's a blood clotting protein. But in liver diseases, it's the opposite. These are high levels of VWF is a problem. And as I had told earlier, the logic as to it may be a molecule which is too big to be dialyzed. There are likely to be many such molecules, but VWF surely is one such molecule. It's quite large in size. It comes in different sizes, and the molecular weights are given there. In fact, it's described as the largest sized plasma protein in health. So it is the largest, really. Now, different studies show, the first two rows show are already in Schlesinger textbook. So the data is like that raised VWF levels are as good as MEL score in predicting survival in the outpatient cirrhotic over a 1 to 2 year time period. And the levels are raised 2 to 3-fold. We have shown, the next two rows are from CMC. We have shown that in ACLF and as well as in rodenticide acute liver failure, the levels are 4 to 7 folds higher, is as good as MEL in predicting survival over the next 1 week. The in-hospital stay is getting predicted. This same data has now been replicated from a pan-US study by the US ALF group, which is the last reference. So this is my last slide. So this is there are different etiologies of acute liver failure and in ACLF, where we now use plasma exchange. This is an example of a 14-year-old boy with hepatitis A, who had also got, we think may have been partly drug-induced as well. So this boy was quite sick, had met criteria for acute liver failure. The bilirubin was 48, the MEL score was 31, had acute pancreatitis as per numbers, MLAs was high, acute kidney injury, ascites, and bilateral pleural effusions. Underwent PLEX 2 sessions. The child became very well, met me after 3 months, and then I said there's no need to come for follow-up. So it's different etiologies we can use it for. It's not only for rat poison. I just gave an example of rat poison. Thank you.
Thank you, sir, for the wonderful deliberation. And if there are any questions from the audience, sir would like to take it.
Sir, how frequently you do it, once or twice daily, or how long usually they require?
It's an evolving field, so how much has to be done? So what we are doing is we aim for 3 sessions, and we do it now daily. So daily for 3 days. Every day we assess the patient, or the clinician has to decide should we do today or not. We find the person not tolerating it, we will stop it at 1. But if the person is tolerating it, we keep it for 3 days. Very few patients we have done for 5 times, etc. we have done. So most patients 3 days we do.
And sir, what is the standard volume, high, standard or low volume? What do you prefer to do it in a patient?
We use only low volume. We are using only low volume.
So some patients are simultaneously receiving CRRT. So they can be also put on plates?
Yes, they can be. We have only had some 2 such patients because the CRRT is an expensive affair. Comparatively, plasma exchange is quite cheap. Secondly, I've been thinking about this with our team for a long time. Let's say a person has got acute liver failure and is on CRRT, but to start with, the creatinine was normal. Like Dharmesh Kapoor mentioned, it's being done for liver indication. I'm wondering, should we use the term CRRT? There is no, why call it renal replacement therapy? My creatinine is, in the first place, is normal. It's being done for liver indication. So I would rather use a term like venous hemofiltration, or some other term is more scientifically correct than using the word CRRT. It has got some implication because CRRT often the decision whether to do or not is taken by the nephrologist, for example. Here the best judge to make that call would be the person primarily looking after the patient, which will be either physician or hepatologist.
Looks very exciting, sir. Are you facing any problem while doing this? What all problems you are facing or you expect while doing this?
Sure. It's a very serious question. There are now reports from world over in this field. There is hardly any problems. It's very well tolerated, actually. But when we use higher and higher volumes of plasma, there can be more problems. There can be problems of, for example, lung injuries, tralete and TACO, transfusion-related lung injury or circulatory overload. But when we use low volume, that's not a problem. So that's one thing we note. By and large, it's very well tolerated. Liver patients are coagulopathic, so we have to worry about bleeds. So we initially started putting the lines in the neck. Now we moved, after analyzing our data set, we do it only femoral. So femoral, even if it bleeds, we can press, but bleed is not a problem. But femoral area, the problem is infections. So as soon as 3 sessions are over, we pull it out. So we hardly have any infections either. So by and large, it's quite well tolerated.
I think if no more question, I will conclude the session. Thank you, Professor Ripen, and our attentive audience. Thank you.
Thank you.
Thank you, sir. Thank you, sir. Now, one humble request to, since we are already running 20 minutes late, I will ask all the speakers to kindly stick to the time. And second, we need to cut down on the question answer session also. So our next session will be an online session. It is Prognosis, Scores and Management of Acute and Chronic Liver Failure by Professor Shiv Kumar Sarin. And to chair the session, I would invite Professor Kingshuk Dhar, Professor and HOD, RG Medical College, Kolkata, Dr. Kormobir Chakraborty, Consultant Gastroenterologist attached with BB Poddar Hospital, Dr. Sunil Baran Das Chakraborty, Consultant Gastroenterologist, Dr. Vikash Prakash, Consultant Gastroenterologist and Hepatologist, please.
The next session is Prognosis, Scores and Management in Acute and Chronic Liver Failure. That's ACLF by Professor Shiv Sarin, and I'm sure Dr. Sarin doesn't need any introduction.
Greetings from
Can we start
IDS.
now?
I thank Dr. Sujit
Is
and
he
the whole
available?
organizing team.
Okay.
For having invited me for this important conference, the Gemas. I will cover prognostic scores and management in ACLF. I'll try and give you new perspectives of 2022, East versus West. I have no conflict of interest. except that we have very bright residents. Is ACLF of West different than the natural history of cirrhosis? Let's look at this new publication in JHEP reports. This is from the same EASL consortium, Babino consortium. Now this gives you risk of further decompensation. This is a new term. And mortality in patients with cirrhosis and ascites who had the first single decompensation event. Now, this is further decompensation. The term used is further decompensation. What is the further decompensation? Refractory ascites, SVP, HRS, AKI, varicose bleed. You will remember all these are part of also ACLF. The question remains, is it the natural history of cirrhosis that they are describing as in this paper, or it is ACLF? So first we have to understand cirrhotics have probably a defined path. Let's look at those who get ascites. Who have grade 3 ascites, these people will have either further bleeding or no bleeding and 2 or more further decompensations. Now, this is already a patient with ascites who bleeds or who has probably more decompensation. So this is the natural history of ascites and decompensation. Let's look further. Those who have grade 3 ascites, many of them will need a transplant or have refractory ascites, SVP, HRS, bleed, and this is the first. Then they have a second event, then they have a third event. Many of them would probably die. Some will need and get a transplant. So this natural history is also reflected as a natural history of ACLF. Because what is ACLF? That within a short period of 3 months, according to the West, these patients will die. So what I want to convey to you that now the world is realizing that acute decompensation and second and further decompensation are almost akin to sometimes ACLF. Do we have a separate natural history of DCLD, decompensated, compared to ACLF? Probably not. Let's look at this report. Very interesting, this part. Those people who had a MELD of less than 10 or 10 to 14 or more than 15. Now, even these patients who had ascites grade 3 but had a MELD of less than 10 have very high mortality. So even MELD is not reflective. MELD is 10 to 14, but just have ascites and decompensation. They have a high mortality over 3 years period. Let's go back to the canonic data. In canonic earlier studies, liver failure was not necessary. And what happened is liver failure was seen in only 14%. But in all others, it was either kidney or it was lung or some other failure. And 2 organ failures or 3 organ failures did not necessarily include liver failure. So the question remains, how do you prognosticate liver failure? Now, in this very recent paper, they say severity of systemic inflammation is the main predictor of ACLF and bleeding in individuals. Now, in the same study, they say clearly it may be that acute decompensation and ACLF are not separate entities, but more likely a progressive continuum in the natural history of AD. They included further a Padua model. A Padua model of Cliff ACLF has antifibrinolytic factor PAI, and this is more than 90 or CRP. So inflammation will always be there in ACLF, but is it a continuous part of AD or they are distinct entities? Now, in this study, which has come also from the same group of Jonel Tribeca from the Cliff Consortium, they say ACLF patients, as in the West, is a heterogeneous group with respect to number and combination of organ failures, etiology, and underlying disease and precipitating events. They could not use CLIF very well for pulmonary impaired. You can see that CLIF ACLF, if it is above 64, should be reliable. Here, the observed 28-day mortality versus predicted mortality was quite significantly different. So CLIF CACLF underestimates. So what I'm trying to convey that the Western method may not be as reliable and representative. Here ACLF with pulmonary failure means lung involvement. CLIF CACLF was only 50% accurate. Organ failure and outcomes, another method by which the West is defining one organ, two organ, three organ, and outcomes. This concept was initially given by Apostle very long ago in 2012 before the canonic study. Simply one organ failure alive is only around 70% or so, but two organ failure, the mortality is about 70%, and three organ failures, mortality is about 90% or 85% or so. But Apostle gave up this concept much earlier before the cliff started because this is too late. Now let's look at this. When you have organ failures in the cliff consortium assessment, you have 1 point, but here you see by the time the patient gets 2 points, you require 7 or more. You may have cerebral failure, you may have coagulation, you may have MAP of less than 70, you may have respiratory failure. If you have all these, then you get just about 6 or 7 points. Then it is already too late. And if you look at those who get 3 points, for example, he's already in grade 4. You don't require a score to say this fellow will die. Grade 4 means 80% mortality. Further problems with the Western scores. Now you have ACLF 1, 17%, 28-day mortality. ACLF 2, which is 2 organ failure, or ACLF 3A, 3 organ failures, you still have same mortality. And the other way you can look at it, 2/3 of the patients will survive 28 days, whether it is 2 organs or 3 organs. Therefore, going by organ failure as a predictor of outcome may not be truly representative. Why? Organs rarely fail in isolation, not just lung failure, not just kidney failure. They fail concurrently. Hence, doing liver transplant or assessing prognosis just on the basis of organ failure is not good, because you don't have a phenotype of just kidney failure or a lung failure, because they have other organs also. So doing liver transplant in ACLF grade may not help you in decision making. Let's look at this data, very recent. 3 US liver transplant centers wanted to put patients into ACLF2 or ACLF3. Imagine the concordance between these centers, 3 major centers, was only 56 or 60% or so. So if you do not agree in half the patients, whether it is grade 2 or grade 3, how will you allocate organs? Furthermore, when you use ACLF3 just by organ failure, what you ignore? You ignore several things like sarcopenia. You will also exclude cirrhotic cardiomyopathy. You will exclude many other donor and factors related to the host. Therefore, I think the question which I want to put before and decision I want to is that ACLF of West is not different than natural history of cirrhosis. Judge for yourself. Organ failure score is not reliable, especially it may not be of great help that you wait for 3 or 4 organ failures and take for transplant. Is ACLF East different than natural history of cirrhosis? Let's look at from the apostle point of view. Probably yes. So apostle does not include decompensation and further decompensation very clearly. It only includes chronic liver disease F3, F4, which after an acute insult presents as one single homogeneous entity of jaundice. And this is followed by cell death and ascites. Or patients with cirrhosis established who after acute insult get jaundice and ascites. There can be half a dozen other manifestations, bleed, coma, and kidney injury, and ascites following these, sepsis or combination. But the apostle ACLF, the R is absolutely homogeneous. But if you use this category as per Cliff, excluding this, even then you have at least a 9. And if you include this, there are about 30 inhomogeneous groups into this. So if you want to do a new drug trial, how will you do? Because you have so many phenotypes. If you use the NACSELD, North American Consortium for End-Stage Liver Disease, it is extremely heterogeneous and is only based on the ICU SOFA scores. So what is, according to apostle, you are very familiar with this diagram. In this, there is an acute insult, which is reflected as liver failure. Over a period of time, you get extrahepatic organs like kidney, brain, heart, etc. And this is a window of about 7 days or so. When you use ESEL definition, you actually diagnose much later because you need an extrahepatic organ failure. So here are the major definitions and their assessments. In apostle ACLF, you have liver failure leading to acute portal hypertension and ascites and coagulopathy. While in Cliff, you required rapid organ failures. In NACSELD, it is an end-stage liver disease. Let's look at the amount of data which is available for prognostic scores. The EASL Cliff is based on this single study. Then NACSELD on 2,600 patients. But as in this recent important paper, Apostle has ARC about 5,043 centers, 15 countries. And what is the core of this? Core is liver failure, single, bilirubin, HE, grade, INR, and lactate, and reflected with creatinine. While in this, 3 Cliff scores are there: Cliff C, Cliff CAD, Cliff organ failure, and the people get confused. This is the ARC score, which we use every morning, every day for every patient. Jaundice, coagulopathy, encephalopathy, and lactate. Attached is creatinine. And this is the only liver-driven score for chronic liver disease patients. Now, let's take a patient. Bilirubin is about 22. His HE is not there. And his INR is between, let's say, 2. Lactate is 2. His creatinine is, let's say, 1.2. He gets a score of about 10. Here 2 to 4 to 6 and 7 and 3, 10. Now, this patient has a grade of 2. This is grade 2 liver failure. Now, after 4 days, this patient now INR worsens, lactate worsens, creatinine increases. So he gets a score of 9, 10, and 3, 13. This R score puts him into grade 3 liver failure. So it is a bedside method of simple residents can use. You don't require calculators. And what is the relevance? If the score is above 10, then any 1 degree increase from 10 to 11, mortality in 7 days' time is increased by 20%. So you say, oh, patient came at 10, now it is 12. It can be an increase of 20 to 40% mortality. If the score is less than 10, then by day 4, mortality increases by 4%, 4 and 4. And by day 7, about 5%. So we only worry when the ARC score is above 10. And this correlates very well. This is the ARC score correlates very well and has the highest area under the curve. Then we compared this with a newly developed score where we have day 0 and day 7 inclusive. Now here take R score of day 0 and then take R score of day 7 and we develop a model. This model of using like Lil score, day 0 and day 7, the ARC score which is called CAP, ARC is a slightly better model than ARC alone. Can we do next generation by using artificial intelligence? Using artificial intelligence and machine learning. Now, normally I said only 5 things, 4 liver, 1 creatinine. But if you use AI model, we can use many, many more variables. So in a cohort of 2,400 patients, many variables were selected, 10 and more. And then patients are divided into 2 simple, and you can remember it very well. Those patients who have a creatinine of less than 1.5, but their INR is above 3, the mortality is 63%. How simple? Creatinine is normal or near normal, but just INR, the mortality is high. Now, similarly, if creatinine is above 1.5, but this patient does not have a circulatory failure, no hypotension, the mortality is this. But if the patient gets a circulatory failure and has a high creatinine, mortality is high. So this algorithmic, and you can do several calculations into this patient. Another simple score was developed by this US group. An arterial lactate of 4 or more, need of or on ventilation, mechanical ventilation, age above 53, and leukocyte count less than 10,000. This is called a TAM score, transplant for ACLF model. If the TAM score, as shown here, is more than 2, means any 2 are present, the mortality is high. It means survival is just 9%. So futility of liver transplant, which ACLF prognostic score will you use? Now, if you use this, most of these are futile, probably in my mind, for transplant. You can do a patient who has grade 3 or 4, but has no coagulopathy, very unlikely. If the patient is on vasopressors, but patient may not have any HE or kidney involvement. So these are rare isolated cases. Normally, if you are in this category, more than one organ involvement is there. What is the most common reason for not transplanting? We did a survey of the Asian centers, 84 centers replied. The commonest cause of not transplanting in 40 plus centers was sepsis. Now, in the US study, when is a critically ill cirrhotic too sick to transplant? And this is a consensus by multidisciplinary panel of 35 international experts. What did they report? Patients who have got a respiratory failure or a circulatory or a metabolic failure are not good. However, if the patient also has persistent fever or has leukopenia or pneumonia is treated with 72 hours less of antibiotics, SBP of less than 72 hours, and previous infection with a pan drug resistant. So sepsis is the most important cause, and organ failures of these 3 are important. Now, liver transplant can be done with 3 or 4 organ failures. The question is which one? He has circulatory failure, very difficult. Respiratory failure, very difficult. But yes, liver failure, coagulation failure, renal failure, 3 organ failures, but still transplant can be done. So type of organ failure is more important than number of organ failure because you do not have clear phenotype. And in our opinion and usage, best dynamic score is ARC score. I'll just give you my last slide. To summarize, first, if a patient comes to you with ACLF on day 0, you look into sepsis, optimize prevent organ failure. If the patient has an ARC of more than 10, means grade 3 organ failure, this patient goes straight for transplant, or you have MELD above 30, transplant. While you are waiting and the patient's ARC score on day 4 to 7 improves, well, from 11 or 12 it has come to 9. This patient might even come out with medical treatment. On the other hand, if the ARC score continues to increase, he will need an emergency transplant. Now, another patient using European criteria, he has liver plus 2 organ failures. Now, such a patient is too sick generally. He will need a bridge therapy, artificial liver support, or plasmapheresis. You stabilize and improve, then he goes for emergency transplant. And if he is not improving, he goes to supportive care. And if the patient already has 4 organ failures, it is best to give supportive care. It is a very simple algorithm for you to remember that an ARC of 10 or above and an improvement at day 4 and grade 3 to grade 2 liver failure can be helpful. I therefore urge all of you to join ARC, which has now 8,700 patients enrolled, and also to encourage you to publish in Hepatology International, the Asian Journal. With this, I would like to thank once more Dr. Sujit and the whole team for having invited me. Thank you.
Hello.
Hello. Thank you, Professor Sharin, for your excellent talk and elaborative talk. And now question from the audience. Oh, sir is already out of so we can close the session and can move on to the next session.
As you see, it's been, and Professor Sarin has a very limited time and he has done his job. He has given us an insight that probably number of organ failures are not the main important thing. It is like the APSL criteria. It is the few organs that are more important, like the kidneys, the coagulopathy, etc. So I think that's probably should be the take.
This is the most important thing.
Yeah,
before going to develop organ failure multiple way, we should consider this patient for the early liver transplantation where they are going to help.
Okay, we are closing the session.
Sir, if one comment, sir. Decompensated chronic liver disease definitely is different from acute and chronic liver failure because acute and chronic liver failure has a reversible component, which decompensated chronic liver disease doesn't have. Second, the benefit of ARC over CLIF score and Apache score is that it's a dynamic model. So it keeps changing and it helps to decide the fertility scores and the need for transplant.
We shall now proceed to the online live session, Recurrent Acute Pancreatitis, a case-based discussion. May I request the chairpersons to please come on the stage? Dr. Debashish Mishra, Associate Professor and Consultant Gastroenterologist attached to SSKM Hospital. Professor Gautam Chatterjee, Consultant Professor and Consultant Gastrosurgeon from SSKM Group of Hospitals. Dr. D.K. Rai, the HOD of and the Gastrosurgeon, AMRI Group of Hospitals, Kolkata. May I request Dr. Apurva Shiva to join? Dr. Apurva Shiva, the Senior Consultant Gastroenterologist attached with Medica Super Speciality Hospital and Fortis.
Dr. Chatterjee is not from the SSKM, is a HOD of Medical College, Surgical Gastroenterology. Sorry, sir. Sorry.
Extremely sorry, sir. Extremely sorry for that, sir.
It's a pleasure to start this interesting session. Professor Thar Chaudhary will be giving us a talk on acute and chronic recurrent acute pancreatitis case-based discussion. Dr. Sudipta Thar Chaudhary, please.
Thank you, sir. I hope I'm audible to the audience out there.
Yes, you are audible.
Thank you so much, sir. At the very outset, I would like to thank Shrujita and my namesake Sudipta for giving me this opportunity. And I apologize sincerely for not being there for personal reasons. My task today is to walk you through certain cases of recurrent acute pancreatitis. And these are relatively run-of-the-mill cases that we occasionally encounter during our day-to-day practice. Before we go there, I would just like to briefly touch upon what is the definition of recurrent acute pancreatitis. It's important to understand this because over a period of time, this definition is undergoing multitude changes. Now, this is a definition which was initially used by my senior colleague, Dr. Sajid, when he had published his first study in Digestive Disease Sciences in 2010. That was probably one of the largest series in India at that time. Two or more documented episodes of acute pancreatitis more than 2 months apart, with at least one of the following, that is serum amylase or lipase elevation more than 3 times upper limit of normal, and features of acute pancreatitis on imaging. And this usually occurs in a setting of a normal morphofunctional gland. Subsequently, the INSPIRE group, this is a group of pediatric gastroenterologists. We defined it as 2 episodes of acute pancreatitis along with complete resolution of pain of acute pancreatitis more than 1 month between the episodes, or normalization of amylase or lipase along with resolution of pain in between episodes irrespective of time interval. Now, a recent definition has put this time interval between the pain episodes at 3 months. Now, this variance is probably because we actually do not know when pancreatitis actually resolves in an individual. Or is there something called a smoldering acute pancreatitis that keeps on happening despite the person having respite in his symptoms? So in any clinical circumstances, when we come across a patient with acute pancreatitis, there are 2 types of evaluations usually we do. One, of course, is to understand the degree of severity, and one, to evaluate the etiology of the pancreatitis. And for etiological perspective, we start off with the history, which is including looking at the history of alcohol, smoking, family history of pancreatic diseases, looking at the lipids, serum calcium levels, doing a standard ultrasound, looking at the gallbladder, a CT abdomen. And usually in those circumstances, when we do not find an etiology, after 6 weeks, 4 to 6 weeks, we follow them up with an MRI and an EUS to look for a mass in the pancreas or pancreatic ductal anomalies, and EUS to primarily look at the bile duct and, of course, morphological changes in the pancreas. Now, start off with one of the run-of-the-mill cases that we usually see, and many of us would have seen such cases many a times. This is a story about a 27-year-old male who presented to us with the first episode of acute pancreatitis in 2017. He had a history of significant alcohol use prior to that, and at the point of presentation, he had moderately severe acute pancreatitis, as you can see from the CT scan here itself. He He was managed conservatively. He had a very stormy course, was in the hospital for almost 25 days, was discharged. He was well for a year, did not touch alcohol, but after 1 year, he came back with a second episode of pancreatitis. He has restarted use of alcohol since the last 3 months and had a recent binge at a birthday party. And at this point of time, the severity was only mild. Between 2020 to 2021, that was during the period of pandemic, he continued to drink, had multiple hospitalizations for pain. The CT did not show any definite features of chronicity, however, atrophy was gradually being noted at subsequent CTs. However, in 2021, when he was readmitted with mild abdominal pain, a CT done at our hospital showed evidence of calcification and specks of calcification. So, recurrent acute pancreatitis in alcoholics is known to happen, and especially in men, the risk is to the tune of 16.9%, and in women is 5.5%, probably because of the amount of alcohol being consumed. And this is a very interesting study which came out way back in 2009, which shows that in individuals who continue to drink as before, the risk is to the tune almost more than 50%. That is, the risk of developing recurrent acute pancreatitis is very, very high. And there's a high risk of transition to chronic pancreatitis and complication with diabetes mellitus. However, if they cease to drink alcohol after the first episode of pancreatitis, then the risk decreases significantly. Therefore, it's imperative that we emphasize cessation of alcohol to all our patients who come in with the first episode of alcohol-induced pancreatitis, and many a times they may require help or professional help to give up alcohol. And it's not only alcohol which is the culprit. Sometimes it's also smoking. The other, in this NAPS2 study, which was a large study looked at the influence of alcohol and smoking in recurrent acute and chronic pancreatitis, and they had a total of say 540 and 460 RAP patients. Cigarette smoking was found to be an independent dose-dependent risk factor for recurrent acute pancreatitis. This was again a large cohort of patients of acute pancreatitis, over 1,000 plus patients. Recurrence of pancreatitis increases in smoking. So not only do we need to emphasize cessation of alcohol use, but also cessation of smoking with immediate effect after recovery of pancreatitis. Now this is the second case. This is a 45-year-old lady from Bangladesh who had come to us with recurrent acute pancreatitis in 2018. She had multiple episodes over the last 3 years. She had a background history of diabetes mellitus, which was very poorly controlled. At the time of evaluation, you noted that total cholesterol was 260 milligram percent, triglycerides was high, 813, HDL 31, LDL 133, HbA1c of 10.5. No other structural, metabolic or toxic cause was identified. So we knew the diagnosis was probably hypertriglyceridemia, and there was a secondary cause, diabetes, which is probably driving the hypertriglyceridemia. She was initiated on a lipid-lowering agent, fenofibrate, and insulin dose was titrated to manage the sugars. She came back after a year in 2019, and at that point of time, the cholesterols were good. Triglycerides, though not normal, had come down significantly in 232, but however, during the pandemic, we completely lost touch with her. I have seen as recently as then a week before, and between 2021 to 2022, she had told me that she has had multiple pain episodes requiring hospital back in Bangladesh. We did repeat an EUS last week, and we showed no evidence of chronic pancreatitis. Her HbA1c was high, but the triglycerides were elevated, but not really very high enough to cause pancreatitis, 321. So I'll come to it. Before we go into it, just for the benefit of those graduates, if there are any in the audience, is that triglycerides per se are not a risk factor, are not the direct cause for pancreatitis. Triglycerides get acted upon by the pancreatic lipase, which leads to release of free fatty acids. And this is the free fatty acids which leads to acinar injury by increasing the intracellular calcium release, activation of trypsinogen. The free fatty acids themselves aggregate into micelles, release pro-inflammatory cytokines, produce endothelial injury, ischemia, and acidosis. All this leading to acinar injury and pancreatitis. So, for this particular patient, even this minor elevations of triglycerides was responsible for the episode of pancreatitis. And this is a study which showed that risk of recurrence amongst patients with hypertriglyceridemia associated with pancreatitis increases a modest increase in triglycerides. and moderately elevated. When you're talking of elevations between 200 to less than 500, the adjusted rate ratio for recurrence is around 5.47, and when it goes above 500, it's 8.45. So in individuals with hypertriglyceridemia associated acute pancreatitis, what we need is a very tight control of the triglycerides, and this has to be emphasized, and especially in individuals who have secondary risk factors like diabetes, the blood sugars need to be adequately controlled in this group too. Now this is another a case. This is a 20-year-old nurse who presented to us with recurrent abdominal pain for 3 years. Evaluated another hospital, diagnosed to have focal pancreatitis. Etiological evaluation, toxin screens were negative, metabolic workup was unremarkable. MRCP, however, showed presence of pancreas divisum. Now, I'll just go briefly about pancreas divisum because this is an area of concern. Do we really need to intervene in every pancreas divisum? Now, this is an anatomical patterns of ductal anomalies seen. This is a cadaver and magnetic resonance study. There were 6 patterns of pancreatic ductal systems that we identified, of which the most common type was the type 3 type. Type 4 or pancreas divisum was identified in 7.7%. Now, pancreas divisum, as you are aware, is develops from the failure of fusion of the dorsal and the ventral ductal systems, and the frequency varies amongst populations. In the Asian groups, the Asians, when I'm talking about the Asian, is the Chinese and the Japanese population, the prevalence rates are around 1 to 2%. The black population is around 2%. However, in the West and the Caucasian population, it's around 7 to 10%. So early studies showed significant associations between pancreas divisum and the risk for recurrent acute pancreatitis. So this was in 1980 retrospective studies of 47 patients. The group with recurrent acute pancreatitis, the prevalence was 26%. Again, another retrospective 50%, and another retrospective showed almost like 49%. But all of these were retrospective studies. Now, what is the argument against pancreas divisum as a risk factor for recurrent acute pancreatitis? Now, if pancreas divisum is a risk factor for recurrent acute pancreatitis, then ideally we should see a dilatation of the dorsal duct. Most patients do not have a dilated dorsal duct in pancreas divisum. The pancreatitis associated with pancreas divisum is not exclusively restricted to the dorsal ductal system. Rather, it is seen in the entire pancreas itself. Now, you look at another interesting aspect of it. The prevalence of pancreas divisum in patients without pancreatitis, if you look at the autopsy series, is 7.8%, and the ERCP series is 4.1%. This is in a group of patients who have pancreas divisum without pancreatitis. However, in idiopathic pancreatitis, the ERCP series, it goes up to 8%. Therefore, what it shows is that probably endoscopists fail to recognize pancreas divisum in the control arm, because in normal circumstances itself, it should be to the tune of 7.8%. So therefore, there is a slightly over recognition of pancreas divisum in the disease arms. So, an interesting study came in 2004 which showed that a high prevalence of CFTR gene mutation exists amongst patients with pancreas divisum. Subsequently, Dr. Garg from All India Institute showed that this particular gene mutation, especially SPINK1s and CFTR gene mutations, were higher in patients with pancreas divisum and recurrent acute pancreatitis. And the frequency of pancreas divisum was higher in CFTR gene-associated pancreatitis versus idiopathic or alcoholic pancreatitis. So when you compare patients with idiopathic and alcoholic pancreatitis, the risk of finding CFTR gene mutations is probably higher in those with pancreas divisum. Zahir, in a group of patients with recurrent acute pancreatitis, found that the CTSB and SPINK1 gene mutations was higher in patients with pancreas divisum. So pancreas divisum probably in isolation is not a risk factor for chronic recurrent acute pancreatitis, but pancreas divisum in combination with an underlying genetic risk factor probably is the risk, increases the risk chances of development of recurrent acute pancreatitis. Now, this is the only randomized control trial which evaluated the benefit of endoscopic therapy in recurrent acute pancreatitis, and in 19 patients with RAP randomized to stenting versus no therapy, there was significant improvement as regards VAS scale in patients who underwent stenting. 2 meta-analyses have been done, one in 2014 and 2017. The 2014 studies included 22 studies, a total of 314 patients. The median response to pancreatic endotherapy in pancreas divisum was 76%. And in 2017, again, 2023, most of the studies have an overlap of patients. So obviously, you can see a CDN efficacy of 76%. But the problems with all this meta-analysis was the studies were retrospective, the patient populations was heterogeneous, interventions again was variable. Some of the studies used sphincterotomy, some of them used sphincterotomy and stenting, some of them used sphincterotomy and sphincteroplasty. So what we are really excited and looking forward to this is a multi-center international sham control randomized control trial, which is called the SHARP study, which has completed its recruitment. It is a EUS plus ERCP with minor papillary sphincterotomy versus EUS plus sham. And the SHARP trial will determine whether ERCP with minor duct sphincterotomy has a benefit in patients with idiopathic acute recurrent pancreatitis and pancreas divisum. Now I'll come to this case 4, and I'll talk two cases simultaneously. The fourth case is a 35-year-old lady who presented with severe abdominal pain. On admission, the LFT patterns are here, total bilirubin of 1.3, AST of 161, ALT of 89, SAP of 112. Lipase was elevated, other etiological evaluations was unremarkable. In the past, she had a history of similar pain 3 months ago, was managed at another hospital analgesics and diagnosed to have mild pancreatitis. Ultrasound showed a dilated GB, with no calculi, CBD was not added, pancreas was not visualized. She was managed conservatively and with a plan that will follow up with an EUS and an MRCP at 6 weeks, and a repeat of metabolic profile at 6 weeks once pain-free. At EUS, you can see that there was presence of microlithiasis. This is one of the what we call as the starry sky appearance, suggesting microlithiasis. Now I'm talking about another patient. It's a similar age group, 40-year-old lady with again recurrent acute pancreatitis. First presentation in May 2020. Lipase elevated, amylase elevated, suggesting acute pancreatitis. Here again, the LFT showed total bilirubin of 0.3, AST of 20, ALT of 19, SAP of 58. GB is distended, was managed conservatively and discharged. Comes back in November 2020, again with a repeat episode of pancreatitis. LFT is normal, GB is normal, pancreas is bulky with a shaggy contour, and you can see peripancreatic fat stranding here. Third presentation again in December 2021, significant lipase, LFT still normal, MRCP is normal. Here again we repeated the EUS. Here also we saw evidence of microlithiasis. The question is, which of these lady would benefit from cholecystectomy? Do we do cholecystectomy in both or to none at all? So the problems with microlithiasis is the definitions of microlithiasis. Microlithiasis basically refers to stones which are less than 3 millimeters in diameter, that is below the ultrasound probe's detection capacity. At EUS, the sensitivity of microlithiasis is 95%. At microscopy, what we detect is biliary microcrystals, and that sensitivity is 67%. Now, this is the first study is from Dr. Garg that you can see on the top of the table. This is a study including 75 patients in which recurrent acute pancreatic microlithiasis was identified in 10 patients. 10 patients, all of them underwent cholecystectomy. 3 were well after cholecystectomy, 7 were lost to follow. The rest were another group of patients, 12 patients were followed up, and all of them had abdominal pain. So at follow-up, all of them underwent bile microscopy in additional 10 patients. 8 of these patients underwent cholecystectomy, but despite having cholecystectomy, 8 went on to develop chronic pancreatitis. Sajid, in 2010 from our center, had looked at recurrent acute pancreatitis in 188 patients in the age group of 33. Microlithiasis was identified in 24% of patients. Initially, all the patients, 41 of them were treated with ursodeoxycholic acid. 29 of them remained asymptomatic at a follow-up of 1 year. At 1 year, 25 patients underwent sphincterotomy, and amongst the patients who had sphincterotomy, 23 of them continued to remain asymptomatic. 4 patients underwent cholecystectomy during the period of follow-up after sphincterotomy, and 2 are asymptomatic, rest are lost to follow-up. Remaining 12 patients, 7 were lost to follow-up, 5 continued to have recurrent acute pancreatitis, and 2 went on to develop chronic pancreatitis. So, yes, microlithiasis is probably a cause of recurrent acute pancreatitis, but it does not explain in every patient, and some of them may go on to develop chronic pancreatitis too. So should all patients with microlithiasis or rather idiopathic acute pancreatitis recurrent acute pancreatitis undergo cholecystectomy. This is a meta-analysis of 10 studies of 524 patients with acute pancreatitis. The study, sorry for the want of time, I'll just jump my slides. The terms microlithasis and sludge have been used interchangeably. Early studies did not use EUS, and therefore this has led to proper misclassification. So we should suspect microlithasis if the LFT is abnormal within 24 to 48 hours of pancreatitis. EUS says rules, and if EUS, you have to do EUS in most of the patients to rule out microlithasis. And in patients when GB is normal on EUS and LFT is normal, there is no need to do a cholecystectomy. This is, I'm just briefly showing one case, a middle-aged gentleman who came into 3 episodes of acute pancreatitis, each occurring 1 month apart. MRCP showed a dilated MPD. We did a sidenoscopy, showed a little bulky ampulla. And at EUS, you can appreciate that there was a slight bulge at the ampulla with a dilated MPD. He underwent an EUS FNAC, and at FNAC, we could see adenocarcinoma. So in middle-aged age groups, one thing we have to be always cognizant of is the risk of pancreatic ductal cancer or neuroendocrine tumors as risk for pancreatic cancer. For recurrent acute pancreatitis. This is another patient. I'll just run through, if the chairpersons allow me 2 minutes. 23-year-old male who came in with first episode of pancreatitis 2012, continued to have recurrent acute pancreatitis. Each time showed elevation of amylase and lipase. Etiological evaluation is unremarkable. Follow-up for 6 years, and at 6 years developed chronic pancreatitis. There exists in a group of patients who come to us for the first time recurrent acute pancreatitis. A sizable population of them also have underlying chronic pancreatitis. Ramit from our study, from our center, showed in 71 patients recurrent acute pancreatitis, definite evidence of chronic pancreatitis using endoscopic ultrasound in 28%. Ruben, again in a group of idiopathic, slightly older age group of 31 years, showed definite evidence of chronic pancreatitis in 24.7%. So, just briefly, and what we have seen in a recent study from our center, that as we follow up this group of patients with idiopathic recurrent acute pancreatitis, the probability of developing chronic pancreatitis increases incrementally. So the critical step to progression for RAP to CP is the development of fibrosis, and the only way to identify fibrosis is histology. However, obtaining pancreatic histology is difficult, and therefore we have to really rely on surrogate markers like elastography, and one of the elastography tools is RF, or acoustic resonance frequency impulse imaging. And in using this tool, we have seen that in patients with early onset idiopathic recurrent acute pancreatitis, they have evidence of fibrosis very early on in their disease. Therefore, with the increase in the number of episodes, the shear wave velocity increases, indicating that the fibrosis keeps on increasing. So, ladies and gentlemen, to conclude, any uncorrected cause of acute pancreatitis can produce recurrent acute pancreatitis. Overall, the risk of recurrent attacks after sentinel episode of acute pancreatitis is 20%. RAP is probably the most important risk factor for progression of CP. Attempt should be made to establish a cause, and in individuals with idiopathic recurrent acute pancreatitis, we should always suspect underlying chronic pancreatitis. Thank you.
Thank you very much. That was a nice presentation, but a little bit too long because we ran out of time. So I don't think we'll allow any questions here. We'll conclude this session. But nice work anyway. Thank you.
We shall now move on to our offline real platform discussion, Pain Management of Chronic Pancreatitis by Dr. Roopjyoti Talukdar. May I request the chairpersons to please come on the stage. Dr. Sanjay Banerjee, Consultant Gastroenterologist attached with ILS Group of Hospitals, Kolkata. So could you please come on the stage, sir? Dr. Pratik Poddar, Consultant Gastroenterologist attached with AMRI Salt Lake and ILS Salt Lake, Kolkata. Dr. Gargi Nondi, the Consultant Anesthesiologist. Dr. Sanjay De Bokshi, Surgical Gastroenterology attached with AMRI Hospital, Mukundapur.
So good afternoon. Ladies and gentlemen, Our May I welcome here Dr. Rupajyoti Talukdar. He is a well-known clinical pancreatologist and clinical scientist at Asian Institute of Gastroenterology, Hyderabad. He is one of the topmost worker in the field of pancreatology, not only this part of the world, worldwide. He has more than 80 publications, and he will be speaking on pain management in chronic pancreatitis, which is a burning issue and is a difficult to treat problem in our day-to-day practice. Dr. Talukdar, please.
Very good afternoon, and at the outset let me thank Dr. Sujit Chaudhary, Dr. Sudipta, my good friends, and the whole Gemas team for this kind invitation and opportunity. So my job in the next 17-18 minutes would be to speak on the management of pain in chronic pancreatitis, and all of you are aware of the severity of the disease. I know you see many chronic pancreatitis patients in this city of Calcutta and whole West Bengal, and we do have an opportunity to see some of the patients that go from here. So we also have an idea of the type of disease that you see here. So coming to the pain thing, so this is the traditional understanding. Whatever be the etiology of pancreatitis, there will be inflammation in the pancreas, and that leads to transmission of the pain through the pancreatic nerves, dorsal horn, and to the thalamus. This is what happens from pancreas to the brain. But what the patient tells us is not only that. This is a very important thing that we should realize. It's the pain perception that the patient has, and the pain experience. It's not only the transmission, but the perception and experience. And that is not only impacted by what is there in the thalamus, but also what happens in other areas around the thalamus, like the hippocampus, which is an emotion controlling area of the brain, the prefrontal cortex, and the anterior cingulate gyrus. So all these areas in combination leads to the patient's perception and experience. And this is important because these are the areas which are responsible for pain processing, long-term pain memory. So patient having pain long time back can also impact their experience of recent pain, and the emotional responses to pain. And that is why probably different people respond in a different way to pain. So if you look at the natural history, the disease begins as inflammation within the pancreas, and if you see this, I don't know if the mouse works here. It's not working. Anyway, so if you see here in that video, you see microlithiasis, which Dr. Sudipta had just showed in his presentation. And this patient actually presented to us in 2014, where he had recurrent acute pancreatitis. And when he came back in 2017, just 3 years, he has florid chronic pancreatitis. There was a dilatation of the pancreatic duct, pancreatic stricture. So this is how this disease progressed. And what had been happening all this time is there was lots of inflammatory reaction and oxidative stress within the pancreas. Thank you. Yeah, it works now. So if you see here, this is a florid change in the pancreatic duct, with ductal dilatation here. There is a stricture here, calcification, and it just progressed over a period of 3 years. So this is what recurrent acute to chronic pancreatitis transition is, very rapid progression. And then, so these patients, it's important to recognize how the patients are presenting to us. The patient may present in two ways. One is just like an acute episode of pancreatitis, which can be treated just like an acute episode of pancreatitis. And the other way of presentation will be different patterns of pain without acute exacerbation. And it's very important to understand the patterns of pain, because that will help us design the treatment for short-term strategy and with a long-term strategy. So if we see here, the pain patterns are the patient may have fluctuating pain, or patient may have a constant background pain, and on top of that there will be acute exacerbations. Patient may have absolutely pain-free period with exacerbation, and there could be undulating pain. And this is the pain pattern which we have to deal with using short-term and long-term strategies. So short-term strategy, again, if the patient, I said, presents as acute exacerbation, treat as an acute pancreatitis. Otherwise, the patients can be treated using the WHO ladder for the short term. The WHO ladder says it should start with NSAIDs, but NSAIDs usually do not work in this kind of pain, so we can start with a low potency narcotic or low potency opiate derivative like tramadol or tapentadol. But the important thing here is it is very important to avoid high potency narcotics, because, and I'm saying this because now there is an increasing trend in India to use drugs like nalbuphine, buprenorphine. in chronic pancreatitis. But that should be avoided because if you see here morphine derivatives, firstly they can cause dependence, they can cause narcotic bowel syndrome, so they may relieve of pancreatic pain, but they give you a new disease. And the patient will come with constipation and narcotic bowel pain. And that is very difficult to treat. And thirdly, and most important, most unrecognized is, morphine derivatives cause mast cell degranulation, which leads to secretion of mast cell tryptase within the pancreas that can exacerbate the inflammation. Initially there will be pain relief, but in the long term the inflammation can persist. So it is extremely important to avoid high potency narcotics as much as possible. For a short course, fentanyl may be given in hospital under monitored setting, but in home care it should not be high potency. It should just be tramadol hydrochloride or tapentadol. Now let's move on to the long-term management. So if we look at the mechanism, why this pain happens within the pancreas, whatever be the cause, be it alcohol, be it smoking, increased ductal pressure because of stones or strictures, or autoactivation of thing because of genetic polymorphisms or inflammation, all of this will lead to something called stellate cell activation. And once the stellate cells are activated, again I don't have time to go into the details of stellate cell activation, what will happen is it will lead to generation of lots of free radicals, and that leads to oxidative imbalance between the antioxidant defense in the body and the pro-oxidant stage. So finally, the balance should be towards a pro-oxidant stage, which leads to lots of inflammatory cascade activation. And that leads to the recurrent inflammation that happens within the pancreas. So these are basically what I call the mechanistic targets, because these are mechanistic events that are causing the pain. So the pancreatic inflammation and the oxidative stress is what we call the mechanistic targets, which you should look at. So when there is inflammation within the pancreas, they will lead to sustained activation of the pain receptors, and this is called nociception. And because of this nociception, there will be constant transmission of pain stimuli to the spinal cord and the brain. So logically at this stage, since the main mechanism of pain generation is oxidative stress, antioxidant is what is the local or what is the logical choice of treatment. Now when I'm talking about antioxidant, there will be several antioxidants available in the market, but what is most important is the antioxidant that we give for chronic pancreatitis should have methionine. And when we did this meta-analysis using all the studies with methionine containing antioxidants, the number needed to reduce pain was found to be 5, which is pretty good. Anything less than 8 is supposed to be a good number needed to treat. And the composition should most importantly have these 5, at least these 5 components, of which methionine is most important, because in this whole oxidative process, there is something called a transsulfuration pathway, which results in exocytosis of zymosin from pancreatic acinar cell. When this transsulfuration pathway gets deranged, there is no exocytosis. So there will be small quanta of pancreatic acinar injury because of autoactivation of trypsin. But when we give methionine, we donate thiol donors to the transsulfuration pathway. It is restored, and then normal exocytosis starts, and that reduces the inflammation. So that's the mechanism how this works for chronic pancreatitis, and also in our experience in recurrent acute pancreatitis also, it seems to, I don't have randomized controlled data, but it seems to reduce the rate of recurrence of the acute pancreatitis episodes. So this is the importance of antioxidants in these patients. Now, which patient won't respond? Many of you must have used antioxidant and many patients do not respond. The patients who are actively abusing alcohol, taking smoking, elderly patient, chronic use of morphine derivatives, and long duration of CP when the pancreas is absolutely atrophic. There is no pancreatic tissue to generate oxidative stress. So in these patients, they won't respond. But the good thing is, in India, we mostly see idiopathic chronic pancreatitis, no alcohol, no smoking, young patients, and we usually do not use long-term narcotics. So in Indian patients, it's highly likely that methionine-containing antioxidant would work and should be initiated early on in the disease. That's very important. Now let us move on what happens after a few years, maybe 4 years, 5 years into the disease. If you remember those 2 CT scans, in 3 years' time the patient developed from recurrent acute to florid chronic pancreatitis. So in this stage we will have like pathological events like calcification, stricture, cirrhosis, there could be biliary obstruction, vascular complication. And in this stage, what is important is the initial assessment. What should we assess? First of all, it's important to assess the parenchymal volume of the pancreas, because that helps in determining the treatment. how much enzyme he would require or how much endotherapy he will require. Then the location of the calculi, that would determine which modality of treatment he will be benefited. Is it only stenting? Is it endotherapy, ESWL, or surgery? Then the ductal morphology, if there is any stricture, if yes, in which location, head region or body or tail, that will determine what treatment you would decide to give him. And finally, and most importantly, possibility of an underlying pancreatic mass lesion. Suppose these patients come to you with early, recent onset uncontrollable diabetes, rapid onset weight loss, change in pain character, new onset pain. These are the patients where we should be very vigilant about the presence of a mass lesion, and in this case, a pancreas protocol CT is a must. So these are what I call the morphologic targets. Earlier I talked about the mechanistic target where medical therapy was more beneficial, but here, besides medical therapy, because these are morphologic problems, so we have to deal with the morphology by interventions. What kind of intervention? So you are all aware of this, like it can be endotherapy in the form of either ERCP with pancreatic ductal stone, especially if the pancreatic stones are very small, less than 5 millimeter, towards the head or body. Or if the stones are big enough, more than 5 millimeter, it's ESWL. So this is how the ESWL is done in our center. And then for select patients, ERCP and stent has to be present. This is a stone fragment. If you see, it has come out from the pancreatic duct after sphincterotomy. And same here. So this is pancreatic juice flowing out after the sphincterotomy of the obstructed duct. Now, who will again respond to endotherapy? Like, is it that all patients should undergo endotherapy? No. Only patients who have an obstructive stone in the head region or up to the body region, like this, these are the patients who would respond to endotherapy best. And this is the beauty of ESWL. If you see here, this is the pre-ESWL image of a patient where you see a thick chunk of stone. After ESWL, the density has come down, meaning the stone has been pulverized. And finally, when we saline flush, this is the pancreatic duct with no stone at all. So this is the beauty, and you can see the therapeutic, the technical success immediately within few hours. For the clinical success, we need to wait for some time, and over 6 months, 1 year, we can come to the long-term benefit. And these are two of our papers, and there are many more papers currently published from global literature. And what we could see here is up to 5 years, there is almost 60% pain-free period in these patients. And this is the most recent paper that we published with an experience of over 5,000 patients. Now, which patient will not respond to endotherapy? Patients who have a full duct of stone, penductal stones, stones with local complication, gastric outlet obstruction, multiple strictures. So these are the patients who should not even be attempted for any kind of endotherapy. Directly, this patient should be sent to the surgeon. Because by doing endotherapy, you are wasting time, money, and also maybe you can give more complications which will delay the surgery. So these patients should be sent directly for surgery, and the surgical options would be LPJ or some resection procedure based on the morphology of the disease and the site of the stones and strictures. And the other benefit of intervention in these patients are, as you all know, patients with chronic pancreatitis are prone to develop diabetes. And if we see here, when these patients undergo early endotherapy, so this is a long-term series of over 500 patients which we followed for 6 years. And if we see here, patient who underwent endotherapy before the development of diabetes was delayed by around 4 years. So this is an added benefit of doing early endotherapy in these symptomatic patients who has obstructive ductal stone. But the thing is, this was more relevant only to the patients who had idiopathic obstructive chronic pancreatitis. Patient who had smoking-related chronic pancreatitis or alcohol-related did not have an improvement or delay in the diabetes. Now the problem is, again, this is an experience of all of you. Whatever you do, give medical therapy, do surgery, be endotherapy, these patients come back with pain. If you do endotherapy or surgery or even total pancreatectomy, a significant proportion of patients will come back with pain. So what is happening here? So this is where I would say that it's important to realize that the primary disease is not in the duct. So that's why even after removing the stone, something is still going on in the parenchyma, in the nerve. So it's important to understand the disease is beyond the pancreatic duct. And what happens in these patients? There could be two scenarios. in scenario 1, the patient may have a persistent ductal stricture or some morphologic abnormality, which should be treated as per the morphology required. But there is a second scenario where these patients have an intact sphincterotomy, they do not have stones in the duct, still they have pain. So what is happening in them? So here, what I would like to introduce to you is something called sensitization. So what happens in these patients as the oxidative stress and other inflammation goes on in the pancreas, this will constantly trigger stimuli which the patient perceives as pain. Initially, only the pancreatic segment will be affected, and that's why they get pain in the epigastrium and maybe in the back in the T10 level. But as this inflammation goes on, there will be inflammation even in the nerves and spinal cord. I don't have time to discuss the mechanism there, but what happens basically is the entire spinal cord, several segments above the pancreatic segment also get sensitized. So at this stage, even if you do a celiac ganglion block, the patient may still continue to have pain because these other segments are also sensitized. So when there is pain in the stomach, in the duodenum, or maybe even in the small intestine, the patient may perceive that as pain. This is sensitization. And how do we see that? We see that, I said this is all these are spinal sensitivity, and then the whole thing changes in the brain, and that leads to a different perception of pain or low threshold of pain, which is called central neuroplasticity. So how do we see that? It's very difficult to identify that in the clinical, routine clinical practice. So there is something called pancreatic quantitative sensory testing that we are currently working on. So here we try to give different kind of stimuli to different segments, and then based on few algorithm and arithmetic, we do calculate the scores, and that tells us if the patient has neuropathic pain or nociceptive pain. And this is another very new thing we are trying to do, adding QST with EEG and autonomic changes. So this is myself, I was the first healthy control in this study, and this is one of my research coordinator doing the test in a patient. So based on that, we can say the patient has either segmental sensitization if only the pancreatic segment is stimulated, and the widespread sensitization or global sensitization if more segments are activated. So since this is not available in routine clinical practice, we have also tried to look at if we can find clinical surrogates by which the general practicing doctors can use. And what we found here in this study is if the patient has or gives a history of involvement of new areas of pain. If he comes to you and says, now I have more pain in different areas, the pain goes to different areas, and the patient has long-standing diabetes and has significant depression. So these three are independent predictors which can tell you that, yes, this patient has neuropathic pain. That is why it's extremely important to take a good pain history. It's not about just asking, do you have pain or do you don't have pain? It's very important to ask if the pain has a change in character, if there is a new areas of involvement of the pain, if the pain has involved other parts of the body, so if the radiation pattern has changed. So these are more important questions to ask rather than asking having pain or not in order to identify neuropathy. And then if these patients have signs of neuropathy, the best available modality we have now is pregabalin. There are no other studies so far, but we are currently doing a study on using non-enteric coated pancreatic enzymes to see how much it affects pain. I think the results will come sometime in the early next year or mid of next year. And then the other strategy that we have more minutes is to combine antioxidant, methionine containing antioxidant with pregabalin. And this we had published like a few years back, and where we could show that the combination, if the patient is using combination at 2 months and even at the end of 6 months, there is a significant persistent reduction in the pain. So it's not only pregabalin, adding antioxidant could help for a longer pain relief in this patient. And finally, what happens, I talked about oxidative stress, I talked about the mechanical targets, I talked about sensitization, but what happens, just like any other chronic disease, as the disease progresses, these patients tend to have anxiety and depression. This is known, any other chronic kidney disease, chronic cardiac illness, they also have depression. But what is so different in the depression and anxiety in chronic pancreatitis? So this is what we tried to look at and just published this year, like 2 months back, and there were more than 600 patients and control. Almost half of these patients had some degree of depression, but what was more intriguing, when we looked at the brain using magnetic resonance spectroscopy into the metabolites, if you see here, I'm not sure if you can see the graphs here, it may be too bright. So in the patients who had severe depression, chronic pancreatitis and pain, in those, in the hippocampus, the important brain metabolites are very reduced. And when we tried to do some kind of bioinformatic analysis, there was a significant negative correlation with the metabolites in the hippocampus, specifically this metabolite called N-acetyl aspartate, with the level of depression and severity of pain, which means that what is happening is probably been regulated by the hippocampus to the change in metabolites. So what to do about this? We started counseling this patient, talked to them about their disease and their outcomes, answered all their questions, spent 35 to 40 minutes with each patient. And what we see was, this is pre-education or pre-counseling, the proportion of patients who had depression, no depression, were depression-free and pain-free, significantly more after 3 months after post-counseling. And when we looked into a little bit more, there was improvement in the pain score, improvement in the pain episode, improvement in the emotional factors and quality of life. So what does it mean? By doing a good counseling, if the patient starts understanding their disease, probably there is some metabolomic changes in the brain and they start coping with their pain. Because we are not doing anything to the pancreas by counseling, so why should they have reduced pain? It should be probably being regulated in the brain, and now we are doing it in a bigger way. We are doing a randomized controlled trial and looking at some mechanistic aspect with functional MRI, and probably next year I might be able to tell you the results. So finally, if we look pain as a holistic, from a holistic perspective, this is what everyone knew from many, many years: pancreatic change in morphology, pancreatic inflammation, sensitization can cause pain, but now we learn more that it can also be related to altered pain metabolites, brain metabolites, widespread sensitization, descending inhibition, all neuropathic events, anxiety, depression. There could be stress. We have data on stress, adverse quality, life events, all these data I have not shown you today for lack of time, but we have the data that shows that can aggravate or modulate pain. And finally, poor quality of life. And the good thing is all of these have some form of treatment or other. For morphology, we have endoscopy, surgery, antioxidant, and there are several other treatments that has been attempted. No strong data. We need to do more multi-center randomized control trial. Probably that would give us more insight how much it will be beneficial. So finally, ladies and gentlemen, the take-home message is antioxidant should be started early on in the disease at the right dose, at least for 3 to 6 months. If need be, it can be extended. Endotherapy or intervention, be it surgery, ESW, should be done if the patient has obstructive ductal stone or stricture with recurrent pain. That may also give them the benefit of delay in the onset of diabetes. If the patient has signs of neuropathy, pancreatic neuropathy or central sensitization, neuromodulators is the way to go. Antidepressant, I don't use much, and there are no strong data for the use of antioxidant in this kind of situation. And all throughout the treatment duration, the patient's nutrition should be given importance. That's a very common thing that we overlook in clinical practice. Nutrition is extremely important. Just giving a pancreatic enzyme replacement is not enough. They have to be given supplements. Personalized counseling is a must, and cessations, alcohol, smoking, dietary modification, those things should be taken care of. So finally, I'd like to acknowledge all the people who have been working with me. So these are the people who had contributed to the most of the data that I have shown, granting agencies and the collaborators. Thank you very much, and I'd be happy to take questions if time permits.
I just want to add something. I am interventional pain physician working at ESI Institute of Pain Management, Kolkata. Dr. Talukdar nicely addressed all the aspects of the management. I just add on what we do. The celiac plexus block and now the radiofrequency ablation of the splanchnic nerve is coming into the area, and it helped to reduce pain for almost 2 years. So, in the meantime, the central sensitization is settles down, and we also do the IV desensitization with the ketamine, which is address the NMDA receptor, which is the main part for the central sensitization. And we also use the combination of the TCA and the pregabalin, which you tell. So these are the part where we can do some intervention, but it should be the holistic approach, as Dr. Talukdar said.
So I think we are short of time. We are running late, so we can move on to the next session.
Thank you.
Thank you.
Thank you. Thank you very much, sir. We shall now proceed to our session on bariatrics. May I request the chairpersons to please come on the stage. I'd request Dr. Shundip Chakraborty, consultant gastrosurgeon from AMRI Group of Hospitals. Sir, you are requested to be on the stage. Dr. Badul Dash, consultant surgeon from AMRI Group of Hospitals. Dr. Vijay Rai, consultant gastroenterologist attached with Leave Gastro Hospital. Dr. Siddhartha Bhattacharya, consultant surgeon attached with AMRI Group of Hospitals, Kolkata. Dr. Udipto Rai, consultant surgeon in Medica Super Speciality Hospital. Dr. Nikhil Sonthalia, consultant gastroenterologist from Apollo Group of Hospitals.
Hello. Our next speaker, he doesn't need any introduction. Sarfaraj. He's a bariatric and laparoscopic surgeon at Digestive Surgery Clinic, Kolkata. He's the head of the GI Minimal Access and Bariatric Surgery at Bellevue Clinic, Kolkata. Ex-assistant professor of surgery, Medical College, Calcutta. He's a vice president, Hernia Society of India, and EC member in IIGS and OC. He has authored several books and chapters and has 20 international publications. Sarfaraj.
Thank you very much, Sandipda, and thank you very much for making me at ease. Whenever I come to present in front of erudite physicians, it is very difficult to not stay nervous. I'll try not to be nervous in front of you, ladies and gentlemen. I bring greetings from this beautiful hospital, Bellevue in Kolkata. That's where I work. And I've been given a daunting task of talking about role of bariatric and metabolic surgery in GERD and CLD, chronic liver disease. And I thought that how should I present this to an august and esteemed audience, and I'm glad that I have most of my surgeon friends on the chair. So it's going to be a little easy. I'll start by breaking into two. First, I'll take up the chronic liver disease and then the GERD. You know, this is a medical problem, right? Chronic liver disease. And I'd like to differ on this. It's also a surgical problem to some extent. And the reason why I think that it could be is because for NAFLD and NASH, it has been seen that obesity is a significant risk factor, so much so that almost about 60% of these patients are obese. And if you look at the cirrhotics, if a medical gastroenterologist managing a cirrhotic in a lean patient versus a cirrhotic in an obese patient, this is the difference. There's poorer survival, severe hepatic decompensation, 3 times more in fact, according to one paper, poor eligibility to liver transplant, poor outcomes after liver transplant, and higher non-response to antiviral therapy. It is not that this disease comes alone. The chronic liver disease of NAFLD and NASH doesn't come alone. It comes as a pack of wolves, which is called the metabolic syndrome. And it stands to reason if there's a metabolic syndrome in a patient having diabetes, hypertension, cardiac disease, sleep apnea, arthritis, fertility issues, and NAFLD and GERD, it stands to reason that the underlying reason, which is obesity, should be addressed. And if you look at the review published just 2 years back, the weight loss is the mainstay therapy of these diseases. Now, this is a video of this patient which we operated recently. She's just BMI 37. And you see the liver is BMI 37. It's not even like BMI 50 or 55. We're just talking about BMI 37. It's so difficult to get the liver out. And that's the kind of liver that I think the physicians are trying to treat. Now, which suggests that it is not about the weight or the BMI that we're talking about. We're just talking about the visceral obesity and how much it influences the health of a person, especially the liver. So what about the impact of weight loss? If the obesity is the cause of NAFLD and NASH to a large extent, what is the impact of weight loss? It is usually seen, and I heard it in so many conferences, that we talk about a 5% weight loss. But if you look at the SOS study, if you need some significant clinical benefit on metabolic diseases, you need a 15% weight loss, which is to be sustained. And that, ladies and gentlemen, brings us to the most important point. That is, it is difficult to achieve anything more than 5% through diet, activity, and drugs. 95% of patients, according to one study, fail despite the best possible efforts. So there comes the question and the entry of surgical weight loss. Would we do it as a recommendation in many patients? I don't think there's a large subset which would benefit from this, but there's definitely a subset which would benefit by considering bariatric surgery in chronic liver diseases such as NAFLD and NASH. Let's look at this paper from France, 180 cases followed up for 5 years. These patients were severely obese, BMI more than 35, liver biopsy proven NASH. They underwent metabolic and bariatric surgery. And out of these 180, 80% stood through follow-up. And after 5 years, liver biopsy was repeated. And what did they find? Resolution of NASH in 84%, fibrosis decreased in 70%, and fibrosis disappears in 56%. And this reduction of fibrosis is accruing. So at 1 year, 2 years, 4 years, 5 years, and maybe more, this fibrosis is still going down. We don't know how long. So it was recommended from this paper that there is histological reversal of NASH and regression of fibrosis. This is something unthinkable. 20 years back when my professor, Dr. Gautam Chatterjee, taught me, I didn't think that cirrhosis would be a irreversible, reversible disease. It was absolutely unthinkable. But today, in 21st century, 2022, we might consider that as a possible finding. In fact, the AGA guidelines also say that. Now, let's look at the next very important study, the Splendor study coming from Cleveland Clinic. And what did they do? They saw 1,158 patients which were enrolled in the beginning of this 21st century. 650 underwent bariatric surgery, 508 were under non-surgical treatment. That's medical treatment for their NASH. They were all biopsy-proven NASH. So again, we are looking at biopsy-proven NASH. Let's say 600 in each arm for simplicity's sake. And the median follow-up is 7 years. What were they looking at? They know that there is difficulty in getting liver biopsies from large group of patients. So they looked at clinical outcomes. And what were these adverse clinical outcomes? Did the patient progress to cirrhosis? Did the patient develop hepatocellular carcinoma? Did the patient undergo a liver transplant? Did the patient have a liver-related death? And they were clubbed as adverse liver outcomes. And what was the finding? They found that the surgical group had 2.3% adverse liver outcome versus 9.6%. That's 4 times more in the medical arm. With that, I think it is probably okay to say that if a patient has NASH, the patient must be given an option of surgical weight loss with this data suggesting this is your risk reduction. And the decision should be based by a discussion between the gastroenterologist and the patient. What about impact of bariatric surgery in cirrhotic patients? Now, this is a very dicey area, and looking at it, I thought maybe there are very few centers in the world which do it. And those who do it, I've just done 2 cases, so referred by another center to optimize these patients. And we always choose a very, very well compensated patient. So they are like very good patients. But many of these centers who do it on a much sicker patient. And here is a systematic review. Look at it. Initially, obviously, the background is if you have a morbidly obese patient who is going for a liver transplant, the technician, the surgeons might say, no, I'm not going to do it. It's too difficult technically. Or they may have so many comorbid conditions that the medical team might say, no, we're not going to take this. So the aim was to see whether the bariatric surgery prior to the liver transplant, during the liver transplant could help, A, and B, if the liver transplant already done, would bariatric surgery in the morbidly obese patient help the liver to survive more? And what did they find? Not a big paper, just 187 patients in group A, 32 in group B, and 64 in group 3. And that's all the literature is. But let's see what wisdom we can find from this literature. If you do bariatric surgery before liver transplant, 82%, more than 80% of patients became eligible to get listed for liver transplant. That's a great thing. These patients were initially ineligible for the liver transplant. And the 30-day mortality of the bariatric surgery was 0. Major complication was seen in 1%. And the 1-year graft survival, 70%, pretty good. So this seems to be a great idea, something that most surgeons are toying with, and there are many centers who are actually looking into this. What about bariatric surgery with liver transplant? Very few numbers, less than 50. 30-day mortality 0%, and 1-year graft survival 100%. Not much of meaning because of the low numbers, but it is encouraging. What about bariatric surgery after liver transplant? Now this is the Waterloo. There were 5 deaths beyond 30 days, and these are less than 100 cases. So what it means is that maybe after liver transplant, what the patients need is a better nutrition, and the bariatric surgery might be depriving them of a good nutrition in that phase of time, or the immunosuppression may also be hampering the good outcome. Whatever be said, the guidelines from the meta-analysis is that the bariatric surgery is safe and effective as a bridge to liver transplant in selected patients who would otherwise be ineligible. And the same thing was reviewed again by the 2022 systematic review, that it should be done for well-compensated cirrhosis. So not uncompensated cirrhosis at all. Let's go to GERD. What is the role of bariatric surgery in metabolic surgery in GERD? Well, let's look at the relationship. It seems that GERD is common in general population. I mean, all of us have it once in a while. 1/4 of the patients are actually clubbed as GERD in general population. But when you look at severe obesity, that's like 3/4, 73% in one paper. So obesity definitely has a relationship with GERD. And it is not only that the obesity has a relationship with reflux, it has also a relationship with endoscopic esophagitis, esophageal adenocarcinoma, and Barrett's. Is that independent? Yes, it is. It is not directly only related to the GERD symptoms, but the endoscopic findings are independently related with GERD. We know now that many patients who have GERD may not present with symptoms. They may be having a chemical esophagitis going on in their lower part of esophagus, and then they can have Barrett's and cancer. In obese patients, is it true? Yes, probably more so. In one study which looked at more than 200 patients, they found that 12% of these patients who had no reflux were going to go for bariatric surgery, and they had endoscopic severe LA grade 3 esophagitis. So which is pretty much something that we need to be aware of. What can be the cause? Well, we know that the obesity comes with raised intra-abdominal pressure. A hiatus hernia is seen in almost about 20% of cases. And manometric studies, as in this particular paper, showed that many of these obese patients have a lower esophageal sphincter pressure and esophageal dyskinesia. And it is very common for us as bariatric surgeons to see these hiatus hernia. We need to bring them back. We have to dissect all the sac and then do a cruroplasty to make sure that this is not going to cause a reflux in the post-operative period. So this, and then what procedure to be done? That's what comes next. Now, this is a good paper which talks about is an obesity linked to GERD, or is there a specific obesity which is linked to GERD? And it seems that it is a central obesity or an android obesity or a visceral obese, whatever you may want to call it, it doesn't matter as long as we understand that is the visceral obesity or android obesity which causes more GERD than the gynecoid obesity, which means there is more intra-abdominal pressure and there is a metabolic syndrome working. Again, same thing. People have looked into the manometry in these morbidly obese patients, and they found that the intragastric pressure and gastroesophageal pressure gradient had a correlation with waist circumference, but not the BMI. So my question to this elite audience, in fact, I might like to have a comment from you all. Do you think that GERD is a part of a metabolic syndrome? Or do you think it's only mechanical intra-abdominal pressure which is causing it? And I think there's so many learned people out here who can answer this question. It is true that when you see a patient of GERD, your mainstay therapy is PPI and probably prokinetics, and that would cover a large population. But there would be some times where there's a large hiatus hernia, refractory treatment leading to poor quality of life. There's some adverse effects of PPI which is now brewing up, and the patient has a severe esophagitis. Then what do? Do you still recommend PPI or do you move ahead with surgery? Looks like that most of the international experts would believe that surgery can be considered in this group. But then, as a physician, what would you refer them for? A fundoplication or a bariatric surgery? So let us look at what is the preferred surgery in patients with obesity and GERD, and I'm talking about severe GERDs now here. So if you look at the literature, there might be proponents of each group, fundoplication group as well as the bariatric group, but you would find that there are more literature which suggests that fundoplication fails in patients with obesity. There's 31% recurrence in obese GERDs, whereas in non-obese GERDs there will be a recurrence about 4.5% at fundoplication. And in one paper, another paper, very important from a large group, showed a quarter of the patients had reoperation or dissatisfaction after fundoplication. So it's possible that the bariatric surgery would work better for your obese patient with GERD if you are considering surgery. And if you look at this patient, this particular very important paper, old paper but very important, they looked at 238 patients, out of which 152 had Roux-en-Y gastric bypass for severe obesity and severe GERD. And when they followed them up after 6 months with the GERD questionnaire, they found that 80% and more had no GERD symptom and 97% had no PPI after 6 months. And the next paper which I'm quoting is where they did not only look at GERD questionnaire but looked at the esophageal manometry and 24-hour pH monitoring. So better paper, much better, more objective evidence. And what did they find? Not only the reflux symptoms are going down, but even the esophageal exposure, esophagitis also went down. And in another paper with Barrett's esophagus, published only 2 years back, they looked at 8 studies with 117 out of 10,000 patients with Barrett's, and they found there was endoscopic regression of both for short and long segment Barrett's after Roux-en-Y gastric bypass. And that is a great thing, I feel. I have mentioned only in bariatric surgery Roux-en-Y gastric bypass, not mentioning sleeve, whereas I think in liver transplant, most of the times I was referring to sleeve gastrectomy. And why is that? Because as far as sleeve gastrectomy is concerned in bariatric surgery, it is considered to be a potential contraindication to a GERD patient, and people who employ sleeve also do a chloroplasty and sometimes a Nissen fundoplication with their sleeve to make it anti-reflux, because sleeve is a potentially refluxogenic operation. So probably when you are referring a patient for bariatric surgery or you're referring a patient for GERD in a severe obesity, then a Roux-en-Y gastric bypass is probably a better option to be considered. So what are the take-home messages from this particular talk? A, mainstay therapy of chronic liver disease, NAFLD, NASH and cirrhosis, of course, medical, it's weight loss. But in a select patient, especially in NASH, the role of surgery is great, and the evidence mounting cannot be neglected. They are too important to be not shared with the patient. And I think bariatric surgery will have some role also in dedicated liver transplant centers where they would get a bariatric surgery prior to the liver transplant to optimize them and make them eligible. As far as GERD is concerned, I think there's a more relationship with central obesity than just the BMI. And it's important to get these patients weight loss, not only for the GERD, but other parameters of other factors or other diseases in the metabolic syndrome. They will benefit, some of these patients will benefit from bariatric surgery. This select group should be referred to bariatric surgery. And if it is done, then it is better to get them a Roux-en-Y gastric bypass than a sleeve gastrectomy. Thank you very much for your attention.
Thank you, Sarfaraj. Excellent presentation.
Thank you.
We are convinced. I'm not sure about how the endocrinologist, if there are any in the hall, they would counteract or compare along with the bariatric surgery and the recently new SGLT inhibitor agonist, the semaglutides, what's their effect on obesity or the NASH. Now, my question is, how do you select your patient for bariatric surgery with the NASH patient, and whom do you consider going ahead with the bariatric surgery?
Right. So when we get our patients, it's basically for obesity at our clinic. We do not get referred for NASH. We get referred for obesity. And when we do their workup, we would find NASH or NAFLD as a part of the metabolic syndrome. It is not common for us to receive patients from gastroenterologists saying, I want a bariatric surgery for NASH. So that is something that we need to differentiate right now. But when we do our workup, we would say that almost a quarter of our patients are already in an AFLD or NASH state. It's already. We do not have a liver biopsy as a preoperative protocol. But intraoperative liver biopsy is something that we take these days. That, like, for example, the patient I showed, that patient would have a liver biopsy and to document that this is NASH, and then we would follow them up and would encourage them to also undergo a liver biopsy later on for academic purpose as well as their own good to know whether they're progressing or not. So having said all that, I think we do not yet get patients coming directly for bariatric surgery for NASH, but there would be a time when patients would get to know these literature exists and the benefits of the surgical weight loss on NASH, and there will probably be some time in the future when these patients would be referred for NASH itself. So, but I think we do not know right now how much of what we are doing, but we do all our BMI more than 35 patients with metabolic syndrome as bariatric surgery.
Yeah. Can I ask a question?
Yes, please.
So, there are multiple meta-analysis in endoscopy journals showing efficacy of endoscopic sleeve gastroplasty in NASH patient. So, what is your take on laparoscopy versus endoscopic sleeve in this group of patients, especially taking consideration the technical difficulties in presence of portal hypertension?
I think Dr. Amit Meadow was supposed to take a bariatric endotherapy lecture. If he does take that, he's probably going to attend to that. ESG has been around for about 6 to 7 years now, and the short-term data shows about, the meta-analysis showed about 15 to 18% weight loss, TWL, and they showed encouraging results. Now, as a surgeon, I have done gastric plication about 12 years back when it was popular in Europe, and this is the laparoscopic equivalent of the ESG. And after 2 years, I gave up because I found that none of these results were sustainable, number one. And number two, they were not as devoid of complications as we thought. There would be halitosis, which I see now in the ESG patients also. And finally, I think we revised all our gastric plication, the 32 gastric plication that I did between 2009 and 11 after about a year or two. So even these patients probably may not be that sustainable, but I think that that's a good area of research, and we are watching that space very carefully. We are into it already, so we will be watching and we'll be seeing what it can do.
Yeah. Dr. Beg, we in day-to-day practice, we commonly across patients where they have gone to the surgeon for lap chole and the surgeon opens up and they found that the liver is cirrhotic. They just close the abdomen and they send back the patient without even removing the gallbladder also. And in other scenario also we have seen the patients who are having the calculus cholecystitis and they are cirrhotic patients. They are stable patient. They are referred to the surgeon for operation of the gallbladder, and when the surgeon opens up and he sees a lot of collaterals and vascularity, they just close down and they again send back to the physician.
Okay.
So it seems that it is very challenging, it's very difficult to do the surgery in the cirrhotic patients. So what is your experience when this decompensated patients who are having obesity and they are planned for the liver transplant, what is the success rate and what is the risk involved in reducing the weight by bariatric surgery in such kind of patients?
I'll take that, the first part of the question, which is easier to answer. If the patient with has been referred for a laparoscopic cholecystectomy and the surgeon finds an incidental cirrhosis or a NASH difficult technically to operate, then I think the surgeon has to decide A, whether it's technically okay to do it, where is he doing the surgery, what is the preoperative liver function test, what is the albumin level, what is the SGPT level, does he or she sees a ascites in the abdomen, is there portal hypertension. If these things are unfavorable, it's better to back out and refer it to another center who can do it. And also, you need to know the indication for the surgery. An asymptomatic gallstone would probably not merit the surgery. So many factors can be considered before the surgeon takes a decision of moving ahead with a laparoscopic cholecystectomy or not. I think a good center, Laparoscopically trained, good dedicated center can do most of the laparoscopic cholecystectomy, even in a cirrhotic, even in an NASH, and that can be done. Now coming to the second part is bariatric surgery, whether you would then do the bariatric surgery with. So we get so many patients where we are doing concomitant cholecystectomy with a sleeve gastrectomy or concomitant cholecystectomy with a Roux-en-Y gastric bypass, because these patients, and I would tell you that almost a third of these patients have very bad liver. And even when we put them on a diet program, a very low calorie diet, 10 days prior to the surgery, the size of the liver is still huge and difficult to manage in many situations. So, yes, it's doable. Any good dedicated center who is managing bariatric surgery would be able to do a cholecystectomy for these severely obese patients as well.
Thank you very much, Sarfaraj. I think we should pack up now. We move on to the next session. Thank you very much.
Thank you. Thank you, sir.
So thank you, sir. Two important announcements. First, due to some technical glitch, we could not communicate with Dr. Amit Mehdev. So we will break for lunch now. And another thing, that lunch time is shortened, so we will meet after 30 minutes. Thank you.
The post session will begin with the case-based management of IBD by Dr. Vinit Ahuja. May I request the chairpersons to please come on the stage. Dr. Shujit Chaudhuri, Senior Consultant Gastroenterologist from AMRI Hospital, Kolkata. Dr. Joydev Roy, Consultant Gastroenterologist attached with EDF Hospital, Kolkata. Dr. Sanjoy Mondol, Consultant Gastrosurgeon attached with AMRI Group of Hospitals, Salt Lake and Mukundapur, Kolkata.
Professor Vineet from AIMS will deliver the talk. Please start.
Good afternoon. Thank you very much. I'm grateful to Dr. Sujit Chaudhary for inviting me to Calcutta, and we had a delicious meal, absolutely top-end meal, and I'm really thankful to you for that. Okay, so I'm supposed to talk about case-based management of IBD. Today, when we talk about IBD, there's so much going on out here that we are talking about what is known as therapeutic ceiling. Therapeutic ceiling is that you give a drug, it achieves efficacy 60%, 70%, not beyond that. You have a medley of drugs, one after another, but none of them go beyond 60% or 70%. So you're talking about how to go above that, how to go into the supra-atmospheric level and all. And it is a question of getting faster, stronger, higher. Like initially we talked about symptomatic response, then we talked about normalization of CRP, comes up fecal calprotectin, and you want to normalize it. Then we talk about endoscopic healing. These are already there. These are all established norms now. And what is coming up in 1 or 2 years is addition of histological healing or transmural healing for a patient with Crohn's disease. So it's a case of getting faster, stronger, higher. That is what we want to do. And why do we want to do that? We want to do that because we know Crohn's, it has a maddening behavior. It just keeps on progressing from inflammatory disease to a stricturing disease to a penetrating disease, and it causes mayhem for the patient. You have patients who start with just few ulcers, and subsequently they may develop strictures, they go on to develop fistula. Ulcerative colitis is also not that innocent. Ulcerative colitis, you feel a patient has proctitis, and a few years later you find the patient has come up with a major relapse, whereas the patient has progressed on to pancolitis while still being on treatment. You do have the yin and the yang in the sense that some patients do have pancolitis to start with and go on to subsequently mellow down and have proctitis. At the same time, these are inflammatory chronic diseases. There is a lot of proliferation going out, a lot of restitution going on. So what is it going to lead to? It is going to lead to epigenetic mutations and all, and that will lead to cancer. So you have a high risk of cancer in these conditions in Asian countries or in India, where sporadic colorectal cancer incidence is low. Despite that, the cancer after colitis is very high. So comes up this equation. The equation is, on one side you want to go faster, stronger, higher. You want to achieve unbelievable targets. Not only mucosal healing, which is endoscopic healing or symptomatic healing, but transmural healing. You want to restructure the whole intestine the way God made it, like absolutely neat and clean. On the other hand, what do you have? You keep on adding drugs. You keep on sequencing drugs. You have multitude of drugs. And each of those drugs are based on changing the aberrant immune responses. In other words, if they have benefits, they have major side effects. What does the patient want out there in middle? The patient wants that the life should be less complicated. The patient wants non-invasive monitoring modalities. The patient wants the long-term outcomes should be improved. In fact, so when I'm going to talk about case-based today, I'm not going to, I thought that I'll take approach generally not taken, where we talk about cases, they're very tough cases, how do you sequence your therapies, we all have discussed a lot about it. Today, I'm going to talk about, when I'm going to talk about a few of the case scenarios, I would say, is when patients are stable. When they are on stable remission, they are doing well. What do they want and what do you do? What they want is very simple. They cannot take medicines endlessly. They cannot take 5 drugs every day endlessly. They want to stop. They are doing well. They want to know that if I stop therapy, what will happen? Why not I reduce therapy or stop therapy? So let's talk about a very mundane topic, I would say. This is not a glamorous topic at all, but a mundane topic. Maintenance therapy, what are the scenarios? First of all, is maintenance therapy necessary for patients with ulcerative colitis in remission? We have been all brought up with the general philosophy that patients with ulcerative colitis, you have to endlessly treat them. There are only 3 randomized control trials which are available for this scenario, and one of the major, the trial which had the maximum number of patients, I am putting up out here. These are 112 ulcerative colitis patients who were in clinical, endoscopic and histological remission on 5-AS or sulfasalazine for at least 1 year. Thereafter, for one arm, Asacol was given. For the other arm, they were given only placebo. All therapy was stopped. What happens? For patients who were in remission for only 1 year, it was seen that the relapse rates were definitely higher. But for patients who were in remission for more than 2 years, the relapse rates were similar, clearly suggesting that yes, if you stop therapy, in the short-term basis, on the short-term run, you are not causing any harm. So should we practice this? In fact, this is what the study said. The conclusion of the study was that it cast doubt about whether continuous maintenance therapy is necessary in patients with prolonged clinical, endoscopic and histological remission. But yes, we know that ulcerative colitis or Crohn's disease, both of them are pre-malignant conditions. So you need to give some kind of anti-inflammatory therapy. So there comes in the role of 5-ASA maintenance therapy, since it is safe, reduces the probability of relapse, and also reduces the risk of colorectal cancer. So en bloc or blanket suggestion cannot be that you stop therapy of 5-ASA in patients with clinical, endoscopic and histological remission. Yet at the same time, a discussion can be considered. A discussion with the patient can be considered that there are selected ulcerative colitis patients where you may consider stopping therapy. Patients like patients with proctitis who have been in clinical endoscopic remission, patients who have been in remission for several years, that may even include patients with proctosigmoiditis, patients who have had a history of one or single disease flare only. Why do you want to endlessly treat them for decades and decades? Patients who have not required systematic corticosteroid therapy. So these are suggested situations where one may consider stopping therapy. At the same time, remember that patients who have had extensive colitis, who have had frequent disease relapses, acute severe colitis, it's a no-brainer. Don't even think about stopping therapy. Okay. Next question the physician would ask is, can I decrease the dose of 5-ASA? The patient is on 3.6 gram. Can I decrease it to 2.4 gram or to 1.2 gram? If you look at the effective dose for maintenance, that is 2 to 2.4 grams. But this comes with a caveat. This comes with a rider. The rider is adherence is high. If the adherence is high, then you can safely reduce the maintenance dose to 2 to 2.4 grams a day and carry on with that. If the adherence is not good, then in those cases, there is no point. If the patient is doing well on 3.6 grams and you reduce the dose, there's a very high chance that the patient would go and have a relapse. Now let's come to 5-ASA. 5-ASA is something like bread and butter or something like that. It is in terms of any patient with ulcerative colitis and some patients with Crohn's disease, 5-ASA is given. So you have various combinations of 5-ASA which are being given, which is actually very good for the pharmaceutical company. But what about the patient? And as we are used to writing so many prescriptions, so we just say continue same, continue same. These are the various situations. 5-ASA plus azathioprine, 5-ASA plus biologicals, 5-ASA plus azathioprine plus biologicals, 5-ASA plus IV steroids. Would you continue 5-ASA in these situations or not? What does the data say? There's a population-based study which was done in US and Denmark. This talks about stopping 5-ASA in patients with UC who was started on biological therapy and found that there was no increase in the risk of relapse or adverse clinical outcomes, suggesting 5-ASA can be stopped if you are starting biological therapy. This is continued 5-ASA use after initiation of anti-TNF or immunomodulator. Again, continuation of 5-ASA does not offer any benefit to patients with diabetes. You can safely stop 5-ASA out here. What about antimetabolites? Azathioprine, methotrexate, azathioprine plus 5-ASA. Would you like to continue 5-ASA? Again, there is data now which shows that there is no benefit of continuing, or it shows both ways, that it was equal, continuing and stopping, so you can have the choice of stopping 5-ASA. All our patients with acute severe ulcerative colitis, they're put hospitalized, they're put on IV corticosteroids. Most of the times we never stop 5-ASA. If you go to any of the big conferences, the question would be asked that should somebody would get from the audience and say, should I stop 5-ASA or not? Nobody knows the answer. Very recent trial from Israel, which has come up in CGH, which shows, there's a randomized trial which showed that corticosteroids and mesalamine versus only IV corticosteroids, you need not give 5-ASA in this situation. So in all the 4 situations, 5-ASA plus biologicals, whether starting or continuing, 5-ASA plus azathioprine or methotrexate, 5-ASA plus IV corticosteroids, you don't need to give 5-ASA, you're not causing good to the patient. What about azathioprine monotherapy in IBD? Azathioprine, particularly, it's something which is no longer what I would say the favorite of Western world, but yes, in Asia Pacific countries out here, still South Asia, it's still a very, very useful drug. And this data from North India shows clearly that patients who have been on azathioprine for 3 years, 5 years, 10 years, still have an excellent cumulative, they have a very poor, low relapse rate, excellent response rate, showing thiopurines remain a viable long-term option. What's the problem out here? The problem out here is that many of us have been taught over the years that thiopurines do not continue for more than 4 years, do not continue for more than 5 years. They have a high risk of lymphoma. Yes, they do have a risk of lymphoma, no doubt about that. But is it possible that it's a little hyped? Because again, if you look at data from North India, you find that patients who were on thiopurines for a long time, and this is a group of 1,000 patients, of which 250 patients were on thiopurines for more than 5 years, 70 patients on thiopurines for more than 10 years, it was seen that although no case of lymphoma occurred out there, no case of skin cancer occurred out there, but yes, it shows that, it doesn't show that the risk is negligible or zero, but at the same time it shows that the risk is definitely low. What do you do when you stop thiopurine? What is the relapse rate? Well, it seems, as the study showed, that if you don't look at the table, it's a little complicated. I'll just explain to you. If you stop thiopurines early on, let's say within 2 years, 3 years, the risk of relapse is high. If you stop thiopurine after 4 years, the risk of relapse goes down. In other words, the more you continue with thiopurines, the lower the relapse rate would be. If you stop thiopurines early, the relapse would be very high. So if you want to withdraw immunomodulator, do not be in a hurry. It's a very good drug. If patient is doing well with it, continue with it. You can discuss with the patient. You can go up to 7 years. I've shown you data for 10 years also. So especially in patients who have achieved long-term remission, it will be better and prudent to continue with immunomodulator monotherapy. You can stop 5-ASA in this situation. They need not take 5-ASA. What about combination therapies we give? Biologicals and azathioprine, or biologicals and methotrexate. Do you have to continue both these drugs together, or do we really need to give both the drugs? Why do we give azathioprine in such a setting? We give because of antibody formation by monoclonal antibodies. Infliximab, 31% risk. Adalimumab, fully human monoclonal antibody, the risk is less but not 0, 12%. Vedolizumab has very low antibody formation rate, 1 to 4%. Ustekinumab, 0.4 to 3%. So showing that at least for infliximab and adalimumab, if you want to decrease the immunogenicity, you have to give an immunomodulator in the form of low-dose azathioprine or methotrexate. And a recent DW abstract also showed that combination therapy with thioprins or methotrexate is associated with better clinical outcomes with infliximab, but not with vedolizumab or ustekinumab. If you are going to give vedolizumab or ustekinumab, you need not combine with azathioprine. What about even with infliximab? Do you have to give it for years together, or you can withdraw it? This very recent analysis in CGH again showed that when you withdraw immunomodulators, it was not associated with the loss of response. So we have these kind of combinations which are very commonly running in our OPDs. Infliximab or adalimumab with azathioprine or methotrexate with 5-ASA. Can we stop 5-ASA? Yes, stop it. Can we stop ASA as well? Yes, you can stop it. But when? 6 months, 1 year, 2 years. If you go by echo statements, it says that for infliximab as well as adalimumab, you can give it for 6 months. At least 6 months should be given. However, if you look into further data, you find that you can actually give it for 1 year. It may not be a bad idea to even give it for a longer duration, especially in cases who have a high risk of being refractory or which are refractory patients who have a high risk of having biological failure. There you may continue azathioprine for 1 year or 2 years along with infliximab or adalimumab. Otherwise, if patient is doing well, after 6 months to 1 year, you can consider stopping it. Now the third scenario, you have a patient with infliximab, azathioprine and 5-ASA. You stopped 5-ASA. Now you have to make a choice. Should I stop azathioprine or should I stop infliximab? Here obviously the most important factor is the cost out here for our country. And or the other thing is that if you stop, that is if you stop biologics, what happens? So if you look at the multi-center UK data, you find that there is definitely a relapse. But as I told you, it's a half class full or a half class empty situation. So you have 36% relapse, but rest of the patients did have a drug holiday. 2 years relapse, around 50%, but 50% of patients had a drug holiday. That's an enormous amount of drug holiday for 2 years, and consider the cost. If you look at the Indian data, we also find again similar kind of relapse rates, roughly around 40 to 50% relapse rates at 1 to 2 years. So what do you do in such situations? If the patient is in clinical and endoscopic remission, you can consider stopping biologicals. You can, however, at this point of time, you have to continue with azathioprine or methotrexate. Remember, most relapses would occur within 6 to 12 months, and if you retreat, it is safe. What about perianal fistulizing disease? This is another scenario where you would you consider stopping biologics? People feel that biologics should not be stopped in perianal fistulizing disease. This is a multi-nation cohort which looked at that and found that, again, in perianal fistulizing disease also, the relapse rates are to the tune of 50% or 60%, not so high. So you can consider stopping out here also, especially if radiological healing is occurred. The target for perianal fistulizing disease healing is that if you demonstrate on MRI that radiological healing has also occurred, not only symptomatic response. If you demonstrate that radiological healing has occurred, the chances of relapse would be the least. There's a very interesting study from Ludhiana which took up patients with ulcerative colitis. They were given 3 doses of infliximab and azathioprine, and thereafter infliximab was stopped. This is a case scenario which in India we have been talking about from last 10-15 years. Why do we not just continue with azathioprine after initially getting the response with infliximab? So that is what this study did. And it showed very good results. It showed that corticosteroid-free remission was 60% at 2 years, 35% at 6 years, again suggesting that, okay, that is the same story kind of trial which was done in France, which showed that over 7 years, 20 to 30% of patients did not require any biologicals at all. Tofacitinib is out here, so how are you going to maintain it? We all know it 5 milligram twice a day. The good part of tofacitinib is that if a patient has a relapse in between, you can just hike up the dose for a few weeks, go back to 10 milligram twice a day, and thereafter decrease it back to 5 milligram twice a day. There is no data on combining it with azathioprine, and we have now safety and long-term data available up to the range of 7 years. So it is not that you have to stop tofacitinib at 1 year because Octave trial showed that, or 3 years because the long-term Octave results showed that. You can go beyond that for 5 or 7 years also. Now I'll briefly touch upon strategies to minimize the risk of a clinically significant relapse, because now what you have done is you have reduced the therapy. So you would also like to, as a successful doctor, you would like to see that the patient does not go into relapse. So how are you going to select it out? First is select out your patients and all. But foremost, I would like to tell you that whatever you may do, you cannot predict relapse 100%, and you cannot be 100% sure that the patient does not have a relapse. This is an interesting study which took up around 100 patients of ulcerative colitis who were in clinical remission, endoscopic remission, histological remission, like complete healing, and on therapy. Therapy was not reduced. Follow up for 1 year, still 18% of them did have a relapse. So relapse is part of the natural history of disease. It is governed by certain factors which we have still not deciphered. Yet at the same time, we know that there are certain categories or candidates who are notorious in terms of they would have a higher chance of relapse. So there you would not minimize therapy. That is difficult to control disease. Patients who have a poor prognostic factor like stricturing disease, perianal disease, or while you're considering withdrawal, at that time the patient still has maybe symptomatic response but still has endoscopic response. So there obviously you would think twice. Now patient has this is another case scenario. Patient is on biologicals, he had a relapse. You have escalated the dose. Patient is on, let's say, infliximab. You decide every 4 weeks the patient will be given therapy, or adalimumab, every week you'll be giving maintenance dose. After 3 to 6 months, the patient is back in remission. What are you going? Can you de-escalate back? Can you move back to the previous normal? That is every 8 weeks of maintenance therapy. Yes, you can do that. It has been found to have good results. Again, if the patient, let us say you stop treatment out here. For 2 years, 3 years, the patient is doing well. Patient was on infliximab, adalimumab, vedolizumab, you stop. 2 years, patient doing well. Patient comes back with a relapse. The question which comes to your mind, these are simple questions. Okay, should I start again with the same drug with which the patient had achieved response? Yes, you should start with the same drug with whom the patient had achieved response, except that you will have to give the induction dosing. Again, resuming the same anti-TNF patients in patients who relapse is safe and effective. Third strategy, early detection and treatment of relapse is something very important. If you pick it up early, you can treat the patient before the patient goes into the spiral. Risk of relapse is highest in the first year after drug withdrawal. So more intensive monitoring initially in the first year. You can monitor with symptoms, serial CBCs, CRPs, or serial fecal calprotectins. FCP is an excellent method to do that. And in event of relapse, will you be able to again capture the response or not? That's the question which comes to your mind. Yes. Infliximab, adalimumab, vedolizumab, 80% of the times you are able to capture the response. As azathioprine also, 70 to 90% of times you are able to capture the response. But yes, again comes with a caveat. The caveat is that you may have to get a little bit of steroids initially to induce the response. So this is my last slide. So basically today I've talked about case scenarios which I told you are mundane, which are not the glamorous case scenarios, but I thought this was very important if you want to treat patient holistically. That is during maintenance phase, how you optimize your treatment. So if it is a case of ulcerative proctitis in remission for over 2 to 3 years, you may put the patient just on rectal 5-ASA, 3 grams a week, that is 1 gram alternate day, or you can stop therapy and observe. 5-ASA in ulcerative colitis, extensive colitis, left colitis, you can reduce the dose if the patient was on 3.6 or 4.8 grams, give 2 to 2.4 grams a day maintenance therapy. Azathioprine and 5-ASA, stop 5-ASA. Methotrexate and 5-ASA, stop 5-ASA. Biological plus azathioprine plus 5-ASA, stop 5-ASA. Then you can decide whether you want to stop azathioprine or stop biological. That obviously would depend upon economic factors mainly, and also other factors that you'll have to discuss with the patient as well. Chances of relapse, highest in first year. You can do fecal calprotectin serially every 3 months. When not to de-escalate is aggressive disease, previous history of acute severe ulcerative colitis, visualizing CD and all. Thank you so much for your attention, please.
Excellent presentation. I wanted to ask a different question. I'm a surgeon, so Crohn's disease, stricturing Crohn's disease, do you have a different approach if it's an inflammatory stricture or a fibrotic stricture? And how do you differentiate between that when you're planning your treatment?
So inflammatory stricture, we generally do not go for surgery and would try medical therapy. Fibrotic stricture, you would go for surgery, clearly. But as in life, there is nothing like a black and white situation. There is no stricture which is completely fibrotic. Tubercular strictures after treatment can be completely fibrotic. These strictures would have a proportion of inflammation and proportion of fibrosis. So how do you decide that? You can base it on with the help of CRP, fecal calprotectin, presence of anemia, hypoalbuminemia, then do a MR angiography with diffusion-based protocol, and that will help you in deciding whether it's a inflammatory or fibrotic stricture. Spiral enteroscopy is also available. One can go do that and observe the stricture site to make it out. If you find there are multiple strictures, inflammatory stricture, best is to go for biological therapy after you have treated infection. If, however, the patient is not responding and you really need to go for surgery, then still best to decrease the disease burden. That is, you give biologicals and all, decrease the inflammation. If patient can't afford biologicals, then give steroids and antibiotics. Decrease the inflammation so that some of those strictures were fibrotic. There you can do stricturoplasty. You have to preserve the intestinal length. Like where resection has to be done, you would go ahead with resection.
Just one more.
Another thing is that endoscopic therapy can also be tried for some of, if there are 1 or 2 strictures less than 4 centimeters in therapy, then balloon dilatation can be done.
That's what I wanted to ask, is your experience on the endoscopic balloon dilatation for strictures.
Yeah.
So what is the success rate of reaching the strictures and ultimate success?
Earlier we were doing balloon dilatations mainly for ileal strictures and all, because with ileocolonoscopy we were doing it. So strictures which are not inflammatory, anastomotic strictures or short strictures or 1 or 2 strictures, they require repeated dilatations, but they do well over a period of time. Like in the sense, they would require dilatation initially 3 to 4 sessions, and every 2 years or something they would come in obstruction and all. Now that we have this spiral enteroscope and all, so again with that we are doing balloon dilatations. The principles remain the same for that also.
Any question? Yeah, Turunda.
This is a question about fistulizing disease. When are you going to recommend surgery? When you have failure with biologics and all other drugs that you have enlisted?
So the first surgery I am going to recommend to every patient with perianal fistulizing disease is ceton insertion. That is a must for every patient with perianal fistulizing disease, because unless until you treat the infection, the fistula will not heal with biological. Biological will only compound therapy. It will cause infection and all. So ceton, you will put a loose ceton. 1. Number 2, surgery, again, the moment you start biologics, the patient is not responding. Many of the times you do have to add surgery. There are 2 recent very good randomized control trials which have come up, which are basically patient preference randomized control trials known as PISA-1 and PISA-2, which have shown that in one arm surgery was given along with infliximab, and in the other arm only surgery was done. It was found that with surgery and all, the arm was much more effective as compared to patients which were given only infliximab with a ceton thread, or another surgical procedure was done. So gradually, I do not think any perianal fistulizing disease today can be managed without the help of a surgeon. Ceton thread is universal placement. Unless until it's a simple fistula. We are talking of complex fistulas, obviously. Complex fistula, ceton thread has to be put in, and thereafter you can try a video-assisted anal fistula plugs, otherwise fistulectomies or something, or we have been doing stem cell therapies also, that is also surgically done. So those are part. And finally, if the patient is not responding, then you go ahead with a diversion, colostomy or ileostomy. There the patient responds very well, but then that is very bad for the patient, because only in 1/3 of the candidates or patients we are able to restore continuity. And if they are young patients, they are stuck with a bag all through life.
Thank you. Vineet, one comment from you, that is it that the scientific data is enough, for that the 5AS is not required for chemo prevention of ulcerative colitis?
So that's a very good question, sir, because 5ASA, that was the universal teaching that 5ASA is required for chemo prevention. So there were 4 meta-analyses, 3 going for it, 1 going against it. But the reason is that why it was thought to be chemo preventive is that it decreases inflammation. Now if you are giving another agent for life like biological therapy, which also decreases inflammation, if you are giving azathioprine, which also decreases inflammation, then why not? And it has been shown that with anti-TNF therapy, rates of cancer have also gone down. So if you were giving 5-ASA with the philosophy that you're decreasing inflammation, so inflammation leads to cancer and you are stopping it in between.
But there are
so
other
if you're giving other agents which are decreasing inflammation, they would also act the same way. So that is why 5-ASA is gradually
because there are other mechanisms of 5-ASA for carcinogenesis prevention.
Basic principle is decreasing inflammation. So that is the reason it is being phased out for that indication.
Thank you. Thank you, Vineet, for the excellent talk. And let us start this.
Thank you. Thank you very much, sir. We shall now proceed to our next topic, IBD in India, Real Life Challenges by Dr. Rupa Banerjee. We would request Dr. Shomik Banerjee, Assistant Professor and Consultant Gastroenterology attached to SSKM Hospital, to please come on the stage. We would request Dr. Anirban Chatterjee, Consultant Gastroenterologist attached with CMRI Group of Hospitals, to please chair the session. We would request Dr. Shomnath Mukherjee, Consultant Gastroenterologist, CMRI Hospital, and Dr. Indranil Shaha, Consultant Gastroenterologist, to please chair the session.
It's a pleasure again to welcome Dr. Rupa Banerjee, who is all very well known to this audience, Senior Consultant Gastroenterologist, Director of Inflammatory Bowel Disease in the Asian Institute of Gastroenterology, Hyderabad. She has recently initiated the IBD ENC, Emerging Nations Consortium group with 16 countries in South Asia and Middle East to promote collaborative work on IBD in this part of the world. Dr. Banerjee, as you all know, is the author of numerous papers and articles in peer-reviewed journals, including book chapters, and she has got a very prominent Calcutta connection. She's an alumni of NRS Medical College and all very favorite of ours.
Good afternoon, everybody. I thought I'll thank Dr. Sujit Chaudhary first to call me, but what came to my mind was, it was such a wonderful lunch. And I think about all the things I love with Calcutta right now, what strikes me most is the wonderful lunch. Thank you, Dr. Sujit. Thank you, Dr. Shrutipto, for inviting me. What I will talk on is what happens in India, the real life challenges that we are facing in day-to-day practice. See, traditionally IBD was a disease of the West. Today it is a global disease, and if you see all the yellow, this is the part where IBD is on the rise. We just published this paper, more than 10,000 patients across 16 countries of South and Southeast Asia, and we find that yes, it is an emerging disease. If you see the epidemiology of IBD in India, we are in a position, because we are a highly populous country, even if our incidence is low, our disease burden is going to be huge, and by as near as 2025, maybe extrapolated rates, our numbers of IBD will be higher than that of the US. Within this region, we have compared and found that among Asian countries also, the disease burden is highest in India. Crohn's disease is on the rise, particularly in southern India. At our institute also, ulcerative colitis and Crohn's are going neck and neck, meaning thereby epidemiologically we are making progress. Now from all you see, it is slowly Crohn's which is overcoming. I must also highlight that the pediatric population is suffering more from Crohn's disease, and I think this is a burden that we will soon see over the next decade. It is affecting the active age group, when people have their careers, their social life, everything to manage. So what are the challenges in India? A populous, happy country like ours, IBD is not considered a public health problem. There are no true population-based registries. There's limited access to healthcare facilities, poor physician awareness, and of course, all the time the confusion with whether it is just what our patients call amoebiasis or tuberculosis, or is it IBD. So the real life challenges that we will discuss today is one, diagnosis, where infectious diseases rule, the TB versus Crohn's dilemma, the treatment approach. Should it be step up, top down? There's a lack of multidisciplinary care here and the overlooked problems. Balancing between cost and cost effectiveness, what we do all the time, what to do when the best is unaffordable. And introspection. Do we have time to think that our IBD may be different? Why is it increasing? Can we prevent it? And improving healthcare and access. So if you see, infectious diseases remain big killers in the developing world. And if you see the projection to 2030, you will see that in the low-income countries, in our developing world, infections will still, though lesser than before, will still be there. The infectious disease mimics of IBD are everywhere, and for every individual patient, it is important for us still to rule these infections out. The TB factor. TB is one of the most common infections in India. 90% of infected patients develop latent rather than active disease. And here, latent is important because more and more we are using the biologics, and as we use biologics, the risk of flare of TB increases by 5-fold. Then you have intestinal tuberculosis. If you see this is an old slide of mine. I keep using it because how would you say, is it TB or is it Crohn's? It's very difficult because they are clinically similar, radiologically similar, endoscopically similar, and even the pathologist will give the same report. Not only us, this is the same across Korea, China, India. 30 to 45% actually are receiving anti-tubercular therapy before the diagnosis of IBD. And the problem is so real. We had this young girl in May 2015, 15-year-old high school girl, abdominal pain, semi-solid, watery loose motions, multiple ulcers in the ileum, ileal biopsy non-specific, CT enteroclysis, our radiologist felt, multiple segmental wall thickening, looks very much like Crohn's disease. There was a long history, imaging colonoscopy like Crohn's. We started budesonide mesalamine, did not work, steroids did not really work that well. Treatment was planned in the lines of Crohn's disease with infliximab. Chest X-ray normal, TB quantiferon negative, MAN2 negative, no family history of tuberculosis. Before starting, they wanted another colonoscopy. So we did another colonoscopy to map the disease, and that time the TB PCR from the second biopsy specimen came positive. When this came positive, we were kind of, we decided to start a 4-drug anti-tubercular therapy, and what happened? She was better. Within 9 months, she gained 9 kilos. Repeat colonoscopy showed mucosal healing. CT enteroclysis, the same radiologist said there is still some thickening. We kept the patient on follow-up, but she's doing well. So sometimes it is a lesson to err on the side of tuberculosis, and because we see the real-world consequences. These are papers, well-designed papers showing the high risk of tuberculosis during infliximab therapy despite TB screening. So we have to keep this in mind. How to differentiate? If anyone asks me the question, do whatever you have in your kitty to try and see which way, mix and match on a case-to-case basis, and then take an individualized call. Sometimes we do empirical therapy, but empirical therapy has its limitations, and we should be aware that empiric ATT may delay treatment of Crohn's with long-term risk of complications for Crohn's, and treatment for Crohn's disease is disastrous if intestinal tuberculosis is missed. A standard algorithm which we follow, and we published this in Lancet recently, this is if there is a chronic ileocolonic inflammation, use all that you have, treat either like TB or treat like Crohn's disease, but keep a follow-up, and 2 months seems a justifiable time when you can find whether the patient has improved or not. In the meantime, you are getting the TB culture and other reports. Patient doing well, complete therapy. Culture negative, but problem, re-evaluate and revise therapy accordingly. Culture negative, but clinical improvement is there, complete the therapy. We should not give half-hearted TB therapy. It's always worthwhile to give the 6 months of treatment. Now comes the treatment approach, step up or step down. IBD treatment in India is a balancing act. On the one side, we don't want under-treatment, and the other side, we do not want over-treatment as well because of the cost, the risk of infections in this part of the world, and of course, the common lymphomas and other adverse events. Standard step-up treatment has been advocated always. We know that. They also say the top-down first, biologic first, why not the best drug at the first go? But in this part of the world, as again, TB, side effects, cost issues are there. So what should we do? We have to, when we first see a patient, decide are they a low risk or a high risk patient, and that should help us to determine the medical therapy. So our approach to therapeutic intervention so far is in between, an accelerated step up. If it is a high risk patient, then don't wait for ages on mesalamine when you know it is not working. Don't use recurrent use of steroids when you know it's a high risk patient. So these are the things that we follow. Early biologic usage based on risk factors. If there is less young age, presence of perianal disease, use the biologic. Pediatric age group, use the biologic because growth is a concern, and once there is no growth, even if the disease is in control later on, the growth does not come back. This is a patient who gave me his photograph to share. You see, this is pre-infliximab. This is post-infliximab. And on maintenance therapy, he runs his own channel, and this is how he is. So it does make a difference. We need to understand when to use it, and risk stratification of IBD, I think, is most important. Patients with IBD have varying disease courses, and only if we risk stratify, we can prevent either over or under treatment. Our algorithms for new IBD therapies in practice. When a new drug comes, we ask the pharma, what is the cost? And every decision sometimes is just based on that. And if you see, yes, we should still go steroids to immunosuppressants to biologics and then tofacitinib as the world or the Western world says. But sometimes for cost benefit now, even before any biologics, we are using for ulcerative colitis tofacitinib as the first line rescue therapy. Other problems in India, IBD is a multi-organ disease, needs a multidisciplinary team. And as gastroenterologists, we always think we are the one with that ladder with us. We are on top of everything, but we cannot. We must know our limitations. We don't know the whole disease. If I show you these pictures, it doesn't make sense to us except this is episcleritis. You should know, the ophthalmologist will tell, which will subside with IBD treatment alone. But this is scleritis and urgent treatment is needed, otherwise there is loss of vision. This is early and late pyoderma. If we treat early with the best drug, it will work. Fistulizing Crohn's disease, as Vineet just explained, needs the surgeon. It's not one person alone, it's a combination of two. The overlooked issues in India, IBD and mental health. If I ask you to raise your hand, no one will raise your hand. Do you ask your patient, are you feeling happy? Forget about navigating sexual health. We have so many patients who actually have problems. They talk more with our assistants, but I think that is again another important area which needs to be addressed. Mental health in IBD, what do the statistics say? Significantly higher rates of even major depression. Patients with major depression have a lower quality of life and earlier onset of IBD symptoms. 50% of patients with mood disorder have onset of depression greater than 2 years even before the onset of IBD. So controlling the depression and anxiety is also very important. The only known trigger for flare has often been, said to be stress. We actually at the Emerging Nations Consortium now in 9 countries analyzed patients and the primary caregiver, another person whom we miss and may need help. And we found depression from mild to moderate to severe at least present in more than 72%, a high caregiver Zaret burden index more than 67% for the primary caregiver. And the next is balancing between cost and cost effectiveness, what to do when the best is unaffordable. IBD is a costly disease and we all know that. There are direct costs, there are indirect costs, and as I mentioned, the mental health and everything is at stake. On top of it, majority of our patients have no insurance and pay out of their pockets. So what should we do? Optimal use of immunomodulators, judicious use of surgery, a definite exit strategy, and the low-cost alternatives. Vineet has gone into this in detail, but just like that, we use azathioprine despite the headlines, and it seems to work for us. We have published on the same, get an NUDT15 done, and then you are in a relatively safe zone because we need lesser dose of azathioprine than that is being recommended in the Western world. We drop the biologic when switching from combo to mono because the patient says he cannot. Use surgery rather than go for a second line rescue biologic and then that second line doesn't work, only then go for surgery. We should do that. Patients with toxic dilatation, extensive pancolitis, pre-counsel them for surgery. Sometimes limited resections work better for limited disease because it proves effective either when biologics are unaffordable or contraindicated. Use of biologics is limited in this part of the world. It ranges, you will find it strange, to around about 4%. In India, it is around 15 to 18%, not more than that even today. We need an exit strategy because our patients ask, when can we stop biologics? And are they effective if restarted? That is the first question our patients ask when we meet them. And that is a challenge from the doctor's standpoint. What do we tell them? In the Western world, they have these standard guidelines. You know, you find the right patient and how you will reduce it. They'll tell you the ideal candidate to consider. But that is the Western world, through the Western eyes. Here, de-escalation happens first. The planning has to happen later because we ask the patient, why did you stop? Why did you miss the dose? Any complications, any side effects? Because everything has to happen after the patient has already stopped, and that is a challenge. We just have analyzed more than 300 patients who have discontinued biologics. And we found 60% actually stopped biologics by 1 year. 80% of those in remission remained in remission after stopping biologics. 55% stopped because of financial constraints when they were symptom-free. 20% only because of lack of improvement, and 22% relapsed by 2 years, requiring biologics again. So in the Indian context, what we found, if they relapse early, by 1 year or at 2 years. Those who can grow by that, they are actually doing well. So there is a subset of IBD patients who sustain long-term remission of therapy after initially severe disease. Why and how do we identify these people should be our direction for research. Of course, low-cost alternatives, we encourage biosimilars, maybe half the cost. Novel therapies, we have patients all the time on complementary alternative medicine. That was the CGH cover a few years ago, cannabis smoking, I don't know, ginger, turmeric thing, fecal transplantation, anything which is low cost. I think we should research more on that. Finally, the introspection. Our IBD may be different. IBD is an interaction between genetics, immunology, environment, and microbiome. We differ from the West. We are genetically different, our environment is different, our microbiome, and we are doing a lot of work in that area, is different. In the situation, we have no data from this part of the world. We have very few dedicated IBD specialists. Dedicated IBD units are rare, and I would ask what they can do, just a minute more, what they can do, and they should be a part of this movement. There is a need to data to formulate guidelines suited to this region. The Emerging Nations Consortium, we are trying to work, and in our first paper, what we are seeing is indeed our disease looks to be different from them. Extraintestinal manifestations are common, but primary sclerosing cholangitis is less common. So these kind of things, more left-sided disease, less colectomy in ulcerative colitis, more stricturing disease, less perianal disease. So there is difference, and our guidelines should be based on that. There are additional concerns. We know we are a large population. 70% live in the rural areas. Where is the availability of colonoscopy at every district or village? In fact, when we are conducting the AIG IBD rural outreach program, what we are seeing, we are doing a door-to-door survey for IBD and GI diseases. It is actually something giving back to society. Not only that, it was a revelation for me that symptomatic patients were evaluated at the local, are continuously evaluated at the local camp daily. And then we have mobile doorstep endoscopy and colonoscopy every week. You can see Dr. Patel there with his, within the van. And more than 15,000 colonoscopies, what we are finding, there is a rising incidence of GERD, obesity, metabolic disorders in our villages. They don't have the diarrheas or infectious diseases. And what are we finding? An emerging IBD in rural India. So the reason perhaps lies somewhere between. This is on the way to the village. I clicked these, processed food in even the smallest village, increasing urbanization with government schemes providing good accommodation. Can we prevent it? And I think that's what I would leave you with. This is a paper we published in Lancet on the challenges in diagnosis and management of IBD. Do join us at our web platform, ibdenc.org. The key messages today: IBD is on the rise in India. There are unique challenges. Healthcare systems will struggle to provide affordable treatment, bridging the rural-urban, rich and poor. Optimizing treatment is necessary. There is a global need for a low-cost, yet effective option. What I always feel, what is the ethics of the socio-economic adjustment of treatment that as doctors we always do, not giving the best because it is unaffordable or unavailable. This is our team, and I would welcome you for the AIG IBD Summit in April. Thank you.
That was a very lucid talk, Dr. Banerjee. Just to come back to the main point, I think the incidence of IBD has increased over the last 20 odd years. Is that mainly because the incidence is increasing, or we are getting better at diagnostics and awareness and other things as well?
I think this debate was there also a decade ago. So it started 2 decades ago. This came as 1 decade ago. But let me tell you, in the Emerging Nations Consortium, just to give a quick answer, we have countries like Afghanistan where there is no colonoscopy available. And even they say that now people are coming more with bloody diarrheas. So they are seeing a much more of bloody diarrheas, and the patients are being sent to that one center in Kabul, which is doing the regular screening. For women, it's a big problem. So what I'm trying to say is, this is not one country, the entire region is seeing this change. And I think now we have crossed beyond the...
Yeah. And in this part of the world, we are seeing a milder disease compared to the West.
I wouldn't say it is a minor disease, but I would say that the demographics are different. I wouldn't say it's a minor disease.
Because we use less biologicals. And
we use less biologics because of the non-affordability factor more than anything else. But our dynamics, the difficulty of TB together with it, makes treatment a challenge. I wouldn't say it's mild at this stage.
Madam, one question. What is your experience about drug-resistant intestinal TB? About ileocecal cocks which are drug-resistant? How to suspect them? Even after giving 6 months of ATD, we are still not getting improvement.
So what we normally do is, if it is tuberculosis and you treat for 6 months, there will be some response. If there is response but internally you find ulceration still present, we sometimes continue the TB treatment for up to 9 months. But frankly, drug-resistant tuberculosis in isolated intestinal TB is an extremely rare condition. I wouldn't say no, though earlier we said intestinal TB was never drug-resistant, but I would recollect one patient who had proven multi-organ. She had a uterus removed, then she had lung TB, and then but isolated ileocecal TB, drug-resistant, is rare. But we should still, and that's why I mentioned, complete the TB treatment so that we don't encourage drug resistance. Even if for latent TB, a single monotherapy of ATT should not be used. It should be at least a combination of 2 drugs. If there's a family history, then even 3 drugs before you start biologics.
On the issue of milder disease, would you agree that phenotypically our Crohn's are definitely different from that what we see in the West? Because we get less of stricturing disease, less of perianal disease in this part of the world as compared to the West.
Yeah, so I will tell you that we are just going to, we are submitted for ECHO, the paper. So we have tried to identify the gut microbiome. So we are doing the gut microbiome 1 in a population with isolated terminal ileal disease, full-blown Crohn's disease, normal, and we are comparing it with the Western data on Crohn's disease, because terminal ileitis, isolated terminal ileitis, there is no microbiome data as such. What we are finding it is it's a transition from the normal to the isolated terminal ileitis, but it's distinct from that of full-blown Crohn's. And our Crohn's microbiota and the Western reported have similarities. It is not grossly different, but a few bacterial differences we are finding. But the major findings like Faecalibacterium prausnitzii is low in Indian Crohn's, and it is low in the Western Crohn's also. So there is that patch, and I think the microbiome may be one of the factors, but that is what we are finding.
What is your opinion about tofacitinib in the maintenance of Crohn's or IBD?
Tofacitinib right now has major role only for ulcerative colitis, not for Crohn's. And we have got around about 100 patients on tofacitinib. And interestingly, at least half of them are first line before use of any other biologics. Results seem to be good, but not as early, like 1 week or so. But they do respond within a few weeks, and I think it's a very low cost option. So I have used in many who cannot afford biologics. So as I said, I mean, the socioeconomic ethics, the guidelines will tell you after a biologic failure because of the risk of infection. But what do I tell a patient who cannot afford the biologics? So we are giving for that.
What precautions you took before starting tofacitinib in ulcerative colitis?
It's the same like any other biologics. We have to check into their vaccination status. We have to do all that we have in our kitty to rule out any tuberculosis. Herpes zoster is another worry that we have. High lipid profile, so it's worthwhile to do additionally a lipid profile before you start tofacitinib, so that if there are changes you can monitor. Those with already high lipid profile, we initiate treatment if they are not on it, and those are the guidelines that we would normally give. Zoster vaccine is still not available in full form in India, but I think by early next year it will become available.
Another thing is that Crohn's disease and tuberculosis diagnosis is a dilemma. Most of the time we send the sample for TB PCR, but it is very rarely come to be positive. In that case, we have to start tuberculosis therapy with empirically. So what is your experience?
I agree with that, but I think you can use the gene expert that is there. We can use the other modalities. Usually with time you will, you have to monitor that. But empirical antitubercular therapy now, we have reduced it significantly after we resorted to a full, analysis of history, duration, and then we are able to choose. But empirical, if you have to use it, then you have to. I think that is the challenge that I mentioned.
Yes, TB PCR is most of the time comes to be negative.
False positive also happens. For us, sometimes we see a lot of false positive also. But we still treat for TB if anything comes positive.
Okay, due to time constraints, I think we'll have to wrap up the session.
Thank you.
Thank you very much.
Thank you. Thank you very much, madam. Thank you, sirs. Thank you very much. We shall now proceed to our next topic of discussion, Changing Spectrum of Chronic Pancreatitis in India by Dr. Pramod Garg. I would request the chairpersons to please come on the stage. Dr. Partho Pratim Bose, Senior Consultant Gastroenterologist attached with PLS Hospital. Dr. Dilip Todi, Senior Consultant Gastroenterologist attached with NH Group of Hospitals. Dr. Dipankar Rai, Professor Gastrosurgery, Kolkata Medical College. Dr. Joydeep Sarkar, Senior Consultant Gastroenterologist attached with Kothari Medical Center.
Hello. May I welcome Dr. Pramod Garg, who doesn't require any introduction, really. He is a professor of gastroenterology and he's an associate dean of research at the All India Institute near Delhi. His publications have been more than 110, and his experience is there in basic and translational research. He is the Secretary of International Association of Pancreatology since 2016, and he is the Governance Council member of ISG. So, Dr. Garg, please deliver your lecture.
Thank you, Mr. Chairman. I'd like to thank organizers, Dr. Sujit Chaudhary, for this opportunity to discuss about chronic pancreatitis changing spectrum in India. I see my teacher, Dr. Chaudhary, here, and good afternoon, sir. So those of you who have grown with chronic pancreatitis in India, being a special kind of pancreatitis called tropical, you will see how things are changing over time. So the issues that I'm going to discuss would be what is chronic pancreatitis, how does it develop, why does it develop, and how do we manage, but that's not the focus today. To paraphrase Mrs. Churchill, chronic pancreatitis is a riddle, its pathophysiology an enigma, and the mechanism of its pain remain a mystery. And I think this remains true even after so many years of investigations into its etiopathogenesis. But perhaps there is a key, and we'll see how a normal-looking pancreas here might develop into an end-stage chronic pancreatitis with atrophy, dilated duct, and calcifications. So in India particularly, chronic pancreatitis is a fairly prevalent disease, maybe around 100 per 100,000 population. We'll briefly discuss about the historical perspective and current status, how the phenotype of the disease has changed over time. Is there a change? And if there is change, then what is the reason? So in most of the conferences that I have grown up with, I would always see a patient with chronic pancreatitis having a large dilated duct, multiple large calculi, or on MRCP also very large dilated duct, almost atrophic pancreas and large calculi. And this is what people thought, that this is chronic pancreatitis, which is here in India, kind of end-stage disease, right at the time of presentation. So it was a large series of more than 1,000 patients first reported from Kerala, where patients were young, in their adolescent, they were malnourished, 90% of them were diabetic, and they had large pancreatic stones, the pictures that I have just shown you. And this is a picture given to me by Dr. Ramesh. These are the patients who were malnourished, ate cassava, large calculi, large duct, required insulin, often couldn't afford it actually, and they died very early. And Dr. G. Varghese actually said that pain in childhood, diabetes in adolescence, and death in prime of life is the usual clinical picture in these patients, which he termed, for want of a better name, a tropical pancreatitis, India being a tropical country, and the name still carries on. Is it true anymore? Now, we'll see some of these factors that I've listed. Causes, are they all tropical? So in a series of 411 patients that we studied at AIMS, we found 38% of patients were having alcoholic chronic pancreatitis. They were consuming large amounts of alcohol for a long time, often smoking being another additional factor. 58% of our patients had what we call as idiopathic pancreatitis, 2.4% had hereditary pancreatitis. In a series from PGI Chandigarh, 38% of their patients were labeled as having alcoholic pancreatitis. Then second point is young age of onset, and the age of onset in our series was 24.6 years. From Kerala, this is a very important series from Kerala, of 220 patients, the mean age of onset was 30 years, not in adolescent. And from Chandigarh, it was 33 years. So both in North India and South India is different. How about malnutrition being a cause of chronic pancreatitis? We had a series of 224 patients, of whom 75% were either normally nourished or overweight. Only 25% were undernourished with a BMI of less than 18.5. However, a third of these patients lost weight after the onset of the disease. And we thought that malnutrition actually is an effect of the disease rather than a cause of it. Coming to cassava, cassava theory has been now almost given up. In our patients, no patient ate cassava. In Kerala, again, there was a study by Dr. Nathan which showed no association of cassava with chronic pancreatitis. And in an animal study, the rats fed cassava didn't develop chronic pancreatitis. The next is that all of these patients have severe disease with large calculi. So AIM study, we found patients actually present with early CP and recurrent pancreatitis more often. In fact, the series from Chandigarh I mentioned, more than half of these patients actually had early non-calcific chronic pancreatitis, meaning thereby that if you are aware and patients come to you early, you can start picking up early disease. How about diabetes? So diabetes was seen in our patients in 35% of patients with a mean age of 30 years. From Cochin, again from Kerala series, diabetes was seen in 59%, Chandigarh only 23%, and only 50% of these patients required insulin. That means not 90% have diabetes, not all of them require insulin. Then earlier series showed that these patients actually died very early. We found that probability of surviving for 35 years, that means the age of onset was 25 years, and till the age of 60 years was 83%. That means these are the patients who are having near normal life expectancy. This was the time the Indian life expectancy in males was about 65 years. Now, this is a very important paper published. It wasn't actually an original article, but more of a review article by Dr. Balakrishnan. Unfortunately, he's no more with us. But he showed very clearly how the disease has changed in Kerala from 1984 to 2004, over 20 years that he studied. Mean age at onset was 20 earlier, went up to 30. BMI went up from 16 to 20. Socioeconomic status increased from poor to middle class, and diabetes prevalence actually came down from 77 to 59%. So these are very important differences that he mentioned occurred over 20 years. And a study that he conducted, actually a multi-center study of more than 1,000 patients, only 3.8% could satisfy those criteria of so-called tropical pancreatitis. So this is the perception about the special type of CP that we are supposed to be seeing in India. Young age, cassava eating, severe disease, malnourished, diabetes, and very early death. In reality, what we are finding is that it's majority idiopathic CP, about a third of alcoholic CP. We see both young and old patients, they don't eat cassava. We see early and advanced disease both. Malnutrition is an effect of disease, not a cause. Diabetes seen about a third to half of patients. And I would say they have reasonably good prognosis. So far I've showed you that how the phenotype of the disease has changed in India. The next question is, what is the cause for this change? We really don't know that. Now, has there been a change in onset of disease, neutral status, diabetes, and prognosis? What is the cause? One factor which emerges very clearly is the rapid economic development. Now, these are the data from Kerala state GDP, because we have seen, and Dr. Balakrishnan has shown, the rapid change in the Kerala patients. So in 1970s, the mean state GDP was $320 million, which increased over about 30 years to $13 billion. The per capita income increased from a mere $15 to $525 in Kerala, a 40-fold increase. And when we analyze this, the state GDP, the age of onset, BMI, and prognosis, we found they went in parallel. So as the GDP improved, their age of onset increased, their prognosis became better, and their BMI also increased. BMI, of course, has a clear-cut relationship with that. Now, there's a flip side of development also. With increasing the socioeconomic status, the alcohol consumption increased. National average alcohol consumption per capita in India is about 4 liters. In Kerala, it is 8 liters. It is actually number one. It has surpassed Punjab many years ago. And of course, urbanization increased. So this is a photograph I showed you, given to me by Dr. Ramesh. And this is a photograph of a patient seen about 5 years ago and sent to me by one of our previous DM students. And if you see the differences here, the picture will tell you what has happened in Kerala. They are no more malnourished. They live in a good house. In fact, if you see the painting behind, it shows you the social status, and the patient is doing relatively well. So this is the development in terms of GDP. But what has happened is that the alcoholic chronic pancreatitis, which was seen earlier in 2%, has gone up to 33% in Kerala itself. And so has diabetes. Diabetes has increased in Kerala from 7 to 11% in the population. So chronic pancreatitis, of course, interaction between genes and environment, both factors important, which is more, depends on the individual case. So there has been a change, and environment seems to be the change, because if you look at the population level, in 20 years or 30 years, the population genetic makeup does not change. So when we talk about genetic polymorphism and mutations, they are there for decades and hundreds of years and don't change over a short period of time. So how does it develop from this? What we have seen and others have reported, that patients with acute pancreatitis, if they recover, about a third a quarter of them will develop recurrent acute pancreatitis, and up to 50 to 80% of them may develop chronic pancreatitis. In a study we conducted many years ago of 75 patients with recurrent pancreatitis, 47% developed features of chronicity over a mean follow-up of 5 years. So likely is that more patients will develop the disease. So how does the disease progress? This is a normal looking pancreatic parenchyma, and over years, if you see the parenchymal changes, it worsens, and you can see these early changes on, say, EUS, and later you can pick up these changes when they have advanced disease on ultrasound of the abdomen or on CT scan. And this is how the ductal changes progress from a normal looking pancreatic duct here. It dilates a little bit, becomes irregular, and finally you have a markedly dilated duct. This takes time. Over the years, patient develop. The progressive model of disease is that you have acute pancreatitis to recurrent acute to chronic pancreatitis. The paradigm of the disease progression in terms of pathophysiology is you have injury, it leads to inflammation, and inflammation leads to fibrosis. So you may have recurrent injury, like in recurrent acute pancreatitis, recurrent inflammation, and finally fibrosis leading to chronic pancreatitis. So this is the spectrum of disease. You can see very early change if the patient comes in early with acute or recurrent acute pancreatitis, and then you have established chronic pancreatitis, dilated duct and stones, and finally you have end-stage disease with atrophy of the pancreas, marked calcification, and dilated duct. This is how the disease progresses. So this is what has been also, it's more of hypothesis. Some patients may come with acute to recurrent acute to chronic pancreatitis, early, established, and end stage, but there are patients who may present to you for the first time with established CP or with end stage CP. So a little bit about why does it develop and what initiates injury. So we know there are two components in the pancreas, the parenchyma, which is comprised of SNR cells, and the ductal system. Ductal system actually gets involved much later, except perhaps in those who have CFTR gene mutation. Otherwise, it is believed that most patients have injury to the SNR cells, and multiple factors are there, environmental factors and genetic mutations, and both of which may also lead to oxidative stress, which may also contribute to the pathophysiology. In a prospective study from our center, from SGPGI, Dr. Chaudhary did that, from AIG, Dr. Nagesh Reddy and Chandak did that. Multiple genes have been found. The prominent among them are SPINK1 mutation, about 40%, 9% patients have CFTR, and some other genes have also been reported being associated with CP in India, and that seems to be the primary cause for this. So the current concepts, ladies and gentlemen, I'd like to summarize by saying that there is a changing profile of phenotype of chronic pancreatitis in India. Many patients are being diagnosed early because they come in early with acute or recurrent acute. Neutral status of these patients has improved. In idiopathic chronic pancreatitis, it is the genetic mutations or polymorphism which puts them at risk of developing disease, and coupled with environmental factors, they may come with over disease. And of course, alcoholic chronic pancreatitis is increasing in India. Thank you for kind attention. Happy to take questions.
Excellent talk, Dr. Dor. I was just wondering, there is data from Kerala over the last 40 years, economic development. What about the alcohol use? Is it the same like before, or is it increased? Because the whole issue that whether this tropical pancreatitis is not actually nothing unique there. So what can be the cause? Is it the alcohol with the background of malnutrition at that time, which is not here at this moment?
So alcohol use, I've just shown you, has increased in Kerala by many folds. It is now very high consumption in Kerala, and that is why the alcoholic pancreatitis was seen at 2% earlier in 1970s and 80s. Now it is around 33% in Kerala and might be increasing. So it has actually increased.
So what we used to say tropical pancreatitis is probably in a background of malnutrition, alcohol.
Yeah. So I think basically because of malnutrition, these patients presented with a very advanced disease right in the beginning. So that contributed to the pathogenesis of the disease, to the phenotype that was reported earlier.
Thank you. Excellent talk as usual, Dr. Pramod. I was just wondering whether you have any observations, I mean, since Doctor is there from AIG also. So when you have done genetic studies, have there been any difference in the genetic, causes of chronic pancreatitis being due to genetic origin in the younger age group more than that you have found in the West here in India? Because we don't have really tropical pancreatitis now existent. So is it because we find a lot of younger patients who have calcifications and quite severe disease? It's, is the dominance of genes in them more than in the...
So your question relates to the earlier onset of disease in India compared to West, right? So I think this has been a consistent observation. Even if our age of onset has increased to about 25 or 30, in the West, even now the age of onset or the mean age at diagnosis is about 50 years. And one of the reasons could be high prevalence of SPINK1 mutations. So SPINK1, as I showed you, varies from 35 to 40% in India, but the Western figures are somewhere around 15 to 16%. So they have also reported patients coming in early childhood or adolescent, particularly those with hereditary pancreatitis and particularly those with genetic mutations. So if you look at the series from Western countries of patients with CP and genetic mutations, you find there also patients with early onset of disease. Those who have alcoholic pancreatitis, their mean age of onset is around 50 or 55. Idiopathic in elderly again is around 50 to 55, but genetic mutation associated disease is the one which presents very early. And the best example of that is hereditary pancreatitis. PRSS1 mutation, you find the age of onset is about 15 years, 16 years in Western countries. So I think largely to do with genetic mutations.
As a surgeon, I just want to point out, I mean, probably it's a bit of different disease than West, because even we have so many young patients with bad chronic pancreatitis, we have mostly more periampullary carcinomas compared to pancreatic adenocarcinoma developing in chronic pancreatitis compared to West. I mean, the figures we see there, that pancreatic adenocarcinoma in chronic pancreatitis, we have so many young patients with chronic pancreatitis. I think the chances of malignancies are bit less. I don't know whether the patients actually succumb to diabetic or other problems or not, but we don't see so many malignancies developing.
So I think it depends on detection. So we did both case control and cohort studies among patients with chronic pancreatitis, and we found there is about 100 times increased risk of pancreatic cancer in those who have got idiopathic chronic pancreatitis. So obviously there is a very significant increase in the risk of pancreatic cancer among chronic. But if you look, your question is that you see more of periampullary in India than pancreatic cancer. So that is true. We also see more of periampullary. But if you look at the contributing etiologies or risk factors for pancreatic cancer, smoking is the highest risk, right? It's about 8 to 9%. Diabetes, long-standing, is again about 8 to 9%. Attributable risk. Attributable risk to a factor means you have a factor which could be causing the disease. For chronic pancreatitis also is about 8 to 9%. So large majority of pancreatic cancer, we do not have any of these risk factors. So there could be other factors which we don't know, which are at play in the Western countries and not so much in India. So overall incidence of pancreatic cancer in India is somewhat lower than in the Western countries.
Any question from the house? Thank you very much.
Thank you.
We shall now proceed to our next topic, the present management of Helicobacter pylori infection by Dr. Uday Chand Ghoshal. I would request the chairpersons to please chair the session. Dr. Joyanta Dasgupta, ex-professor and senior consultant gastroenterologist attached with IILDS. So we would request you to please chair the session. In addition, we would also request Dr. Gautam Rai, consultant gastroenterologist attached with the B.R. Singh Hospital. Dr. J.R. Mahapatra, senior consultant gastroenterologist from the PLS group of hospital. Dr. Gautam Rai, I mentioned once again, Dr. Gautam Rai, consultant gastroenterologist and attached with the B.R. Singh Hospital, and Dr. Somnath Mukherjee, senior gastroenterologist, CMRI Hospital.
Hello. It's a great pleasure for our next speaker, Professor Uday Chandra Ghoshal. I think it is a homecoming for him. He was here for a few years here. Now he is a professor, Department of Gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Science. And he's a medical teacher with an experience of teaching postgraduate level, MD, DM and PhD students for more than 29 years. Only the first Indian representative in the prestigious Rome Foundation that guides care of patients with functional gastrointestinal disorders all over the world. Medical researcher with 29 years of research experience with more than 400 publications and 10,000 citations. The list is very big. Now I am inviting Professor Uday Ghoshal to deliver his lecture on management of H. pylori infection. Professor Ghoshal, please.
Thank you. Thank you, the chairperson, Dr. Jayanta Dasgupta, with whom I worked. So I'll be talking about present status of management of Helicobacter pylori infection. At the beginning, I like to thank Gemas for giving this opportunity to me to come back to home once more, particularly Dr. Sujit Chaudhary. Now let us look back. In Royal Perth Hospital, Australia, in 1983, two people started working. Robin Warren was the PhD guide of this young gentleman, Barry Marshall, at that time. So Robin used to think that stomach contained bacteria and people used to laugh at him. And when I was talking with Barry Marshall, he said, because I was not such a great guy, so I thought wherever I went to do PhD, they did not take me. This is a medical person, what science he will do. And then finally somebody suggested to me, go to Robin Warren and tell him, I believe stomach has bacteria and he's surely going to take you. And this is what he did. And this led to an epoch-making discovery in 1983 that the stomach has Helicobacter pylori. So obviously that history is different. I'm not going to touch on that further because my job is to talk about management. So I will address the following issues. In whom diagnostic workup and treatment for Helicobacter pylori infection needs to be undertaken, so that one should know that where I should test for Helicobacter pylori, where I should not. For example, if you are having a patient with gastroesophageal reflux disease, you must not test for Helicobacter pylori, because if you tested, you are in a soup, because you can't eradicate, because that may increase GERD. On the other hand, if you don't eradicate and that fellow gets a stomach cancer 10 years later, he will say, you were supposed to eradicate my Helicobacter pylori. So therefore, that is a situation where you don't test. What are the tests for H. pylori infection? How to treat H. pylori? What are the adverse effects of the drug compliance eradication rate and how to improve it? And what about reinfection? I will not touch on reinfection much, but I will talk about testing Helicobacter pylori. Simple thing that we do is rapid urease test. So what is rapid urease test? You have a test tube in which you have urea, which is NH2CONH2. This has phenol red, and we all know that in phenol red, in pH below 7 will be yellow. The moment pH become more than 7, it will be pink. So if you pour a gastric biopsy into this, now we know that Helicobacter pylori liberates an enzyme called urease. And this urease, it liberates because it has to survive in the stomach acid. So what it does is that it goes into the stomach, it liberates urease, the ammonia that is present in the stomach, urea that is present in the stomach is converted to ammonia, so that around Helicobacter pylori there is a neutral pH so that it can survive and quickly go into the mucus layer below the over the epithelium to protect itself from acid. That is what it does for survival. That is what you are using for the test. So what you are doing is you are adding Helicobacter pylori. if Helicobacter, you are adding gastric biopsy, if Helicobacter pylori is present, its urease is going to break the urea, it is going to make ammonia, and the ammonia is going to change the media pH to alkaline, and the yellow will become pink. But remember one thing, many of us actually inappropriately report the result. Many of us, when we are doing endoscopy, you are in a hurry, you just repeat negative in 15 minutes or 20 minutes. No. If you don't observe for at least 2 hours, if it is a sol media, that is solution, you are supposed to observe for at least 2 hours, so that you give enough time to the Helicobacter pylori to do all the reaction and change the color of the media. So that is very, very important. But this is for solution. But if you are using a gel, for example, all this commercial kit that you get, you have to wait for 6 to 8 hours. If you do not wait for 6 to 8 hours and report it negative, most often it will be false negative. So the time is very, very important. Also remember, delayed positivity may be false positive, because if you keep this for a long time, like 24 hours, it can automatically change because of the spontaneous change in the pH in the room temperature. So too delayed reporting is wrong, and also fast reporting is wrong. If you are getting positive quickly, report quickly. But if you are getting negative for solution, wait for 2 hours. For gel, wait for 6 hours. Urea breath test, most of you may not have it. And in fact, we have urea breath test machine. It is not working because whole of the country is facing a problem of getting substrate. That is, you need the isotope of the carbon containing urea. So urea containing isotope carbon, that is either C13 or C14. But because of some restriction in importing isotope from other countries, based on the government decision, many of the machines are lying idle in the country. So this is the best test. You know why? Because when you do rapid urease test, you are pinching only as part of the stomach mucosa. Now this particular area may not have H. pylori. So maybe H. pylori is lying in the stomach elsewhere and not the area which you have biopsied. So that's why it is called local test, whereas urea breath test is global test, because the patient drinks C13 or C14 urea. Now if Helicobacter pylori is there, obviously urea is going to be broken down to carbon dioxide and ammonia. The carbon dioxide containing C13 or C14 is going to get absorbed, is going to be exhaled from the lung, and then you use a machine to detect C13 or C14. So it is a global test and is the best test. Now how about histology? Histology has the same limitation as rapid urease test because it is also a local test. If the patient is on PPI, there is a reduction in the density of H. pylori. Also, there is a proximal migration of H. pylori. Therefore, if you take an enteral biopsy in a patient on PPI, histology and RUT are going to be negative. So that's why you are supposed to take biopsy more proximally, and you should take at least 4 to 6 biopsies. Now, obviously, there are specific locations, for example, incisura, greater curvature, on the near antrum, lesser curvature near the antrum, and also you take from the antrum as well as body. What stain to use? Gram stain is really poorly sensitive. The best stain will be Gemas stain, but what is the problem of Gemas stain? Gram stain shows you gastric histology quite well, or hematoxylin eosin stain particularly shows the gastric histology quite well, but it fails to show H. pylori very well. Whether if you use Gemas stain, it shows H. pylori quite well, but doesn't show gastric mucosal appearance quite well. That's why R.M. Genta from Netherlands invented a stain which combined the beauty of Gemas stain and Genta stain, HE stain, Gemas stain and HE stain, and it produces what is called Genta stain. Methylene blue stain has been extensively worked up by Dr. S.P. Misra and his group, and that is found to be also a good test. Fecal antigen test is a very good test because it is also a global test. If H. pylori is present in the stomach, the antigen is going to be liberated in the stool, and therefore it is a very good test. In fact, when we don't have the facility for urea breath test because of substrate non-availability, fecal antigen test is a good test. H. pylori is difficult to culture. So therefore, H. pylori culture only a few lab does with success. Also, H. pylori culture has a limitation because you take a long time to get the culture result. H. pylori serology is useless. The reason is it is used for epidemiological investigation. In a given patient you do serology, there is a problem because somebody had H. pylori infection. Even after eradication, the serology is going to remain positive for quite some time. Let us compare sensitivity and specificity of different tests. Now let me tell you, the sensitivity and specificity is quite good, taking urea breath test as a gold standard, and you will realize almost 90% is the sensitivity of the most of the test and specificity. But remember one thing, if somebody is on PPI, sensitivity of histology and RUT reduces tremendously to the extent of 60 to 65%. So therefore, if somebody is on PPI, there is a problem, the sensitivity and specificity is poor. Second is if somebody has GI bleed, and now you are testing him for H. pylori, the sensitivity is very low to the tune of 50 to 60%. There are multiple reasons why GI bleed patient has low sensitivity, which I will not detail because of the shortage of time. Now, when should we treat for H. pylori? But before that, typically we do 3 tests, and if 2 tests are positive, you consider H. pylori infection. Typically we do not rely on only 1 test, but for clinical purpose this is not really true. Clinically, if you get even RUT test positive, you can treat the patient, but when you want to analyze your data and publish a paper, they will not agree with it, because there are other bacteria which liberate ureas. For example, Klebsiella liberate ureas. For example, Proteus liberates ureas. So therefore, merely urease test will not be enough when you are going to a scientific investigation, but for clinical purpose, I would say it is enough because there are not much Klebsiella or Proteus in the stomach. So the indication for treatment of H. pylori is duodenal ulcer for sure, and the number needed to treat to prevent 1 recurrence is 2. So if you have treated 2 patients with duodenal ulcer by successful anti-H. pylori eradication, in 1 the recurrence will be prevented. So this is a very low NNT, and therefore this is really an important indication. Gastric ulcer, NNT is little higher, 3. So if you treat 3 patients, 1 recurrence you will prevent. Low-grade malt lymphoma is very, very important because this is a malignant disease, and by simply giving antibiotic and PPI or triple regimen for 14 days, you can cure and prevent its recurrence. But remember one thing, if you are treating high-grade lymphoma, only H. pylori eradication is not enough. There you have to also give chemotherapy. After gastric cancer resection, family history of gastric cancer, in high-risk individual before NSAID treatment. What about uninvestigated dyspepsia or functional dyspepsia? This is Rome algorithm. And the Rome says today, every patient of uninvestigated dyspepsia in whom you want to diagnose functional dyspepsia, first test for H. pylori. If it is negative, fine. If it is positive, eradicate. And after eradication, if symptom persists, this will be called as functional dyspepsia. If the symptom disappear, it should be called as H. pylori associated dyspepsia. But let me tell you, it is largely governed by the Kyoto Consensus, which was held in Japan. So therefore, this is it acceptable in Indian setting? I believe it is not. If you want data, I'll give you 3 studies. This is a study which was done from Sere Kashmir, Dr. Shaukat Ali Jargar group. This is a large number of FD patients. They were tested for H. pylori, and those who were positive, one group received triple therapy, another group received usual placebo plus standard treatment. They did 12-month follow-up, and they found there was no difference in the symptom improvement whether you added H. pylori therapy or not added H. pylori therapy. So therefore, this study shows you negative result. This is another study just recently published from Gangaram, where they did similar design, that is functional dyspepsia, HP positive, randomized to HP eradication, no HP eradication, the outcome was same. This is another study, it is a complicated design where they divided patient into group A, group B, group C, group D, and all the patients receive either H. pylori therapy or no H. pylori therapy, only PPI, but in addition, those who had anxiety and all those, they received psychological intervention in addition. But the bottom line of the study is whether they received H. pylori eradication or did not receive, there was no difference. So therefore, based on these three studies, though I know three studies are not enough, but if all three draw negative, and if you consider gastric cancer frequency in India is much lower than in the China or Japan, probably we cannot buy this Western recommendation or Rome recommendation today for our country that every functional dyspepsia or uninvestigated dyspepsia need anti-H. pylori treatment. Difficult, because you see, you have to incur the cost of the therapy, you have to consider the recurrence rate high. Third, you have to consider it is not easy to treat our H. pylori. So many other reasons why we will not presently make it as a routine recommendation. So what are the treatment available? You have multiple regimen. For example, PPI amoxicillin clarithromycin, PPI metronidazole clarithromycin, then ofloxacin bismuth metronidazole tetracycline, ofloxacin bismuth furazolidone tetracycline, PPI amoxicillin and rifabutin. Now, let me tell you one thing, that if you are using PPI, the newer generation PPI are better than the older generation, for example, omeprazole. Because it has been shown that if you do a very good acid suppression while treating H. pylori, your eradication rate is going to be higher. For example, when 20 milligram BD omeprazole was used, it was 20% eradication. 40 milligram BD, 40% eradication. Esomeprazole 40 milligram BD, 60% eradication. And venoprazan 20 milligram BD, 90% eradication. You know why? The reason is, if you just take Western data, they will say, even there are meta-analysis which will show omeprazole is as good in acid suppression as any other PPI. But look at the Western CYP polymorphism. 95% of the Western people have wild type of CYP, cytochrome P450 metabolizing enzyme, and only 5% has mutated form. Look at the Indian data. There is a large study published in JAPI by cardiologists, not by gastroenterologists. They looked at CYP polymorphism among people who were treated with PPI for coronary artery disease along with low-dose aspirin, and they found one-third. That means we have wild type wild type in 30%. We have mutated type homozygous in 30 to 40%. We have mutated type heterozygous in 30 to 40%. So therefore, the PPI is not going to be the same in India as in the West, because our CYP polymorphism is different. And look at, this is one of our study where we took patient of GRD, we were giving them either omeprazole or dexlansoprazole, and we just measure their gastric acid while on PPI and look at the density plot of omeprazole and dexlansoprazole. See, dexlansoprazole density plot shows acid suppression is very consistent. On the other hand, omeprazole is so erratic. Sometimes it is suppressing so well, at other time it is not suppressing very well. So therefore, I would say, if you are giving anti-H. pylori, don't give omeprazole, give a newer PPI in a higher dose. Now, how about resistance of the bug to different antibiotic? Here is a study from Lancet which shows, yes, clarithromycin, metronidazole, levofloxacin resistance is common. Look at the Indian data. It is a I cannot present everything to you, but let me tell you, resistance varies from 30 to 100%. Metronidazole resistance in some region was 100%. And if you look at this Maastricht consensus, it clearly shows that if your clarithromycin resistance, which is not uncommon now among Indian strain, is there, less than 15% if the clarithromycin resistance, you give different kind of regimen, then erythromycin resistance is more than 15%. So therefore, drug-resistant H. pylori is more difficult to treat, because the regime, you can go through this Maastricht consensus. I cannot go one by one because obviously I have a shortage of time, but actually drug resistance you cannot test for every patient. You have to have local data, and local data show that resistance is quite common to all drugs in Indian H. pylori, and therefore, and this is related to indiscriminate use of antibiotic over the counter and even on prescription. So therefore, you have to be very careful to select your regimen depending upon the local resistance pattern. Also, some of the pharma companies, they actually suggested 1 week anti-H. pylori therapy regimen should be enough, and this was sort of promoted about 2 decades ago. Now we realize that if you treat less than 10 days, eradication rate is very low. So therefore, there are multiple meta-analyses now that more than 10 days should be the eradication. Now also, there are some data to show, this is one of the consensus that we published quite some time ago. Now what it shows is that if all this anti-H. pylori therapy is associated with adverse effect to the tune of 20%. So if some patient is given anti-H. pylori therapy, adverse effect is 20%. And in 5% adverse effects are so severe, they stop the drug. So therefore, because their compliance become poor, the eradication rate become lower. So if you give probiotic along with anti-H. pylori therapy, the side effect reduces, therefore compliance become better and they have a greater eradication. And this map shows you eradication rate of H. pylori reported in different studies from different parts of the country. Again, because of the shortage of time, I will not go through. But what happens is resistant H. pylori, you have to take other regimen, for example, sequential therapy, where you give 1 week PPI plus amoxicillin, and in the second week you give PPI, clarithromycin and metronidazole, 83% success. Concomitant therapy, PPI, amoxicillin, clarithromycin, metronidazole, and subsequently, again next week, PPI, amoxicillin, clarithromycin, metronidazole, or hybrid therapy, where first week you give PPI plus amoxicillin, and the other week you give a full regimen or Bismuth quadruple therapy. And as you can see, Bismuth quadruple therapy did the best. Earlier we did not have Bismuth available. Again, the Bismuth had come into the market, so therefore Bismuth you can use. And what happens is, metronidazole is difficult to accept because metronidazole resistance in Indian patient is quite high. So if you want to know more about it, this is the best consensus that we published recently. This is called Bhubaneswar Consensus Report of Indian Society of Gastroenterology on anti-H. pylori therapy and diagnosis and other things. You can go through this consensus. Thank you so much.
Thank you, Dr. Ghoshal, for that brilliant talk. Many of you must be knowing that Dr. Ghoshal is a very important member of the Asian wing of the Rome Foundation, and he has been instrumental in propounding newer ideas like post-infectious irritable bowel syndrome or post-infectious dyspepsia, even post-infectious malabsorption, which was previously called tropical sprue. So my question to Dr. Ghoshal is that recently also the problems of H. pylori has been linked with gastric dysbiosis rather than H. pylori itself. In functional dyspepsia, the improvement by giving anti-H. pylori treatment has been said due to the change in the gastric microbiota or the intestinal microbiota rather than due to H. pylori eradication itself. And that's why also probiotic in addition has been added to the treatment. What is your...
Yeah, that's right. So there are studies from Singapore, for example, Cochrane Givi has published that when you treat patient of functional dyspepsia with anti-H. pylori therapy, what they found is that it is the antibiotic effect which resulted in the improvement and not necessarily anti-H. pylori effect. You'll say, what is the proof of that? What they found is those who received anti-H. pylori therapy versus those who did not receive anti-H. pylori therapy, actually in the long run, their symptom recurrence was similar. That means those who had anti-H. pylori therapy, they had a dip in the symptom severity early. Then that again came back to the earlier level during follow-up. What does it mean? If it was H. pylori which caused eradication, improved the symptom, then it should not have recurred. In fact, let me tell you, H. pylori doesn't recur even in India so often as we thought earlier. There was a beautiful study by Philip Abraham. What it showed is 5% is the recurrence rate following eradication even in India, because adult stomach is more difficult to colonize by H. pylori than the stomach of the children. And that is the reason that what Gautam has suggested, it is gastric dysbiosis, which is often known in functional dyspepsia. There are two other studies, one by Victoria Tan from Hong Kong, who did a randomized controlled trial of rifaximin in functional dyspepsia. And she found that rifaximin was effective to the tune of anti-H. pylori eradication, very similar to anti-H. pylori eradication from the other studies. Therefore, it is the antibiotic effect of H. pylori regimen which is leading to improvement and not anti-H. pylori effect.
Nice lecture as usual. I have got to question that what about the vonoprazan based combination, because the best of the DW, they have quoted so many papers with vonoprazan triple combination with and 10 days therapy to 14 days therapy is very good.
Very good question. I did not touch much on this because this drug is not available in the Indian market. Obviously, PCAB such as vonoprazan is more effective in acid suppression than PPI. Also, the vonoprazan effect is not related to whether you are taking the fasting stomach or fed stomach. Also, it is not dependent on CYP polymorphism. And as I told you, greater is the acid suppression during anti-H. pylori eradication therapy, higher is the success rate. So there are multiple studies now. There is meta-analysis now that vonoprazan-based triple therapy is superior to PPI-based. So we are waiting for the vonoprazan to come to our country.
Any questions from the floor? If nobody has any further questions, can we wrap up the session now? Thank you again, Professor Ghoshal.
Thank you. Thank you very much, sir. Thank you, chairpersons. After a long discussion with the pearls of wisdom, we shall now move on to the brain teaser. It would bring to you a different kind of a flavor. May I request the chairpersons to please come on the stage. Dr. Saurabh Ghosh, Professor, Medical College, Consultant Oncologist and Surgeon in AMRI Group of Hospitals, Kolkata. Dr. Chanchal Goswami, Consultant Oncologist, AMRI Hospital and Ruby General Hospital. Dr. Dipankar Rai, Professor and Surgical Gastroenterology attached with Kolkata Medical College Hospital. Dr. Devkumar Rai, Consultant Surgeon, AMRI Group of Hospitals, Kolkata.
Good evening, everyone. To start the session, I just want to cut down the anxiety level. I am not going to tease your brain at all. Though these things are still as a brain teaser, but this is an interesting case-based discussion in which me and Dr. Devkumar Roy already halfway through. And to balance the boat in which we are riding, there are two surgeons. They are not familiar with the case. Dr. Dipankar Roy and Dr. Saurabh Ghosh is there. And to take out the journey safely, after the surgery, we need some opinion for the safety of the patients, and that will be discussed with Dr. Chanchal Goswami for the safe passage. So, benign stomach SOL, is it always GIST? Probably after once the session is over, you will conclude that no. So, these are the panelists. So, to start with, this is the case in which a 47 years female patient presented with epigastric pain, some fullness in the stomach, loss of appetite.
The patient was referred from outside. The USG suggests a stomach SOL, and the CECT picture is there with a lesion at the lesser curve of the stomach. Can I have the pointer, please? So you can see that mass. So, audience, what's your opinion? What is this? Anybody? Okay, so move on. So this is the endoscopy finding. There is a mass with a ulcer crater at the lesser curvature of the stomach without any evidence of the bleeding. So any guess what it could be? Anyone? Dr. Roy, Dipankar Roy, sir, your opinion?
Endoscopic view looks like a gist.
Saurabh, same.
Yes, even on the CT scan, on seeing this, I would say it is a mesenchymal mass, most likely to be a gist.
So patient was undergone endoscopic ultrasound, and this is the report: large hypoechoic vascular mass lesion in fundus and body of the stomach, and it was interpreted as also as a gist. The mass lesion is about 5 into 3 centimeter in the fundus and body of the stomach. Move on. Yeah. So what you will suggest? Routine pre-op biopsy, MRI, PET scan, any pre-op tumor marker? Anyone?
No, we would, considering that it seems to be resectable, there were a few hypodense lesions in the liver. Was there any comment about that? Were they simple
It's a cyst only.
Simple
It's a cyst
cysts.
only, yeah.
Fine.
You
So
can
if it is a resectable lesion, then and with a diagnosis of gist, biopsy is not recommended because they are very vascular. They may bleed. So we would go for upfront resection. I don't think I need any more.
No more. Straightaway operations.
Yes.
Dipankar, same? Or any different point?
Yes, same. Same. Only thing, the CT cut here, it showed more of a distal stomach growth. But you said US fundus and body.
Fundus and body.
Yes. Yeah. If it is resectable.
Body. It's in the lesser curvature.
Lesser
Mainly
curvature.
lesser
Lesser
curvature in the
curvature,
body.
more towards the
Mid-body.
fundus.
Mid-body.
Yes.
So audience, all agree that it's a gist? So far, okay. So for the treatment purpose, FNAC was not done as advised by Dr. Saurabh Ghosh. We are referred from the other center for surgical. We are also suspect it's a gist. We did full up preoperative workup, and we took up the patient for the laparoscopy resection, and we have consented for the proximal gastrectomy. So if it is a difficult procedure, we may land up for the proximal gastrectomy. Accordingly, the consent was taken. So treatment plan is okay? Okay. So this is the operative view. So this is the mass. We have started this dissection along the lesser curve of the stomach. We are opening up the plane. There's a nice plane in between. Sorry.
Click on that. No, just click on the picture. Click on the. Just click. No. Or click enter.
Fast forward. Okay. So we are carrying out the dissection along the lesser curvature. So nice plane is opening up. In the diagnostic laparoscopy, we didn't find anything suspicious in the liver and other part of the stomach, no nodule in the pelvis. So we carried the dissection.
I just add on, the CT scan actually said the left gastric artery is encased, but it was not encased actually, it was just abating from it. So I could manage to save the left gastric artery.
So dissection along the left gastric artery. Just to move a little west.
So esophagus was slinked, and now we are resecting the specimen with adequate margin from the incisura. With the endoGI stapler. So gastric calibration tube was placed to ensure that there is no stomach narrowing. So just to carry on, so after the stapling part over, we are just overrunning the staple line with the absorbable bar sutures. So to prevent the proximal migration, we are just taking few stitches for the newly formed lesser curvature with the wrapping of the crural areas. And the specimen was retrieved from the 12 mm port sites. Next. Postoperative recovery was uneventful. We did a CT in the second postoperative day, and it shows the nice passage of the dye in the distal part of the duodenum and the small gut without any narrowing. So patient went home on the 4th day with adequate food the patient was taking, no gastric outlet for obstruction, and till 4 weeks of the follow-up, patient is doing well. Now the surprise part. This is the histopathology report. I am just reading out the impression part that excised tumor from the gastric body at the lesser curvature, well differentiated neuroendocrine tumor, grade 1. And that report was confirmed with the ISC panel, in which also the impression was a tumor from the gastric body and antrum lesser curvature, well differentiated neuroendocrine tumor, grade 2. So the problem is, if we consider the neuroendocrine tumor, to start with, if we know preoperatively the primary site, whether tumor is functional, we can know the stage, we can know the grade, we can know the pace of growth and somatostatin receptor studies. Most of the thing was not done preoperatively, as we are not aware of the fact that it's a NET. So we are trapped about we don't know the unknown lymph node status, no functional workup, no metastatic workup. So now what?
Can I just ask the pathology report, how big was the dimension? How big was the tumor?
Dimension was 7.5 into 6 centimeter. 7.5 into 6 centimeter by 5 centimeter. Yeah, entire specimen. 4.5.
4.5 into 3 centimeter.
So unknown.
No. Only one if you can go back to that. Pathology.
Pathology, okay. Carry on? Okay.
Yeah.
So unknown lymph node status, no functional workup, no metastatic workup. Now what? Completion surgery, go for post-operative functional workup, or just reassure the patient and the follow-up?
No.
Dipankar, what's your suggestion?
First, I must say, this has happened with me also. Not such a big one. That's why I wanted to know the size. Small tumor, suspected GIST, came out to be neuroendocrine tumor. I have faced it. So, but it was small, say 2 centimeter, something like that. So this can happen, that I can say. Now, what should you do? At least we should have a scan, at least to look for any other disease there, because we have not done the complete lymphadenectomy. No, this is obviously it was not.
So you are in favor of completion surgeries. Another look and
staging,
go for completion surgery.
Staging.
No, so this is a low grade tumor. I mean intermediate grade 2, since between 3 to 20%. So most likely they will exhibit SR receptors, somatostatin receptors. So the next step for me would be to go for a DOTA PET scan. In this low grade or well differentiated or moderately differentiated tumors, a DOTA PET scan would tell me. In all probability, there may not be, although the large tumors are almost more than 50% associated with lymph nodal metastasis. The DOTA PET will tell me that, and based on the DOTA PET report, I would decide on the further line of management. If it was more high grade on the histopath, then I would have gone for an FDG PET. But in this case, since it's low, Ki67 is pretty low, I would go for a DOTA PET first.
So scan first.
Yeah.
Dr. Chanal Goswami, if this patient comes to you, what will suggest?
Yeah, I think what Saurabh has said is absolutely correct. Since this is a incidental diagnosis of neuroendocrine tumor, going back, I don't know whether it was prudent to do a biopsy during the upper GI endoscopy, and probably you could have got a preoperative diagnosis of neuroendocrine tumor. You, as you said, that you suspected GIST, taking it to be vascular, you did not think of a preoperative diagnosis, but in hindsight, probably that could have been wiser. But anyway, in hindsight, we are all wiser. So I think if it is at this point of time, what Saurabh has said, you can do a DOTA PET scan and DOTA tox scan and see. But essentially, in my mind, this is a low grade or intermediate grade. Probably you don't need to do anything.
Dr. Devkumar, how you want to follow this patient?
Absolutely, and just to tell you, this CT scan we had done, that did not show any sizable lymph node actually, in the lesser carb area, in the left gastric area, anywhere. So yeah, I think we'll just go for the scan and then take it further from there.
Okay. So we just taking some arbitrary things. If the PET scan is negative, doesn't show any lesion. So now these questions will arise. Do we need to follow up the patients? If yes, then how frequently you want to do the PET scan, or how you want to do the functional assessment in the postoperative period? So what's your opinion?
So in the preoperative history, there were no clear functions. So for all practical purposes, we only see two functional NETs. Those glucagonomas and VIPomas are for theoretical purposes. Nobody has ever seen those cases. We see either insulinomas or we see gastrinomas. The patient didn't have any features of neuroglycopenic symptoms, nor did the patient have severe peptic ulcer-like syndrome.
Nothing, no
So maybe it was not a functional tumor.
Not a functional
we know that non-functional NETs are more common than functional NETs. So it was probably non-functional. So, and if the PET, say DOTA PET does not show any residual disease, no nodes, no metastasis elsewhere, I would follow up the patient for 3 monthly for the first 2 years with upper GI endoscopy and EUS if EUS is there, and CT scan every 6 monthly. If the patient is asymptomatic, doing well, imaging doesn't show anything, he carries on like that.
That apart from the PET scan in the postoperative period, do we need to do the functional assessment status at all in this case?
Chromogranin, yes, sorry, I should have mentioned that. I would also always do a serum chromogranin A to see whether it's rising or not. That is a good marker that can be easily done, blood test.
Okay. And how will you watch for the recurrence?
I mean, what you are asking, whether you need to assess for functional status, no?
Yes.
I don't think there is anything you can assess for the functional status, especially. This is non-functional.
No, functional assessment from the other aspect I am telling you, there may be metastasis somewhere that can be taken up if the functional assessment comes positive or something like that.
If the metastasis is large enough, it will be detected on a CT scan also. It's not like a CT scan cannot detect metastasis. If it's a more than 2 centimeter tumor, metastasis elsewhere, it will get picked up on the CT scan. Most common gastroenteropancreatic metastasis would be to the liver. The CT scan is a good modality for evaluating liver.
So take home message that incidental detected neuroendocrine tumor postoperative functional assessment is not required if the patient is functionally negative preoperatively.
I would say specific functional assessment is not required.
Not required, okay. And any role of adjuvant treatment, Dr. Chanchal Goswami, first I want to come to this patient's case, whether we are not going for any compression surgery, PET scan is negative, how will you assess the patient postoperatively, that we already discussed. So whether the adjuvant treatment is at all necessary, if yes, how you want to do the assessment?
No, adjuvant treatment is not necessary in this case, not at all, because the patient just requires routine observation. My take is that if you have seen a negative PET, you don't even need to do future PETs in the follow-up. CT scan is good enough. And that too, I think these are so low, slow-growing tumors. CT scan at 6-monthly interval for the initial 3 years is good enough, and then you can do it annually. Otherwise, what Saurabh has said is clinical examination, a serum chromogranin A, and upper GI endoscopy suffices. That's what you need, and they are unlikely to recur. And even if they recurs, you will get enough time to work upon, and they can live for ages. So there is nothing to panic, and there is no rush for treatment in this group of patients. And honestly speaking, till date, neuroendocrine tumors, most of the situations, neoadjuvant and adjuvant treatment has not made a huge difference. It is the surgery which has made the difference. There are certain areas of adjuvant treatment, but this particular case does not need any adjuvant treatment.
And if you just, I have just mentioned few points about the adjuvant treatments, when it is required, and out of which what is the recommended, if you can highlight us a bit on that.
Well, the only adjuvant treatment which is of some benefit is somatostatin analog in certain patients, but targeted therapies like everolimus, mTOR inhibitors, and VEGF antibodies like sunitinib, etc. are not recommended. It is only meant for metastatic and recurrent diseases. So if at all there is any role of, and I personally believe it is somatostatin analogs is also a drug to be recommended for secretory neuroendocrine tumors who are symptomatic, because this particular drug only arrests the tumor and gives symptomatic relief.
Okay. So apart from the somatostatin analog, most of them are not recommended. So
not in the adjuvant setting, but if it was
Adjuvant
metastatic,
treatment is
then
not
PRRT is the first line therapy.
So what I got in the internet, this is the recommendation for the newly diagnosed gastric neuroendocrine tumor. It's a low grade, newly diagnosed with low and intermediate tumor volume, what we got. So these are the only recommended, that observation if no hormonal treatment is present. Are you okay with this? So this is the standard recommendation, and that's why I highlighted this part, as this patient is an incidentally detected low intermediate tumor volume. So we just observe the patient for any recurrence. So thank you very much. Definitely we have learned something new out of this brain teaser section. Thank you all the panelists for one.
Thank you to
very much.
Gemas for giving us this opportunity.
Thank you.
Thank you, Anirban. Thank you.
We shall now proceed to our next chapter, a panel discussion on management of NFLD by Dr. Gurdas Chowdhury. The panelists are, may I request the panelists to please come on the stage. Dr. Kaushal Madan, Director Hepatology, Max Hospital, Delhi. Dr. Kaushik Das, Professor and Consultant Hepatologist attached with SSKM Hospital. Dr. Vikas Prakash, Consultant Gastroenterologist attached with AMRI Group of Hospitals, Kolkata.
Dr. Kaushik, is he here? Now we can manage with two of us. So, you know, I think the surgeons have just left the hall for coffee. Okay, okay. You're welcome, but I was just wondering how many physicians are here, gastroenterologists and physicians. This is primarily a kind of a teaser of a different type. Instead of quoting literature and studies, we would take the opinion of our hallowed hepatologists as to how they would manage certain things in certain clinical situations. Okay, fairly straight. So today I have the privilege of asking them questions where I would face a doubt as to what to do. These are the settings for NAFLD. NAFLD with obesity, straightforward, common garden variety, overweight and alcohol. I think most of us probably would be enjoying our evenings. Increased liver stiffness and abnormal LFT, diabetic NAFLD and liver cirrhosis. Okay. You know, one of the problems that we have is that when we read a particular paper, we are focusing on only one drug. So here today's point is, given a situation, which one would you choose and why? So that's the approach. Is that okay? So first, obesity. most of the people who are coming up today and speaking, I think barring very few, I realized that they're a little fond of food, I mean, including myself, so that was pretty evident. And so all of us, if you do decide to get a fibroscan done, we would probably have high CAP scores. So here is a 35-year-old male detected with NAFLD on an ultrasound during a checkup. BMI is 30. Is an IT professional, sedentary lifestyle, eats out often. Family history of diabetes and CAD, coronary artery disease, but he himself doesn't have it. And his values are shown here. So borderline elevated liver enzymes, HbA1c is okay, lipids are a bit on the upper side, and his fibroscan shows fat, CAP is 310, and LSM is 7. So may I just start off with any one of you, so Kaushal, you can take the first ball. So what should be the focus of advice when this patient comes to consult you? I'm talking about the focus of advice, not which medicine.
I think one is to make him realize that he is suffering from a condition where right now nothing will happen, and in future he may progress to a state where he will have complications of liver disease. So I think making him realize that this is also an important condition, whereas most of his physicians, maybe his diabetologist also would have told him, oh, 1.5 times LFTs or SGOT, SGPT are okay in diabetics, so just forget about it. So I think making him realize is also important, and then emphasizing the fact that this is like his diabetes, is a lifestyle condition, and the treatment should be focused on lifestyle management rather than pharmacotherapy, looking at his parameters.
So to cut a long story short, this is a man who's incidentally detected, primarily a faulty lifestyle, BMI is high. So the focus should be on trying to get him to expend more calories and to consume less, right? So that he gets his body into shape. The question is, that's something which we all understand, and we write in the prescription that, weight reduction and so on and so forth. What are the special steps that you as a physician take to get good outcomes? So I'm now moving to outcomes in the clinic.
So regarding the second question, patients will follow our advice if it is incentive based. So if the patient knows what his present condition is, where are we heading, and we give them realistic goals. If there is a plan of action with the doctor and not just an arbitrary advice to lose weight, and why should he lose weight? How can he lose weight in his present scenario? Say if a person is working for 14 hours a day, I can't ask him to hit a gym for another 2 hours. So maybe in his office, during his free time, he can walk about. Maybe in his free time, he can join a recreational hobby which is entailing use of energy and maybe jogging or walking during his free time.
So let me ask you the question. Now you have given him some advice, probably written a prescription, and you have asked him to come after 3 months. What are your targets of monitoring going to be? Is it compliance to what you advised, or is it more objective evidence of weight loss, or improvement in his lipid profile, or fibroscan? Today I'm challenging you as a physician, not as a great academician from ILBS.
Sir, objective definitely will be in terms of numbers. So the patient has to lose weight, because if hypocaloric, this diet will be the first important thing. If the patient is following our advice, definitely he will lose weight. Once he loses his weight and cuts down on maybe processed food and fatty foods, definitely his CAP score is going to come down. Once the CAP score comes down and the liver inflammation settles, the LSM is going to come down, and the lipid profile likely is to improve. So compliance I'll check by reports.
Any physicians would like to tell us how they manage these patients, because academicians often are not very good at it. They would use exactly what they did, scare patients. So fear is not always a very good driver in the long term. I hope you would appreciate. For short term it works, but here you're getting them to modify lifestyle. And then, walking them through certain steps, including diet and exercise, means a lot. So how do any of you do that? Yes, sir. Dr. Torunda.
your IT work, you can do some sort of exercise. For example, you don't have to get glued to the your laptop all the time. In between, when you go, would do a little bit of exercise. So the second part. The first part, I'll discuss the natural history. I found that if we discuss the natural history, that why it is important for him to lose weight, everything comes in when he understands that cirrhosis everybody understands, liver cancer everybody understands, and then he concentrates.
Just two questions for both of you. Which one do you think is more important, diet restriction or exercise? And which would you prioritize?
Diet, of course, sir.
Diet. And what's your preference for a diet? Just a hypocaloric diet, or would you specify any particular type of diet?
As per recommendations, Mediterranean diet we would advise, but we don't
No,
know
no,
how
forget
much.
Mediterranean diet. We can't do it here. I mean, what do you do? That's what we're asking you. What do you do?
We'll ask him to, sir, cut down on carbs and maybe, sir, unsaturated fats and maybe for fruits. If a patient is hungry, most of the time patient is not hungry, actually he is thirsty. So he can go for adequate water intake. He can take filling foods like some seeds or nuts, which keeps him filled most of the time.
Okay. In the interest of time, we'll move on. Okay.
Can I add?
Yeah,
So
yeah, please.
I usually tell that it's not just diet, it has to be a combination of diet and exercise. Otherwise, it wouldn't happen. So much so that even if patients are not able to lose weight, if they are exercising regularly and maybe involving some amount of muscular exercises in their routine, even if they are not able to reduce weight, they are able to reduce the amount of fat in the liver. So exercise is as important as diet.
So those are the good things we'll tell. And when they come back, you're going to monitor what? Compliance to your advice or objective parameters?
Objective parameters, we look at weight, we look at the liver enzymes. CAP and LSM will not change so rapidly. So 3 months is not the time to remeasure a CAP and fibroscan. I usually wait for at least 6 months.
Okay, great. We'll move on to the next case because we have 5 of them. I'll take 4. We'll come to more contentious issues later on. So I think most of you are looking forward to the lovely food here that we had over lunch, and possibly if there's a dinner, there will be some alcohol. Many of us are in this category. So let's see. Doctor, 50 years old, not regular with exercise, partying once, every 3 times a week maybe. BMI is 29, ultrasound shows fatty liver, slightly elevated enzymes, gamma GT is high, albumin 4.2, good preserved liver functions. Fibroscan borderline 7.2 is the score for LSM. I call it LSM, liver stiffness, because actually it doesn't necessarily mean fibrosis, okay, although we tend to think that that means fibrosis, and of course there is increased fat in the liver. What would be your advice? So I think everybody would say, ask him to stop alcohol. I mean, you know that that's not a very practical thing. We wouldn't do it ourselves. So what would be the possible advice where he is expected to have a life expectancy of about, say, 75 to 80 years of good quality?
So I usually tell these patients that you've got 2 negative influences. So if you continue to drink alcohol, at least give me something. So I asked him to, he was talking about incentive. To such a patient, one of the incentive is if they lose weight, you can allow them to possibly continue social drinking. So that's the kind of incentive I give to such a patient, that at least reduce or negate one of the negative influences on your liver, and we can at least continue moderately with the other.
How about you?
Sir, evidence-wise, sir, in NASH patients, we have to stop alcohol completely. As per evidence, sir, I don't know how practical it is. In the study by Chang et al. Also with 328 patients, even 1 to 2 drinks per day increase the fibrosis. And the odds is 0.32 of decreasing steatosis and fibrosis if there is a alcohol intake concomitant. So I'll go for an objective evidence. If the patient decreases the BMI to less than maybe 24, if the LSM decreases further, if the CAP decreases further, if the objective parameters inflammation he can monitor with little bit of alcohol intake, then only we can continue the alcohol. If fibrosis is on the other side of the border, we should stop alcohol for now.
Okay. Any differences of opinion from the House? So shall we move on to the third, more contentious cases? The only point I wanted to inform you is that sugared cocktails are supposed to be worse for fatty liver disease. So if you take your alcohol relatively not contaminated with sugary drinks, that's actually supposed to be better. And with regard to what the others said, I would say that, yeah, I think moderation, you see here, heavens are not going to fall in 3 months to 6 months. And you can actually give them a little time of seeing how the situation is evolving.
And one more thing in alcoholics is that they tend to overeat when they drink. So in addition to the empty calories of alcohol, the other calories also go in. And it has been seen that patients who give up alcohol or reduce their intake of alcohol are also able to reduce their weight because the intake of calories also come down.
Okay.
Also, sir, steatohepatitis is much more severe with alcohol intake in natural.
Sure. No, I mean, what I meant was there were two approaches. One is to say that, okay, here for 3 months or so, become a nice guy and let's evaluate and see how things go and then be liberal again gradually. Or you start with moderation right from the first visit. Which one do you normally practice?
Moderation, but sir, it has to be a dynamic procedure. So
Sure.
we'll measure again and again. And
Sure. So now we go to the third one. 50-year-old male, diabetic, hypertensive, takes his pills, BMI 29, sedentary, liver enzymes somewhat high, cholesterol 300, triglycerides 220, synthetic liver functions are okay, HbA1c 7.3. Fibroscan again does show fat, LSM is now 10. Now how would you approach the management in this patient?
So I think in this particular patient, in addition to all the advice which was given to previous patients, I would also want to start pharmacotherapy upfront, in addition to anti-diabetic medication to get his sugars under control. And if you ask me specific medication which I would start in this, maybe vitamin E or saroglitazar would be my
So this is
first
beyond
approach.
lifestyle changes and control of diabetes, which I'm sure all of us do pronounce. But after that, how do you go about it?
So, so like I said, to begin with, it would either be vitamin E or saroglitazar in addition to all the lifestyle measures. That would be the first step. And yes, the other question you may want to ask me is, would I like to start anti-diabetics or would I like to refer this patient to a diabetologist? And the message here which I want to give is that patients who are first diagnosed to have diabetes and do not have very high HbA1c and they come to you with deranged LFTs, I think it is perfectly all right for hepatologists to start these patients on medications like metformin or sitagliptin or even SGLT1 inhibitors to begin with.
How about you, Vikash?
Sir, I'll maybe, I don't know about vitamin E, sir. We'll start maybe at Orvastatin.
No, but look at it here. Cholesterol 300, triglycerides 220, right?
Yes.
And so one of the common prescriptions we see is whether to give him a statin with fibrate
Yes, sir.
or to give him saroglitazar for the dyslipidemia and the fatty liver part of it. Vitamin E, I would put it in the first range of medicines which one touches upon. I mean, if you have done away with ursodeoxycholic acid, I guess. So that's where we are. So which is your preference and why?
Sir, at Orvastatin, with these triglyceride levels, I think alone at Orvastatin with saroglitazar will take care of. If at all we are adding vitamin E to this patient, that's again the first line drug against triglycerides. So we already have 2 drugs which will take care of triglycerides, plus that Orvastatin, plus the saroglitazar, plus vitamin E. So we have 3 drugs for triglyceride, which is
Loudly into the
So we have 3 drugs for triglycerides here, vitamin E, at Orvastatin, which works mildly for triglycerides. So 220 triglycerides will be taken care of by these drugs itself. I don't think fenofibrate is.
So which is your preference and why?
So I'll take atorvastatin and saroglitazar only.
You prefer that?
Yes, sir.
Okay. And Kaushal, why did you prefer saroglitazar?
So saroglitazar, in the initial studies, one, it will definitely control hypertriglyceridemia. It has also been shown to have good profile on atherogenic lipids. It will mildly reduce the cholesterol as well as LDL levels. So I think the first line we can start with saroglitazar, ask him to do the indulgent lifestyle management. Maybe that in itself can control the lipids further.
The high LSM also.
Okay. I'll go back to this patient. His BMI is 29 not too high, but by the ICMR criteria, it is in the obesity range for Indians, and he's a diabetic. So what are your thoughts regarding any of these anti-diabetics or particularly weight-reducing agents? Any of the glutides?
Sir, semaglutide, I can't convince my patient to take an injection to decrease weight. I took it I've used only for my 2 patients who were diabetic. So it's difficult to convince somebody, sir, although 2.2 milligram we used and there were very good results. But for why are we using this, we should understand only BMI of 29. If the patient,
Can't hear you.
If the patient is not very obese, the 29 BMI, if it start injections, it's difficult to convince. If the patient decreases by himself, it will be better. Because sir, semaglutide won't help for LSM anyways, because in the 320 patient study, it has not shown to decrease fibrosis. It is sent only for liver inflammation, which I think can be controlled with other drugs.
Right. So I think semaglutide is now available in an oral form in India, and we've had experience with about 10 or 12 patients in which we use semaglutide starting at 3 milligram per day. But the important thing is 50% are not able to tolerate the side effects and they stop. Those who do tolerate it and continue have a significant weight reduction, and I've had patients losing about 5 to 8% of weight in the first 2 months of use. But if you ask me, would I start at the first line? No. I would possibly begin with, if I have to start anti-diabetics, a combination of metformin and DPPI inhibitors.
So, if I understand right, weight is not the primary target in this patient so far as both of you are concerned. Am I right?
Sir, weight and diabetes both go hand in hand.
No, I agree with you. So diabetes is being looked after. You can possibly step up the medicines, change the medicines that he is already on, but more acceptable medicines. And right. So any vote here? How many of you would think in terms of, let's say, vitamin E, almost most of us would write. How many would prefer atorvastatin fibrate combination? How many would prefer Saro? So let's go with the a statin plus fibrate. How many of you use that? Oh, that's very good. Okay. And Saro? Slightly more. Okay. Okay. Yeah,
I think if this patient is being seen by a diabetologist, he would already be on a statin plus fibrate combination, or at least a statin. He would already be.
What we have to balance is, if he has come to us for the fatty liver part of it, there is something called a pill burden. So would you therefore continue with atorva and fibrates, because obviously his values are still up, or whether you would like to add Saro, and if you are going to add Saro, would you then ask him that he can discontinue the other? Am I right?
Yeah. We do that in practice.
And semaglutide is not, or any of the glutides is not quite fondly looked upon by most of you. Any of you have tried glutides in your patients? What has been the response, or how has it been? Can we have a microphone, please? So
Yeah,
did that?
I have few experiences with SEMA.
Oh, never mind. But is that patient coming back to you, or has he
Yes, sir.
kind of?
Yes, sir. Yes, sir. They have a gross weight loss. That is a major advantage.
Yeah. I'll come to the next patient, but I think that's one of the issues that we all need to be cognizant of. Whenever there's a new medicine in the market, we jump to use it. And overall, the experience in the West at least says that people who have been on these glutides, although there's impressive weight loss, but their quality of life goes for a toss. And most of them curse their doctors, because there's a lot of gastroparesis and inability to eat and so on and so forth. So that has to be balanced, the quality of life. We'll take the fourth patient, and that will probably be the last, and then we'll take questions from the house. So diabetes with increased liver stiffness. Now this is the patient for 60-year-old male, diabetes, hypertension, dyslipidemic, the usual combo. He is on metformin, on one gliptin and telmisartan. BMI is 27. Liver was enlarged, but no spleen, no ascites. Investigations showed elevated liver enzymes, HbA1c 8, lipids were high, but albumin was fine, and his liver fibroscan shows a cap of 290 and LSM of 13. Okay. Now, here the questions would be regarding beyond lifestyle changes, choice of medications for diabetes. So, Kaushal, if I may start with you, which one do you prefer? I think most people would agree that metformin is always the first line, but in this setting, many would like to go on to a SGL2 or a GLP-1.
Right.
Which one do you prefer and why?
I think I would still prefer GLP-1 because of the associated weight loss and other associated cardiovascular profile improvement with GLP-1. Although that is also there with SGLT2, but this is a 60-year-old male. I would be scared if he gets UTI, which is one of the common side effects of SGLT2 inhibitors. So I would, if I have to add, then I would prefer GLP-1.
While we are on that, Vishal, your take.
Sir, I'll go for SGLT regarding the high fibrosis.
Can you speak into the microphone?
Sir, SGLT inhibitors will be my first choice, considering the fibrosis in this patient. And likely that will be more beneficial. UTI, sir, we have to monitor anyway. GLP may not be tolerable, sir, 60 years, there may be some paralysis. And I think, sir, SGLT...
may I just throw it open to the house? All of you are physicians, and I'm sure you see a lot of people taking SGL2 inhibitors. How often have you found very troublesome UTI in these patients? Any of you? I mean, it's quite common. Yeah, can you just share your experience, Dr. Sir? Sorry? Female patients, yeah.
Similar to placebo, there is no increase in UTIs. There's an increased risk of genital fungal infection, which is very easily amenable to, treatment with local antifungals and maybe just a shot of fluconazole. But UTI, urosepsis, pyelonephritis, it's higher in placebo than with SGLT2 inhibitors. So that has actually now gone out of the window.
So, I mean, can we once again relook at it and take a fresh look at the whole problem? Are you sure that it's UTI which is very common in your practice?
I have not seen severe UTI. Definitely I have seen UTI if there is uncontrolled diabetes. In these patients maybe...
But uncontrolled diabetes, they are prone to UTI anyhow. So the question is that why blame this medicine? That was the question. True, if you get a urine test done, you would find that they have 4+ urine sugar. That's expected. But the fact only is that
But the thing is that if we get a UTI, then I think should we stop it?
It's recurrent UTI. So if you get more than 3 episodes of UTI, that is only the indication for stopping SGLT2 inhibitors.
I generally, sir, in male patients stop if they get...
So, no, but I think that point that you made, sir, I think it was a very interesting point, and I would like to make my physician colleagues think again. What patients I see on SGL2, I really don't see much of UTI. They are often sent to me because of a panic created because the urine test shows 4+ sugar. But that's expected. But UTI per se is not that common. The tolerance is good. And there have been studies, especially by Ambrish's group, which showed that there is a good amount of melting of the fat from the liver. So it's worth considering, because if you're talking about quality of life, the GLP-1 agonists, I mean, you have to weigh that part also. So end of partying and, kind of doomed for the rest. So that
Sir,
kind of...
60 years, he will have some paralysis
Yeah.
because of long diabetes.
Now for liver fat and increased liver stiffness, what would be your preference in this setting? So let's start with you, Vikash.
Sir, diabetic and dyslipidemia, I think, sir, saroglitazar will start. But personally, sir, if my experience, if it is to be shared, sir, I think obeticholic acid also works wonders.
Obeticholic acid. How about you, Kaushal?
I think with increased liver stiffness and because of, I think, decades of use, I would have put this patient on vitamin E because of its antioxidant property, hoping that it would have an effect on liver stiffness, although that has not been proved. And among these, the choices which you have given, I think only obeticholic acid is the one which acts on fibrosis. All others do not act on fibrosis. Although there is some non-robust data with saroglitazar showing that LSM improves.
Obeticholic acid, are you using it frequently? Because at the moment it still doesn't have approval for use in fatty liver disease. So what's your take on that?
So I've put some patients, but I've never used 25 milligram dose, which is the one which was, touted according to the Regenerate trial. I've only used patients with 10 milligram dose, and with 10 milligram dose, hardly anyone develops pruritus, and almost always they have a normalization of liver enzymes.
Okay. How many of you here are using obeticholic acid for fatty liver disease? And how are your the response that you see?
I agree with Dr. Madan. I used to give 10 milligram dose. So far I have not proposed. But I prefer definitely
I mean, at least in my experience, I'll tell you that Saro, one thing that is in favor of Saro is its safety profile. I've hardly seen any adverse effects with Saro. What about the table there? What do you prefer and why? At the moment. Okay. Obeticholic acid, I have that little worry because at the moment it still doesn't have the official sanction for use in this setting. But nevertheless, we have been waiting for many years, it hasn't come.
So there is a recent meta-analysis which has shown that 10 milligram of obeticholic acid should be used generally, in our setting, which is most effective. And
Oh, sure. I mean, if at all you use it, it will be 10, not a 25. That's fine. So I think I have more or less finished my questions. I'll now throw it open to the House. Please, here are two experts, so fire away. Any questions for them? All your issues?
Question.
Yes, sir.
Where is the evidence with saroglitazar?
Where is the evidence for saroglitazar? Today I am in a privileged position. I am not taking questions.
Can you show me even one phase 3 randomized control trial? I have not seen any data with saroglitazar, and it is many years now that saroglitazar has been touted as the panacea for NAFLD, dyslipidemia, diabetes, every illness. But show me one randomized control trial in NAFLD, NASH or diabetic dyslipidemia. There is none actually.
Right. So there is one very good, robust phase 2.
It's phase 2.
Yeah, phase 2 randomized control trial called the Evidences 4, where it definitely shows that the improvement in the MRI PDFF, the fat content of the liver, and the ALT levels. That's one. Second, there's the RCT from India, 102 patients. Unfortunately, only in the abstract form, not published yet, I agree. But that has also shown significant improvement in ALT and significant improvement in histology on paired biopsy. No improvement in fibrosis. I agree. But it is short of publication, it will get published, it's a phase 3 trial.
It's more than 2 years now, it's not been published.
Yeah. Third, personal experiences and retrospective trials. I think all of us who have used saroglitazar, patients come back to us and say, Dr. Saab, itne ALT to zindagi mein kabhi nahi hue. Itne normal ALT. I have never seen ALTs like these. So patients will come back with ALT like 10. That's how much they fall with saroglitazar. That is personal experience. Obviously, that cannot be touted as RCT.
We have a biopsy-proven trial even from ILBS, and Sarit sir has published that 1.5.
It's abstract.
No, that's okay, but what doctor is asking is that for a level 1 evidence, you need a randomized control trial, which internationally, which hasn't yet come. The only two things I would say in favor, or I would say to balance it, saroglitazar for a different indication has been in the market for long, and therefore the safety profile is well established. With regard to how effective it is for fatty liver disease, that's the question that needs to be addressed, and whether it would reverse early fibrosis or not, again, we don't know. So those are the ifs and buts. But anyway, my time is up. Thank you very much, and Sujit, thanks a lot for this opportunity. Enjoy your evening.
Thank you, sir.
Thank you very much, sir. With this, we shall now proceed to an online discussion by Dr. Mahesh Goenka on poem, standard and variations for echalacia. The chairpersons are Dr. J.R. Mahapatra, Senior Consultant Gastroenterologist, attached with the Peerless Group of Hospitals, Kolkata. We would also request Dr. Anirban Chatterjee, Senior Gastroenterologist from CMRI, Dr. Obhijit Sharkar, Senior Gastroenterologist, NH Hospital, to please chair the session.
President, Indian Society of Gastroenterology and Society of GI Endoscopy 2016-17. He is Governor, Indian Region, American College of Gastroenterology. He has more than 200 publications in various medical journals and books. So I think what Dr. Goenka is going to talk about is poem, the standard and variation for achalasia. So without wasting much time, I would request Dr. Goenka to go ahead with his deliberation. Okay, Mahesh, you are on.
Sir, you need to unmute yourself.
I think link problem.
Yes, sir.
Can you see me and hear me?
Yes, sir. Yes, sir. We can.
All right. Thank you, Dr. Mahapatra, for that kind introduction. I am missing Calcutta. I am at this moment in Varanasi for my ISG duty as a National President of Indian Society of Gastroenterology. They have an UP chapter of ISG annual meeting being held in Varanasi. I'll be back to Calcutta today. So the topic which has been given to me by Dr. Sudipto and Dr. Sujit Chaudhary is to talk about poem. I think poem has been a game changer, and so it's worth talking and spending some time on it. What I'll be doing for the next 20 minutes is to talk to you about indications, contraindications, preoperative preparation. Since I'm aware that in Calcutta there are only about 2 or 3 centers which are doing poem, I would talk about a technique in little details, talk about the results and some variations and take-home points. So I think we have progressed quite a bit in the evolution of third space endoscopy to reach where we are. It all started with EMR, ESD, then we have submucosal flap, then poem, then beyond that we had STIR, G-poem, Z-poem, and PREM, and now we are in 2022 having mastered some of these techniques. So what is third space endoscopy? Third space endoscopy basically means that you raise a mucosal flap, enter with your endoscope into a submucosal area, and then you increase that area by putting some substance inside that and the work in the submucosal plane. So these are the principles of poem. What we do is that we create a mucosal incision, then you create a submucosal tunnel, then you start a myotomy about 2 centimeters distal to the mucosal incision. The myotomy is extended into the stomach side, and then finally you close the mucosal defect. The moot point is that the muscle and the mucosa are not reached at the same point. So when poem was started, almost about 15 years back, it was primarily for type 2 achalasia. But over a period of time, it has been realized that this is possibly good for all achalasia types, whether it's type 1, type 2, or type 3. This has been used in pediatric achalasia. It has been more recently used for other disorders of the motility disorders, spastic disorders of the esophagus, and also as redo procedures after failed pneumatic dilatation, failed Heller's myotomy, and even failed poem. Now, there are some absolute contraindications, but patient needs to be cardiovascular, pulmonary-wise stable. It should not be a case of pseudoachalasia, and sometimes if there is extensive fibrosis, you may have to abort the procedure because it may be difficult to create the tunnel. Now, before I go into the procedure, let me talk about the equipments. These are essential components, and you must have all these before you start the procedure. So you have a high-resolution endoscope with a distal cap attached to it. This is a very important, though a small component of the whole accessories, because it keeps the working area a little away from the lens, and so it allows the visualization. You do the procedure under carbon dioxide rather than the room air. You need to inject methylene blue or some other contrast inside or material inside the submucosal tunnel, which can be either done with injections, syringes like this, or by a jet, water jet. You need to have devices to control the bleeding and to close the mucosal defects by using various types of clips. There are three basic types of knives which can be used to do the procedure. I use one of the first two. I don't have any experience with speed post. Those who have used it say that this fastens the procedure. However, the two standard techniques are either to use a hybrid type knife, which is T-type, Herbe knife, or an Olympus knife, which is triangular, or TT knife, which has a triangular tip, which allows equal distribution of energy all around. Now, hybrid knife has the advantage, it's a single stop shop, because it can do everything. It can cut, it can coagulate, it can inject, and somehow this is my preferred knife, though it makes a procedure a little more costly. So you need to have your setting decided. Each person may have a different settings, but in general, and this is what I use for endocut, effect 2, and for post coagulation also effect 2 is one which is used. Now this is a patient which I'm going to show you some of the details of the procedure. This patient on manometry, esophageal manometry, is type 2 achalasia. This is as compared to the normal manometry. You can see a propagation and look at the LES, and by this you diagnose achalasia cardia, and this was definitely achalasia cardia type 2. So what should be the patient position? Again, this depends on the comfort of the individual, but generally it is done in a supine position because it makes the orientation of the instruments very clear. Anterior and posterior is very clear where you're making the incision. More than that, what it makes is that when there is a pneumoperitoneum or capnoperitoneum develops, you can easily discern that, and I'll be discussing about it a little bit later. Now, the first step is mapping of the upper GI endoscopy, and I think it's very essential that you, before you start the procedure, you do a diagnostic endoscopy. Here you can see the spine on the posteriorly. So you know that that's a posterior wall. Then there's an anterior wall. You find some resistance at the lower esophageal sphincter. Then you retrovert in the stomach to rule out pseudoachalasia or a tumor present in the G junction. So here the scope is retroverted. You clean all the muck from the stomach and the esophagus because you do not want to contaminate the area of your operation. So this is mapping upper GI endoscopy, which is essential component. After you have done that, the next step would be submucosal injection. And here, what we do is that we are now taking a needle, and this can be either an anterior poem, which can be where you'll be injecting at 1 to 2 o'clock position, but mostly we do posterior poem, where you inject by the side of the spine in about 5 o'clock position, as is being shown in this particular video component. So you take out the needle and you generously inject about 15 to 20 ml of methylene blue, as you will see, and you create a good bleb at around 5 o'clock position, as you can see. So this bleb will act as a cushion, and when you are cutting, now you can see which part of the bleb is more vascular and which part is less vascular, and you start your incision from the less vascular area. So this is a nice bleb which has been created almost about 8 to 10 centimeter proximal to the G junction. So the next step is mucosal incision, and once you have created a bleb, you start from distal end and you make an incision about 3 centimeter in length proximally. This is, as you can see, that we start from a less vascular area, and you make initial days of learning, you need to make a little more longer incision, but as you become experienced more and more, your length of the incision will become decreased. Now, after you have done the incision, I think submucosal tunnel entry is the most important limiting step. And I think if you have learned this, then you have learned half of the poem. So after you have done the incision, you just don't push the scope inside the submucosal tunnel. You create a space by the side of the incision. So you are undermining the two edges. And I am doing a little bit of cut here by using the same knife. And you create a space beneath the mucosal incision so that the endoscope does not create a trauma while you're entering. At this stage, it is very important that you avoid the injury to the muscular layer, because that's what you don't want to do. You don't want a disruption of the mucosa as well as the muscle layer at the same level. So you can see that now nicely a wide, the incision has been made wide by creating some space around that, and then you enter with that. So the next step is submucosal tunnel creation, and if the videos run, now this I've shown both a triangular knife as well as a RB knife. The technique is the same, that so you are keeping your knife more towards the muscular side rather than the mucosal side. You don't mind if there's a slight injury to the muscle side, but you don't want to do a mucosal injury. So your cutting is towards a muscular plane rather than the mucosal plane, and you inject every time before you cut. So you inject either by the water jet of the RB or by needles when you are using the TT knife. Now the TT knife with needle with holes also available. So you progress, and if you come across small vessels, you can coagulate with the same knife. They say up to 1.5 millimeter you can coagulate with the same knife, but if they're bigger vessels, then you need to change your instrument. So you can see how the tunneling is done. Now you are not moving the knife when you are doing the tunneling, you are moving the scope right to the left, left to the right to cut to create the submucosal space. Now, prevention of bleeding is a very important step, and see, this is a large vessel, as you can see. Now, if I go on creating the tunnel without taking care of the vessel, then the vessel is going to bleed and the whole area will become very bad. So what you need to do in this situation is that you coagulate that, and I'm using a coag forceps, coag grasper to do this. This is Olympus grasper, very effective, and you can see that how the vessel is becoming gradually white, and you may have to use it 2 or 3 times as I'm showing it here in this particular video. So by that you have removed that vessel as an impediment for proceeding further. So you can take care of the bigger vessel in this way. However, if the bleeding happens, as is shown in this particular component of the video, then you do the same technique. You catch the vessel which is bleeding, and then you coagulate it. Sometimes you can use the same setting of 2, but sometimes you can change the setting when you are coagulating. So after you have reached that, you have made that area avascular, you can cut that particular vessel by using the cutting current. Now, identifying the gastroesophageal junction is very important, and as you reach that G junction, you can see there is a palisade of vessels which are there. The vessels become more and more vascular in that area, and there are palisade of vessels which are crisscrossing. And the identification of the gastroesophageal junction is done by a few criteria. So, length of the gastroscope, what you are inserting, the palisading vessels I talked about, you can go in and see the tightening at the LOS, the opening of the submucosal plane, and presence of oblique gastric mucosal fibers. And then you go into the stomach and retrovert to find out the presence of the dye in the stomach. So these are some of the landmarks for identifying the G junction. Next step is, of course, a myotomy. A myotomy is usually started about 2 to 2.5 centimeter distal to your mucosal incision. You can use any of the knives. You can use a hybrid knife. You have a T-shaped T-knife. You have a hook knife. So here you can see the circular muscles are very clearly seen. And what I do usually in my practice is that I first, in the initial part, cut only the circular muscles. But as I go distally, as I go close to the G junction, I cut the longitudinal muscles also. Here you can see beneath the circular muscles, the longitudinal muscles are seen, and the longitudinal muscles are not tightly snapped. So when you're cutting the circular muscle, there is some space which will be created between the longitudinal muscle fibers, and you may be exposing to the mediastinum. So here you can see the myotomy is being proceeded. Myotomy is usually not a very difficult procedure. And finally, so what is the length of myotomy? For category 1, that is type 1 or type 2 achalasia, usually you don't need to do a myotomy more than 6 centimeters, 4 centimeters in the esophagus, 2 centimeters on the cardia. For type 3 achalasia, you need to do an extended myotomy, which is much longer. And for sometimes for jackhammer esophagus or distal esophageal spasm, you may not go up to the LES, but you may do a long myotomy. The final step is, of course, mucosal closure, and this is also very important because you need to do a more or less a watertight compartment created here. So the first clip is always placed on the normal uncut mucosa that approximates the two divided mucosal lines, and then you go proximally one by one. Usually we use through the scope clips, but people have used over the scope clips. People have used Apollo over stitch for this purpose. But in our practice, we use through the scope clips, and we are very comfortable with that. Now, capnoperitoneum is very common. Let me tell you, it's a very, very common sequelae, and you can see that air below the diaphragm, and if required, you can put a needle and take it out. And it is not to be considered as a complication, it's actually a sequelae of POEM, and it happens in about 50% of the patient. So we keep the patient nilorally for 24 hours, IV analgesia, antiemetics. We usually don't do oral gastrografine, but some people would practice that and do it after 24 hours. We continue PPI and we do a manometry after 3 months, and you will find that the LES pressure has improved after 3 months. So POEM efficacy has been proven beyond doubt. Now, most of the data, a large series from Illinois, has shown that the success rate is more than 90%. But the important question is that, is it improving quality of life? And it has been shown in this study that the quality of life is also improved. Now, the important point again is that how does it compare with the two other established modalities, pneumatic dilatation and Heller's myotomy? So this was an randomized trial where POEM and pneumatic dilatation were done in equal number of patients, and look at the outcome. The POEM compared to pneumatic dilatation, success rate was almost difference of about 40%. Eckert score decrease was also much better for POEM. Retreatment requirement for POEM was 8% compared to 41% with pneumatic dilatation, and adverse effects was also low. However, POEM was associated with little more reflux than pneumatic dilatation. Now, finally, we have had Heller's myotomy as the procedure of choice for POEM, for achalasia cardia. So how does it compare with, and this is a study published about 2 years back in NEJM, where endoscopic and surgical myotomy has been compared, and the results was, in terms of success, almost similar. Clinical success 83% with POEM, 81.7% with Heller's myotomy, with only 1.4% absolute difference. But what was interesting was that the procedure time with POEM was much lesser, 13 minutes less than the LMH. There are fewer side effects, 2.7% with POEM compared to 7.3% with LHM. There is, however, a slight increase in the reflux. So what about the POEM in difficult situations? I'm not going to details in this. Associate diverticulum may be a challenge. Sigmoid esophagus can be a challenge, but sometimes we put a Ryle's tube inside the lumen to keep it on the right track. Otherwise, in sigmoid esophagus, you may lose the axis sometime, and redo POEM sometimes can be very, very difficult. One of our recent patients, we had a huge problem because their patient had a pneumatic dilatation a couple of months back in another hospital. And we tried a POEM and we had extensive fibrosis. Somehow we couldn't get over with it. So these are the complications. I talked about capnoperitoneum, retroperitoneal carbon dioxide, capnothorax, capnomediastinum, some mediastinal injuries, and bleeding either intraoperative or delayed may happen. Overall complication rate for minor complications is 11% and major complications is 1.4%. Now there is obvious question about anterior versus posterior myotomy. There are a number of studies which have compared that, and more or less most of the results say that anterior and posterior myotomy has similar result, though the study from Hyderabad showed that the posterior myotomy had higher esophageal acid exposure, where the anterior myotomy had higher inadvertent mucosal injuries. Now, what about partial full thickness versus selective circular myotomy? Again, the results are similar. However, if you look at this data, partial full thickness myotomy was faster, 56 minutes as compared to circular myotomy. So if you want to cut only the circular muscle, you will spend more time doing the procedure than if you are liberal and you don't mind doing a full thickness, partial full thickness myotomy. Now, post-part procedure reflux is an important point and is often talked about. Some people have tried to shorten the gastric myotomy to reduce it, but was not successful. So some technical modification has been done, and this is what I wanted to stress in this. This is, if you get a good exposure to the muscles in the lower esophagus, these are the oblique fibers and these are the circular fibers. So if you spare these oblique fibers from being cut and you only cut the circular fibers, that means once you reach the G junction, you do your myotomy more away from the midline, then you are likely to spare the gastric sling or the oblique fibers, and that has been shown in a study to reduce the reflux of a significant reflux of grade B or more by almost half. So this is one technique which has been used for the last 4 or 5 years, and again invented by Dr. Inouye from Japan to reduce the reflux. Of course, you can combine the combined POEM with endoscopic fundoplication. I have not done it till now. Dr. Amol Bapaye from Pune is expert in doing this, and they completely enter the abdominal cavity and then do a fundoplication from outside using the techniques of polyp threads. Now, this to me looks very, very demanding procedure, and I have no experience of this. Thank you very much. If there are any questions, I'll be happy to take it.
Hello. Yeah. Well, that was an excellent speech by Dr. Goenka, and the topic is now open for discussion. Anybody having any questions, any comments about poem? I've got a question, Dr. Goenka. What is the incidence of reflux disease in standard poem and in surgical fundoplication, in surgical Heller's myotomy? Incidence of reflux.
Yes. If you look at overall reflux rate, there is possibly a difference of about 15% more with poem alone compared to Heller's myotomy. But if you look at symptomatic reflux, then that data in NEJM also, if you do a sub-analysis, there's not much of there's no difference, in fact, between Heller's myotomy and the reflux. I think the difference we have to understand is the technology, because when you are doing a Heller's myotomy, you are actually disrupting the diaphragmatic crust, which is not being done in the poem. So poem has its own technical advantage, whereas I understand that Heller's myotomy has its own advantage. Now with the last few years of oblique fibers or sling fibers being spared, I think the reflux is not going to be a major problem. People have tried to do, as I said, fundoplication through the endoscopy, but I think that's too invasive a procedure. The other technique people have used is using Gerdex after doing poem to reduce the reflux rate. But I agree, at this moment, I think that's the only cause of concern, though not a major cause of concern for poem. But let me tell you that poem is highly acceptable procedure now with the patients. Patients know about it, and they've seen others doing very good with poem, and it is now becoming increasingly being used. I would also tell you that I learned my first poem. I remember I went to a remote village in China about 13 years back, and first 2 poems were done on a pig model. So I think there is a learning curve. For the first 10 to 15 procedures, there is a learning curve, and after you have done about 15 to 20 procedures, you are almost as good as an expert.
I think the statistics says that more chance of reflux with poem as compared to Heller. And
agreed.
But the degree of reflux is not very significant, because the mild to moderate, not severe reflux what you get with poem, usually we get is mild to moderate. And the problem with this, that can be tackled with your PPI, and sometimes you can do associated procedure like ARMA or ARMS. So you don't have to worry that much about the incidence of reflux with this procedure. And second thing about that anterior versus posterior poem, apart from the duration and the complication rate, is there any difference between these two? Because I know that to entering the tunnel is easier if you are doing by the anterior poem as compared to posterior poem.
I think it's, Dr. Mahapatra, this all depends on your habit. I have been doing almost all my poem with the posterior route, and we find that to be easier. I think it all depends on what you have learned and what you are practicing. I don't think there is one advantage over the other. What Dr. Hyderabad's study showed, though it was a small study on 30 patients on anterior and 30 patients on posterior, they found that the mucosal injuries were more with anterior poem, and they found that the reflux was more with posterior poem. So I think there's nothing much to choose. The other 3 comparative studies which I quoted in the table found no difference between anterior and the posterior. So it all depends on what you are comfortable with. I am more comfortable with posterior poem, so I do mostly posterior poem.
What is the status about speedboat use in doing poem?
I have no experience of using a speedboat. The people have, few cases have been done by people in India. I talked to them personally, some of them, and they said that the control on the incision was not good initially. But then I think again that is a point of practice. If you do a speedboat for quite some time, speedboat is supposed to be faster than any other knife which you use. But I'll tell you that I have seen people in China, they finish procedure in about 15 to 18 minutes. So I think, again, it's a learning curve and a procedure competence which matters. One thing which is very important, that you cannot do poem without carbon dioxide insufflation. You have to have carbon dioxide insufflation, and you have to have an end carbon dioxide measurement. And sometimes when the EPCO2 goes beyond 45 to 48, you may have to abort the procedure for some time before it comes back to the near normal.
Yes, wondering about one thing. What is the success rate of POEM in case of type 1 achalasia?
So when it all started, the story was that it was practiced primarily as a modality for type 3 achalasia, then the type 2 achalasia, and now all three. So I don't think there is a huge difference between the success rate between the three types of achalasia. Of course, in practice, you get type 2 achalasia more commonly than type 1 and type 3. But I don't think the type of achalasia any further is considered to be deciding the procedure. Okay. Of course, for type 3, they say the results with surgery are inferior compared to type 1 and type 2. So there is more reasons to choose POEM over Heller's for type 2.
I think, Heller's is more preferable in type 3, as they suggested, but type 2 and 1 results are good with this POEM.
Any question from the floor? Anyone or any comments?
I think we'll wrap up the session. Thank you very much.
Thank you.
Thank you. Thank you very much, sir. With this, we shall now proceed to our next session, Medical Therapy of NFLD by Dr. Kaushal Madan. May I request the chairpersons to please chair this session, Dr. Gautam Rai, Consultant Gastroenterologist, SSKM Hospital, Dr. Jayanto Mukherjee, Consultant Gastroenterologist, ILS Hospital, Dr. Vinayak Sinha, Consultant Endocrinologist, AMRI Hospital.
NAFLD, as you know, is the very complex pathophysiology, and therefore no wonder it is the most happening field in liver diseases, having multiple targets for drug therapy. To talk on this, we now have Dr. Kaushal Madan, who is an ex-assistant professor of hepatology ILBS and presently is the principal director and head clinical hepatology Max Hospital, Gurgaon. He is also director Artemis Center for Excellence, Digestive and Liver Disease. He is the general secretary of INASAL and he has more than 100 publications in peer-reviewed journals. Dr. Madan, please.
Thank you, chairpersons. Thanks to Dr. Sujit and Gemas for this invitation. I am no more the secretary. Secretary these days is Dr. Ajay Doseja.
Sorry about
So I've been asked to talk upon pharmacotherapy for non-alcoholic fatty liver disease, and the session which was prior to this, which was on the panel discussion on NAFLD, I think most of the issues have already been covered. I'll just go through the data. As was pointed out by Dr. Chaudhary, the lifestyle management remains the backbone of treatment for non-alcoholic fatty liver disease, and jumping to pharmacotherapy, you would be doing not doing justice to the patient you would be managing. So first and foremost, we have to advise lifestyle management. So if you look at this study of 261 paired biopsies among biopsy-proven NASH patients who had a resolution of NASH, they lost about 9 to 10% of body weight. Those who did not have a resolution of NASH, their body weight loss was about 2 to 3% or less than 2%. So based on that, this pyramid was created. If you lose about 3% body weight, there is an improvement in liver fat. 5% of body weight, the ballooning and inflammation improves. 7% of body weight, there is a resolution of NASH. And if you lose more than 10% of body weight, which is what should be targeted, you also have an improvement in liver fibrosis. And we all know that recent studies suggest that it is the fibrosis and not the histological NASH which is the driver of non-alcoholic steatohepatitis to advanced stages. But the problem with lifestyle management is that only 30% were able to achieve at least 7% of weight loss. There was also a study almost 10 years back from Dr. Gaurdas's group, in which he showed that patients who had stuck to their lifestyle management were able to reduce significant weight, improve their ALT, improve their insulin resistance. but only less than 30% of patients in their group also were able to stick to their lifestyle management plan. So that is the problem with lifestyle management, and when you have patients who have advanced disease, you are forced to start them on pharmacotherapy. So which pharmacotherapy? Remember, NAFLD patients have three concerns: fat in the liver, high ALT, and now since all of them come with a fibroscan report, high fibroscan value, that is LSM more than 8. Although we all know that histological improvement is the holy grail, but in your clinical practice, neither the patient seizes nor the physician orders a liver biopsy. I think among all of us, at least I can tell about myself that for a diagnosis of NASH, I have not ordered a biopsy in last 5 years. There are three categories. So three things which the patient look at, and three categories of NAFLD patients: those who have only fat in the liver, those who have fat with elevated ALT, and those who have fat with fibrosis with or without elevated ALT. And there are only three drugs or three categories of drugs which are either approved or available in our country. So we will only be talking about these drugs. There is no point in talking about drugs which will take about 2 to 3 years to come. So these are vitamin E, the PPAR agonist. Pioglitazone was already available. Diabetologists have been using it regularly, and now hepatologists have preferred using saroglitazar and the obeticholic acid. And to understand which drug to give, let's divide the pathogenesis also into 3 steps. So the first hit is the liver fat, which goes through the step of necroinflammation and then liver fibrosis. Yes, in some genetically predisposed individuals and especially diabetics, liver fat may directly lead to liver fibrogenesis. And there are certain steps which may fuel this progression, like oxidative stress, inflammatory mediators, cytokines, apoptosis. And those of you who are believers of the multi-step hypothesis would agree that all these steps are very important. And there are certain modifiers. These are the nuclear receptors, the PPARs and the farnesoid X receptors. So these are the ones you have to target with whatever drugs are available to you. So first, targeting the liver fat. Which are the drugs which remove the fat from liver? So PPAR agonists are the one. So we'll talk about saroglitazar. It is a novel dual PPAR alpha gamma agonist. The alpha part improves plasma lipid by increasing fat disposal from the hepatocyte, mainly by fatty acid oxidation or its transport out of the liver. And the gamma effect is mainly on improving the insulin sensitivity both in the liver as well as the muscle. So this was the study I was talking about, the phase 2. Now remember that according to the regulatory criteria, all phase 2 trials of NASH have to demonstrate that there is an improvement in liver fat by means of MRI-PDFF. So if a drug in phase 2 trial shows that it has a significant impact on reduction of liver fat in MRI-PDFF, that's a good drug. That is the drug which is then allowed to go on to a phase 3 trial. So in phase 2 trial, if you show that there is a reduction in fat, it is a good drug. So saroglitazar 4 milligram did show that there was a significant improvement in MRI-PDFF and a fantastic improvement in ALT levels. But there was no biopsy here. It also showed that almost 40% patients were able to achieve more than 30% reduction in MRI-PDFF fat. Now 30% reduction in MRI-PDFF is now used as a surrogate to show NASH resolution. So even if you are not able to do a biopsy, if you are able to show a 30% reduction in MRI-PDFF over 6 months or 1 year, then you can say that this patient will have a resolution of NASH. So 40% patients were able to achieve this. Again, this was the phase 3 trial. Dr. Sareen happens to be the first author for this, but again published in an abstract form from India, 102 patients, 52 weeks of saroglitazar. Primary endpoint was more than 2-point reduction in NASH score. 52% patients in the saroglitazar group were able to achieve it, but unfortunately, there was not even a mention of a reduction in fibrosis. They had a paired biopsies, but they did not even mention this in the abstract or when it was presented, whether there was an improvement in fibrosis or not. And that is what we actually want to achieve. The recent study, but again without biopsy, single arm study from Punjab, 101 patients, 24 weeks of use of saroglitazar, significant improvement in the ALT levels, and statistically significant improvement in their LSM levels on fibroscan, but again not very robust. Another study presented just 2 days back at ASLD from AIG, single center RCT, saroglitazar versus vitamin E in biopsy proven NASH. It does improve the CAP value, that is the liver fat, significantly much more than vitamin E, but no improvement in their LSM values or weight. Another study which was again presented just in the recently concluded ASLD, among liver donors who had more than 10% liver fat, this is from Kerala, 17 patients, this was the pre-treatment MRI PDFF, and this is the post-treatment PDFF, again showing that there was a significant reduction in liver fat. So saroglitazar, at least if no improvement in fibrosis, does improve or does reduce the fat significantly from the liver and normalizes the AST-ALT levels. So this was patients who only have fat. What about targeting oxidative stress? Vitamin E. This was the famous PIVANS trial, you're all aware of this. 3 groups, placebo, vitamin E, 800 units for 2 years. Pioglitazone 30 milligram. As long as these 2 drugs were used, there was a significant improvement or normalization of ALT. The moment you stopped them, the ALT went up again, unless the patient improved their lifestyle. Significant patients in the vitamin E group also showed histological improvement. And interestingly, as compared to placebo, vitamin E group was also associated with improvement in histological steatosis. How vitamin E reduces fat, the mechanism is not clear. So there was the tonic trial which was in children, also showed that vitamin E was associated with histological regression of NAFLD or NASH as compared to placebo. So what about effect on other outcomes? So it has no effect on fibrosis, but this was a retrospective study, large study of vitamin E versus placebo, 800 units per day. Median use of vitamin E was 5.6 years. The RCT was 2 years. 2/3 of these patients also had diabetes. The RCT did not include diabetic patients. 2/3 of patients also had cirrhosis. The RCT did not include cirrhotic patients. And it showed the hepatic decompensating events were lower in the vitamin E groups. The transplant-free survival was better in the vitamin E group. And all-cause mortality was also lower in vitamin E groups. So this again is contradictory to large population-based studies which have previously scared us in terms of vitamin E use, saying that vitamin E increases all-cause mortality. So this is a study, although in a small number of patients, with 5.6 years median use of vitamin E, high dose, showing that there was a reduction in all-cause mortality, not only liver-related mortality. So vitamin E reduces fat, also reduces inflammation, also is associated with good liver-related outcomes in long-term use. Third, patients who have liver fibrosis. We did talk about obeticholic acid in the previous discussion. Based on this Regenerate trial, which compared placebo, OCA 10 and OCA 25, primary outcome, improvement in fibrosis without worsening of NASH. And patients who had more than 1 point improvement in fibrosis were significantly more in the 25 group, also in 10 milligram group as compared to placebo. Those who had even more improvement in fibrosis stage were also better in the OCA 25 milligram group. Then they also compared patients who had worsening of fibrosis. So in the placebo group, equal number of patients had improvement and worsening of fibrosis, whereas this 25 milligram group, few patients had a worsening of fibrosis and large number of patients had an improvement in fibrosis, thus accentuating this effect or the antifibrotic effect. Patients, I told you, look at ALT levels. So there was a significant improvement in the ALT levels, both in the 10 milligram as well as 25 milligram group. Only problem is pruritus and a rise in LDL. Pruritus happens, it is dose dependent, occurs early in patients who are given high dose. So it is a dose dependent side effect. If you reduce the dose, possibly you'll get away with lesser pruritus and less number of patients will develop it. Second problem is LDL, and there was a fear of causing a significant rise in LDL and therefore a significant rise in cardiovascular events. However, they demonstrated that patients after 18 months of use, somehow the LDL returned back to baseline without any intervention. Other patients who had a higher rise were also given concomitant statin therapy, and in them the LDL returned to baseline levels for 6 months. So this is something which is modifiable, so not to fear the LDL rise. And now again this data was presented 2 days back in ASLD by Dr. Sanyal's group. Here they re-looked at the regenerate data by a consensus method. 3 histopathologists read the biopsy reports pre and post, and they also presented the largest safety data of OCA with more than 8,000 patient years of exposure. And they found that the new consensus method also confirmed the previous results, and it was possibly not a fluke. So 3 hepatologists read the slides and again found that patients who received OCA 25 milligram had almost double response rates as compared to placebo. Further, most frequent AEs were at 25 milligram dose was pruritus. The modest rise in LDL which occurred, it returns to baseline within 12 months without any intervention. All other adverse events were balanced between the placebo 10 milligram and 25 milligram group, suggesting that apart from these 2 side effects, which are usually manageable, it is a safe drug. This was a data published later which looked at factors which might predict response to OCA, and interestingly an ALT decreased by more than 17 units at 6 months of use suggests that these are the patients who are likely to reduce fibrosis on OCA therapy. So if we look at the relative performance of these drugs, I told you patients look at liver fat, ALT and fibrosis. So saroglitazar is a drug which avidly reduces liver fat. Vitamin E also does that as per the PIVANS trial, but OCA possibly has no effect on liver fat. All 3 drugs equally reduce the ALT levels with adequate use and adequate dosage. Only drug which has an effect on fibrosis is obeticholic acid. Vitamin E in a retrospective study has also shown to improve liver-related outcomes, and I showed you that study. That is from Dr. Naga Chalasani's group. And in terms of adverse events, we discussed this in panel discussion. Possibly saroglitazar is devoid of most of significant adverse events. Vitamin E, there is a concern about the carcinoma of prostate with long-term and high dosage use. And with OCA, we've talked about pruritus and the rise in LDL levels. So coming to anti-diabetics for NAFLD, and I'll only talk here about semaglutide because that is something which is available in the market and orally available drug, available in the strength of 3 milligram, 7 milligram and 14 milligram. And the use was based on this particular RCT. Again, this is a study, phase 2 RCT of semaglutide in NASH published in NEJM, where 0.4 milligram subcutaneous per day for 72 weeks, 1.5 years of use of injectable semaglutide, there was a significant improvement in ALT levels, and possibly the only drug up till now which has shown that almost 60% patients there was a resolution of NASH without worsening of fibrosis versus only 17% in placebo. And I think no discussion is complete on NAFLD unless we talk about UDCA, because stop here, somebody from the audience will get up and ask, sir, what about UDCA? So what about UDCA? This was the first large randomized control trial of UDCA in NASH patient, biopsy proven, no different from placebo, both in terms of ALT reduction and improvement in histology. Then they thought that let's increase the dose of UDCA to 22 to 28 milligram per kg per day and do another RCT. Again, there was no improvement in liver histology, inflammation or fibrosis. Then they thought, let's give even higher doses, 28 to 35 milligram per kg per day for 1 year, and another randomized control trial with placebo. Here they did show that the ALT reduction was significantly better in the high dose UDCA group, and in a non-robust manner, a fibro test reduction from baseline was better in the UDCA group as compared to placebo. But clinically, in clinical settings, a dosage of 28 to 35 milligram per kg per day is impractical, possibly will lead to a lot of diarrhea in Indian patients. So to end my talk, take home message, lifestyle measures have to be applied in all, and a combination of diet and exercise with a target weight reduction of at least 10%. Patients who have only liver fat, normal ALT, no fibrosis, they do come to you with a ultrasound report saying grade 3 fatty liver, grade 2 fatty liver, but they have no fibrosis, normal ALT. Just give lifestyle measures. If you are forced to start a medicine, you may start saroglitazar or vitamin E, but that is not what I am recommending. If you have raised ALT in these patients with no fibrosis, then saroglitazar or vitamin E can be the first drug to be started in the appropriate doses. Those who have also a fibrosis of more than F2, then the first drug can be a saroglitazar plus vitamin E, but these are not the usual recommendations. Combo therapies have not yet come as part of recommendations, but yes, this can be used, or you can start OCA, or a combination of OCA plus saroglitazar, because they will take care of each other's adverse events. Thank you so much for a patient hearing.
Any questions from the audience? Thank you for that excellent presentation. How frequently do you follow up these patients, monthly or annual, 3 monthly?
So once we are sure that what we have to follow, what objective parameters we have to follow, and patient is following that advice, then 3 monthly is sufficient.
There used to be this concern about vitamin E and increased cardiovascular events. Is that still a fact, or?
So there was another large meta-analysis of large population-based study which refuted that claim that it leads to an increase in all-cause mortality and cardiovascular mortality.
Dr. Mahapatra.
Pardon?
Diabetes and vitamin E.
Yeah, so like I talked about, the initial study was done in non-diabetic patients, and even the ASLD recommended that it should not be used in non-diabetics because the study was not done in them. But this particular study, 2/3 of these patients, the retrospective study, were diabetics, and there have been subsequent, I'm sorry I did not show them, subsequent studies of vitamin E, pioglitazone versus placebo in diabetic patients also, although small number of patients, 30-35 patients in each group, and it was found to be well tolerated, not contraindicated.
So the latest ADA-ESD algorithm for diabetes has now taken cognizance of NAFLD as a complication of diabetes, and it has proposed that we should be using pioglitazone or GLP-1 receptor agonist. What is your thoughts on that?
Yeah, so I think, the Diabetic Association is suggesting that we should be using pioglitazone or
GLP-1 receptor.
Right. So I think that there is nothing new in that, because that is based on the PIVENS trial, which used both vitamin E and pioglitazone, or pioglitazone versus placebo. And for long we have seen that diabetologists prefer to use pioglitazone, hepatologists prefer to use vitamin E. And there's a problem with pioglitazone you are well aware of, that is of weight gain of almost average of 3 to 4 kgs or up to 5 kgs in these patients over 1 to 2 years of use. So that becomes counterintuitive. At one side you are asking the patient to reduce weight. So we hepatologists have not somehow been able to bring ourselves to use pioglitazone that frequently, but I agree the results are almost similar to vitamin E.
What should be the dose of the lipaglyn that is marketed only in India, not in Europe or USA? It is marketed as lipaglyn, saroglitazar. In our practice, for hypertriglyceridemia, we use only 4 milligram. In this case, what should be the dose?
So in this case also it is 4 milligram. So it is possibly the only drug, but I agree with our diabetologist friend here who says that without robust evidence, the FDA in India or DCGI in India should not have approved it, but it is the only drug which is approved for use in patients with NASH by DCGI and possibly by any drug regulator anywhere in the world. 4 milligram dose.
4 milligram. How long?
The studies have suggested 6 months to 1 year. The RCT which is available is for 1 year. Again, not published in a full article format, only in an abstract form.
Okay.
So regarding the pioglitazone, although there was a weight increase, there was a decrease in inflammation and liver fibrosis. That's why low dose pioglitazone is the recommendation, not the 45 one. As regards vitamin E safety, 4 doses were used, sir, 800, 1200, 1600. Maximum benefit was with 1200. However, 800, more than 800 is not recommended because the cardiovascular effects outweigh the benefit of more than 800. That is why we use 800 only for NASH patients. 400 twice that.
Yeah, 400 twice a day.
So,
yes, so one of the adverse events previously mentioned in the other studies was increased risk of hemorrhagic strokes. But that has not been seen in the studies done in patients with NASH.
So thank you, Dr. Madan. With this, we end this session. Thank you all.
Thank you, sir.
Thank you. Thank you very much, sir. We shall now proceed to our next session. It's an online session by Dr. Prasoon Jalan, Nutrition Therapy of Cirrhosis. The chairpersons are requested to please come on the stage. Dr. Kingshuk Das, Consultant Gastroenterologist of Apollo Hospitals, Kolkata. Dr. P.P. Bose, Consultant Gastroenterologist, Prialis Hospital, Kolkata. Dr. Obhijit Sharkar, Consultant Gastroenterologist, attached with NH Hospital, Kolkata. Here is an announcement from the Housekeeping Board that a cocktail dinner would be served at around 8 p.m. after the sessions are over. All the faculty, the delegates, the guests and the members are requested to be present for the dinner.
Can you see Prasoon on the screen?
I don't know whether you can see me.
Prasoon, good evening.
Yes,
good evening.
Good
People are asking me to chair the session and introduce you. So how do I introduce you? That same Prasoon
we are friends for a long time.
Friends for a long time, since 1990s. So see, this is to introduce Prasoon will be a huge story. Starting from a village and reaching now to Texas and doing his job in BCM is something, a great thing. I think we must clap you before your talk. I think audience, we must clap that. So Prasoon started his journey, everyone knows, who are from medical college in 1990s, and he reached PGI Chandigarh, and we are friends together. I was DM senior resident, he was doing MD there, and we fought. The three things were there that we fought and fought and fought, and Prasoon was really, without taking care of his hairs, without taking care of his socks, a gentleman who used to come with his shoes without the socks, Prasoon. Do you remember those days? And then we were really something, he was so brilliant, you know, today he is there. Now after that, I hope that he went to Leeds, and there he finished a lot of things. He did there some of the areas of his interest, and from there he went to whatever, he went to Mount Sinai and whatnot. He added so many degrees on those sites, I have no time to tell that. And from there now he's in Belarus BCM, College of Medicines, and he's now their assistant professor. I was going through his in Google's, what you read that, both in medicine and surgery. And that's something which is really difficult for us to understand. He got Wilson Award there in 2006, Don Wilson Award, and he is fellow of ASGE as well as fellow of American College of Gastroenterology. And then he had a governance award in clinical research, American College of Gastroenterology, as I said, more than 50 publications, international publications. And if you see, he has studies both involving, in fact, the pancreas also, the small bowel, the pancreas, where not the main interest is in liver. And he has a transplant hepatology experience also. Proshun, is it enough to introduce you? And then he will be talking to us on nutritional aspects in cirrhosis, and the most neglected, at least to Bengal Proshun knows, that liver rog hoyeche ar kichu khete deo na, eke seddho diye rakho. And Proshun used to tell, and we used to discuss there in the ward that what food a person should get. And we have a huge development. Proshun will tell us about the pathophysiology, I hope, and how to, in short, to diagnose the nutrition in the person who is suffering. And then possibly he will give us a little bit of investigation and new insights in the nutritional therapy and what we can do for that. Proshun, it's all yours. With me, Pathuda is here, he is also from PGI, and Abhijit is here, also will be asking you and disturb you in between. A lot of audience there will ask you in questions. Proshun, it's all yours.
Thank you for the kind introduction. Yeah, I totally agree that we have a lot to talk about, not from the management of cirrhosis, but also in other areas. And I also know that I can't join you with the cocktail. I wish I was there. And I'm between, my talk is between your dinner and other recreation, right? So I try to be a little bit more focused and precise. Let me share my screen. Just hold on a second. Okay, can you see my screen?
Yes, sir. Yes, sir.
Okay. All right. So
can't see your video.
But you can see my slides, right?
Yeah, I can see your slide, but not
Okay.
your video.
I'll leave it to slides and I'll come back to the video in a minute.
Okay.
Okay, so we are going to talk about the nutrition in cirrhosis. And when you talk about nutrition, we all know that it's very important. And when you talk about cirrhosis, especially decompensated advanced liver disease, there is an interplay between malnutrition and frailty and sarcopenia. That means people get frail, people lose muscle mass, and that's related to not only cirrhosis itself, the disease, but also because they're not active physically, they have other environmental in a problem, like if they get confused, they're not being managed, they're not in the appropriate setting. Also there could be infection, and that all leads to further decompensation, increased cost, decreased quality of life, and eventually poor outcome, including death. So how common is it? Malnutrition is a typical burden in cirrhosis, as Kingshuk mentioned, and 20% of the patients with compensated cirrhosis and more than 50% with decompensated cirrhosis. So it can progress to further liver failure, and as I mentioned that it's not just the adipose tissue, and also the muscle tissue gets depleted. So interestingly, in female, depletion of fat is more frequent, and male, loss of muscle tissue is more rapid. Because of this malnutrition and sarcopenia, eventually people get more hepatic encephalopathy, more infection, worsening ascites, and that goes to reduced overall survival. In liver cancer, there is increased complication and decreased survival. After surgery, more time to recover. After liver transplant, more time to get back to their own self, and also they have got more risk of dying on the wait list before the transplantation. So nutrition is so important, and as King Shuk mentioned, it's overtly neglected in cirrhotic patients. And it is really a therapy, not just assessment and some supplement. So we are going to talk about how to screen, what kind of nutrition management principles we apply, how do you assess sarcopenia, because they're very closely interrelated. What do you do in patients who are obese? They can be sarcopenic or malnourished as well. There could be other nutritional deficiencies. There could be nutritional treatment options for HE, any particular area we can focus, other special considerations, and areas of research. So the first thing is, who are at high risk of malnutrition? People who are underweight, the BMI less than 18, which you don't see very often in Texas, where I am. However, when they get advanced cirrhotic, they do lose weight. And also patients with advanced decompensated cirrhosis with child PUC or advanced B. All patients at risk of malnutrition should have an assessment by a dietitian or a nutritional expert, wherever you are. The key is, this is a very important area, often overlooked, and you need an expert opinion on that. So, an outpatient, every 6 months, they should have evaluation. If they're sick, more frequently. As an inpatient, at admission, then hopefully every week. The muscle mass and sarcopenia go hand in hand. Now, there are many ways to measure it. Most sensitive and specific way is do a CT at the L3 vertebral level. Unfortunately, that means more radiation, and it's not practical. I think still the regular anthropometric methods are helpful, and what we say is our eyeball testing and hand grip strength. We cannot overlook our clinical parameters. And although studies are not perfect, showing that they are not the best, however, that's the more practical. You also can do bone mineral density, as I will explain later, which will give the bone health. And there are many other ways subjectively to assess, like Royal Free Hospital Global Assessment, and very important, patient-reported or family-reported dietary intake. So we call calorie assessment 3-day, and that is one of our tools we always use in our day-to-day practice. Sedentary lifestyle is highly prevalent in patients with cirrhosis. Most of the time, as King Shuk mentioned, people say, oh, don't move, don't walk, and don't run. That's the worst thing we can really advise them. So what is our goal? Our goal is the golden rule. We call 35 kilocalorie per kilo of actual body weight per day in non-obese individual. And very important is 1.2 to 1.5 gram per kilo of actual body weight per day of protein intake. If you take any message from this talk, this is the one. So what is the problem in cirrhotics? How do you measure the dry weight? Well, we have to be practical. You can take as post-paracentesis weight after the patient has ascites, or you can subtract the weight based on the amount of fluid retention. Mild, you can reduce 5% from the body weight, moderate 10%, severe from the body weight 15%, and additional 5% take off if there are bilateral pedal edema up to the knees. And again, so 35 kilocalorie per kilo of body weight per day, calories and protein is 1.2 to 1.5 gram per kilo body weight per day. So cirrhosis is a state of starvation. What happens here, they have got impaired gluconeogenesis, and also preferentially they are using more amino acids. Way back in 1983, the studies have shown that when a patient of cirrhosis, decompensation, fasting, 12-hour fasting is equivalent to almost 3 days of fasting for normal, average, normal, healthy individual. That's you and me. So if the patient is fasting overnight from 7 p.m. to 7 a.m., that means almost 2 to 3 days of fasting for us. Why that happens? Because of reduced PO intake. Of course, we have cirrhotic patients don't eat very much. They have ascites. they have upregulation of all the cytokines, they may have more bacterial overgrowth, delayed gastric emptying, impaired gut motility, they have got loss of taste. Some people drink, they don't eat very much, and there is also not enough intake of protein. There is intraluminal bile acid deficiency, bacterial overgrowth as I mentioned, they can have pancreatitis, chronic. And again, they have impaired gluconeogenesis to reduce the store of glycogen, and they break down the fat and muscle. There is a hypercatabolic state, and also with every time they get paracentesis, they lose a lot of protein. Some patients require paracentesis every week or even twice a week, and so much protein goes up that we cannot replace by giving albumin. The goal of albumin is not to replace the protein, it's more for the volume. So also, this is very important to understand the nocturnal nutritional supplement improves, studies have shown, total body protein status in patients with cirrhosis. That means if you're giving in the daytime, which is great, but you're not giving the protein supplement, nighttime feed, they lose muscle mass and protein much faster. There is always a concern of giving protein in patients with high ammonia with encephalopathy. But studies have shown there is no difference between low protein diet and normal protein diet in the precipitation of encephalopathy. So please give more protein to them. And also we have seen that high energy, high protein diet at late evening snack that improve nitrogen retention. Simply increasing caloric intake does not reverse or prevent sarcopenia. So practical advice is healthy eating of variety of foods, both vegetable protein and animal protein. With the exception of alcohol, virtually no food is excluded in patients of liver disease. So they can eat everything. In most cases, eating adequate calories and protein is much more important than avoiding specific type of food. And food intake, 3 main meals they should eat, including 3 snacks in between. And especially important is late evening or nighttime snack. So reduction of total protein intake is not advisable. The mechanism of sarcopenia and why this breakdown happens. And as you see, that's very much correlated with increased HE, hepatic encephalopathy and ammonia. So increased portosystemic shunting and liver synthetic dysfunction. So as a result, so the ammonia easily goes to the brain and bypassing the liver. And patient has accelerated starvation, decreased amino acid, and also decreased testosterone growth hormone, and increased endotoxemia in the gut with the mycobacteria, and also the myostatin is an inhibitor of myocytes. So it all lead to more muscle breakdown, leading to further sarcopenia. So the potential management approach, first thing is, please give enough calories and protein. If needed, give supplemental enteric nutrition. If you can't, preferentially, you can give NG tube enteral feeding if the patient is not taking enough. TPN is second choice, but first choice is use the gut. And we have a lot of patients in the ICU who cannot really eat very much. So we always put them feeding tube, including, we call Dove up here, and give supplemental feeding. What about the branched chain amino acids? Well, ideally, we should give food which contains branched chain amino acid. But sometimes it's necessary to give, especially in decompensated cirrhotic with neuropsychiatric problems. Avoid hypomobility. So in patients, we encourage them to walk, to jog, and if they can, run. 150 to 300 minutes of moderate to vigorous intensity exercise per week, and including muscle strengthening exercise at least 2 days per week is very important. So there are many areas we can improve sarcopenia. One is we can use the ammonia lowering therapy. There are many in the pipeline. The myostatin antagonists, we can use zinc, antibiotics in improving permeability, and some mitoprotective agents. And also, if the patient has deficiency of testosterone, that also helps. The only problem is when the patient has advanced liver cancer, we don't use it. they often have testosterone deficiency. So what about obese patients with NAFLD, as we just discussed, with cirrhosis? Again, should not be sedentary. There is a huge problem with sarcopenic obesity, including, especially the problem everywhere, including in India. So here, if the patient's BMI is more than 30, look for fluid retention, estimate the dry weight, as I mentioned. So here, you can restrict the calories, but do not restrict protein. So instead of 35 kilocalories per day, per kilo per day, so you can reduce it to 25 to 35 if the BMI is 30 to 40, and reduce the calories to 20 to 25 if the BMI is more than 40. However, do not reduce the protein intake. Still keep the protein intake around 1.5 gram per kilo per day. You can use hypocaloric diet. So the goal is to lose 5 to 10%. Well, we have a lot of patients, NASH patients, obese. Before they go for transplant, we ask them to lose weight. This is the only way you can achieve. Lower the calorie, but not the protein. What about micronutrients? They're often deficient in fat-soluble vitamins at A, D, E, K, and you should measure especially the vitamin D level. And if the level is more than 20, please supplement it. Keep it more than 30. It's a smaller dose if it is less than 20, but if it's less than 10, use much higher dose of vitamin D. Keep the level more than 30. What about the sodium? We try to get too restrictive of sodium, and they eventually don't eat very much, because it has been found that almost 20% reduced calorie intake happens if you restrict sodium too much. So standard recommendation is to give 5 grams of salt every day, so 1 teaspoonful, including all the salt you have in the diet. However, I don't usually restrict the sodium a whole lot. I always say eat more and eat more protein. So there is this concept, gut, liver, muscle, brain axis. So again, it's not just the liver. Think about the gut, think about the muscle, think about the brain. There's a very close interplay between all these 4 organs. So for hepatic encephalopathy as well, if you go back there, the more ammonia happens, when the liver is the primary place where the ammonia metabolism happens. The next place metabolism happens is the skeletal muscle. So if you are really, liver is not functioning, and the patient has sarcopenia, there will be more and more encephalopathy. So we always say that avoid protein restriction, go with the adequate energy and calorie intake, and you can use branched-chain amino acid containing diet. And oral diet intake is preferred in patients who can tolerate it. If the patient who are confused, cannot take orally, give enteral feeding. Practical advice again, 1.2 to 1.5 gram per kilo of protein, even with episodes of repeated encephalopathy. At least 33% may come from plants. Branched-chain amino acid, 14 to 16 gram per day. Late evening snack or late night snacks. Avoid fasting longer than 3 to 6 hours. Encourage small frequent meals throughout the day. So they should eat meat, chicken, fish, dairy product, eggs, and of course you can use plant-based choices as well. What about the other issues we have? Patients, as I mentioned, they have low testosterone, they use drinking alcohol, they smoke, early menopause, they're more osteoporosis, sometimes they use steroid for many reasons, advanced age, and they have amenorrhea, postmenopausal. So there are many factors can eventually lead to bone loss and sarcopenia. Especially patient is cholestatic, patient has cholestatic liver disease, like PBC and PSC, and patient is getting supposed steroid treatment. So always give the calorie, give the nutrition, give the protein, check the DEXA scan, look for osteopenia in a baseline and every 2-3 years. If there is rapid bone loss, do it every year. Give calcium and vitamin D. You can use bisphosphonates and consider testosterone supplementation. So this is what we do. If the T-score is more than minus 1.5, repeat in 2-3 years, calcium, vitamin D. And if there is osteopenia and osteoporosis, then definitely use bisphosphonates. So what about in critically ill patients with cirrhosis in ICU? They're hospitalized, they have ACLF, they're in ICU, they may have acute alcoholic hepatitis. Again, increase the protein intake, increase the calorie intake. Do not restrict it. This is very important. And especially, okay, people say, what about tips? The studies have not shown placing tips help in a controlled trial, but if the patient needs tips for other reasons, using tips, placement of tips has helped to regain their body weight. So if the patient has NG tube, you need to place, patient has variceal bleed, don't hesitate. This NG tube placement is not a problem even if patient has large varices. The patient is going for liver surgery or transplantation. It's very important to maintain the total calorie intake and the protein intake. And sometimes we do give supplements with nasogastric feeding. Now, post-surgery, post-transplant, there may be ventilation, may have been prolonged ICU stay, they may be having sepsis and bile duct other complications, and that's the stage they're hypercatabolic, they need more and more nutrition. Again, if you want to give enteral feeding, start soon and increase the calorie and the protein intake. So what areas we can do future research? Nutrition is a very poorly understudied and difficult to do. We can definitely do more and more studies where increasing muscle mass, increasing protein, where to see the outcomes. The data are really lacking. The ammonia lowering strategies, there are many drugs in the pipeline. I'm sure that with use of these drugs, that will help to reverse muscle loss and bone loss and improve the clinical outcome. Graduated exercise is very important, and we don't know how much exercise and how often you should do it. The using exercise physiologist and nutritionist in your team is very important when you're managing decompensated cirrhosis. What about the supplements, especially branched-chain amino acids? We need more data. We have problems using supplements over the counter because half of the time you don't know what it is inside. So I'm not very the supplements. However, in isolated cases, we definitely can recommend using some supplements. And I'm sure that there will be more targeting protein therapies are coming, but they're in the pipeline. And we can discuss that more in the next talk. With that, I can stop sharing and I can take questions.
Hello. Well, thank you, Dr. Jalal. That was a thorough and extensive discussion on the nutrition and chronic liver disease. Is there any question or any comments or anything in the Indian context, maybe? I've got a question for you. In a grossly malnourished cirrhotics, how do you improve the nutrition? I mean, apart from standard calorie and protein management, would you recommend overnight feeding tube feeding?
So in an inpatient, definitely.
Below 18, BMI below 18. So to start with, we need to improve the nutrition. So how do you, what will be your advice?
So first thing is you need to involve a nutritionist or dietitian as well as the exercise physiologist, physical therapist. Now, if the patient is in the hospital, as you mentioned, we usually do a calorie assessment, a 3-day calorie or 1-day calorie assessment. How much is the nutritional intake for the patient? I will definitely recommend a feeding tube, especially overnight feeding tube in this patient, supplemental. Start with overnight supplemental tube feeding. If they are not taking enough calories, as I mentioned, need to have 35 kilocalories per kilo per day, and protein is 1.2 to 1.5 gram per kilo per day. If they're not taking enough, and use the nutritionist's help, put the feeding tube in, and give supplemental nutrition. If they can take orally enough, encourage them to take high protein, high energy drinks. We use here Ensure Plus or Boost. In general, they have got 14 grams to 18 grams per can. So, as I said, with the measurement of the daily intake, I usually tell them drink 3 to 4 cans every day. I need, on average, 80 to 100 gram protein for you all. And I, of course, the nutrition-wise, the calorie-wise, I need 2,000 kilocalorie per day or more. So, yes, to answer your question, definitely use NG tube feeding, or we don't see nasogastric here is nasoduodenal tube, and that's very helpful. In addition to encouraging oral intake. Nighttime snacks, if they can take peanut butter jelly sandwich at night, that really helps. All I said, that before you go to bedtime, take a good peanut butter jelly sandwich or even nuts.
Okay, and one more question is, as you have mentioned about the sarcopenic obesity in cirrhosis is quite common, where the BMI is more than 30. How do you handle that sarcopenic obesity? What kind of dietary advice do you give to them?
So as I mentioned that here, do not restrict the protein, but give them low calorie diet. So if the BMI is more than 30, instead of giving 35 kilocalorie per day, give less. So if the BMI is between 30 to 40, give them 5%, lower the 5, like 30 kilocalorie per day. If it is BMI is more than 40, give them 5 kilocalorie per day. So the rule of thumb is ask them to eat 1/3 less than what they're eating. Don't restrict the protein, but restrict the calorie. So they should still eat small meals, frequent meals, less fructose containing food, less carbohydrate, but don't restrict any protein. So again, cut down the calorie by 1/3.
Okay.
And how do you actually diagnose sarcopenic obesity in your clinics?
So here we use, in the hospital, we use L3, Schwartz muscle assessment, but that's not practical. Sarcopenia and frailty go hand in hand. There's an easy clinical tool Jennifer Lai has proposed, in liver frailty index, which is based on hand grip, bed to chair, all this mobility assessment. But I said that eyeball test. Look at the hand grip. Look at the regular anthropometric measurements. BMI is not always the best, especially if the patient has the ascites. So reduce the BMI, as I mentioned earlier, they take the body weight off based on the ascites or fluid overload. However, so use your general judgment, regular anthropometric measurements. You can use skin fold, you can use hand grip, and you can use the in general mobility part to check the assessment of the frailty. But if you have the tools, you definitely can measure Schwartz muscle index.
Yeah. So, Prasoon, it was a wonderful talk, and it's a very encouraging also to. Prasoon was also from my alma mater, that is medical college, and it's really proud to have somebody who has gone to Texas. From PGI also he was there in the common place. I just wanted to ask you, you have told us something which is quite revolutionary. If I have got you correctly, we used to learn in our undergraduate and even in our postgraduate thing that animal proteins should be restricted in a person with hepatic encephalopathy because of the presence of aromatic amino acids, and we are targeting basically aliphatics or branched-chain amino acids which are. You have mentioned that in hepatic encephalopathy you take up to 33% of vegetarian protein and the others could be animal protein, and you have even given a very nice slide in which a lot of non-vegetarian food was supplied. So you have mentioned that, I mean, this theory doesn't hold any good, that in a person who comes to you with hepatic encephalopathy,
before that stage he reaches hepatic encephalopathy, you give him a lot of protein, that's fine. That's according to the classical teachings. But when the person enters hepatic encephalopathy, you don't restrict his animal proteins, is that what you mentioned?
Correct. So animal protein still is the best source of protein. Yes, we do have good source of protein from vegetarian food, but especially if the patient is vegetarian, we do not restrict any animal protein. So we always say eat whatever you feel is the best for you, especially high protein diet. Now, occasionally you will find patients, they're taking, for example, here we see, took a big steak, then they went to hepatic, precipitation of encephalopathy. So that we always say, don't take a large meal, use small frequent meals. But to answer your question, there is no restriction for protein, including animal protein. That's correct.
What about the aromatics versus aliphatics?
That data hasn't shown to be very valid. So I don't think we need to pay a lot of attention to that. More importantly is they need to have protein, and the animal protein is the biggest source, and they should have it. Because as I mentioned that if you lose muscle mass, they're not eating, they're having paracentesis. So the ammonia, the first place where they get the metabolism is the liver. The second place is the muscle. So if you're losing muscle because not eating well, especially the protein, then you'll have more and more ammonia production, causing more encephalopathy.
I think, thank you, Prashun, thank you, Jalal. A really beautiful insights you have given us over the last 30 minutes or so. Thank you again. And please come back to Calcutta next time and give us a physical talk, physical presence. We need your presence here. And really, we appreciate that whatever work you are doing, we will always get in touch with you on those aspects. Thank you again.
Thank you. Appreciate it.
Thank you. Thank you very much, sir. Thank you, chairpersons. We shall now proceed to our next topic, palliation in pancreatic cancer by Nalini Gora. It's an online discussion again. I would request the chairpersons to please chair this session. Dr. N.P. Bohidar from the Senior Consultant Gastroenterologist from NH Hospitals, Professor Shorab Ghosh, Oncosurgeon from Medical College Hospital, and Dr. Shomik Banerjee, Assistant Professor and Consultant Gastroenterologist, SSKM Hospital.
Good evening and welcome to my co-chairperson. It is a privilege to welcome It's a privilege to welcome Dr. Nalini Gouda, who is the Clinical Adjunct Professor of Medicine, University of Wisconsin School of Medicine and Public Health, and the Program Director for Advanced Endoscopic Fellowship, Milwaukee, and also the Associate Program Director for the Gastroenterology Fellowship Program, Aurora Healthcare, Milwaukee, and who will be giving us a lecture on a very neglected topic, at least in this part of the country, palliation of pain in pancreatic cancer, especially advanced pancreatic cancers. Dr. Nalini Gouda, please.
Good evening, everyone. Thanks for your kind introduction, and thanks for inviting me for this conference. Sorry, unable to be in person, but at least I will try to deliver the talk live, so it comes out better and we can have a discussion. So I know we are running a little behind on time, so in the next few minutes I will talk about what can we do as endoscopists and gastroenterologists in the palliation of pancreatic cancer. So pancreatic cancer, as we all know, has a very high mortality, at least in the United States. It's likely to be the fourth most common cause of cancer-related death fairly soon. Worldwide, it's about the seventh highest mortality. We all know at the time of diagnosis, resectability is less than 20%, and 5-year survival rates are still dismal at about 5%. Those with pancreatic cancer, we know, present to us with gastric outer obstruction. Pain control is something that we could potentially do. Also control the tumor growth by local sensitization and treatment. And after Prasoon's talk, I should have mentioned about nutrition that I will not be covering in this talk in the interest of time. Recently, I did give a grand rounds for the American College of Gastroenterology, and maybe those who are interested can still go and access the recording. So what is our role in palliation in pancreatic cancer? In the next few minutes, I'll be talking about biliary drainage, whether you do ERCP and stent or now endoscopic ultrasound guided drainage of the bile duct. I'll also talk about gastric outer obstruction. How can we manage it either by stent, surgery, or endoscopic ultrasound guided bypass? And tumor localization and fiducial placement and what its role. Also about some pain management and local therapies. So on the picture above, you can see why biliary drainage is important. As we all know that the liver is drained through the bile duct from through the pancreas. So any lesions in the head of the pancreas can cause obstruction. So one could get into the duodenum and stent the bile duct, or you can do percutaneous drainage of the bile duct, or now you can do endoscopic ultrasound guided biliary drainage. So lesions of the head of the pancreas are most likely to cause biliary obstruction, also can cause jaundice, pruritus, and obviously cholangitis. Current concept in management of pancreatic cancers is upfront stenting prior to neoadjuvant therapy, which has become very common. You could do a surgical bypass, or you could do percutaneous drainage or endoscopic drainage. Surgery is not preferred because of increased recovery time, and it's rarely done these days, even in the non-developed parts of the world where stents could be expensive. Percutaneous drainage, again, I personally do not prefer. It's not desirable. You have somebody with cancer and looking at palliation, having an external bag, leakage, infection of these tubes. So it should be your last resort to send somebody home with a percutaneous drain. So should we routinely then do endoscopic biliary drainage? We all know not everyone needs drainage. Only head of the pancreas lesions which cause biliary obstruction, or if you're not planning to do upfront surgery or surgery is delayed by greater than 2 weeks, then you want to drain the bile duct so you prevent the risk of cholangitis and delaying surgery. If somebody has concomitant gastric outlet obstruction, you need to consider that and stent the bile duct first, because later on it would be difficult to access once you put the transpyloric or transduodenal stent. We should recognize that ERCP, even amongst experts, I know a lot of you here are very adept and experts in ERCP, we still have a complication risk of about 5 to 8%. So it should not be done routinely. For upfront surgery, you do not need to do routine ERCP, and this is the paper that was published in the New England Journal a few years back that showed very high complication rates which have delayed surgery. So the limitations of this study, though, was that the ERCP had high failure rates, which is a little more than what you would expect. Complication rates are also reportedly higher. And at that time, we did not have data on endoscopic ultrasound guided intervention. And I know there are many of you who would rather do endoscopic ultrasound guided drainage therapy up front. So biliary stenting, endoscopic metal stents again are favored over plastic stents because they have longer patency and hence fewer complications and need for repeat intervention. So you could argue that plastic stents are cheaper, but they occlude much sooner, and the cost of repeat ERCP might be much more than the cost of a metal stent. So if you're doing palliative stents, probably metal stents up front is more economical and better for the patient in the long run. Covered stents have less tumor ingrowth, but then you risk migration and also have a higher risk of post-ERCP pancreatitis. And the reasons why you cannot stent at times are because the stricture is too tight, there is a mass effect, and sometimes causes an acute angulation, which makes stenting challenging. Even in those with pancreatic cancers, if you have inadvertently cannulated the pancreatic duct, please try to place a small bore plastic stent so you can minimize the risk of pancreatitis. And as I said earlier, if you are facing with a concomitant biliary and gastric outlet obstructions, either synchronous or asynchronous, try to evaluate them at the same time and proceed with double stenting during your first initial procedure. Drug-eluting stents have been in experimental stages. I did participate in one of the animal studies. And the idea here is that these stents increase possibly the patency of the stents, and potentially they could improve local drug penetration without necessarily causing systemic toxicity of some of these chemotherapeutic agents. So there has been increased patency shown in some of these small studies, but again, there has been no data on showing that they have any survival advantage. What we are now seeing more and more being done is the endoscopic ultrasound guided biliary drainage, because we all acknowledge that ERCP, even amongst the best of us, has about a 5 to 7% failure rate. So how do we then access the bile duct and drain? So you could do what's the biliary rendezvous, that's what has been described several years back. Or now you can do a direct access choledochoduodenostomy or hepaticogastrostomy, where you can puncture the bile duct, again, through the liver or in the duodenum, or you can do antegrade drainage, where you can pass a stent through the liver across the ampulla. All these have been reported very successfully. Clinical success, again, for endoscopic ultrasound guided biliary drainage is very high, because initially they were all done by the experts. It's about 94%. However, remember that the adverse event rates, even amongst the experts, is still reportedly high, around 17%. So those of you who are doing it and starting it, please proceed with caution. Data also suggests that primary endoscopic ultrasound guided biliary drainage might be able to minimize the complications that we talked about with ERCPs. Here are some pictures that I'm showing, that biliary rendezvous with endoscopic ultrasound guided drainage followed by ERCP. Once you've identified the liver duct on the endoscopic ultrasound, you puncture the duct, you inject some dye, so you delineate the intrahepatic ducts and also the bile duct. And once you've done that, then you pass the guide wire, which could be tricky at times. You cannot manipulate it the way you want it to go, but with a little bit of perseverance and patience, you can get the guide wire down through the ampulla. And once you have it, then pass your ERCP scope and do a routine standard sphincterotomy and stent placement. So now, with the advent of lumen opposing metal stents, the process has become a little easier, and you can do a direct access choledochoduodenostomy. You typically have a dilated bile duct, which usually becomes an easier target. And once you come into the duodenum, you identify it, and then you place a small bore lumen opposing metal stent, and this can cause biliary decompression and does the job well. And here is where examples of antegrade drainage, where you can access the bile duct, and then once you, just like how we talked about in earlier slide about accessing the bile duct and doing an ERCP, here instead of doing a conventional ERCP, once you pass the guide wire, then you advance a stent. Here in this picture you see an uncovered stent that is passed across the ampulla, and you can deploy it and hence complete the procedure done, changing the scopes and the laborious wire exchanges. How about gastric outlet obstruction? Tumor growth and related inflammation is seen in about 15 to 25%, which can contribute to gastric outlet obstruction. Typical presenting symptoms are nausea, vomiting, and poor oral intake. Options at this time would be surgical bypass, or you can endoscopically palliate by stenting the duodenum, or you can do endoscopic ultrasound guided gastrojejunostomy, which is the new kid on the block, and I will show you a couple of slides about this. Endoscopic stenting for gastric outlet obstruction. The technical success rate is very high once you pass a guide wire. Here you see a completely obstructed lumen. You can pass a hydrophilic guide wire that will not poke and create false passage. You typically do it under fluoroscopic guidance. In my personal practice, I usually pass a stone extraction balloon catheter and inject some dye, so I know where the lumen is and I'm not creating a false tract. Once you have identified that, you also can assess the length of the stricture and the stent that is needed. It's easier to deploy, it's good palliation, short, long length of hospitalization, because one can get it done and probably go home the same day or next day. The problem is it has a high recurrence of symptoms because the stents might not expand fully to palliate. There could be a problem in growth. And also remember, on one side, duodenum is fixed, and once you place a radially expanded stent, there is up to 10% risk of perforation. And if you have to do an ERCP subsequently and drain the bile duct, that would be very, very difficult, if not impossible. How about endoscopic ultrasound guided gastrojejunectomy? This has proven to be an alternative to stenting and surgery. Lumen opposing metal stents are used now to create connection between the stomach and small bowel. You usually want to go and make sure you're connecting distal to the small bowel obstruction. Technical success rates are reported at 92% and clinical success is about 90%. However, remember the adverse event rates are still high, about 12%, though the technique is getting refined. We still have a few ways to go with the technology to make it foolproof. There has been a recent paper showing the types of complications you can get, so that means that we have more complications data as well to look at. Here's a picture showing endoscopic ultrasound guided gastrojejunectomy. You have your endoscope, you pass a nasojejunal feeding tube, and then you pacify the bowel so you can see where the obstruction is. Once you have done that, you can again insufflate the lumen with some water and preferably some methylene blue, so you create a target. And then once you have done that, you pass a lumen opposing metal stent as shown here, and you deploy it as you would in a pseudocyst. Again, the problem here is that the bowel is not tethered to the gastric wall as in a pseudocyst and tends to slip away, and hence the complication rates that are reported. And there are 3 types of complications that are reported based on whether you have injured just the gastric wall or the small bowel as well. So still needs refinement. We do not have certain tools like the iToy balloon that is available in Japan. So wait for this area to see more technological advancements. What we know now from some of the studies that were recently presented at this year's DDW is that endoscopic ultrasound gastrojejunectomy was compared with either endoscopic stenting or surgical gastrojejunectomy. Fairly large studies with impressive numbers. If you look at it, the technical success rate is very comparable to surgical gastrojejunectomy or stenting. But more important here is the rate of reintervention is very low, length of hospitalization is very low, and adverse events, though I told you are still high, compares to the surgery and endoscopic stenting is much lower. So it looks like this will be our way forward in palliating these patients. Again, one more study looking at endoscopic ultrasound guided gastrojejunectomy versus surgical gastrojejunectomy. Again, here the important thing is resumption of nutrition, which we know is very important. If you look at the pre-procedure albumin levels, much lower in this group as opposed to the surgical group. And the resumption of chemotherapy is much quicker. So if you have a patient with cancer, you want to do the best to palliate, and you can resume chemotherapy much quicker in these individuals. How about tumor localization? So image-guided radiotherapy has been a concept that's in evolution, and the idea is that you want to deliver radiation precisely to the target lesion and avoid radiation of the surrounding areas. So when you localize the tumor, you can decrease the radiation toxicity, though there are not large data. The smaller series do suggest that it is possible. And we can place radiopaque gold markers by endoscopic ultrasound, so you can delineate the tumor, and technical success rates are very high. If you know how to advance a 19 or 22 gauge needle, it should not be that difficult. How about pain control? This is a big problem for all patients with pancreatic cancer. About 70 to 80% have substantial pain. You can do celiac plexus neurolysis, where you can do injection of an anesthetic like bupivacaine plus alcohol, or now you can actually do radiofrequency ablation, which I will talk to you in the next slides. The goal again is to control pain and decrease narcotic use because narcotics are not without side effects as well. The efficacy data of celiac plexus neurolysis, however, I have to admit, is very moderate at best, and some people advocate that bilateral injection might be better than unilateral. Again, the current goal here is that it probably is a salvage therapy. It's not being used primarily for pain control. We do have adverse events that can occur with celiac plexus neurolysis, especially diarrhea that oftentimes is self-limiting. Abdominal pain, hypotension, something that you can notice even during the procedure. These are the scary things that you hear about and you hope it never happens to you, though I've done once where I've had an abscess. That's a serious adverse event. Paraplegia has been reported and some ischemic injury and death. So this is not something that you should do without discussing with the patient. And there has been some talk about doing neurolysis even at the time of diagnosis. So if you upfront do neurolysis as soon as you diagnose, would that actually palliate the pain better? We probably need more data on this, though there are some preliminary studies that suggest that this might be beneficial. How about using radiofrequency ablation? Our surgical colleagues and radiology colleagues have been doing splanchnic nerve blockade in chronic abdominal pain, either due to malignancies or chronic pancreatitis. Radiofrequency ablation has been done. There was a small study done by Shyam Varadaraja's group where they did a randomized controlled trial to see celiac plexus neurolysis or radiofrequency ablation. At 4 weeks, the pain scores were lower in the radiofrequency ablation group. Again, there is no difference in opiate use. Technology is still expensive. Preliminary data do favor RFA over CPN. Again, I would not recommend that we all start doing it until we get more data because of the cost and other implications. How about endoscopic ultrasound-guided injection therapies? Again, these studies have been small, either in animal or human. Most of these studies at this time seem to be feasibility data. We do not have definite data on outcomes and survival. Studies often use concomitant therapy, which is radiation or chemo, and just not local injection therapy as a standalone. So it's hard to compare data and see if it is truly beneficial. And I don't think it will ever come to that point where we can do it in the absence of not using a standardized treatment. And what I think the concept here is that when you do local injection therapies into the tumor, these agents sensitize the tumor so that you can minimize the toxicity and potentially increase response to systemic therapies. Again, you know pancreatic cancers and bile duct cancers are significantly fibrotic, so penetration of the drugs becomes very difficult. Injection therapies have been in evolution for at least over 2 decades. We have done cytoimplants and the TNF arrays have been done. Again, data are very small and we need longer term data, and I hopefully one of these days we would have better therapy. Brachytherapy is where you inject seeds and microparticles or liquids directly into the tumor. Again, the idea is you get a steady exposure of target tissue to low energy radiation, and you can use EUS to deliver therapy. Again, goal here is to downstage the tumor so you can take a locally advanced tumor that is unresectable to a resectable stage, and there's one study that is ongoing at this time. We talked about radiofrequency ablation. You can also use it to cause coagulative necrosis within the tumor. I think last week there was a study coming out of Malaysia that showed that it is potentially feasible as well. So in summary, endoscopic biliary drainage is superior and favorable to surgical or percutaneous approaches. If ERCP drainage is not feasible, then I think you should send the patient to a person who is capable of doing endoscopic ultrasound guided drainage. Or if you are the person doing it, you can even consider EUS first approach, which seems to be both preferable and feasible and probably lower complication rates. Consider biliary drainage at the time of stenting for gastric outlet obstruction. And based on the data I have shown you, endoscopic ultrasound-guided gastrojejunectomy may be preferable over surgical approach and definitely seems to be superior to transpyloric stenting as long as we have the expertise that is available. Early celiac plexus neurolysis may be beneficial in pain control. Again, it's not a firm recommendation, but it's something that can be done in a study protocol. local injection therapies such as and brachytherapy, RPA, are still experimental and in treatment of pancreatic cancer and not advocated for routine use. Thank you for your kind attention.
Thank you, Dr. Goda, for an excellent deliberation, covering almost all the aspects. The session is now open for questions from the audience, if any. Perhaps I could set the ball rolling by asking you one question, Dr. Goda. When
Sure.
we do a surgical gastroenterostomy for a bypass of the gastric outlet obstruction, we have to take the small intestine to the stomach, either through the mesocolon or anticolic. It doesn't naturally go there, and we have to make some efforts to keep the small bowel opposed to the stomach while we fashion the anastomosis. So when you're doing it endoscopically, EUS guided, how do you get the small bowel to get opposed to the stomach wall? What is the technique?
So that is where the current problem and challenge is, and that's where the complications have occurred, because the small bowel slips away once you puncture from the stomach. So the Japanese have developed, Dr. Itoi has developed a balloon that would actually bring the small bowel up, and because the balloons are there, it'll tether the small bowel lumen to the gastric wall. That's as opposed to where you have pancreatic necrosis, inflammation, and these walled-off collections are now next to the gastric wall. There have been some talks about introducing, once you puncture the needle, maybe using like a T-tac device to bring the gastric wall, the small bowel close to the gastric wall so it does not slip away. That's why I was talking about that now the complications have been classified where you've just punctured the gastric wall, so not a big deal. You can close now with the closure devices. Or, you have now not only punctured it, now your stent is sitting in the peritoneum. The worst complication is where you have actually punctured, cut through the small bowel and the gastric wall, and your stent is sitting nowhere. And then the patient now needs a surgical repair. So that's why I'm not advocating everybody should do it, but I think the data favor that those who have done it and the expertise is there. Probably in the next few years, I think we would have better devices to bring the small bowel loop and have it secure to the gastric wall for us to puncture.
Thank you. Any other questions from the audience?
Yes, it is very encouraging. About 3 decades ago, 4 decades ago, we didn't have much of these palliative measures for pancreatic carcinoma. And once the surgeon says that we cannot do anything, then it was all hopeless. So it is heartening. Almost most of the things that you said can be done by the endoscopist. And it's a good relief both to the patient and the family. Yes, there is one question from the floor. Dr. Mahapatra? Here is a question from the floor.
There is increased incidence of post-ERCP pancreatitis with covered SEMS. But what is the incidence of cholecystitis? Because once you put a covered stent, there is a likely that the opening of the cystic duct can be blocked with a covered stent. And what is the incidence of cholecystitis that?
I think they've done a study doing head-to-head comparison. There has not been much difference. I think it's still under, thankfully I've not had any serious complications. I think I've had once, but usually it's under 5% from all I can recall. It's not that high. And I don't think it made a difference whether it was covered or uncovered stent. There was a head-to-head study done and it didn't show much difference. As you said, if you have a cystic duct that's opening very close near the stricture and you place the covered stent, that's a theoretical risk that people all worry about. In those situations, you can just put an uncovered stent.
Thank you, Dr. Goda, very much. Thank you very much for all the information you gave. And we close this session. Thank you.
Thank you.
Thank you. Thank you very much, sir. With this, we shall proceed to our next online session on bariatric endotherapy by Dr. Amit Mahadeva. I would request Dr. P.K. Sethi, consultant gastroenterologist from Medica Group of Hospitals, to please chair the session. I'd also request Dr. Sanjoy Mondol, consultant surgeon, AMRI Group of Hospitals, to chair the session.
Good evening. Our next topic is bariatric endotherapy, and for this it's a great honor to invite Dr. Amit Mehta. He is a senior gastroenterologist, Global Hospitals, Mumbai, and he will speak on bariatric endotherapy. Over to you, sir.
Yeah, hi, I'm Dr. Amit Maidev. Can you hear me well?
Yes, sir. You are audible, clearly audible.
Okay, first of all, I would like to thank Dr. Sudeep Ghosh and the entire organizing committee of Gemas for this wonderful opportunity, and it's a great pleasure for me to talk to you today on bariatric endoscopy, I will say, rather than bariatric endotherapy, because this is basically endoscopy for obesity. So let me share my slides and then I will proceed. So you can see my slides, right? Yeah.
Yes.
Well, to begin with, I just want to tell you that obesity is an issue which we have been now more and more started seeing in India. And this was a very recently conducted study. It was like a nationwide cross-sectional study in India, which was published in 2020 in the Annals of Neurosciences, which shows that the overall prevalence of obesity in India is almost 40%. Now just imagine, look at the population of the country and the number of obese people. So you see here, this is a tremendously bothering problem which is now started affecting the people of India, probably because of changing lifestyles, changing eating habits, and probably maybe lack of exercise or their work patterns. But what is more peculiar is the type of obesity that we see in India is predominantly central obesity, or what we call as visceral obesity, where the fat collection is mainly in the central part of the body, and that too around the viscera. And that is exactly the reason why these patients or these people who become obese in our country, they tend to develop comorbidities very, very fast. In fact, because of this, WHO in fact modified the BMI classification of Asians and predominantly Indians, where they show that even at low BMIs, anywhere between 23 to 25, we are at increased risk of comorbidities. Anywhere between 25 to 30, moderate risk, and anything even above 30, you don't have to be morbidly obese. You have a severe risk of comorbidities, various types of comorbidities. And that is exactly the reason why various treatment modalities have evolved for the treatment of obesity. And if you were to compare the various treatment modalities, starting with very simple treatment modality like lifestyle management, diet control, and then finally going up to surgical procedures, you see surgical procedures are extremely effective, very, very robust weight loss you can achieve. But compared to the simpler procedures, you can see here that these procedures can be associated with little increased risk. Now, there is a very interesting study which was published where it shows that though bariatric surgery has got excellent long-term results, you see here very good long-term results, excellent short-term results, various types of bariatric surgery, you can achieve excess body weight loss of more than 75-80%. And in many surgeons' hands, these are now become very safe surgeries. But in spite of all that, the overall adverse events can be associated with bariatric surgery. You can see here various types of adverse events, and especially the problem of leakage. If leakage occurs after laparoscopic sleeve gastrectomy or a Roux-en-Y bypass, it can become a nightmare not only for the patient but even for the treating surgeon. And that is probably the reason why less than 1% of all obese people actually accept to undergo bariatric surgery. And it's extremely difficult for any obesity program director to convince the patient to undergo a bariatric surgery. Now the good part is that this, if you were to study this study which was published in 2021 in International Journal of Obesity, if you were to see all the various comorbidities associated with obesity, and if you were to see how much weight loss is required to reduce or reverse the comorbidities, you can see here, on an average, the total body weight loss which is required for reducing the comorbidities by almost 95% is only 10 to 12%. You don't need to achieve a huge amount of weight loss. Even if you can achieve a 10 to 15% total body weight loss, you can reverse the comorbidities to an extent of almost 95%. And that is the reason why the modality of bariatric endoscopy is now becoming more and more popular, because without doing a major surgery, without subjecting the patient to any major risk, you can perform some procedures by which you can achieve a reasonably good weight loss of around 10 to 20%, which is good enough to reverse the comorbidities associated with obesity. The first and the most commonly used bariatric endoscopic procedure is a simple gastric space occupying therapy, which is called placement of a gastric balloon. Now what we do here is, through the mouth, by an endoscopic guidance, we can place various types of fluid-filled balloons inside the stomach. And once you place these balloons, this balloon occupies the space in the stomach. And because of the space occupying effect of the balloon, the patient's appetite reduces, the patient's satiety increases, and this aids the patient in reducing the patient's weight. There are various types of balloons available: air-filled, gas-filled, fluid-filled, refillable, swallowable, etc. But the three balloons which are available in our country is the Orbera intragastric balloon system, where you fill in about 500-600 cc's of fluid of saline mixed with little bit of methylene blue. And another common balloon is this adjustable balloon, which is called as the Spatz balloon, where we can start with 300-400 cc and slowly increase it every 15 days and go up to 900 cc, and thereby occupy quite a large percentage of the stomach capacity. Third, and the new balloon which is now recently marketed in our country, is the swallowable balloon, which comes in the form of capsule to which this small catheter is attached. All that the patient has to do is to swallow this balloon like a capsule, and then you instill some fluid inside this balloon with a pump, and once the balloon is filled with 300-400 cc's of fluid, then you just pull the catheter back, the balloon gets detached, and 4 months time this balloon automatically opens up, the fluid comes out, and the balloon passes out in the stools. Well, the most common accepted indication for endoscopic balloon placement is primary therapy for class 1, class 2 obesity, BMI anywhere between 26 to 39, 40. It can be used as a preemptive therapy for patients who have sleep apnea, hypertension, or some other comorbidities. It can be used as a bridge therapy before bariatric surgery or liver transplant. Nowadays, we get a lot of patients referred from our liver unit, where before doing the liver transplant, they want to optimize the patient's weight a little bit. They ask for a balloon placement for 4-5 months, after which the patient can undergo a transplant procedure. And of course, it can be used for reversal of NASH. Even if you lose 10-15% of total body weight, these patients are shown to have excellent reversal of their NASH. There are some absolute contraindications of balloon placement, like portal hypertension, portal hypertensive gastropathy, acute duodenal ulcer, severe gastritis, or coagulation disorders, and of course if the patient is pregnant or if there is a large hiatus hernia. If you were to compare the three types of balloon, you see here, this is from the latest meta-analysis systematic review which was published in 2021. The average approximate total body weight loss at the end of 1 year you can achieve is 10 to 12% of total body weight loss with these three types of balloons which are available in our country. The second commonly performed procedure as far as bariatric endoscopy is concerned is a procedure which is almost similar to a laparoscopic sleeve gastrectomy, but here instead of cutting the stomach and removing part of the stomach, by doing a endoscopic suturing technique used by a flexible endoscope, we can pass the device through the mouth, attached to the tip of the scope, and we can actually reduce the size of the stomach by doing a full thickness internal plication of the greater curvature of the stomach. So how is this procedure done? You can see from this cartoon that the endoscope is passed inside the stomach. You can see here this is the large capacity stomach. Then by using argon plasma coagulation, we do marking on the anterior wall and then one marking on the posterior wall. And then this area of the greater curvature of the stomach, in the body of the stomach, just proximal to the incisor angularis and just distal to the fundus of the stomach, we are taking full thickness sutures like this, and thereby we plicate the entire greater curvature of the stomach and convert the stomach into a tube, and thereby what happens is the stomach capacity reduces, the stomach length reduces, and also the stomach gastric emptying gets delayed. So therefore, when the patient eats food, that food tends to go and stay in the fundus of the stomach, and this is how that device is attached to the tip of the scope. This is the needle which we can transfer from one side to the other, and then after the needle is loaded, we can go with the screw type of device which is rotated, and the stomach wall is pulled between the two towers, and the needle is passed through and through the wall of the stomach, and thereby we can take continuous sutures and create a very nice plication. Again, the most accepted indication is class 1, class 2 obesity, BMI 25 to 35, 39, and it can be used for the treatment of comorbidities like NASH, joint pain, hypertension, dyslipidemia, sleep apnea, diabetes, and of course, very important evolving indication is patients who have already undergone a laparoscopic sleeve gastrectomy and they have regained weight after 1 or 2 years. When you do their endoscopy, you find that the gastric remnant has now again enlarged in size. Instead of subjecting the patient to a Roux-en-Y bypass or a repeat laparoscopic procedure, we can just do a endoscopic sleeve gastroplasty, and therefore these patients accept it very well. Absolute contraindication again is portal hypertension, coagulopathy, etc. Relative contraindication is severe gastritis, because in the presence of gastritis, if you do this suturing, the patient can have bleeding. A very complicated device you see here. This is the suturing device. You have to use a double channel endoscope from Olympus. You see here, this is a double channel endoscope, either from Olympus or Fujinon. This device is attached to the tip of the scope, and then this device is passed inside the stomach wall. Just to show you how the procedure is done, this device is now attached to the tip of the endoscope. Here you can see inside the stomach, this is the incisura angularis. Now what I'm doing is, I'm going to load the needle first on the needle driver, which is coming out from this tower. This is the needle driver. Now I'm loading the needle. The needle is taken on this side now. This is the 20 proline through which we are going to do the plication. And now I'm going to select an area which is just at the anterior wall of the stomach, just proximal to the incisura angularis. Now this is the screw type of a helix device which I'm going to rotate, by which the wall of the stomach is pulled between the two towers, and now I am taking the first stitch which goes through and through, and thereby what I do is, one after the other, I keep on taking these sutures. Now you can see here the first full thickness suture is taken. This is not just a mucosal suture. This has gone through the muscle wall of the stomach, and thereby even if you pull quite tightly on this suture, it's not going to pull through, it's not going to cut through. And now one by one, starting from the greater anterior wall, going along the greater curvature, I'm going to keep on taking these sutures until I come to the posterior wall. So I'm going to go ahead, show you this video. You see here how this continuous suturing is being done, and this way, once we keep on suturing it and come to the posterior wall, then I again go back and start going towards the anterior wall in a U-shaped fashion, and once I've reached the anterior wall again, I release the needle and I do cinching. So with this, now the capacity of the stomach keeps on reducing, the length of the stomach also reduces, and the gastric emptying of the stomach also starts getting delayed. So first suture, second suture, third suture, sometimes you have to use up to 4 sutures. But you see here, after doing the gastroplasty, this is how it looks from inside. It almost looks like a tube, almost as if you have performed a laparoscopic sleeve gastrectomy. What are the main advantages of doing endoscopic sleeve gastroplasty? It is a gastric restrictive procedure, but it maintains the anatomic structure, maintains the innervation, maintains the blood supply. It is potentially reversible. If the patient has severe retching, vomiting, or if he has pain in the abdomen, you can just go in and cut the sutures, everything will open up, the whole stomach will come back to normal. It is reproducible, it is very easy to learn, provided you know how to use this device properly, it is repeatable. So nowadays, after 7 or 8 months, if you find that some of the sutures have loosened up, if the patient's weight loss has got plateaued, then we go in and put 1 or 2 more sutures, again the patient's stomach can be reduced. Of course, it is very safe. In all the studies which have been published from our data of 300 patients which we have done till now, there is no serious adverse events. It is much more durable than the balloon. And finally, it can still be upgraded by surgery if the patient is not satisfied. If the weight loss achieved is not up to the target, then you can go ahead and perform a surgical procedure. What are the results of endoscopic sleeve gastroplasty? The first data came from Saudi Arabia on 1,000 patients, which they did. You see here, total body weight loss at the end of 18 months was almost 15%. So quite good results. In fact, there was a systematic review and meta-analysis published in 2020. 8 studies published from 2016-2019, more than 1,500 patients, again total body weight loss, approximately at 2 years, almost 18%. 18% total body weight loss and more than 51% or 55% excess body weight loss is quite good to achieve a reversal of comorbidities and to give the patient a good reversal of the obesity. In fact, there was this comparative study comparing endoscopic sleeve gastroplasty with laparoscopic sleeve gastrectomy in this non-inferiority propensity score matched comparative trial, again from Saudi Arabia, where it shows us that if you really compare it, total weight loss at the end of 3 years, the difference between ESG and LSG is only around 4 or 5%, 4.8%. So not too much difference. And even reversal of comorbidities, the difference between endoscopic sleeve gastroplasty and laparoscopic sleeve gastrectomy, there is not too much significant difference. So it is a comparable procedure. There is no doubt that a laparoscopic sleeve gastrectomy will achieve a more weight loss as compared to an endoscopic sleeve gastroplasty. That means it is a more robust procedure because you have cut part of the stomach. There is no fear of the sutures opening up. But as a via media, as an intermediary approach, the endoscopic sleeve gastroplasty is very good. There was a recent study in 2022 published on the effect of gastric emptying, gastric motility and the hormones after endoscopic sleeve gastroplasty, and they found that the most important effect of endoscopic sleeve gastroplasty was that it delays the gastric emptying. And because it delays the gastric emptying, the patient does not feel hungry for 6 to 7 hours, and even if the patient eats, the patient feels full early because the stomach size has reduced. And from this very recent prospective multi-center randomized trial published in 2022, you can see here that the total body weight loss of endoscopic sleeve gastroplasty along with lifestyle management was around 14% as compared to simple lifestyle management was only 0.8%. Well, there is another gastric restrictive procedure which is called as the POSE-2. Now here, this is also similar to an endoscopic sleeve gastroplasty, but the device which is used is a little bit different. You can see here instead of doing suturing, they are doing placing a plication, almost like a stapling device. The technique of stapling is a little different. It is not U-shaped, it is vertical and transverse staples. But here also, from this data which was recently published, the technical success is good, but mean total body weight loss at 12 months was approximately 16%. Now I am going to tell you about 3 procedures which are not only used for obesity done by endoscopy, but also for reversal of type 2 diabetes or treatment of the metabolic syndrome. Now here, what we do is we have used various techniques by which we can either bypass or replace the lining of the foregut. Now the whole intention of doing this is it is thought that in patients who have type 2 diabetes, they have basically abnormal enteroendocrine cells in the foregut, that is predominantly that portion of the proximal duodenum and the early beginning part of the jejunum, because of which wrong signals are given to the pancreas and these patients develop insulin resistance. So if we bypass the nutrition directly which is going into the distal jejunum and bypassing the foregut, then you can achieve the result of reversal of HbA1c. Or second way is by completely changing the lining of the foregut. So this device was invented, which is like a sleeve. Now in this, what we do is we place this sleeve at the pylorus, and this sleeve gets fixed here at the pylorus because of these barbs, and this long silicone tube which goes till the distal jejunum. So the nutrients bypass the foregut and directly enter the distal jejunum, because of which it stimulates the L cells, leads to secretion of GLP-1 and PYY, and stimulates insulin secretion. However, this device in the initial trial which was published in the United States had a little bit of complications like liver abscess, because the anchors which were fit at the pylorus caused a little bit of infection over there, and because of that infection patients developed liver abscess and the device CE mark was taken out. But this open label randomized controlled trial continued in UK at 2 academic centers, but over here also they found that there was no significant benefit of using this duodenal jejunal bypass liner over 2-year period, and adverse events were quite concerning. So therefore this device is not available now for clinical use. There are some centers in the world who are trying to attempt modification of the device, but we'll see whether it any time comes into clinical use. The second and a very interesting technique is to change the abnormal lining of the foregut. Now this can be done by using this simple catheter, and to which this balloon is attached, and in this balloon you can fill hot water of almost 95 degrees, and then what we do is, by passing this balloon over a guide wire, we can ablate the mucosa of the duodenum, starting beyond the ampulla of Vater, right till the DJ flexure, and then within a period of 1 or 2 months, or maybe 3 months, new mucosa comes with new enteroendocrine cells, and they have found that it can improve the HbA1c levels. You see here, there were 4 studies till now published on the duodenal mucosal resurfacing, which have shown that there can be a drop of HbA1c of almost 1.72% values at the end of 3 months, and at 6 months also, this value drops by approximately 1%. So it's not very durable. Still, it is under modification. But the final treatment which I want to tell you is that if you were to see this, out of all the bariatric endoscopic procedures, intragastric balloons and the tissue apposition devices, like the endoscopic sleeve gastroplasty, are probably going to be long lasting, and they will be probably the middle of the road approach for those patients who do not want to undergo surgery, and for those who find lifestyle management extremely difficult, but you want to reduce their weight by at least 20% and thereby reverse their chances of developing comorbidities. Thank you for your attention.
Thank you, Dr. Mahdev. Fascinating talk. Questions from the floor?
If there is no question, sir, I have a question. If you do both procedures like gastric balloon and endoscopic sleeve gastroplasty, and you have a patient, which one to choose and for any particular patient?
See, balloon is very simple compared to sleeve gastroplasty. Endoscopic sleeve gastroplasty requires a lot of training. The learning curve is very steep.
My question is, if you are doing and you have a patient, which one to choose and what are the indications, basically, which is more important for you?
Well, more long-lasting procedure is endoscopic sleeve gastroplasty. If the patient wants short-term benefit, patient is willing to get a replacement of the balloon after 1 year, you can do that. Usually you use it with the patients who do not want too much of a weight loss, maybe 10 kilos weight loss, 12 kilos weight loss, maybe young girls who want to get married, they want to reduce their weight just before marriage, you can place a balloon, or you can do it for reversal of NASH before the patient is undergoing a liver transplantation. But otherwise, the endoscopic sleeve gastroplasty will be a more preferred approach than a balloon placement.
I have a question or more of a concern. The balloon, I guess, is more of a short term. You take it out, most of the patients would gain back their weight, if I am not wrong. The sleeve gastroplasty, which you have done, used to be done by the surgeons as a gastroplasty laparoscopically. They stopped doing it because they didn't have the good results. So it fell out of favor. So how is your endoscopic gastroplasty different from that of what the surgeons were doing it and which went out of favor?
It's a little bit different. You know, when you suture the stomach greater curvature from outside, it's a little bit different from what you do from inside. When you do gastric plication from inside in a full thickness manner, and that too, if you see the way we have modified the technique by leaving the incisura intact, leaving the antrum intact, leaving the fundus intact. So we are looking at ways by which we are going to reduce the gastric emptying. Second is, after 7-8 months or 8 months, if the weight loss starts plateauing, you can easily go in again and do again a few sutures, which can be easily done by endoscopic sleeve gastroplasty. If you tell the patient that I want to do a repeat laparoscopic gastric plication, they are not going to accept it. But endoscopic sleeve gastroplasty, it's a one-day endoscopic procedure which does not even require admission.
Do you do that procedure under anesthesia?
Yes. It's done under general anesthesia because it takes about approximately 1 hour.
Okay.
And the device is little bit cumbersome to swallow, so therefore it's better to be done under anesthesia.
Okay, so, okay, fine, thank you.
Sir, we don't have any long-term results like 5 years, 7 years, no.
This technique is relatively new. And I'll tell you what, long-term results you get best only with Ruava gastric bypass. Even the laparoscopic sleeve gastrectomy, after 2 years, they start regaining weight. So with endoscopic sleeve gastroplasty, even if they regain weight, in fact, beforehand itself, we tell the patient that after 7-8 months, you should come back. I'm going to repeat your scopy. If I find the few sutures have loose, and I'm going to take a few more sutures. So the patient is continuously under our management. And what happens is, once the patient loses some weight, that patient gets extremely motivated. That patient knows how good it feels once the weight is lost. And that is the time the patient starts transforming their own life they start doing exercise, they automatically start following a proper diet. You don't even need to do suturing again.
Okay. Sir, what about the cost of, I know the gastric balloons, but what is the cost of ESG?
ESG cost to the patient, the cost is 2.5 lakhs. If you ask me, the cost of the device presently is 1,10,000 rupees, inclusive of maybe 4 sutures and 4 cinches. Cost price for the doctor. Now, in addition to that, suppose you don't want to charge anything, you can do the whole procedure if 1,50,000. But if you want to keep, the hospital needs to earn something, the doctor has to earn for the professional fees, I think 2.5 lakhs becomes a reasonable amount, which is lesser than a surgical procedure, little more than a balloon, and it will give you reasonably durable results.
I think the surgical procedure is more or less the same cost, but I guess then we can just to talk about it. Anyway.
Yeah, the only issue is here, the surgical procedure, some patients get scared. Because even that 1% risk of leak, if by chance it happens, then you are in deep trouble. Yeah.
Agreed.
What about the complication of this ESG itself?
There are no complications, no serious complications. Okay. Some patients may have some pain, some patients may have some perigastric collection, some patients have developed some hematoma, rare complications of splenic injury, when initially we used to suture the fundus also. But nowadays we don't go near the fundus will leave intact. So very rarely we damage any structures outside the area of the short gastric veins or even the spleen.
Okay, I think we'll close the session for now. Thank you.
Thank you so much. Bye.
Thank you very much, sir. We shall now proceed to our next session, recent updates on third space endoscopy by Dr. D. Nageshwar Reddy. I would request Dr. P.K. Sethi, consultant gastroenterologist, to please stay back and chair the session. I would request Dr. T.N. Lahiri Mujumdar to please come on the stage and chair the session. Dr. T.N. Lahiri Mujumdar perhaps doesn't need any introduction. We would also request Dr. Obhidesh Shorkar, consultant gastroenterologist from NH Group of Hospitals, Dr. Debottom Bandopadhyay, consultant gastroenterologist, AMRI and Group of Hospitals, Dhakuria and Mukundapur.
So at the end, we are going to have a very interesting session on third space. And the speaker, I don't think he needs any introduction. A God-gifted man with a golden hand who actually put our Indian advanced GI endoscopy in the world map. So here is Dr. Nageshwar Reddy from Hyderabad, whom we welcome to deliver the lecture. Dr. Nageshwar Reddy, please.
I'd like to thank Sujit Chowdhury for this kind invitation to give this talk in the Gastro Summit 2022. I would have loved to come there, but because of other obligations, I'm giving this lecture in a recorded form. My talk is on recent advances in third space endoscopy, and as you can see, in the last few years, there's been a lot of advances. From doing just poems to a variety of other conditions, we are now advanced to do a lot of techniques to solve problems in third space. Now, first of all, what is third space? Third space is the space between the mucosa and the muscularis. The first space is the luminal space, the second space is the peritoneal cavity, and the third space is the space between the muscularis propria and the mucosa, so-called submucosa. This space can be expanded completely and a variety of procedures can be done. The indications for third space are very clear here. The most important indication is peroral endoscopic myotomy. Second is STIR, or endoscopic full thickness dissection of subepithelial tumors, transgastric peritonioscopy, implantation of stimulatory devices, and so on. So there are many indications for third space endoscopy, and in recent years there has been a marked increase in their use. It was actually in 2007 that Pankaj Parisha published this article on submucosal endoscopic esophageal myotomy for treatment of achalasia. Soon in 2008, Professor Haru Ine from Japan did the first case in September 8th of an anterior myotomy. The total operation time at that time was 110 minutes, and he published a series of cases in 2010 of POEM in achalasia cardia. The procedure of POEM has now been standardized. There is submucosal injection followed by entry into the tunnel, and after entry into the tunnel, the mucosal submucosal dissection is done to clear the tunnel completely. And once this is achieved, we actually do a myotomy, first only the circular muscles and then the longitudinal muscles to complete the whole process. And once the myotomy is done, we will then close the opening of the submucosal tunnel with clips. So this is a very standardized technique that has now been done in many patients very successfully, and you can see the myotomy that is being done in these cases. We now have several series of large number of cases, including long-term follow-up of POEM with effective results. So it is safe and efficacious. We also have two very large articles where these patients have been followed up for more than now 10 years, telling us what are the important areas where progress has occurred in this area. Also, we are now getting better, and this is again from China, showing very clearly in a randomized trials of a standard POEM versus short POEM. That is, short POEM is sufficient. 3 to 4 centimeters is sufficient in most patients, especially when they have type 1 achalasia and sometimes in type 2. Only in type 3 we do a long myotomy. So short myotomy of 3 to 4 centimeters is sufficient in most patients. Again, we actually did a randomized control trial comparing long myotomy with short myotomy, and from this it's very clear that both have similar efficacy. So nowadays we are actually advocating short myotomy in most of these patients with the type 1 and type 2 achalasia cardia. Now, how long does the efficacy of POEM stay? And again, we have followed up these patients for more than 10 years now, showing very clearly that POEM efficacy remains for a very long period of time. And again, there are many long-term studies that are available. In general, type 1 and type 2 stay for very long periods without any problem. Of course, there are some problems and solutions for this. Sometimes we find very advanced sigmoid esophagus. In these cases, a short myotomy is sufficient. Sometimes the mucosa can be very bad, so maybe severe fibrosis, and the problem of GERD is there in these patients. So we have now developed a preoperative risk scoring system for predicting poor responders to peroral myotomy. For example, those people who have a sigmoid esophagus, dilated esophagus, do not respond very well, or those who have had previous surgery. Points can be given, and you can actually calculate which patients respond and which do not. Similarly, this is again from Shanghai, we have this scoring system which can predict clinical failure for patients after peroral endoscopic myotomy, where based on this scoring system, based upon the mucosal injury and clinical reflex and so on, we can say which patients are likely to respond well to this procedure. There are many adverse events during POEM. It could be aspiration pneumonia, insufflation related mucosal injuries, bleeding and so on. The most important of this, of course, is going to be reflux disease. Gastroesophageal reflux after POEM is unpredictable, but is responsive to proton pump inhibitors. And this is a large study which we did. We showed that most patients who have reflux after POEM respond well to PPI therapy. So we can now decrease the reflux in this patient by several modifications. First of all, we should not extend the myotomy beyond 2 centimeters below the GE junction. Second, we can do preservation of the sling fibers by as soon as we enter into the gastric tunnel, we turn towards the right side, towards the lesser curve. This will preserve the sling fibers and decrease the incidence of POEM. And third, of course, we have the technique of POEMF, where using this technique described by Inoue, we can go and create an endoscopic fundoplication. So using these 3 techniques, we have now reduced the incidence of gastroesophageal reflux after POEM procedure. We have also found that this fundoplication can be done in many centers, which is being done. So you can see from third space now there are many acronyms that are there. For achalasia, we call esophageal poem. For esophageal diverticulum, D poem. For gastroparesis, G poem. For Zenker, Z poem. And for Lisping's disease, it's R poem. Especially in recent years now, large esophageal diverticulum, especially the pulsion type of diverticulum, can be treated with this technique of poem, where a central muscular diverticulum can now be cut very easily, as we are doing in patients with achalasia cardia, and then create, as you can see in this case, we are cutting the internal septum, separating the mucosa from the two areas, and then once we cut it completely, you can produce a flat esophagus. This is pictorially shown here how we can do D poem, and we have seen that D poem is very effective to treat patients with pulsion diverticulum of the esophagus. Similarly, G poem is another type of third space endoscopy, which is done for patients with gastric outlet obstruction. Patients who have gastric outlet obstruction due to either idiopathic gastroparesis, diabetic gastroparesis, post-operative gastroparesis respond to this G poem. It's also very important to work up these patients well. We know that those patients who have an abnormal gastric motility disorder documented on scintigraphy or by doing a flip technique or electrogastrography can predict which patients will respond to G poem. Now, in G poem, predominantly we are cutting on the greater curve of the stomach against the muzzle layer and cut the pyloric muscle. Now, this is a study again which is shown very clearly in endoscopy that electrical stimulation in treatment of refractory gastroparesis, actually you can see which patients with refractory gastroparesis will respond. Comparing G poem with electric stimulation, those who respond to electric stimulation will also respond to G poem. Now, coming to the third aspect is Z poem. Z poem is for Zenker's diverticulum. Conventionally, in patients for Zenker's diverticulum, we would do a cut of the septum starting from mucosa. But increasingly now, we have started to do this Z poem, where we can inject on the septum, separate the anterior and posterior submucosal space, and then cut the muzzle layer up to the lower part. Typically, Z poem is now done for patients who have recurrent Zenker's diverticulum or those having small Zenker's. For long Zenker's diverticulum, Z poem is not going to be very useful. So, you can see again there are many studies which have looked at endoscopic myotomy poem procedure for Zenker's, and you can see very high technical success rates, but of course one has to be careful about complications in these patients. Now we come to other step, that is STER again, which is predominantly developed in China by the Shanghai group, where using a longitudinal mucosal incision 5 centimeters proximal to the tumor, we can do submucosal tunneling and create a small tunnel to approach these tumors. Typically, the tumors that are amenable to this are those GIST tumors in the esophagus and leiomyoma in the stomach. These are the type of tumors which would often respond to this. Leiomyomas in the esophagus and GIST in the stomach are the tumors that would generally respond. You can close the mucosal flap after this. Again, we have a large number of series both from China and Korea where these patients have been treated, and resection of these tumors have been done quite successfully without any problem. So, in third space endoscopy, you can see typically we are dealing with achalasia cardia, we are dealing with subepithelial tumors and refractory gastroparesis. Recently, esophageal diverticulum, esophageal strictures and Hirschsprung disease have also been treated by third space endoscopy. So, all these diseases like achalasia cardia, subepithelial tumors, Hirschsprung's disease and nodes fundoplication have now shifted from being surgical diseases to more endoscopic or medical diseases, and this is a dramatic shift that has occurred in this field, and this is very exciting because more and more diseases are going to be added to this space. So, again you can see the impact of third space endoscopy, and more important, I would like to bring your attention to this nodes fundoplication. This is a nodes type of procedure When we introduced nodes in 2003, my colleague and me, Dr. G.V. Rao, we did the first human appendectomy through the stomach. At that time, it was very new. There were no instrumentation. Further development did not occur in this area. But now see the dramatic developments that are occurring. An example is nodes fundoplication, which can be done very easily endoscopically with great success. There are going to be many more areas of improvement in this, and hybrid nodes. Again, we have this report where patients having endoscopic full thickness of gastric carcinoma with laparoscopic lymphadenectomy is extremely useful. So instead of doing open surgery, we can now do a full thickness resection of the gastric tumor, and regional lymphadenectomy can be treated by laparoscopic resection. So this is a new concept that is coming, that more advanced tumors can now be treated with oncological free resections by these techniques. Again, we have this very important paper where there is endoscopic full thickness and endoscopic lymphadenectomy for advanced colonic cancer in inoperable patients. The first human experience that came from China again, Zhenzhou, and you can see very clearly that these patients on follow-up are doing very well. So indicating that endoscopically we can treat our patients by a variety of techniques without resorting to surgery. Otherwise, this type of tumors would require surgical resection of colon plus followed by lymph node clearance, which can now be done accurately with a combination of endoscopy, full thickness resection and lymphadenectomy. We are proceeding further, and again from China we have this very interesting transrectal gallbladder preserving cholesterol lithiasomy. It has also been done through the stomach, again from our group in Shanghai, where through the stomach they have been able to go inside and remove the gallbladder and stones. So I think these are all again coming back. The true nodes procedure which went off in 2003 are coming back again because of advances in technology and technique, where all these things can be done very effectively, and hopefully in future many of the routine surgical procedures could be done by endoscopic techniques. We are also introducing new devices, and this is a new device called the Speedboat, made by a British company, where there is a single device where there is integrated injection needle, we have precise cutting tissue, and also we have a microwave energy for coagulation and ablation. So all this can be done in a possible way. So, and bipolar electrodes of course are a part of this. There is a generator which also includes, you can see here the generator which is part of this, and you can do submucosal tunneling with this thing. And then you can see the video in this case, we are using this Speedboat, we are doing a submucosal cutting of this area, and then we can go inside and do all the third space procedures with using a single instrument, the Speedboat, where there is microwave, there is bipolar cutting, and also there is injection needle. So this is now becoming more and more important in our armamentarium when doing third space procedures. And this is a paper we published using this tunneling technique, in using this for POEM, STIR, and also we are using for ESD and for also G-POEM. I think this has got a great future. Now, what is going to be the future of third space endoscopy? I think there are going to be many more indications, and as I see it, one of the most exciting indication is going to be GI placing. We know that many of the gastrointestinal disorders like achalasia, gastroparesis, GERD, chronic constipation, and some patients with irritable bowel syndrome basically have an abnormality in gastrointestinal electrical generation. So if you can alter the electrical activity of the gastrointestinal tract, you can solve many of these problems. And I think the future of third space endoscopy is going to be this, our ability to place these electrodes in the submucosal space to generate an electrical wave, which will then control the gastrointestinal functions. So I think this is going to be the future, and I am very optimistic that based on the current research that is being in this area, that this will become an important modality of treatment in patients with variety of these disorders. Finally, I think many of these procedures require teamwork. We have a fantastic team at the AIG hospitals in Hyderabad, India, and a lot of advances that I have shown you now are possible because of this team. This team not only involves endoscopists, surgeons, pathologists, radiologists, all of them are part of the team, and only when we work together, we can produce these results. Once again, I'd like to thank Sujit for this kind opportunity to take part in this very important symposium.
Thank you for giving an excellent overview on third space endoscopy. We can have some questions and comments. Okay, fine. So with this, we can have any questions, comments here only, in-house. Okay. Then should close the session and move forward. Okay, thank you.
We shall now proceed to the last session of the 7th Gastro Summit. It is the clinical case presentation. May I request the judges to please come on the stage. Professor Jayanto Kumar Das Gupta, ex-professor of gastroenterology, IPGEMAR, Kolkata. Dr. Kingshuk Das, senior consultant gastroenterologist, Apollo Hospital. Dr. Uday Chand Ghoshal, professor and HOD of SGPGI, Lucknow.
Good evening. So this is one of the most important session usually, but it's at the end so that you can stay back and really try to put your things on the board. I think Pathuda, Dr. P.P. Bose joined as the third judge. Yeah, I'll explain you. Yeah. I think we'll start with the first one. Your presentation will be 10 minutes. Kunal is coming, I hope. Kunal Kumar Gupta. Yeah, you are from Peerless. So I will tell you what as the judge we are supposed to do. We will see your content, we'll see your presentations, the style you are presenting, the discussion you are answering, and possibly a factor which judges will themselves decide what marks will give marks on that also. It's 10 minutes presentations, and then we'll take 5 minutes time to ask you or decide among ourselves. So it's Kunal's slide now.
Good evening everyone, I'm Dr. Kunal Kumar Gupta. I'm pursuing my DNB training.
Kunal, just a minute. Can you put a 10 minutes timer? Can you put a 10 minutes? Sorry.
Go on.
Okay. Put the timer on. 10 minutes.
Shall I start?
Just wait a minute. Yeah, start it? Yeah, you start.
So this patient presented to us first in 2010. She was a 40-year female patient who was decompensated cirrhotic at that time with a MELD score of 16. She was anti-HCV reactive and her HCV RNA load was around 2 lakh. But her HBsAg serology was non-reactive. In view of pancytopenia with hypocellular marrow, we could not start her with pegylated interferon and ribavirin at that time, and DA was not available in India at that time. So she was followed in 2014 and then lost to follow-up. She came again in 2017 for re-evaluation. This was her complete blood count. We showed a bicytopenia, and her LFT was like this. USG was suggestive of dilated splenoportal axis with minimal ascites and endoscopy showing a small esophageal varix. Her HCV RNA load was 3.72 lakh copies per ml with a genotype of 3. She was started on sofosbuvir with velpatasvir for 12 weeks. SBR was achieved in February 2018. She again came to us about a year later after achieving SBR, and this time with a painful swelling and discharge over the right buttock area. She underwent an excision of the lump over the right buttock area with flapping. I would like to draw the attention of the audience that her serology was done preoperatively, which was non-reactive for surface antigen, but she was reactive for anti-HCV, and HCV RNA was not detected. Post-operatively, she also received 10 units of FFP with 4 units of platelet. On biopsy, it was a keratinous cyst. About 14 months later, she again came to our hospital, and this time she came with an acute and chronic liver failure-like presentation. And this time, the surface antigen, which was non-reactive about 3 months before, came reactive. Going further with the serology, her IgM anti-HBC was reactive at a titer of 200. HBe antigen was non-reactive, but anti-HBe was reactive, and the DNA titer was about a lakh international unit per ml. Based on these reports, we started her on entecavir as she was having an acute kidney injury. She also had a bloodstream infection with a high sag ascites. She had a prolonged stay of 25 days, and this was her on-discharge liver function test. So at this point, the possibilities that we considered in this patient was acute hepatitis B leading to ACLF in a case of HCV positive decompensated cirrhosis, or a spontaneous reactivation of chronic hepatitis B leading to ACLF in a case of HCV positive decompensated cirrhosis, or the third possibility would be HCV-HBV co-infection with an occult HBV initially, which was followed later on with reactivation after we have started her on DA therapy and SBR for HCV. So the dilemma always remains regarding the differentiation of acute viral hepatitis from acute exacerbation of chronic hepatitis B. This is particularly important as we can see this in 2 studies. About 40 to 50% of the patient first present to us in our clinic with a reactivation rather than an acute hepatitis B. So the differentiation from acute hepatitis B from exacerbation are based on this table. I'll consider this table based on my patient. So we cannot differentiate in between these two based on history or any evidence of portal hypertension as she was already cirrhotic previously. Her IgM anti-HBC titer was low, so it was supportive of acute exacerbation rather than acute viral hepatitis. Her HBV DNA level was high. If we consider combination of an anti-HBE positivity with low IgM anti-HBC titer and a high HBV DNA, then likely she had a chronic hepatitis B acute exacerbation. So based on this, she was likely an acute exacerbation rather than an acute hepatitis B. She was again admitted in September 2020 for routine paracentesis, and she was found to be COVID-19 positive. It was a mild disease, and we discharged her after 3 to 5 days. Further following, she was continued on entecavir, and her HBV was not detected in 10th 2020. She had repeated admission after this with due to recurrent UTI, further decompensation, followed by further decompensation in form of hepatic encephalopathy, refractory ascites, SBP AKI, and she finally succumbed to her disease condition in May 2021. I'll just do a little bit of review of this case. So there are basically 3 phases of hepatitis B virus reactivation. First is the increased hepatitis B virus replication, characterized by rapid rise in the HBV DNA titer. Then the second phase is a necroinflammatory host response, characterized by rise in the aminotransferases with symptomatic hepatitis and jaundice. And finally, they attain a recovery phase with a fall in the DNA levels.
Just wait, Kunal. Yes. I would have put just like a TV shows, I would have put a button and just stop the presentation. Yes. You are supposed to present a case, not like this. I hope that there must be a communication gap from our side to you. This is not the way you present a case for a presentation and for a discussion. It's a different. I don't know, I put up the button and stop you. Okay, continue.
Continue, but I want to think that we want to that no literature review.
Nothing,
like
we
that
didn't. We wanted a
presentation.
case presentation
So what is
from your side.
what is the final diagnosis, and then now you just continue.
Yeah,
and
continue.
then we will
Finish
ask.
your presentation, then we'll ask.
So if you look at the literature, the worldwide prevalence of HBV-HCV co-infection is about 1 to 15%.
No, you have nothing related to the case. You give a final diagnosis.
So this is my final diagnosis: hepatitis C related decompensated cirrhosis of liver with probable acute exacerbation of chronic hepatitis B leading to ACLF and rapid decompensation. And these reactivations are likely due to directly acting antiviral achieving SBR in HCV positive patients.
Okay, if I am allowed to ask you a question, that this is not the right way to present. When you are asked, yeah.
Yeah. Actually, it was not instant. Maybe it was, we could have told them earlier that review of literature is not required. So, please bear with us. I have spoken to the teachers of Peerless Hospital and also other institutions. They have not been communicating. Yeah.
Okay.
Okay, thank you very much.
Can you go back to your slides where you are writing that is a hepatitis C positive patients when you are talking about hepatitis B? Just go back. Yeah, possibilities. Yeah. This is you are still writing acute hepatitis B leading to ACLF in a case of HCV positive decompensated cirrhosis. You have already treated hepatitis C in this patient and cleared the virus. Your RNA is negative. Now what do you call now? You still write HCV positive decompensated cirrhosis.
So,
Are you justified in calling that?
So at the initial presentation in 2010, he was already decompensated at that time with hepatitis C virus.
Now suppose you have treated this patient who is a decompensated cirrhosis, HCV related, you have treated with 12 weeks and the person is HCV negative now. Can you still call it HCV positive decompensated cirrhosis?
No sir, it's not HCV positive. HCV RNA negative
This is HCV RNA negative. Anti-HCV may be positive throughout life.
Now that's okay, but if you stamp it as
It's not. It's a decompensated cirrhosis. The etiology was hepatitis C, but now still you can't say HCV positive decompensated cirrhosis.
Now, the Kingshook, one thing
Hello.
that, okay, I want to...
You have mentioned that acute hepatitis B leading to ACLF. It is in which year?
Sir,
Patient has got ACLF when?
in sir 2017.
17. Then the progress of the disease?
She succumbed to in 20.
He recovered from ACLF.
Yes sir, she was discharged in this that admission. Sir.
The criteria of ACLF? Why you are saying that this is ACLF?
So 28-day increase.
The criteria, why you are coining the term as ACLF? Why it is not decompensated cirrhosis?
Sir, within a span of 4 weeks, he presented with jaundice and encephalopathy. That's why.
Then?
In a pre-existing case of chronic liver disease. That span of 28
The
days.
organ, any mention of any organ failure?
She had an AKI at that time, sir.
But that may be due to the infections, and actually what you were saying, that there was no organ. So, or whether you define this patient as a ACLF or is an acute decompensation in cirrhosis.
Sir, I will consider ACLF in this patient in view of rapid decompensation within a span of 1 week, 1 month, sir.
Okay.
Go to your possibility slides. There are so many confusions in possibilities. Yeah, that Dr. Janto Dasgupta has asked you that acute hepatitis B leading to ACLF in a case of HCV positive decompensation. You are mixing out the terms. That was our primary aim to tell on these slides. That possibilities you are just overlapping or maybe confused on that side or whatever. And obviously there was a miscommunication, that's why you went on discussing. Anything you want to ask more? Anything? Jantuda?
Regarding the one thing that I want to ask you is that whether this is
an acute flare of chronic hepatitis B, or it was an occult HBV which has been revealed and because of the therapy by DA therapy in patients of HCV cirrhosis. So what is your final diagnosis?
Sir, acute flare or a reactivation in case of chronic hepatitis B.
There was no documents to suggest that the patient was having chronic hepatitis B.
Occult infection may be there, sir.
So this is a possibility of occult because there was no document that the patient was having the occult HBV infection previously. So whether the patient has repeated hospital admission, why it is not an acute hepatitis B with underlying decompensation.
What is the viral load?
Viral load was high. That cannot differentiate between these two.
Anyway, he has on.
Show that slide. Show that slide. The differential between the acute and chronic. You showed the slide, no? Yeah. Tell different from there.
Sir, a low titer of anti-HBC IgM would suggest acute exacerbation. Our patient had a titer of 200. Generally, the cutoff considered is about 1000. And secondly, sir, HBV DNA titer was very high, which would be again suggestive of acute exacerbation. And if we consider a combination of these things, that is anti-HBV positivity with a low anti-HBC titer and a high DNA, then it is likely a exacerbation rather than acute hepatitis.
Okay, thank you. Thank you.
Thank you, sir.
We change the. Yeah, Bikash.
Sudden deterioration of a chronic decompensated liver disease. So that way you can defend your first diagnosis. Second one, which you can say that your mistake was not to do anti-HB core total when he was diagnosed with
Yes,
hepatitis.
that was the mistake on our.
So if you would have done, you could have documented that he had already had occult infection and now it's a reactivation.
Thank you.
Okay.
Can we change the serial? Can we go to? Yeah. Thank you. Adrija, Adrija, are you ready? Yeah, Adrija, you come.
Very good evening, everyone. Today I shall be discussing myself, Adrija Ganguly, Dr. Adrija Ganguly from Medical College, Kolkata. I am a second year resident there. And today I shall be discussing an interesting case which soon turned into a nightmare for us, but later gave us some important learning points too. An unusual case of colonic perforation. A 42-year gentleman presented with bloody diarrhea for last 3 months with no known comorbidities and no addiction. The stool frequency to begin with was 5 to 6 times a day, and later when he presented to us, it was 10 times a day, with Bristol type 6, with visible blood in stools, and repeated urge to defecate small quantities of stools. And he also had nocturnal frequency. However, he denied any pain abdomen, significant weight loss, fever, any joint pain, skin rash, red eye or oral ulcers. There was no perianal complaint, perianal pain, discharge or swelling. There was no history of previous surgery, any recent travel, radiation exposure, illicit sexual or high-risk behaviors, and recent change in diet. At this time, sitting in a tertiary care center, we were thinking about a chronic large bowel type of diarrhea, and the first thing which came into our minds was ulcerative colitis. So we ordered all the relative investigations. The lab work was done, the abdominal X-ray was sent, and also the stool routine OPC was sent. In the lab work, we saw that there was slight anemia with leukocytosis. The CRP was very high, 88, and albumin was slightly on the lower side. Now, after this, we ordered an unprepared sigmoidoscopy as our routine. And in this unprepared sigmoidoscopy, we saw that it was not like ulcerative colitis. Rather, the patient had a huge ulcer, rectal ulcer, but the surrounding mucosa was apparently normal. So, our team decided that we'll do a prepared colonoscopy to know what's beyond. So, we did preparation and colonoscopy was performed. And in colonoscopy, we found that there were large, deep ulcers in rectum, proximal descending colon, and ascending colon. We did not further negotiate because of the unsatisfactory preparation of the bowel. And here we can see that there were large, deep ulcers, and the surrounding mucosa was apparently normal, retaining the normal vascular pattern. But the trouble began when the patient developed severe abdominal pain later that night. On examination, the abdomen was tender, there was guarding and rigidity, and there was rebound tenderness. So that's the nightmare of every endoscopist, that there might be some iatrogenic perforation. And unfortunately, we were right. There was pneumoperitoneum, and as the patient was deteriorating, we consulted the surgery team, and the patient had to undergo exploratory laparotomy. And to our surprise, there was not just one, but 3 perforations, and it was actually the sloughed of ulcers noted at cecal region, ascending colon, and rectum. We didn't even go to cecum, we just went into the ascending colon, that too distal ascending colon, but the cecum perforation was the largest one. The primary repair was done of the perforations in ascending colon and rectal, and for cecum, a cecostomy tube was put, peritoneal toileting was done, and loop ileostomy was done for this patient. As the patient was recovering in the post-operative period, his histopathology report came. And to our surprise, those ulcers were actually, the report suggested that it was Crohn's. The lining mucosa was completely ulcerated, replaced by the necrotic exudates. There was crypt distortion, cryptitis, there was dense inflammatory infiltrate, there was transmural extension of the inflammation, and also serositis. The lymphoid aggregates were seen, however, no granuloma was found, and no evidence of TB or malignancy was sent. Still, we have sent a gene expert from the colonic ulcer biopsy, and it came also negative. Now, during follow-up, as the patient pulled through a very difficult phase in the post-operative period, the patient came to us 1 month later after being discharged from surgery, and where he was only put on the supportive management and antibiotics. But when the patient came to us, he was doing very good without any diarrhea. There was no bleeding PR or through stoma. The stoma was also good, and the blood work which he came with was exceptionally good. The anemia was corrected, there was no leukocytosis, albumin was also normal, and the CRP also came down. And we performed a repeat colonoscopy in this patient, and to our surprise, the entire colon was almost healed with just slight redness or erythema at places, but such deep ulcers were all gone. So the issues in this case were the first is the diagnosis of Crohn's. The patient responded with the Crohn's, which caused an perforation, where the ulcers were so deep that it caused perforation. It responded just with antibiotics and fecal diversion, that too in a very short span of time, within a month, without any immunosuppressive therapy whatsoever. And there was another question, if we consider this as a case of Crohn's, then what to do next to prevent the relapse, or how to maintain remission in this period, in this patient. So we started the patient on azathioprine. Now the patient is doing well, there's 2 months, 3 months have gone by, and the patient is doing well without any complaints, and he's also being planned for the reversal of stoma, but the long-term maintenance of remission in this patient is yet to see. So the learning points from this, that B1 type of disease has higher prevalence of bloody stools than B2 and B3, but the pain is more in the stricturing or penetrating type of disease than the inflammatory type. And our patient also did not complain of pain whatsoever. But the risk of complications are supposed to be lower in this category of patient who have an isolated colonic disease and present in relatively late in life. But caution against perforation should be there in case of deep ulcers because of the transmural involvement. And even though immunosuppression, even without immunosuppression, such patients can have a very dramatic response just with antibiotics and fecal diversion. But having said that, the chance of relapse remains high in these patients. As there is no specific feature of Crohn's disease for diagnosis on biopsy, we have to consider all the factors and history, presentation, biopsy and the response. All of things taken together, Crohn's disease remains the best bet in this case. Thank you.
Yeah, I think presentation was good, better. Slides were good. Tell us, what was the preparation used for the colonoscopy? As you said, first time you prepared, you didn't prepare. The second time, what preparation did you use?
Sir, polyethylene glycol.
And how much polyethylene glycol? How much fluid?
Sir, the regular preparation which we give, 2 liters to be taken, the split dose we have used.
And air insufflation, did you use CO2 or what?
No, sir, the regular air. The CO2 was not used in this patient.
And this was done by experienced gastroenterologist?
No, sir, it was done by residents because we were not expecting ulcers to be beyond that. We
So-
were thinking just a localized disease in this patient.
Now tell us, what are the sites of perforations? Can you have a perforation beside the site of inflammations? You can have a ulceration at a different site and you have a perforation in a normal site. Can that happen?
Sir,
What is the physics of perforation, colonic perforation, when you do a colonoscopy?
Sir, when we do a colonoscopy, perforation can be due to 2 things. Either due to mechanical trauma, due to the manipulation of the scope, or the trauma due to the scope or the defective instrumentation, or it could be due to the barotrauma. So barotrauma can occur even in places where there is no
Very good, we understand. Yeah. Okay, now tell us, what is the explanation? Your explanation is right, that you have diverted the whole fecal flow and that's why the healing happened without any drugs. Is it known?
Yes, sir, it's known that
So-
fecal diversion results in, actually, sir, in about 60% of the cases, fecal diversion can give a good response, but the problem is with the relapse rate. Because a fecal diversion with a stoma, in 60% will give good response, but in only half of the patients can be attempted for the reversal of stoma.
Why this happens? Why? When you do a fecal diversion, the ulcers heal. Why? Why this happens? What is the mechanism?
Sir, the mechanism that there are certain components in the fecal matter that induces the inflammation. And this has been proved by, again, rediverting. It has been seen that after reversal of the stoma, some patients, there's a significant number of patients relapse. And they end up having a major surgery like proctocolectomy.
Okay.
So my question is that you are very sure it is a Crohn's disease trauma or it is an iatrogenic perforation in different aspect. There is ulcer you have demonstrated, but you are not very sure this is Crohn's. And it is localized to only one area, just like solitary rectal ulcer syndrome like presentation.
Sir, the presence of multiple perforations.
Because the patient responded without any medicine, just diversion. Then you are not very sure whether you are dealing with a case of Crohn's disease. Then you have started azothioprine just on the guess that it might be Crohn's. But why you are considering it is Crohn's?
So actually, the time lapsed is very less. The patient has, it's just been 2 months that we have started the patient on
you can wait.
But fecal diversion can result in a very good response rate,
Yes.
but the response rate is very short term.
So my question is that why you have started azothioprine?
Sir,
For what basis? Is there any indication? Because this is a drug. And you are not very sure whether it is a Crohn's or not from your presentation.
Yes, sir.
There
So
will
we
be
are not
multiple
sure.
reasons for
Sir,
colonic perforation.
For the prevention of relapse.
Yes, yes.
For
That
the
is-
prevention of
No,
relapse.
relapse, you are not, initially you are not very confident whether it is a Crohn's or not. That is my
Before that,
question.
I want to clarify from you that it is only one diagnosis in your mind that it is Crohn's disease, but you have not discussed about the differential diagnosis. Though you have managed properly, definitely this has happened. But regarding the diagnosis, only one There's only one.
No, sir. We were
no other
also
alternative, no differential diagnosis?
So we were also considering tuberculosis, but the
Do you think this is TB? No.
Sir, no,
No.
sir,
Then
no.
what are the other
Sir,
possibilities?
we thought of ischemic colitis, but the areas involved were not supporting that.
Why
because
not?
It was
Why not? Why not?
Because those were not the watershed areas, and also
And
the.
what is the age of the patient?
So 42 years. With
And
no
that is
coexisting
not in
comorbidity.
favor.
And also the biopsy report, there was abundant inflammatory cells. In ischemic colitis, we do not see, there's paucity of inflammation in the biopsy.
Now you have
And
taken the
any other?
biopsy from the ulcer area which has shown some inflammation. Because there is ulcer, there will be inflammation. But from other areas where there is colonic perforation, you have got any histological evidence?
So
If it is there.
histopathological report is just of the perforated area, the margins of the ulcer which perforated.
In other areas of perforation also there is inflammation.
Sir, but in ischemic colitis, there is not supposed to be
No, I'm
inflammation.
not saying of ischemic colitis. I am just asking you, the biopsy from other areas of perforation, is there any evidence of any inflammation or not?
Yes, sir, inflammation.
And other areas also?
Yes, sir, all the areas have similar report.
They actually, all of us, all the gastroenterologists will agree that this colonoscopic finding, what you showed us, that is not suggestive of Crohn's disease. You know, number one, the primary colonic involvement. Number two, that perforation as a presentation, though there is iatrogenic has been exaggerated, but there are multiple areas of necrotic ulcer, and there is no evidence to suggest that this is Crohn's disease. I have strong reservation for the diagnosis of Crohn's
Yes, sir.
disease.
So we were
but
also
I think
surprised with the biopsy report.
Why not an infective ulcer? You know, the amoebic ulcer can perforate. These bacterial infections can perforate. And there are different areas. Why not an infective colitis with
Sir,
perforation?
yes, sir. For in points against infective colitis in this patient was, the patient was suffering from 3 months. There was no fever at all. And also, amoebic colitis is supposed to be more on the right colon
Very
side.
good, very
and
good.
Not
Pradip,
in the rectal.
very good. Just wait, Pradip.
If you go through the biopsy report, which is a surgical biopsy specimen, which suggests Crohn's disease, there is no doubt. You can't go away from the biopsy report, first of all. And maybe something is missing in the case, which is leading to different points. Otherwise, I don't doubt the diagnosis of Crohn's disease after a biopsy of surgical specimen. Whatever you say. Whatever, if you don't can't fit a case, then you can't fit.
Agree.
And you have to treat full-fledged like Crohn's. You can't do a reversal therapy, you can't do a colonoscopy again and proof of diagnosis. So I think that you should treat this case as Crohn's after a full-fledged biopsy. There is no doubt.
Okay, just tell us just one point. Why did you present this case to us? Just one answer.
So because the first look of the patient, we thought of
Only one sentence. Why did you like to present this case to us?
Because it was an atypical presentation for Crohn's disease, and the patient pulled through a major iatrogenic complication which we created.
Have you done some?
It was a great learning for us.
It's very unusual.
Thank you. Very well done. Okay, take your seat. We go back to Prashant Kumar. Very well done. Adrija, thank you. Very good. Very confident. Prashant, come. Yeah, start.
Good evening, sir. I am Dr. Prashant from Peerless Hospital, and I am going to present a case of a patient who presented to us with fever and jaundice. Fever has always been fascinating for us and has been following since our MBBS and MD days, but it has been also very much puzzling to us, and so was this case. So this was a 34-year-old married Hindu male who had education up to 12th standard and was having a private business, resident of Ajamgarh, UP, got admitted in our hospital on 20th July 2022 with chief complaints of fever for 1 month and yellowish discoloration of eyes and urine for 20 days. So history was, he was apparently well around 1 month back. Then he developed fever, which was sudden in onset, high grade up to 103 degree Fahrenheit, intermittent in type, 2 to 3 spikes over 24 hours with no fixed interval, not associated with chills and rigor, and subsided on taking antipyretics. There was no history of cough, sore throat, rhinorrhea, shortness of breath, or chest pain, any rash, arthralgia, myalgia, malaise, or fatigue. No history of any burning micturition, dysuria, any headache, vomiting, convulsions, or altered sensorium. No history of weight loss, night sweats, or any evening rise of temperature. There was no history of any travel, contact with animals, or high-risk sexual behavior. Around 10 days post the onset of fever, he developed yellowish discoloration of eyes, which was initially noticed by his family members and which gradually progressed over time. It was not associated with pain, abdomen, vomiting. Later during course of hospitalization, he developed pruritus, which was mild intensity, generalized, and more during evening hours. There was no history of any pain, abdomen, or vomiting, any clay-colored stool, IV drug abuse, CAM intake, OTC intake, or any blood transfusion in past. No history of easy bruisability or gum bleed, any rash, arthralgia, or back pain. No history of travel or any high-risk sexual behavior. So past medical history, he is a known case of psychiatric illness, and for last 6 years was taking risperidone and trihexyphenidyl combination, divalproex and amisulpiride. Patient had stopped taking these medications after the onset of fever. There was no history of jaundice in past and no history of any chronic infective illness. Personal history is he is non-alcoholic, non-smoker, takes 1800 kilocalorie mixed diet. Family history was there was no history of any chronic infective illness like TB in family or no history of malignancy. Surgical history was non-contributory. So the course before hospitalization in Peerless Hospital, he got first episode of fever on 23rd June, consulted a local doctor in UP, was advised to take oral antibiotics and paracetamol, was afebrile on 25th June. Again, he has a recurrence of fever on 26th June, consulted another doctor, started on oral antibiotics and paracetamol, and was continuing medications, but fever was persistent. So on 3rd July, he got admitted in Mission Hospital in UP with fever and jaundice, and some of the lab reports were done, and these were the reports which showed that total leukocyte count was nearly normal and had a deranged LFT, mainly bilirubin. There was direct hyperbilirubinemia, and SGPT and OT were altered. Alkaline phosphatase were not done initially, but the latter reports which showed on 13th of July showed an elevated alkaline phosphatase of 531. So other tests which were conducted were hepatitis B, markers were done, hepatitis B and C and NT-HEV were non-reactive and NT-HEV was reactive. Ultrasound was done which showed hepatosplenomegaly and partially distended thick-walled GB. So patient was basically treated as a acute hepatitis E, but he had persistent spike of fevers, so he had received in that hospital injection ceftriaxone and was given tablet azithromycin initially and cefpodoxime. This was the antibiotic history which he had received till now on OPD basis and after being admitted to the hospital. But despite all these medications, his fever persisted and he left against medical advice on 17th of July. And he reached Peerless on 28th of July 2022. So we had a syndromic diagnosis of chronic or persistent undifferentiated fever with jaundice, and we were not fully confirmed that this was mainly due to hepatitis E. So we had other differentials like tropical infections could have been the cause, or we also thought of chronic granulomatous diseases, whether infective or non-infective, or whether it was a drug-induced liver injury with superimposed infections, or was any malignancy in the form of lymphoproliferative malignancy. So workup was done. On general examination, patient was conscious, cooperative, and well-oriented. He was well-nourished. Icterus was present. There was no pallor, cyanosis, clubbing, edema, or lymphadenopathy. Pulse was 98 per minute, regular. BP was normal, and temperature was 102 degree Fahrenheit. On systemic examination, per abdomen inspection was normal, and palpation, temperature was raised, but there was no tenderness, guarding, or rigidity. Liver, lower border was palpable, 3 centimeter below right costal margin in mid-clavicular line, firm consistency, smooth surface, and round edge. It was non-tender and non-pulsatile. Percussion top space was dull, liver border was present, dullness in 5th intercostal space in right mid-clavicular line, and liver span was 16 centimeter, auscultation were negative, no rub, bruit, or venous hum. So after these initial examinations, we had a patient who was febrile and was icteric and has a hepatosplenomegaly. So initial labs which were done in our hospital, they were also similar to those done earlier. Leukocyte count remained near normal, and there was altered LFT with conjugated hyperbilirubinemia, SGPT-OT were elevated, and so was the alkaline phosphatase and GGT, but there was no definite hepatocellular or cholestatic type. It was a mixed pattern of injury which was demonstrated by LFT. So we repeated the tests of malaria, dengue and typhoid which came out to be negative. RK39 was done because he was a patient residing in UP, and leishmaniasis is often endemic disease to that area, so this was also ruled out. Again, viral markers were repeated and HEV again came to be reactive. So an ultrasound was done, so liver was mildly enlarged, portal vein 11 mm, spleen was enlarged, gallbladder showed diffusely thick-walled, and there was periportal lymphadenopathy. Chest X-ray was absolutely normal, and blood cultures and urine cultures showed no growth. So again, we were left with the possibility of hepatitis E, but persistent fever, high rising fever for 1 month could not be explained only by these findings. And another positive finding which we got was the periportal lymphadenopathy.
Just tell us, what are the infective workup you included? You have included, yeah, this slide has come. Okay, okay.
So other investigations which done was leptospira, scrub typhus, Epstein-Barr virus, which also came out to be negative. We also did an autoimmune profile, all came to be negative. IgG was 813, IgG4 was normal. We also had kept in diagnosis of HLH syndrome, hemophagocytic lymphohistiocytosis, for which ferritin, fibrinogen and triglycerides were done, which came out to be normal. So considering the lymphadenopathy has to be the additional factor which we got in our investigations, we did a CT abdomen which showed mild hepatosplenomegaly with periportal and para-aortic lymphadenopathy. GB was diffusely thick-walled with no calculus or biliary tree waves not dilated. So here also we only got hepatosplenomegaly with lymphadenopathy. CT scan was done to see whether we have any parahilar lymphadenopathy was there or not, but it showed a thickening and fibrotic band-like lesions at subpleural locations of basal segments of lower lobes bilaterally. So we did a bone marrow aspiration which showed adequate erythropoiesis, myelopoiesis and megakaryopoiesis. ME ratio was 3.3:1. Trephine biopsy showed normal cellularity, adequate erythropoiesis, myelopoiesis and megakaryopoiesis. Impression was reactive marrow changes, so we also did not get any clue from bone marrow examination as well. We again repeated the labs, and in latter half of the reports we can see that although there was deranged LFT, but AST, LT had settled a bit, but alkaline phosphatase and GGT were persistently increasing and had reached up to 945:221. So we did an MRCP to see if there was any biliary tree anomaly. So hepatosplenomegaly, MRCP showed hepatosplenomegaly with diffusely altered signal intensity, diffuse wall thickening in the gallbladder and CBD and periportal lymphadenopathy. Impression was sequelae of acute viral hepatitis. So we decided to go for an liver biopsy, but when we explained this to patients, they were very much reluctant to undergo liver biopsy and asked for if any other investigations could be done which could help localize the site of lesion. So we did a PET CT which showed enlarged liver 21.6 centimeter with diffusely increased FDG uptake. Multiple lymph nodes were seen in periportal, portocaval and para-aortic region, and the impression which was given was likely suggestive of infective pathology. So we nearly laid down our conclusion that the pathology was still present in liver and hepatobiliary region. So this was the PET CT, and we did a USG guided liver biopsy, and the liver tissue TB-PCR showed MTB trace detected and rifampicin resistance was indeterminate. We waited for the liver biopsy report which showed multiple epithelioid cell granuloma having central necrosis with mononuclear cells and Langerhans giant cells at periphery. Reticulin stain showed considerable fibrosis around the granulomas. There were no viral cytopathic effect, balloon degeneration, steatosis or features of CLD, and an impression of granulomatous. This was the slide, and we can see the reticulin stain. We can see the different granulomas present there with central caseation. If I could show, this was the Langerhans type giant cell marker. So patient was started on ATT, and this was his lab reports 4 weeks post ATT. Fever subsided, hemoglobin was 12, bilirubin came down to 2, ALT, AST settled, and alkaline phosphatase GGT also started settling. And the rapid TB culture report, which came out after 4 weeks, already we had started ATT initially, they showed growth of MTB complex after 4 weeks of incubation. So finally, a diagnosis of granulomatous hepatitis of tubercular etiology was made.
Okay, very well presented. Very good. The presentation, at least don't feel bad. Kunal, we expected a presentation like that from you. I'm sorry to tell here. What were the ATTs you gave and what were the doses?
What was it? Sir, we started with 4 drug regimen, although patient had hepatitis and we consulted physician, but they said in hepatitis we should start with a modified regimen. But Amrapurkar et al. Study was there, they started with 4 weeks regimen for 2 months. So we started with HRJD for 4 weeks we started and 1 month post. But
you tell INH, rifampicin and pyrazinamide also you gave?
Yes, sir, yes, sir.
You gave pyrazinamide?
Yes, sir.
With a bilirubin of, how much was the bilirubin? 9?
5, sir.
5.
What prompted you to do liver biopsy? It's a very good diagnosis.
Liver biopsy is because we got, there was diffuse intake. Everywhere we were getting a diffuse intake, mild hepatomegaly and periportal lymphadenopathy.
Why you did not take the lymph node biopsy?
Lymph node biopsy actually was difficult and a demanding procedure and USG guided that.
Because that was very evident, no?
Yes.
Liver biopsy, it's a wild guess, I think.
Yes.
Because it was a viral hepatitis-like presentation. Yes. Subsequently, there is persistent fever, and you are looking for what is the cause of pyrexia of origin. The liver biopsy is an important thing, but you got some clue that there is lymphadenopathy in 2 occasions, in CT and also in PET scan.
Patient party also, they were very reluctant for putting a needle inside unless we had a great conclusion that we will find the pathology once we put a needle.
Yeah, but I think liver biopsy was a good decision when you have somebody which is hepatic illness. There is no doubt about it. The lymph node could be reactive as well, but I think the reason why we would have done liver biopsy is we are dealing with a hepatic illness with persistent fever. This is particularly important for the student in acute viral hepatitis. Typically, when the jaundice appears, fever disappears. So we always ask students that if fever continues, what could be the reason? The reasons are that 1, leptospirosis, 2, enteric hepatitis, 3, infectious mononucleosis, 4th, hepatic lymphoma, which can present with jaundice and fever, and 5th, continuing hepatocellular necrosis in a patient who has simple viral hepatitis. Now in this patient, see, you had telltale evidence of hepatitis C. The gallbladder changes typically occurs in hepatitis C. His hepatitis E was positive, and obviously it is a prolonged jaundice. Jaundice is not related to TB here, because tuberculosis, hepatic tuberculosis rarely present with jaundice. So the jaundice was largely related to hepatitis E. And in fact, we saw a patient quite some time ago. Interestingly, this patient is from Bardhaman. Because of this situation like this, he went to SGPGI and he had hepatitis E with tubercular peritonitis. So the same question was raised at that time. In a jaundice of so high level, you want to give ATT, but we dared to give ATT and the patient beautifully responded. Yeah, that's right. See, what is the recommendation?
NFT has to be followed weekly initially.
Continue. Yeah, but typically if you go by recommendation, it is, if you read Patrick Kamath paper in hepatology, they would be little guarded to give all hepatotoxic drug together. So it was a daring decision by you and away from the recommendation.
I think the bone marrow biopsy was not needed.
Bone marrow biopsy didn't show anything. Huh? Bone marrow biopsy was bone marrow biopsy was done.
Yes, sir, it was done, sir. PUO, it's a
The liver biopsy would have preceded it.
second also HLH, sir. Out of 8 criteria, 5 has to be present.
Shomnath, anything?
One point of the list of things where fever continues in the case of jaundice, wouldn't you also, herpes simplex, wouldn't you consider?
Yes, sir. Yes, sir. Yes.
See, even in scrap typhus, the fever continues. All they have tested. That's why I asked. Very well done. Quite. Okay, take your seats. Very good. Very well done. I think Rishabh, you are left with. Rishabh, you have to do much better than the other people to get a prize. Very difficult competition now.
Good evening to all of you. So, a 50-year-old male presented with a yellowish discoloration of sclera and urine since 1 month and pain abdomen for last 25 days. History of presenting illness, he was apparently alright 1 month back, then he noticed yellowish discoloration of the sclera and urine, which was acute in onset and gradually progressive and associated with nausea. Then after 5 days, he was also complaining of upper abdominal pain, which was acute in onset, continuous and severe and deep boring in nature, radiating to back, aggravated by food and movement and relieving with medications. Pain was also associated with nausea. There is no history of any hematemesis or melena, no history of any similar pain in past, no history of alcohol intake, no history of gallstone disease, no history of drug intake, no history of trauma, no history of any surgery or procedure, no history of diabetes and hyperlipidemia, and there is no similar family history. There is also no history of itching or clay colored stool and not associated with fever, with chills and rigor. The patient relatives revealed there is a history of acute viral hepatitis A virus 1 month back and managed conservatively in some local hospital outside. Then after that, he was complaining of severe abdominal pain after the 5 days of onset of jaundice and admitted in another hospital and diagnosed as an acute pancreatitis. Patient received intravenous fluid, analgesic and oxygen support and other supportive treatment, and then gradually he started deteriorated and a relative took discharge and brought him to another higher center, and he was diagnosed as an acute pancreatitis, pleural effusion, sepsis and AKI which required dialysis. So outside, the hemodialysis was started on the day 17th of the abdominal pain and percutaneous diagnostic aspiration of the peripancreatic fluid in view of systemic inflammatory response syndrome and left-sided intercostal pictal chest drainage inserted on the day 18 of pain. He also received blood products outside, and then he was brought to our hospital on day 17 of pain with the chief complaint of shortness of breath, abdominal distension and anuria. On examination, the positive findings include he was anxious, pale, icteric, facial puffiness and pedal edema was present. He was febrile, tachypneic, tachycardia, and the saturation was 86% with 2 liter oxygen. So he was put on NIV support. There is a decreased air entry in left lower zone on chest auscultation, and on per abdominal examination, the inspective finding include the abdomen was distended, the tender epigastrium and left upper quadrant. There is a dullness noted in the left upper quadrant and peristaltic sound was present. So the summary, a 15-year-old male presented with a history of jaundice and pain abdomen, being diagnosed as an acute viral hepatitis and acute pancreatitis, treated conservatively in outside hospital, referred to our hospital after 1 month with the sepsis and complication of respiratory distress and decreased urine output requiring dialysis. So the provisional diagnosis was a case of severe acute pancreatitis, probably due to a viral cause, having a multi-organ dysfunction including AKI, respiratory distress, which is probably due to ARDS or pleural effusion or volume overload secondary to renal failure. So the investigation on the admission day in our hospital, so there is a anemia, leukocytosis and thrombocytosis was present, and a very high CRP noted, and the LFT was deranged, and the BUN was very high, and the very high creatinine. The calcium and lipid profile was normal, and chest X-ray showed there is a defined patchy opacity bilateral in lung field with left pleural effusion. The USG whole abdomen done on the day of admission, and which showed large collection with the internal echogenic material in the anterior to the pancreatic head and body, and collection extending around the head and reaching its posterior aspect, and there was also mild ascites. Outside blood culture was showed Stenotrophomonas maltophilia, for which he received antibiotics. And MRCP done outside which showed pancreatic duct disruption with a track to the peripancreatic space, which was done on day 25 of pain. Then CCT whole abdomen done in our center on the day 3 of admission, which showed acute necrotizing pancreatitis, more than 50% of necrosis, with a collection in the lesser sac, bilateral paracolic gutter and pelvis. So this is the CT of necrotizing pancreatitis, which showed more than 50% necrosis. So the course in the hospital, with above said complaint, he was admitted and shifted to ICU and put on an IV support. He was started on the broad spectrum antibiotic, antifungal agent and other supportive management. In view of persistent SIRS response or organ failure and raised inflammatory markers with persistent fever, the CT guided percutaneous collection drainage was done by the intervention radiology team on the day 4 of pain, on the day 4 of the admission. And the 3 pictal catheter placed, one in lesser sac, one in paracolic gutter and one in pelvic region. The collection sample was aspirated and sent for the culture, which showed no growth. Patient also received renal replacement therapy as per the nephrology team until improvement in the urine output. And the blood components were also transfused. So there is the first one is a laser sac collection drain, second one is paracolic gutter drain. So in view of persistent drop in HB, the IR team opinion again taken, and they advised for the CT angiography on day 6, and which not reveal any source of bleed, but a branch of gastroepiploic artery was noted near the drain, for which subsection angiography done, which showed a focal extravasation from the left gastroepiploic artery for which the embolization done. Then drenogram done, we showed there is a collection between the left paracolic and peripancreatic collection, for which drain size was increased and a Thalquick 24 French drain was inserted. And upsize of the pelvic drain also done. In spite of all above things, there is a persistent drop in hemoglobin noted. And in view of persistent leukocytosis tachypnea and increase in IV support, we have done a CT abdomen and chest, which showed there is a decrease in laser sac and pelvic collection, but there is a development of left moderate pleural effusion, for which pictal catheterization done. But the patient was clinically, after the patient was clinically improving, fever frequency decreased, total leukocyte count and CRP was also decreased, and oxygen requirement also decreased, but there is a persistent HB drop was noted and hemorrhagic drain collection noted. So we did an endoscopy, we showed a clotted blood in the fundus, but there is no ongoing bleed or ooze. Then again, to rule out the site of bleeding, we did CT angio on day 13. We showed no obvious bleeding source, but it's a persistent large volume walled off necrosis, and the collection is supplied by mainly gastroepiploic artery and the left gastric artery. Then we again done a angiography, which showed a subtle contrast extravasation from the subphrenic branch of the left gastric artery, so embolization done for the same week. Gradually his AKI part improved and he is out of oxygen support. This is a walled off necrosis. So after some time, the pleural drain, pelvic and left ureter collection drain was removed as output was very minimal. Nutrition was maintained throughout the hospital course. And after that, after 3 to 4 days, he was complaining of hematemesis and melena with food particle noted in the drain. So we did UGI, which showed necrotic material and slough in the gastric cavity with a large defect along the greater curvature noted. And there is a significant HB drop noted again, for which CT angio done, and we showed a residual perigastric collection with hematoma and blood clot in it, which causing significant compression on the stomach and ill-defined defect in the gastric wall in the fundus along the greater curvature. So this is the bedside endoscopy we did. So this showed the necrotic material with clotted blood in the gastric cavity. And also there is a bleeding noted in the duodenum also, but there is no site identified. And this is the collection between the walled off necrosis and the gastric cavity. We have seen the same content in the both necrosis, in the pancreatic necrosis collection and in the stomach. So blood products were transfused at that time and patient were stabilized initially. Then he again developed high-grade fever with chills and rigor and the drop in HB and CRP noted, for which antibiotic upgraded accordingly. In view of above finding, we have planned for upper GI endoscopy and necrosectomy with the external drain reposition, which was done on day 45 and the nasojejunal tube was placed for the nutrition. At the same time, showed a Klebsiella pneumoniae infection and which sensitive antibiotic is started. After that patient, his fever frequency decreased, pneumonia improved and inflammatory marker also improved. HB was stable. So he was discharged with NJ tube and percutaneous drain in situ. This is the necrotic material in the gastric cavity with the fistulous tract between the pancreatic collection and the stomach along the greater curvature. So we did the UGI and done the necrosectomy using the Roth net, and we removed it with foreign body forceps and with the help of snare. A lot of necrotic material were removed, and after that patient started improving. So the investigation trend was the HB was persistently low throughout the hospital course, and TLC was the total leukocyte count was started decreasing. There's a fluid culture. The collection fluid culture was negative, and the gram strain was also there is no organism found, and blood culture was also that showed no growth. On the day of discharge, the patient hemoglobin was 8.6. The total leukocyte count was 10,000. And CRP was 73, and BUN was also improved, and creatinine was 0.8. On the follow-up after the 10 days of discharge, he was clinically better, afebrile, and there is no dyspnea or tachypnea. There is a decreased drain output, and CT abdomen showed very minimal collection in the lesser sac, drain in situ, and they had planned to remove. So there is only 1 to 2 case report of the pancreaticogastric fistula in the case of acute severe pancreatitis. The one in 2007 and the another one in 2018. And this is systemic review regarding the viral hepatitis related pancreatitis, in which there is a total 46 studies reporting data on the 73 patients were included, and most of the cases were diagnosed in Asia, and most of the patients were affected by hepatitis A, followed by hepatitis E.
Nisab, have you noticed that you have crossed at least more than 3 minutes? Your presentation already is going in 14th minute. If you really want to participate in a competition, then you need to control yourself. You have to look into the slide and talk to your boss who is defending you. Okay, finish up first.
Yes, sir, done, sir. Already. Thank you, sir.
Now the patient is all right.
Yes, sir.
The
Yes, sir.
patient
The
is
patient
okay.
is all right now, yes, sir.
So you are describing a case of acute necrotizing severe pancreatitis.
Yes, sir.
When they presented to you, etiology may be viral, very young age,
Yes, sir.
and he went to lots of complications of acute severe pancreatitis, sepsis, bleeding, everything.
Yes, sir.
And finally, God luck that he came out without any surgery.
Yes, sir.
So when embolization was done, was it very selective? Because why I am saying is, embolization could also contribute to gastric wall necrosis. That is one. Second, as you reviewed the literature, in fact, viral hepatitis can cause pancreatitis.
Yes, sir.
From SGPGI, we reported 16 patients of acute viral hepatitis E causing pancreatitis.
Yes, sir.
So that is the second thing. And third thing that I wanted to say is that obviously it was a very daring management. It is a critical patient, and you know that actually it is good that the outcome has become good. So do you think if we would have intervened earlier, this spontaneous necrosis would not have happened? Because why I am saying is, normally in acute pancreatitis, having a necrosis into a viscera is a very poor outcome. Like I remember the surgical colleague of SGPGI, they reported in British Journal of Surgery 6 cases in which there was a colonic necrosis and all 6 died. So what I am saying is, do you think that if we could have drained earlier, this would have been prevented?
Sir, on the time at the time of admission, we did a CT in which there is no definitive wall found around the pancreatic collection. So we didn't go for the endoscopic or endoscopic ultrasound guided drainage. So at that time we did percutaneous drainage.
Because you received the patient on day
after 1 month of
after 1 month of the acute presentation.
Yes, sir.
So when you received the patient late.
Yes, sir.
That
We
is
received
also.
it, yes, sir.
When sepsis has already
Yes,
occurred.
already.
With that, anything?
No, that is a very good case, but only thing that, and you have managed daringly, that is in the spontaneous necrotic area, and these were doing endoscopic necrosectomy, that is also daring. And I think that the patient has improved, and I think this is very rare case and rare presentation, and I managed well.
Thank you, sir. Thank you, sir. Thank you.
Thank you. I think there was a huge, beautiful competition. There are 2 prizes out of 4. I think a good amount of check will come. I think first you must clap for the second best is Prashant Kumar from Peerless. Prashant, thank you, very good presentation. Beautiful case, but we'll give you the check, I think, Dr. Now, okay. Within 5 minutes you will give? Yeah. Prashant, you get the second best. So runner up. And the first prize goes to Adrija. So I think there is a neck-to-neck competition between Adrija and Prashant. And both of them did very well. It was very difficult to decide. You will be surprised that there is a 1 mark difference. Out of 100, out of 75, there is only 1 mark difference between 2 of them. But cheer up, Rishabh and Kunal. Rishabh did quite well. Yeah. And Kunal, I think just presentation was little different. That's why maybe you got a little bit less mark. Thank you. This is close from our side. I really give the microphone back to the organizing committee.
Thank you, Professor Uday Ghoshal, Professor Dr. Jayanto Das Gupta, and Dr. King Shuk Dash for their exciting session. I think everybody, while busy in their, having the drink and the food, it is customary to go for the vote of thanks. I would like to thank all the faculties, all the delegates who have attended. We would like to thank AMRI group of hospitals and their management committee for extending their support. I would also like to thank all the pharma industry for extending their help to us. Without their help, this program wouldn't have been possible. I would like to thank all the DNB and DM students who took part in the competition. 2 have won the prizes, but I think other 2, they also deserve a big round of applause. I would like to thank Sunil and his team for the enormous effort they have done over last 1 month. Without Sunil, I think I wouldn't have done this conference in this smoothly. I would like to call Dr. Sujit Chaudhary to the stage, please. The next comes, we would like to thank Dr. Shubhasri Bhattacharya. She has been working very hard for this conference. So we would like to send a thank you gift for Dr. Shubhasri Bhattacharya. Dr. Dev Kumar Roy. Dr. Dev Kumar Roy. Dr. Dev Kumar Roy, please. Gift কোথায় গেল দাও একটা একটা ডক্টর দেব করছি গিফটটা দিয়ে দেখ সই করছি করে দিচ্ছি ডক্টর দেব কুমার শুভশ্রী দেব কুমার দা ডক্টর দেব কুমার রায় প্লিজ কাম হিয়ার ঠিক আছে শুভশ্রী তো দিয়ে দাও ওটা সারাদিন রয়েছে হ্যাঁ দাঁড়াও Dev Kumar Rai আসুক দাঁড়াও Dr. Dev Kumar Rai, please come to the stage and to give the prize, and Dr. Shubhasri Bhattacharya, please come to the dais to take the prize from Dr. Dev Kumar Roy. Your support to our conference is really praiseworthy. A big round of applause for Dr. Shubhasri Bhattacharya for anchoring the entire day. Yeah. And I think my job will be incomplete if I do not thank, no, just stay, Dev Kumar Da. If I do not thank Amit and Shayan for their endless effort over last 2 months. We have rebuked them, we have advised them, and in the end, they have done the job brilliant. So please, Amit and Shayan, come to the stars. Sunil, to have the prize. Amit, please come to the dais, Amit. Shayan, দুজনেই দাও এই দুটোই ঘড়ি হ্যাঁ তুমি দাও তোমার Dr. Sujit Chaudhary is handing over the prize to Amit for his beautiful walk over last 1 month. I think Amit deserves a big round of applause. Next comes Shayan Ganguly. He's a chap who has joined us new for last 6 or 8 months, but he has really worked hard. So well done. And and we are giving the prize to now we are giving the prizes. Dr. Ghoshal, please come to the dais, please. হ্যাঁ তুমি যাও চেক আমি সই করছি Prize goes to Audrija Ganguly from Medical College. A big round of applause for Audrija. Dr. Uday Ghoshal will hand over the certificate, and we are handing over the check now in a minute. So a big round of applause, Audrija. So she has done really well. Next comes Dr. Prashant Kumar. Dr. Prashant Kumar, please come to the dais. আচ্ছা সুজিত দা আরো দুটো আছে পার্টিসিপেশন ও দুটো দিয়ে দাও পার্টিসিপেশন দেখো সার্টিফিকেট অফ পার্টিসিপেশন যারা এই করেছে So Professor Uday Ghoshal is handing over the certificate of honor second prize to Prashant. I think we will also congratulate our other 2 presenters. Please come to the dais, please. We will hand over the certificate of participation. I think they have also worked very hard to present the case. And with this sort of experience, they will gain much in their future life. Just wait for a minute. Kunal, well done, and Rishabh, well done. I think that's very good. Certificate of presentation. And it is good that you have presented before the examiners, that is very good idea. You know, that is the idea with which we have done this competition, so that you start presenting before the external examination. You know, it cannot be 100% the DM final examinations, but at least it will give you a bit of flavor for meeting the external examiners. Yeah. Okay. So we are. Certificate of participation to Bishop. Yeah. Next one is Kunal Kumar Gupta. Yeah. Well done, Kunal. I think next year we will see you better presenting the case. Okay. So we end our journey and আসছে বছর আবার হবে. Thank you.